reconstruction, where with the advance of reconstructive surgeries and sometimes with the help of plastic surgeon like Dr. Amrish, we are able to give very good cosmesis and good quality of life. Example is this is the example of breast where the tumor is very large and involving the skin. So I have to excise complete overlying skin, and with the help of LT flap, I am able to reconstruct the breast. Can you play the video? See, this is the lumpectomy defect in the breast. What we do, we remove the complete lump. We do the marking of the LD flap. This is the flap which is going to come into the breast, and we lift the LD flap on its pedicle. Once the flap is lifted on the pedicle, it is mobilized and brought into the breast. So this is the flap which is being raised. Most important is to preserve the blood supply of the pedicle. It is rotated into the defect and primary closure is done. You will see the cosmesis at the end. See, this is nicely sitting there in the defect, and this is the final appearance. Another example where we use plastic surgeons for microvascular reconstruction, where you can take the flap from the abdomen or thigh and do the reconstruction. Coming to oral cancers, with the help of reconstruction, we are able to reconstruct any defect in the oral cavity possible. Sometime we may be not able to do the microvascular reconstruction because of morbid condition. This video which I am going to show is 70-year male who presented with oral cancer, but because of its heart condition, my anesthetist told he will not tolerate the surgery for more than 3 hours. So 3 hours, whatever you want to do, please finish it off. So what I have planned is local flap. I have taken a submental flap where I have done the marking of the flap. This is the local flap. This can be done in 1 hour if you know the technique. Flap is raised based on the submental artery and vein. The flap is harvested. This is the flap which is rotated into the oral cavity, and primary closure is done. This can be finished in 1 hour. See the final appearance once the flap is sitting nicely into the oral cavity. With the help of bones, we are able to reconstruct the mandible also. This is an example where we removed the mandible and we have used the fibula to reconstruct the oral cavity. This is my last slide. Thank you for patient listening, and I am grateful to all my patients for having faith and trust in me, and my colleagues and my seniors, many of them are sitting here from Bidar, for always supporting me and never telling no to me. Thank you for your patient listening.
Thank you so much, sir, for the wonderful presentation. We've learned a lot from it. I thank our chairpersons for chairing the session. We'll have the Q&A at the end of the session. We're still running short of time. Thank you so much, sir. Can we have a big round of applause? Important announcement. I request the delegates to collect certificates and mementos at the selfie point at the end of the session. Also, the session is telecasted live on YouTube, on THG channel and CNN News. Moving on to our next session, dealing with aftermath of perioperative death with medical legal issues. I welcome our respectable chairpersons for the session. Dr. Gurulingappa Patil, Professor Department of Anesthesia, MRMC, Gulbarga, and President ISC Karnataka. Dr. Vijay Talpalikar, Senior Consulting Surgeon. Dr. Uzair MD, Assistant Professor, Department of Forensics. Please welcome our honorary speaker for the session, Dr. Shivkumar Kumar, President ISC Karnataka. Please give him a big hand. Welcome, sir.
Hello. Good morning, everybody. At the outset, I will thank the organizing team of IMA Karnataka for a wonderful scientific session they are doing it. Hello. Now I want to introduce, just now DA from Karnataka Institute of Medical Sciences, Hubli. And he has various degrees, LLB, LLM, and also recently he is in the Mysore University, has got a degree of journalist. And also the list is very much long, so I directly give the session to start. Sir, thank you for accepting our invitation and as a speaker.
Yeah.
Thank you.
Yeah, thank you, Dr. Gurulingappa Patil, for and also organizers of MEDICON for having me here to share my few thoughts about the medico-legal issues in the peri-operative period. Friends, for the last 2 days you have been into the academics. Now I will try to take you in 15-20 minutes a bit away from the routine practice. I would say that it's a beyond operation theater or beyond the... Yeah. I will try to take you a bit away from the ICU, ward or the operation theater. So the topic which is given to me is dealing with the aftermath of the peri-operative death. That's a medical legal issues. Friends, many a times we could come across as the anesthesiologists or surgeons or the physicians or the intensivists, wherein the death of the patient will occur on the table or peri-operative period. The peri-operative period is very, very misled, probably on table, in the ward, in the ICU, or post-anesthetic sequelae or post-surgical sequelae. Yeah. The mishap death occurring on any table where the patient is undergoing any procedure, maybe medical, surgical, under the care of the anesthesiologist or the surgeon or the intensivist, they are called as the peri-operative period. Pre-operative deaths, intraoperative deaths, and anesthetic deaths are still usually applied inaccurately all over the world. Even in the literature, they are not yet defined what exactly is the peri-operative death. But I deal with only intraoperative and post-operative period. So what are the places where the death can occur? Yes, death can occur instantly, unexpectedly, on the operation table, ICU or wards, medical procedures where LPs are being done, epidural central line being done, and also some of the radiological procedures wherein the patient or the child is taken for the CT, MRI and the sedation, or under the short J white, we routinely call it as, they may have a mishaps on the table. And also many times, anesthetists are called for the electroconvulsive therapy for the psychiatrist patients where we can anticipate unexpected death also. The literature, the incidence of intraoperative deaths is 0.5 to 0.8 per lakh anesthetics, and intraoperative death of anesthetized patient is 1 to 30 per 1 lakh patients, even in the many advanced countries. The situations, actions to avoid the legal violence, yes, if at all you have come across such kind of things, the most important thing, how exactly we can avoid, probably I would say that pre-litigation states, consent with the two witnesses, most important whenever you go for the surgical procedures, and video recording with the voice is also advocated nowadays. You have a fully equipped operating theatre with the paraphernalia of the surgeries, drugs adequate in number, uninterrupted oxygen supply in the operating theatre, defibrillator at easily accessible place. Many times the courts have asked that defibrillators were not at the operation theatres, they were somewhere in the corner of the hospital. By the time they got the defibrillator, when the patient went to the ventricular fibrillation and ventricular tachycardia, the patient was no more. The court held responsible that it should have been available at the instant place where you are operating or where you are giving anesthesia. Don't keep anything locked in the operating theatre. There are some emergency drugs wherein the doctors, they keep it locked, or the nurses will keep them locked. They are not accessible when they are really required. Again, it occurs to the efficiency of the services. Anesthesia machine with the necessary ornamentum is a must, including the minimum standard monitoring, and no expired drugs should be kept in the operating theatre. This is very, very important because when the panchanama takes place, probably the ampoules what you have kept, it will be sealed, and if they come across such kind of expired drugs, again you are held liable. And medical indemnity, especially pan-India medical indemnity, can save a lot of, I would say that probably it is a seal of many of the medical legal cases if we have a pan-India medical indemnity. Yeah, what exactly you must do when there is an intraoperative or a perioperative death? Call your colleagues, especially seniors. Call for the police if the situation is going out of hand. be a patient listener to the patient's relatives, cooperate with the legal arm. This is very, very important. If cause of death is known, certify it. If need be, ask for the PM. Never run away from this scene. I have seen night 2 o'clock, 3 o'clock, anesthesia surgeon calling me when the Misha Packer says so and so is up. What can I do? Avoid cover up and unnecessary explanation to the relatives or the media. And never ever have a overconfidence, telling that for the last 30, 40 years I have nothing mishap has occurred, even if it has gone that I have taken it easily. Documentation is very, very important, and expect mob handling in such unexpected cases, because the patient goes by walk. If you declare him dead, probably they have to be brought back to the gunny bag, which is not acceptable in the ordinary course of time, especially in the gynecology, obstetrics. So what exactly the causes? The human error is the factor in anesthesia practice, and the circumstances tend to be immediate, adverse, and conspicuous. Probably would say that yes, we are also human beings. To err is a human. Sometimes that kind of mistake has taken place, but the judiciary will not take it easily because it's a question of life and death. Extreme ages of the patients, especially elderly and infants, they are more vulnerable for the unexpected death, and associated with the comorbid conditions, what we call is the American Society of Anesthesia, especially grade 3 and grade 4 are more vulnerable with the intraoperative or unaffected deaths. Surgical factors, yes, especially aortic, thoracic, and upper abdominal surgeries, emergencies, cardiac neurosurgery, they are bound to have to go for the unexpected death. And anesthetic factors, yes, many times overburden anesthesia because he hopping from one hospital or other hospital without interruption, and they're bound to have some human error which costs the life of a patient. Overdoses, wrong labeling of the drugs, very, very important. I have seen across 3-4 cases wherein anesthesia was called give anesthesia for the cesarean or for the hysterectomy. The tranexamic acid ampoule and the pipecaine heavy, almost they look alike. If at all inadvertently is loaded by the staff, if we give this tranexamic acid instead of a pipecaine, the death on the table is 98%. Death on the table is 98%, even the best of the best centers. Make sure that it cannot be mislabeled, such kind of things. Inadvertent hypoxic misuse, malfunctioning of the anesthesia machine, and airway problems, and malignant hyperthermia, and lethal effects of propofol can have a consequence on this table. For example, when you are intubating the patient, neither you can intubate nor you can ventilate. This is the most important period where the patient can go into the hypoxic encephalopathy, coma, ventilator, and declaring one find a brain death. So, in such cases, what are the reactions of the anesthesiologist and the surgeon who are in the closed walls of the operating theatre? Cardiac arrest, friends, you believe me, 90% of the cardiac deaths are revivable, provided you use your diligence in the operating theatre. Check the equipments, accurate recordings. Dealing with anesthesiologist, yes, senior consult should stand by his side because he is helpless. Senior colleagues should come to his rescue in these situations. And dealing with the dead body after having declared it as the intraoperative death or bed death is very, very important. It is a procedure-related death. Fast documentation is important because the moment the police will come, he seals all the case papers and takes away. Even if you have not written it, probably. And facilitate the transfer of the body to the mortuary is very, very important. Don't assign such kind of a transfer to the relatives. Escort the deceased to the theatre should exit as a mark of respect. Otherwise, patient relatives would take it otherwise. And many times, we will try to run away from the scene, which we should never do it. Immediate cover up with the unnecessary explanations, nor warranted nowadays with the politicians or some middlemen. Settle the matter as early as possible by political and financial means. Never ever do it. It's a double-edged weapon. It's a short-term gain, but a long-term you have a very crucial period. Being too confident, again, is demanding to be defensive. Retaliate the abuse by the abused language. Always be calm and quiet, even if the patients become bit irritant or violent at particular point of time. Yeah, many times it's the tendency for all of us, including the corporate sector, the private government hospital. Is it necessary to inform the police whenever the death occurs on the table? 90% of the forensic experts, or 95%, they do, yes. But it's a misnomer. No, it is not necessary to inform to police all the intraoperative, perioperative deaths. I'll tell you the reason. There is no law, there is no judicial principle or pronouncement in support of the belief held that many doctors that death on the table should be informed to the police. The basic principle is that doctors should inform the police as soon as they suspect the foul play. What do you mean by foul play? For example, it is a non-MLC, interoperatively you find it is MLC, that time you suspect the foul play and should inform the police. And during the course of his duties, whether OPD or OPD, that's what I'm telling you, for suspecting MLC, medical legal, you have to inform the police, otherwise there is no need. It goes without saying that every unnatural death should be informed to the police. Make it a point, every unnatural death on the table of private should be informed to the police. But what exactly is meant by unnatural death? There is no reason for the doctors to inform the police unless the foul play. However, the relatives have a right to they have a right to inform the police if they do not agree for the cause of death, what we have thought of it. If you know the cause of death improperly, you certify the death. There is no hesitation. But if they are not acceptable for the relations, yes, they can inform the police. Yeah. What is unnatural death? It is not defined in the Criminal Procedure Code and Penal Code. But dictionary meaning is a death caused by the external causes, injury or the poisoning, which includes death to the intentional injury, such as homicide or suicide, and unintentional injury, that is an accident. These are called as where you need to inform the police. But death on the table is not at all unnatural death. Even in the Haryana Medical Legal Manual, you do not mention about that. Rather than informing the police, that's what I told, documentation is the important. And you are liable for such kind of police prosecution under section CRPC 174 and 304B. Many times what happens is the practical problem, relatives denying the postmortem, what you must do. Important to record the postmortem denial by the relatives of the deceased patient. Here, doctor's diligence in record keeping saved them from the adverse effects of police prosecution. Yeah. By routinely informing the police, yes, on death on the table, what may happen, unnecessarily delay in the OT work, unnecessarily workload on the hospital administration, unnecessary workload on the police, unnecessarily likely harassment of the relatives by the police, unnecessarily possible hint to the police that they can boss over the doctors, because if at all the criminal prosecution take place, because doctor has to go for the bail and other things. When PM is needed, the PM is needed when the cause of death is not known or when you are not sure of it, to determine the manner of the death, to know the time of the death. Otherwise, there is no reason for everyone to send for the postmortem. Since waiving of the postmortem is not vested with the doctor, it is vested only with the police authorities. This is very, very important. He can play a role of the advisor in such cases, but ultimately it depends upon the police officer whether he has to do the postmortem or not. Your duty is only to inform the police. Consent or permission of the relative is not required for the conducting postmortem examination. If you decide to do it, just inform the police and the police can take a call on that. Yeah. Many times it's a practical problem. Taking away the patient or body of the medical legal case forcibly by the attendants. If say that we want to inform the police, the relatives come in a mass, they say that we don't want a postmortem. We want to take away the body. Yes, in such situations, what you routinely do is take the signature of the relatives and they tell the pros and cons of having done the postmortem. If they do not inform, if they do not want it, they can take away with the signing. But however, you need to inform the police. What is FIR if it is registered against the doctor under 304A? 99.9 of the criminal prosecution under 304A. So, if at all the 304 is registered on the doctor, what he can do is, please do not panic. Involve the IMA or the senior, your colleagues or the associations to rescue. Involve the medical legal expert and the lawyers. Prepare the list of the things handed out and get them countersigned by the police people. Medical expert opinion is a must before FIR is being registered. Most of the police officers, they do not know about it. You just tell that, sir, you cannot have a charge sheet or the FIR registered under us because we need to have an expert opinion as per the Supreme Court order. Filing of an application before the session judge. If at all it happens like, you can challenge this in the Sessions Court or as well as the High Court to squash the FIR if it is on a reasonable grounds. And also, filing a writ petition under 226 of the Constitution to squash the FIR, as I said you. Another 2 minutes. Yeah. The defenses which I would say that ornaments, I would say that who can defend is under Indian Penal Code 80, accident in doing a lawful act. Yes, I have been doing a lawful act. The name mishap is not, can be taken as the mishap. 88, act done in a good faith. Yes, always doctors do a good faith because they are not volunteer to do the mishaps. And IP section 90, consent in the criminal law. Yes, we have been taken the consent. And act done in good faith for the benefit of the person without his consent, it's also a defense for the doctors. As I shared, your medical opinion is a must. Application to cost the FIR, yes, it can be taken care. There's a slide, I don't want to go in detail about 304 and 304A. Most of the police authorities register cases, medical license, that's under this section because they do not know the consequences of 304A. This is a non-bailable and totally wrong. We must bring to his notice as per the Supreme Court orders. And 304A, the act is never done with the intention to cause the death, and this is bailable. I've seen many police officers taking in lakhs to give a bail, but it cannot be. The bail can be taken in the police officer only just by signing a surety either to his friends or his relatives or his sons. There are some of the favorable cases to fight against a criminal case is against you. There is Suresh Gupta, Martin D'Souza, Jakub Maitu, Kushum Sharma, and a recently Supreme Court relief to the doctors. Death during surgery is not a medical negligence. Yeah, these are the avenues where the relatives can go. Consumer Protection Act, criminal case, complaint against the DHO or administrative authorities, and they would demand money and also violence against the doctors. Criminal, yeah. Thank you, one and all. If I have any questions, I am happy to take it. One or two. Thank you.
Thank you so much, sir, for the amazing presentation. We are honored to hear from you, sir. Thank you, sir. A big round of applause for Dr. Sanjeev Talpalika, sir.
Yeah. A medical certificate. There are two things: declaring the death and giving a medical certificate. When you are doing a certificate, you have to mention the death. If you know the cause of death, you give it. Otherwise, do not give any presumptive cause of death or probable cause of death is not acceptable in the court of law. If you know the give it, otherwise you don't have to give it. You have to wait for the postmortem report to come.
I thank our chairperson for chairing the session. Can we have a big hand for him? Moving on to our next session on anti-diabetic pharmacotherapy in type 2 diabetes mellitus, management, role of comorbidities. I welcome upon stage our dignified chairpersons for the session, Dr. Prabhu Shetty, Senior Physician, Bidar. Dr. B. Gumid, Senior Physician, Humnabad. Dr. Sandeep Patil, Assistant Professor, Department of Medicine. I welcome upon stage our honorary speaker, Dr. Sanjeev Talpalika, sir, Senior Consultant Physician. Please give him a big hand.
Hello. he first of all worked in the Nanavati Hospital as a senior this registrar for 2 years. Later on, he switched over to Hyderabad, where he worked in NIMS Hospital, well-known hospital, Hyderabad, as a senior registrar another 2 years. He has participated in many webinars and many this one scientific programs. Dr. Jyoti Tarpadikar, spouse of Dr. Sanjeev Tarpadikar, is a diabetologist working in their own Sanjeevani nursing home. Without reaching much time, I would like to Dr. Sanjeev Tarpadikar to speak over on the subject of anti-diabetic therapy with comorbid conditions.
So, thank you, Dr. Prabhu Shetty, sir. Good morning, everybody. At the outset, I would like to thank organizing committee chairperson, scientific committee, for giving me this opportunity to give today's talk. So, I am going to talk today. Next slide. So, diabetes is one of the, friends, everybody knows it is a burning problem in India. It is a burning problem in India, and day by day the cases are rising in diabetes. You can see 1 in 11 adults have diabetes, that is 90 million. The cases are going to rise to 152 million by 2045, and the day is not near, friends, that India will overtake the China and may become the diabetic capital of the world. And you can see the death responsible due to diabetes in 2021 reported more than 7,41,000. So you can see all over the world the prevalence of diabetic is increasing. You can see in the Southeast Asia the prevalence is increased by 68%. So coming to the classification of diabetes, broadly it is classified into type 1 diabetes, type 2 diabetes. Type 1 diabetes is seen in young people where there is a total exhaustion of beta cells, and the patient has to be on insulin throughout the life. And type 2 diabetes is seen in the later age where the beta cell mask is preserved. But at this stage, friends, I want to tell you, we do come across some subset of patients in our clinic, type 2 diabetes seen in children and adolescent age group. Such obese children, they do respond to oral hypoglycemic agents where the autoantibodies are absent, and especially with the metformin, they do respond with the oral hypoglycemia. Recently, one study is published in New England Journal of Medicine, that is an obese children patient, they have given small dose of dapagliflozin, they have responded with a 5 milligram of dapagliflozin also. So coming to the definition of diabetes, everybody knows it is a progressive metabolic disorder characterized by insulin deficiency or insulin resistance or both. Then coming to the complicated interplay of multiple pathological abnormalities. Diabetes affects multiple organs in the body. So the 1 in 3 diabetic patients, they have cardiovascular disease. More than 50% of the patient of diabetes, they have non-alcoholic fatty liver disease. And CKD affects more than 50% of the type 2 diabetes. Diabetes is one of the commonest cause of end-stage renal disease. So you can see here, co-prevalence of comorbidity condition, complication, Asian Indian phenotype. Diabetes with increased lipid is seen in 84.7%. Diabetes with hypertension is seen in 75%, and with CVD it is seen in 22.2%. So what is the ideal treatment of diabetes? I would like to ask you one question, whether we treat diabetes just for glycemic control, or we have to treat the diabetes with the oral hypoglycemic agents preventing the microvascular and macrovascular complications. So this is an important slide. Wikipedia study, everybody knows it is the longest and the biggest trial done in diabetes mellitus. Reducing the 1% of HbA1c, you can see here, diabetic related deaths are reduced to 21%, myocardial infarction by 14%, microvascular complication by 37%, and peripheral vascular disease by 43%. And coming to the treatment part, patient central approach is very important. When patient comes to a clinic, patient value is important, preferences are given. Patient having the cardiovascular disease, the new therapy drug which reduces the cardiovascular disease, microvascular, macrovascular to be discussed with the patient. Sharing of use to be done. This is patient-centered approach is very important. Then coming to the therapeutic target. Once you label a patient as diabetic, so what is the therapeutic target to be kept? So according to the RSSDI and Endocrine Society of India, ADA 2023, the target is the HbA1c should be less than 7 and fasting should be less than 115 and the postprandial should be less than 160. Now coming to the treatment part, anti-hyperglycemic therapy, therapeutic options are lifestyle modification, weight optimization, then the healthy diet, that is less carbohydrate in the diet. Of course, medical nutritional therapy is also very important and increase activity level. Now, before going to the treatment part, one should know what are the anti-hyperglycemic commonly used. Anti-hyperglycemic commonly used are metformin, sulfonylurea, glitazone, DP4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonist. So, we should know, before starting the treatment, we should know the action of each of these drugs. So what does sulfonylurea do? Sulfonylurea, it stimulates the beta cells of Langerhans, increase the insulin secretion. And what does bigonades do? Bigonades, metformin, one of the commonest drug used in India, in all over the world. Metformin, it decreases the hepatic glucose production and increase the peripheral utilization of glucose. Then coming to the glitazones, thioglutozones, it decreases the insulin resistance. Then coming to the alpha glucosidase inhibitors like acarbose, oglipose, it decreases the glucose absorption into intestine. Meglitinides like ripaglinide and nathiglinide stimulates the beta cell, increase secretion. SGLT2 inhibitor, everybody knows it reduces the renal tubular glucose absorption, has got a glycosilic effect. And then GLP-1 analog stimulates the beta cell, increase secretion. DP4 inhibitors, it has got secreting mediating effects. Now coming to the RSSDI clinical recommendation 2022. This is the inner wheel, friends. It is for the management of type 2 diabetes. A stand for age, B stand for BMI, C stand for CKD, chronic kidney disease, D stand for duration of diabetes, E stand for established cardiovascular disease, that is low risk to high risk, and F stand for financial concern, G stands for glycemic control, S for hypoglycemia. Drug in the green zones to be used for treatment. Drug in the other zones can also be used in a given order. So you can see here, metformin is still recommended as a first line therapy in type 2 diabetes, except there are contraindications. Now coming to the metformin, it is a bigonide used till today. It is one of the important drug used in the type 2 diabetes, and it has been used for more than 60 years of age. It is a cost effective, it is a well tolerated, it is used in type 2 diabetes with renal diseases, cardiovascular diseases, as well as the hepatic diseases. So now coming to the SGLT2 inhibitors like empagliflozin, rimogliflozin, canagliflozin, you can see all these trials, it reduces the MACE without, that is a major adverse cardiovascular effect without atherosclerotic cardiovascular disease. Now, coming to the SGLT2 inhibitors in reducing heart failure, there are various trials are there. All these trials, you can see it reduces the hospitalization due to heart failure. There are Emperor reduced trial, Emperor preserved trial, where the SGLT2 inhibitors are used in heart failure with preserved ejection fraction, reduced ejection fraction. Without diabetes, it is used in the heart failure without drug titration, without dose titration. So it is the most robust benefit in reducing the hospitalization due to heart failure. Now coming to the kidney disease, SGLT2 inhibitor, it can be used in the acute kidney injury, end-stage renal disease, when there is substantial loss of kidney disease, patient going for renal transplantation, going for dialysis. These SGLT2 inhibitors can be used to halt the progression of chronic kidney disease. So now, coming to the GLP-1 receptor agonist, I want to add 2 points in SGLT2 inhibitors. Recently, Emperor trial, they have told if you give the SGLT2 inhibitors in patient with type 2 diabetes with cardiovascular risk factor, you are adding 4 years of life expectancy. There is one more trial has been done, CVD real true trial, all over the world, for more than 4 lakhs patients have been studied. SGLT2 inhibitors has been compared with the glucose lowering drugs. It has been showed benefit among against patient ethnic, racial backgrounds, geographical regions, as well as the CV outcome continuum. You can see GLP receptor agonist like exatonide, liraglutide, semaglutide, all these drugs are given in the injection form once a week. Recently, semaglutide has come in the tablet form, and you can see in this all these trials, you can see the 3-point MACE, 4-point PACE, that is a non-fatal MI, non-fatal stroke, death due to the cardiovascular disease, and hospitalization due to acute coronary disease, that is a 3-point, 4-point is reduced with the GLP-1 receptor agonist. Now gliptins. Coming to the gliptins, like recently we are using lot of gliptins also, satagliptin, alogliptin, sitagliptin, linagliptin. All these gliptins reduces the 3-point and 4-point. Now DP4 inhibitors. What does DP4 inhibitors does? It destroys the hormone. It blocks the hormone that destroys the incretin hormone. Incretin hormone is after taking meals, it is secreted in the body to reduce the blood sugar. So DP4 inhibitors, larger cardiovascular pooled analysis, real world evidence continue to support the overall cardio safety of DP4 inhibitors. Now coming to the both the DP4 inhibitors, they are well tolerated, used in the renal disease, elderly disease, obese patient. And coming to the metformin, gliptins and glyphosate, that is SGLT inhibitor, all the drugs can be used when there is a hyperglycemia. Now coming to the side effects of gliptins, the reported cases of pancreatitis, transient nasopharyngitis, and then the alphalgia is seen. Coming to the glyphosate side effects, major side effect is genital urinary infection, fracture has been reported with empagliflozin, hypovolemia, electrode imbalance. My extensive use of SGLT inhibitor, that is glyphosate, if patient gets genital urinary infection in the first month, you have to stop it. After first month, the patient is unlikely to get the genital urinary infection. Now coming to the RSS ADA 2023, you can see here SGLT inhibitor is used as a first line drug in the cardiovascular, advanced cardiovascular disease, heart failure and renal failure, and for maintenance of weight and metformin is used. Now coming to the main part of my talk, practical approaches. What are the practical approaches in our clinic? So high risk patients are there, high risk type 2 diabetes are there with the advanced cardiovascular disease. What is the first line of treatment? Prefer GLP-1 receptor agonist. Then type 2 patients are there with the chronic kidney disease, with the heart failure, whether preserved or reduced ejection fraction, always prefer the SGLT inhibitors. Now coming to the hypoglycemia is the problem in our clinic. Hypoglycemia and type 2 diabetes in lean and elderly patient without any comorbidities. The first line treatment is DPP-4 inhibitors. Then hypoglycemia is the problem in overweight and obese patient. The SGLT inhibitor is the first drug of choice. Then hypoglycemia is in patient with CV comorbidities. SGLT inhibitors definitely is the first line of treatment. Now coming to the weight loss, patient type 2 diabetes. I told you more than half of the type 2 patients, diabetic patients are obese. So weight loss is the primary. Primary goal is to reduce the weight loss. GLP-1 receptor agonist like semaglutide, liraglutide, and followed by also you can use the SGLT inhibitor where there is a weight loss of 3 to 5 kg of using the SGLT inhibitors. Then primary goal is to keep the weight neutral. SGLT inhibitors is the preferred first line drug of therapy. Then primary goal, long-term compliance is there, safety is there, weight neutrality is there. DP4 inhibitors is the first line drug. Financial concern, most important in our country. Explain the patient of newer drugs in cardiovascular risk factor. Choose the most economic form and start the treatment. When there is a low cardiovascular risk, new generation sulfonylurea, glimepiride, metformin can be used. If the HbA1c more than 10, sulfonylurea can be used with insulin, or you can use all three classes of drug, that is a metformin, SGLT inhibitor, DP4 inhibitor in single pill. This combination of three drugs have got different, from the each class have different action in on different organs. They can be used as a single pill where the adherence is more, drug pill is less, pill burden is less, and cost effective also. So when there is a type 2 diabetes with albuminuria, what is the no firm recommendations are seen to reduce the albuminuria, but still glycemic control, tight glycemic control, and it is one of the important important treatment to prevent the albuminuria. Of course, SGLT inhibitor has been shown to give the reduce the albuminuria. Now coming to the type 2 diabetes, how to prevent the diabetic retinopathy? Again, glycemic control, intensive therapy in steno trial has been shown to reduce the risk of retinopathy by about 60% in type 2 diabetes with medical assessment unit. Now coming to the cerebrovascular disease, type 2 patients with stroke. So what are the drugs used there if the patient land up with a stroke? Same drugs with where the cardiovascular disease to be used, same drugs can be used here. But remember one thing, sulfonylurea and glutenides, that is ripaglinate should not be used. It causes hypoglycemia, leads to the cerebral ischemia. Then patient type 2 diabetes with liver function, chronic liver disease, cirrhosis of liver. Cirrhosis of liver. Insulin is still the preferred treatment for patient with the liver dysfunction. Then type 2 patient are hospitalized for other reasons, for operations, for our treating patient. In patients, you can use temporarily use of soluble insulin. At the time of discharge, switch over to the oral hypoglycemic agents. Then coming to the anti-diabetic therapy in pregnancy, due to efficacy and safety concerns, the ADN DIPSI does not recommend oral hypoglycemic agents in gestational diabetes and pre-existing diabetes. So insulin still it is a gold standard treatment in pregnancy. Now coming to the summary. So summary, glycemic targets must be individualized. This is very important. Then comprehensive evaluation at first visit is very important. And then of course diet. Next slide, please. Diet, exercise, education, they are the main therapy of type 2 diabetes. All treatment should be, decision should be taken patient values, preferences, that is a patient-centered important, and comprehensive cardiovascular risk reduction is very important. Unless contraindicated, till today, metformin remains the first optimal line of treatment. There are various drugs, metformin, SGLT, GLP inhibitors can be a better option in high-risk patients. Try to minimize the side effects. And take-home message is that diabetic is a progressive metabolic disease. Unless and until treated, patient land up with the microvascular and macrovascular complication. So tight intensive therapy to prevent the microvascular and macrovascular complication and to give the legacy effect in the long term. And then HbA1c, all the guidelines show HbA1c should be less than 7. And there are various class of diabetic medication like metformin, SGLT inhibitor, GLP receptor agonist, DP4 inhibitors, glitazone, sulfonylurea, insulin. But treatment part, always remember, it is a stepwise pattern with the aim of reaching glycemic targets. Thank you.
Thank you so much, sir, for sharing with us your knowledge and experience. It was an amazing presentation. We are honored to hear from you, sir. Can we have a big round of applause for Dr. Sanjeev Talpalika, sir? I thank our chairpersons for chairing the session. Can we have a big round of applause for the honorary chairpersons, please? Moving on to our next session on seizure disorders in children by Dr. Arundhati Patil, Professor, Department of Pediatrics, MRMC, Pediatrics Neurologist. I welcome upon stage our dignified chairpersons, Dr. S.M. Patil, sir, Senior Pediatrician, Dr. Burali, sir, Senior Pediatrician, Dr. Rajendra Jadhav, Senior Pediatrician,
Yeah. It's a slide changing pointer. I've been told about that. Yeah. Yeah, I have very little text, only videos. Yeah. You guys need to ring the bell loudly. Because some people are selectively deaf. You won't have to apply that to me though. We'll ring the bell loudly. Yeah.
ಹುಡುಗರ ಕಚೇರಿ ಇಂಟ್ರಡಕ್ಷನ್ ಸುಮ್ಮನೆ 4 ವರ್ಡ್ ಹೇಳ್ತೀನಿ ನಿಮ್ದು ಬಂತ ಹಲೋ ಗುಡ್ ಈವ್ನಿಂಗ್ ಎವ್ರಿಬಡಿ ಡಾಕ್ಟರ್ ಅರುಂಧತಿ ಪಾಟೀಲ್ She is a well-known pediatrician in Gulbarga. She is MBBS, MD, and fellowship in the pediatric neurology. And now she is working as the professor and head department of the MR Medical College, director of the children at the adolescent neuro care in Gulbarga. The area of interest is epilepsy and the neurometabolic disorder preventing the neurology. She is now the almost all the as the time is very short. She is very interested in the pediatric neurology, and now she is for the talk. Thank you very much.
Thank you very much, sir. Thank you very much, sir, for that kind introduction. I am fully aware that as a speaker, it is my responsibility to stick to the time. Without outraging anyone's modesty, I would go with the British saying which says that a good talk needs to be like a woman's skirt. It should be long enough to cover her modesty, but short enough to evoke interest. So this topic today, I promise there are no much text at all. In fact, only the first slide has some text. The rest is all case-based scenarios. And I did not want to go into the nitty-gritty of seizures in children as to the classification of seizures and the theory part of it. I just want to strike a chord with people dealing with children with seizures because it's such a common thing. Almost 40% of any critical care unit deals with seizures in children. And it is important that we diagnose seizures and neither overtreat them nor undertreat them. So next slide, please. This is not working. Yeah. So there are some existential differences between seizures in children versus seizures in adults in terms of being having a unique entity called febrile seizures, which is not qualifying for epilepsy. So they generally don't require much except in certain exceptional situations. The occurrence of birth asphyxia and neonatal hypoglycemic brain injury in children is something which predisposes children to not only acute symptomatic seizures but also epilepsy later. And then we have other childhood specific seizures like self-limited epilepsies, reflex epilepsies like hot water epilepsy, photosensitive epilepsies, sound-sensitive epilepsies, sleep epilepsies, and then we have non-epileptic psychogenic events, very common in adolescent children. And then there is this looming problem of structural malformations, developmental epilepsies, and channelopathies. Right. Next slide, please. This is not working. I don't think I'll need this. So this is the first case. I'll just go through it quickly. We have a 2-year-old male who is born of 3rd-degree consanguineous marriage. He is developmentally normal, has unprovoked generalized tonic-clonic seizures since 6 months of age. They are infrequent, occur every 1 to 2 months. They've consulted multiple doctors, and the child is on multiple drugs, yet he has no relief. EEG is showing frontocentral sharp waves. So I have just highlighted the important stuff here. We must note that he is developmentally normal, and he is having apparently pharmacoresistant epilepsy. The point that I want to drive through the whole presentation is to say that nothing is going to substitute the time that we are giving to the patients in terms of history and physical examination. Any neurologist would agree and say that if there are 20 minutes for a neurological case, then 18 minutes is history and 2 minutes is examination. So this particular child, all the cases that I have presented today are all real cases that I have seen in my clinic. And this particular child was somebody who was going to multiple people, and then that's when we felt that, okay, all that the child needed was time. So in the history that is given, there are many things that need to be asked. The first thing I asked parents is at what time did the child have seizures? And consistently, every single time, the seizures occurred at around 4 to 5 a.m. in the morning. So that now brings down to at least 2 or 3 differential diagnoses. One, it is a sleep-triggered seizure, and sleep is a potent trigger for seizure. And second, what is the age of the child? Third, there is consanguinity. So, and the fourth point is, it is resistant to all the anti-epileptic drugs. Now, why would a normal child have resistance to anti-epileptic drugs? Of course, MRI was done and all other investigations were done. Everything was normal. So all we had to tell the parents is, can you go to your nearest health facility and get his blood sugar done when he has a seizure? And rightly so, they went to the nearest health facility, and each time, they had twice, and each time the blood glucose was anywhere between 28 to 34. And that is when we said, okay, this is not epilepsy, this is a metabolic disorder. And I got a genetic diagnosis done in this child. This child has GYS2 mutation, which is glycogen storage disease type 0. So this was possible. Now, the fact that we need a genetic test will only come only if I suspect that there's a metabolic disorder and not treat it as a simple epilepsy and keep loading him with anti-epileptic drugs. Case 2. We have a 6-year-old child, previously developmentally normal girl. She came with disturbed sleep and regression in speech milestones since the last 3 months. So they again, went to a psychiatrist first because the child was having altered behavior. She was shouting in sleep. And the mother noticed that this child is not like others. And apparently there was a death in the family. And these behavioral issues were, attributed to that death. So this was the girl. If you can just note her, yeah. There you go. There you go. There you go. So this girl is having subtle myoclonic jerks. So myoclonic jerks with regression. Go back to the history. Ask whether she had measles in her childhood. And 2, did she have vaccination for measles? The answer for the first question was yes, she had measles at 9 months of age. 2, vaccination, no, she was not vaccinated. So this is subacute sclerosing panencephalitis unless proved otherwise. So this girl now goes for a CSF IgG, which was sent to NIMHANS, and she was strongly positive there were antibodies to measles antibodies, measles virus. So otherwise, what will happen is there's another differential diagnosis called autoimmune encephalitis, where also the stage 1 presents like this. Behavioral issues, sleep issues, altered sleep, cognitive. They end up with psychiatrists, they end up with adult neurologists, they end up with various people, and if we don't have an index of suspicion, then the child will be losing a lot of time. I know that there's nothing much that can be done here, but if it is autoimmune encephalitis, then there's a lot we can do if we catch them early. The third case is a 6-month-old male baby born to non-consanguineous parentage, came with complaints of fever followed by abnormal movements, which did not subside with multiple AEDs. So I got a call from one of the ICUs. And you can see that the child is continuously having some random, rhythmic, jerky movements of his, especially the proximal joints, and also tongue thrusting. So this was a case of chorea, which followed fever, which became a trigger, and this child was born of consanguineous marriage, and this child had mitochondrial disorder. And any mitochondrial disorder, the child is apparently all right, or may have mild delayed milestones, and fever becomes a trigger because it imposes oxidative stress on the basal ganglia, and the child had basal ganglia lesions, and that caused these extrapyramidal movements. Case 4 is a 6-year-old developmentally normal boy, came with complaints of not concentrating in class and daydreaming often. So the teacher told that your son is like, yellow nodirtana, kanaskantana, hagalganskantana nimmaga. And that when it went for a long time, that is when we had the child here. So please note, yeah. Can we have volume for this? So if you can see, previously the child was, quite, with us. He was doing hyperventilation, he's blowing the paper, and then suddenly he becomes unresponsive and comes back to that. The very short. And this is happening about 100 times per day. And that is what happens in childhood absence seizures. So many people confuse absence seizures with complex partial seizures or focal seizures with impaired awareness. The problem is, if this is considered as complex partial seizures and you treat the child with carbamazepine or oxcarbazepine, that can induce an absent status. Whereas if it is confirm that it is absent seizures, as it is in this case. It's essentially a clinico electrophysiological diagnosis. You have a signature EEG pattern, which is 3 hertz spike and wave discharges. So again, when will I do a hyperventilation? Many of the generalized epilepsies triggered by hyperventilation, but absence is one epilepsy. By default, it will trigger once you do hyperventilation. So the difference between absent seizures and complex partial seizures is absent seizures occurs multiple times throughout the day, whereas complex partial seizures is about 1 or 2 times. The seizure burden clinically is very high in absent seizures, but the child has an abrupt onset and abrupt offset. So that is what differentiates, and ethosuximide is an amazing drug. It just melts like butter when you start ethosuximide. This is case 5, a 4-month-old male baby with history of birth asphyxia, brought with complaints of jerking of hands and feet, not responding to multiple AEDs. So if you can look, I'm just trying to maneuver his, checking the spasticity, moving, look at the left upper limb. And what I did was I restrained the left upper limb and it stopped. So the same thing happened in a very minor intensity in the left right upper limb. I cut short the videos to stick to the time. So this is just clonus. It is not a seizure episode at all. So we've had people treating this because parents are so worried. Muttid kudle kai nadaglik start ಮಾಡ್ತಾನ್ರಿ. So all that we hear is nadaglikatana. So it's a seizure. So start AED. Load them, load them, load them. In fact, I had a child who came to me with excessive drowsiness. I thought he was encephalopathic. I was thinking he has electrical status epilepticus, though he did not have any of the fever or encephalitis features. I just asked how many drugs you're giving. And I saw that the child is on 6 drugs for clonus. And the child was knocked off totally. All I had to do is take off the unnecessary drugs. Clonus is not going to be treated by anti-epileptic drugs. This is case 6. A 1-year-old male child was brought with lethargy, abnormal cry, and jerking of whole body continuously throughout the day. So you look at this child, he has got titubation, he has got fine tremors in his hand. If you can make a note, there is hyperpigmentation of the knuckles, there is hypopigmented hair. I'm sorry, I don't know why the audio is not playing, but this child had a very typical cry, which is called as the bleating goat sign. Any guesses about this child? So this is infantile tremor syndrome because of vitamin B12 deficiency. Again, this is not a seizure. The tremors are not seizures. And that bleating goat sound is just like as a bloat. When the child is crying because the laryngeal tremors, the child is cries like. When the child is crying, there is tremulousness, and that makes that bleating goat sign. So it's unmistakably infantile tremor syndrome and definitely not epilepsy. Case 7 is a 9-year-old girl came with complaints of falling down whenever she hears any sound. So I just clapped here, look at that. She just fell on her own. So this is sound-sensitive myoclonic jerk. This girl had neonatal hypoglycemic brain injury, and that was predisposing her to multiple seizure episodes. So these is a sound-sensitive jerks. They are reflex epilepsies. They don't have to be overloaded too much with anti-epileptic drugs. Not much can be done about that. But I'll tell you what we can do as a secondary prevention. Next slide, please. We've gone blank on that. The organizers need to cover up for this time and give me extra then. So I didn't put any text at all. It's just videos because I want people who are dealing with this to see these. Because seeing is believing. The next slide is actually on a 4-5-year-old kid. Very smart, very active, very bright. All that the parents said that, whenever you see this child upset, he'll just move his limbs and then he starts making this uprolling of hands. And then I called the child, asked them to get a video. Please insist for the video every time. Don't go by the history because it might be quite dramatic and parents might be overwhelmed. They may not able to do much justice to the description. They may not have noticed what has happened in the face. Are the eyes closed? Are the eyes open? A general thumb rule is if it is true epilepsy, eyes are generally open. Whereas if it is not epilepsy, if it's a non-epileptic psychogenic event, the eyes are generally closed. Of course, there's never and always and never in medicine, but this is a general thumb rule. So that is what we need to note. And this child was actually a child who had a lot of sibling rivalry and was catching attention. Imagine a 4 to 5-year-old kid. So child psychology is very complex. You can have even a 4 to 5-year-old kid, and then you did a lot of counseling, and then they came back. I said, stop all drugs, talk to your kid, spend time with him, see that he's included in family decisions, make a truce between the two brothers, and then all the so-called epilepsy disappeared. So anyways, I will close my presentation here. I had a last slide which had a child with Lennox-Gastaut syndrome who used to fall repeatedly, and she started having injuries on her face, and there was middle cranial fossa fracture that caused her raccoon eyes. So one hack that I just started recently is I ordered some soft helmets from the Amazon, and asked the parents to get these helmets to prevent head injury. So these are secondary things that we can do, especially in children who have got very catastrophic myoclonic epilepsy. So at the end of the day, I close my talk. At the end of the talk, I would only have to say that please give time to parents. Please insist for home videos if possible, with full lighting and full face. And then please seek consultation from your pediatric neurologist. I, for one, feel if pediatric neurologist more than 40 patients or 50 patients per day, then he is doing absolute injustice to patients. It is impossible to go through every detail and do justice to the patient. And it is only time that can treat, a time and the brain to act. Thank you so much for your patient hearing.
Hello, 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 hello.
Hello, hello, hello,
Thank you so much, ma'am,
hello.
for your wonderful session. We've learned a lot from it. We were honored to hear from you, ma'am. Can we have a big round of applause for Dr. Arundhati Patil, ma'am, again? I thank our honorable chairpersons for their presence. Please give them a big hand. I request our honorary delegates, please collect your certificates and mementos from the selfie point. Moving on to our next session on management of snake bite and stings, I welcome upon stage our dignified chairpersons, Dr. V.R. Sidri sir, Dr. Prashant Patil sir, Associate Professor, Department of Medicine, Dr. Sachin Gudge sir, Associate Professor, Department of Medicine. I welcome upon stage our honorary speaker for this session, Dr. Dilip Punde sir, Senior Consultant Physician. Can we have a big hand, please?
Madam, I need that.
Yes, point. I will get
I want to show more slides. There is a lot of echo.
Yes, sir. You can have this, so you can adjust the
But I will have to move that pointer.
pointer. I'll get you the pointer, sir. Yes, sir.
Hello, hello, check.
Backward. Yes, sir. Forward, backward.
Hello. I thank Bidar IMA for conducting this conference successfully, 89th MEDICON 2023 in Bidar. I also thank Dr. Dilip Punde sir, who has all the way come from Muket district, Nanded, for a talk on snake bite and other stings. Sir's special interest is toxinology. Sir is a physician. He is included in the roster of experts for snake bite and venoming by WHO 2021. Sir is a member of National Standard Treatment Guidelines Committee of India for snake bites. Sir, he runs his own hospital, Punde Hospital in Muket district. It is a center for ICMR also. Sir has managed till now 8,000 bite cases from 1988 till today. He has spoken in many national and international conferences, and the snake bite mortality in this area around Nanded and this Maharashtra and Karnataka border is around 25%. It is reduced to less than 1% by now. And Sir's mission is a zero mortality mission. And Sir has presented 7 publications and many awards in his account. And as I told, Punde Hospital is a center for Indian Council of Medical Research. And I welcome Punde sir to give his talk on snake bites and stings. Thank you, sir.
Respected chairperson and co-chairman, I salute land of Karnataka. I am grateful to Dr. Mallikarjun and his team. After passing MD, I am working in rural pocket of Maharashtra since last 36 years. I treat patients of Maharashtra, Telangana and Karnataka. This is a map of snake bite affected. There are 2.7 cases of snake bite in India, and we lose 81,000 to 1.38 thousand deaths. Could be more. This is my hospital. This is a one-man institute. I work alone. Snakes are worshipped like anything in India. I will not talk. There are a lot of stunts. Then why more snake bite is high? Because occurrence of big four, poverty, living to poor living conditions, and farming is a main occupation. So the risk is 24 into 7 into 365. Sound is clear? This is a living pattern. Then why there should not be high incidence of snake bite? You can see housing, barefoot, farming pattern. So problem is we lose more than 1 lakh. This could be a tip of iceberg. Big four: cobra, crate, Russell, saw-scaled viper. Big 8, it includes king cobra, syndicate, pit viper. I think some part of Karnataka there is a king cobra. These are the big four: cobra, crate, Russell viper and saw-scaled viper. This is a big 8. One should be aware of non-venomous snakes. People give ASV to non-venomous bites. You can see these are found in our area. Just lower slide, you can see this is a common crate, 10 times dangerous than cobra, and that is a common wolf. This is a highly poisonous, that is non-poisonous. Lot of medical officers, they pour ASV to that common wolf snake. Diagnosis of snake bite, time and place of bite, history is important, activity at the time of bite, examination of bite site, identification whether patient has brought kills, snake, photograph, and systemic exam. There can be 2 marks with edema, 2 marks, other marks without edema, 1 mark with edema, abrasion, 2 abrasions. There may not be bite mark. This is a venomous. Multiple marks. You can see all these. This is not a rule of thumb, but this indicates towards the direction. But many times snake is not brought. Syndromic approach. Local envenoming with bleeding, clotting, all vipers. Syndrome 2, local envenoming with bleeding, clotting, shock. There could be ptosis. This is a Russell viper, mainly in South India. Syndrome 3 is local envenoming, very fast, cobra. Syndrome 4, minimal or no local signs, abdominal pain, sleeping on ground, crate. And then 5 is regarding paralysis with dark brown urine, could be Russell Viper bite. I will not go in the detail, but the neurotoxic, cobra is a postsynaptic and crate is a presynaptic. There is the block. Always remember neurotoxic bite, 5 Ds, dyspnea, dysphonia, dysarthria, diplopia, dysphagia, and 2 Ps, ptosis and paralysis. That is a descending paralysis. 5 Ds and 2 Ps. Venom is a cocktail. You can see this lady had a cobra bite, simply saved on ambu bag in around 90. With ambu bag, you can save the life. Single bite mark, you can see. There was a rapid envenoming. 2 marks, necrosis, massive necrosis. This child was saved with ventilator. This is a crate, postsynaptic, presynaptic block. There is a destruction of the receptors and there is a locked-in syndrome. Locked-in syndrome, patient is totally locked. Usually occurs in crate, but can be seen in cobra bite. Early morning, in your OPD, patient comes with abdominal pain and he tries to move his eyelids, suspect snake bite. This is a classical neuroparalytic syndrome. This is a consumption coagulopathy because of disturbed coagulation cascade is a mechanism in Russell Viper bite. You can see Russell Viper bite, bleeding, rapid edema, nausea, vomiting, shock, intracranial bleed, signs of neuroparesis, multi-organ failure. There is a typical V, you can see the Russell Viper. This is somewhat less venomous edema, but there can be bleeding. How primary management, how the shift to patient. Motorcycle, patient should be in the center. If he develops neuroparalysis, he will make an accident. If you want to apply a tourniquet, apply like for a fracture. I will not go in the details of this. Multiple tourniquets, wrong method. These second, they have amputated their finger. Snakes were non-venomous and they lost the fingers. This lower slide, this man did the mouth suction after cobra bite. It is possible only on Bollywood. It should not be applied in reality. Tourniquet should not be released immediately after bite. Otherwise, there will be a gush of venom and patient will have a cardiorespiratory arrest. Very minimum investigations are required at Taluka place, even at PSC. You can see the investigations. This is a simple test, 20-minute whole blood clotting test. Take a blood in new test tube, wait for 20 minutes, after that reverse it. If clotted, rules out consumption coagulopathy. If not clotted, vasculotoxic snake bite. ASV indicated rapid progressive swelling, swelling more than one joint, local bleeding, necrosis, tender lymph nodes. Then systemic signs, neuroparesis, cardiovascular abnormalities, bleeding, abdominal pain, incoagulable blood, then change in PT, APTT. These are the indications. No absolute contraindication. Unless and until adrenaline is with you, don't touch the patient. We are treating 0.25 cc subacute adrenaline prophylactically. That has reduced the incidence of snake bite. ASV will neutralize only circulating venom. It will not neutralize a necrotic action or it will not reverse the renal failure. It will not reverse the presynaptic block. Cobra bite, 10 vials stat. Further 10 vials in 1 hour. 20 vials for cobra, 20 vials per crate. Russell Viper, 10 vials stat. After 1 hour 10, maximum 30 vials. SAW scale 4 to 6. When vasculotoxic is not identified, give 10 vials. If reaction comes, treat with adrenaline. There can be pyrogenic reactions. Lot of doctors, they won't touch the patient because of fear of reaction. Neuroparalysis, atropine neostigmine. Proud to say that neostigmine is a discovery by Indian anesthetist in cobra bite. Rapid response. We are treating with now this intubations. Initially, I used to treat patients with ambu bag. Fixed dilated pupil in snake bite is not a sign of brain death. It is a sign of envenoming. I have seen neurophysicians declared to be brain dead. You can see 6 days ventilation, comatose, fixed dilated pupil. Patient came after 5-6 days. Occult snake bite. Calcium gluconate is nowadays used. It enhances presynaptic receptor regeneration, cause the shock, hypovolemia, anaphylaxis, septic, cardiogenic. You can see this boy had a Russell Viper bite on the toe. Bites on toes and fingers should be taken very seriously. Within 2 to 3 minutes, he had a cardiac arrest. It was a fibrillation. He was treated, resuscitated. This can happen on fingers and toes. This 55-year male was brought with snake bite, coagulopathy. He had a reaction, treated with adrenaline. After that, he developed a massive infarction. Not possible to thrombolize. No cardiologist was ready to touch. So, AMI can be the complication. This lady, non-venomous bite, developed acute myocardial infarction. Fear releases massive catecholamines. So, admit every bite at least for 24 hours. This is a non-venomous bite with AMI. Recently, this crate bite girl had a torsade. You can see the torsade. We managed with Maxelf. So I will not go in the details. This is for consumption coagulopathy. There can be AKI managed as per the protocol. FAD for renal shutdown, hypokalemia, calcium gluconate, insulin, dextrose, hypokalemia with potassium. See the massive edema. See for compartment syndrome, Russell Viper bite. Capillary leak is the most dangerous, 85% mortality. Patient will have Viper head sign, periorbital edema, hypotension. You can see this is a case of capillary leak. Russell Viper bite, hematuria, puffy face, pleural effusion. These are the surgical complications, gangrene. This lady, extensive necrosis. You can see this is a cobra bite. Again, necrosis, contractures, hypertension after crate bite, memory loss, pituitary, hypopituitarism, neuropathy. We published this case. Russell Viper bite at the age of 13. She got married and was evaluated for infertility. She had empty cellular syndrome. Good case. This man had a wild honeybee sting bite. This is a triple trouble. While running, he had a Russell Viper bite. He was brought to us. He had a coagulopathy. We gave ASV. He had a massive anaphylaxis. Honeybee, Viper bite, and ASV anaphylaxis. He recovered completely. This is a, just 2 minutes, sir. The lady was declared dead by the relatives. She had all complications, was resuscitated. Child had a snake bite in front of doctor in Anganwadi. Medicine is a thrill, energy, enthusiasm. Is a festival of saving lives. Boy had intracranial hemorrhage. All these are the pregnant ladies. They were followed. They had a snake bite. They were followed till delivery. Literature says 40% fetal and 10% maternal loss. At a rural setup, we have not lost a single mother and fetus. Second line, that child, mother had cobra bite, second day delivered. Child is, I named this child as a Nagesh. One day picture, 9 snake bites, venomous. This is our respiratory journey. Eldest and youngest patient. Man was referred as an infection. I told snake bite. They searched on, they brought a cobra. I told this is not a cobra. Again they went back from same room. They bought a crate. Cobra this side, crate this side, family inside. Still we say, Mera Bharat Mahan. Black cobras are very dangerous. CPR, don't be hasty to declare death. This is a mother of one medical representative. She was saved with CPR and everything. Yesterday you had a BLS session. Oh, just a minute, sir. I think that video has to be completed. Why it is not moving? Please see. This man was declared dead and funeral. People were ready for funeral. Somebody saw that he had some breath. 52 hours mechanical ventilator. We celebrated Raksha Bandhan in hospital. I saved this child with simple urinary catheter. This man initially came with a cobra bite, had a massive reaction. After 1 year, same fellow came with viper bite. Again, after 3 to 4 years, he came with saw-scaled viper bite. You can see. I hope he will not come with a great bite now. Madam, problem is with this. Last, just a minute, sir. Actually, time was given, told to be 30 minutes, but now it is cut into 20. This boy had a great bite, declared by parents as a dead. He was saved with ambu bag. I had been to his marriage. He has kept my photo in his Devghar. I told, up to Namaskar, it's okay. Don't garland. Because miles too, before I sleep. See the gratitude of a poor man. I know that I am in a rural setup, hence my pocket is empty, but heart is full of feelings. All 9 cases. Incidentally, it was my birthday. Vertex bite, oral cavity bite, wrap the neck, genitalia bite, cut cobra. You can see all ladies had a bite on 4. They cut by right hand, they catch by snake into snake. Great. So future direction, last 2 to 3 slides. Use of nanotechnology, more purified venom, monoclonal antibodies, specific channel blockers, VD case. Just 10 days back, I attended a national conclave, health education, gumboot, we are distributing to farmers. Just you can see, आदमी में जहर इतना भर गया है कि विषधरों का वंश सारा डर गया है. एक दिन तुम जरूर सुनोगे कि आदमी के काटने से सांप कोई मर गया है. Man is more lethal than snake. This is a mule donated this much blood. This is साथी हाथ बढ़ाना, मिलकर बोझ उठाना. A for awareness, basic life support, clinical assessment, counseling. D for development, E for education, first aid. This is, you can see, this is Oxford. I spoke there. President of Nepal was there. And I will close here. Thank you. I know that I have taken 1 or 2 minutes more. So the second topic I will not cover, that is stings, but this is the gross outline of snake bite. I am really grateful to organizers. Thank you.
Thank you so much, sir, for such a detailed session. We surely enjoyed it while learning. It was wonderful to have you on stage, sir. Can we have a big hand for him?
On behalf of IMA Karnataka State Branch, I thank Dr. Punde sir for a wonderful speech. I'm a great fan of you, sir. 5, 6 years back, you had given a lecture
Yes.
at BRIMS.
Here
at that
only.
time, we had attended your lecture, and that from that day, we had lot of inspiration from you for saving snake bites. I learned lot from you, sir. And just to add, still in our area, we get cases where we are getting a case after 48 hours after the bite, after 3 days after the bite. They just try with local treatment like applying the cow dung and just doing some mantra tantras and not making the patient to sleep, keeping him awake whole night. So these are the some myths about the snake bite still followed, because 2 days back we had a bite patient. He had came 3 days after the bite with swollen limb, and 1 week back patient, they just as you told, it's a crate bite. They just she was lying, she had slept on the floor and just brought that she is having pain abdomen. Slowly she developed ptosis. At that time it's very difficult without any bite mark. At that time it's very difficult for us to convince to the attendants that this is snake bite, sir.
My
This thing.
request to you all, please treat snake bite. Our mission is teach one, each one, save the savior, and mission zero mortality. Who is going to treat poor farmers of the country? So appeal, please treat snake bite.
So just to ask you, sir, that how in rural areas, with your experience, how we can spread awareness about snake bite to all the places in our country, so that we can have zero mortality of snake bite cases.
We are doing mass awareness campaign in regional languages. One thing, we show our photographs. You can use festivals, Ganpati festival, Durga festival, birthday programs. People, lot of roads are loaded with this, you can say, posters. We ask every gram panchayat to have one poster. Teach one, each one. Every time, for every patient at the time of discharge, I present gumboot. Gumboot will definitely prevent a life.
Thank you, sir.
Thank you.
One point I want to add to Dr. Punde's. Punde has really, in detail, he has covered. In our factory, a lot of snakes are there in Hubli. I am working for one company by name BDK Walls. For that prevention, our technical man, he suggested that snake catching pole, that he online he got it, and anytime he finds the snake and all, he will catch it with that and will leave it to the forest. I think that's a very good idea. You can just get that snake catching pole online, it is available. Thank you.
Sir, snake rescuers are not available in rural pocket. That is very dangerous.
Sir, many times we have seen 2-3 children died on the same day, early morning.
Great.
They'll come on one child with gasping, and that time they ask, sir, like, there is no bite mark, there is no snake found in the bed, in the vicinity. I slept on the top, on the bench. But how can you be sure that it is snake bite? They're asking, I cannot prove in history, I cannot prove by investigation. Is there any way to convince them?
Early morning, sleep on ground, and typical neuroparalytic syndrome is a crate. One observation, crates are many times found in houses. Crate is the only snake who eats another snake. I have shown one slide, snake into snake. Ask the relatives to search. Many times you will get the crate. If any query, we'll meet at the time of lunch. I hurriedly tried to give a broad outline. Thanks to organizers again. Thank you.
Thank you so much, sir. It was wonderful to have you on stage. I thank our honorable chairpersons for their presence. Please give them a big hand. It is now time to begin with the first oration of the day, the very awaited and prestigious session for the day, Indian Medical Association, Karnataka State Branch, Professor Nanjundaya Memorial Association oration. ವೈದ್ಯರ ಹಿತಶಕ್ತಿಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಬದ್ಧ. I welcome upon stage our honorary chairpersons, Dr. Shiv Kumar Lakkol, President Indian Medical Association Karnataka State Branch, Dr. Srinivasa S, incoming President Indian Medical Association Karnataka State Branch, Dr. Chiniwala VV, President-elect IMA-KSB. It gives me immense pleasure to invite upon stage our orator, Dr. Karveer Prabhu Kyalkonda, MSDTH RTD, District Sergeant Badami. Please give him a big round of applause.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಡಾಕ್ಟರ್ ಕರವೀರ ಪ್ರಭು ಕ್ಯಾಲಕೊಂಡ ಇವರ ಕಿರುಪರಿಚಯ. ಇವರು ಬಾದಾಮಿ ತಾಲೂಕು ಹಂಗರಗಿ ಗ್ರಾಮದಲ್ಲಿ ದಿನಾಂಕ 1/6/1956 ಜನಿಸಿದ ಡಾಕ್ಟರ್ ಕರವೀರ ಪ್ರಭು ಕ್ಯಾಲಕೊಂಡ ಇವರು ಸರ್ಕಾರಿ ವೈದ್ಯಕೀಯ ಮಹಾವಿದ್ಯಾಲಯ ಬಳ್ಳಾರಿಯಿಂದ MBBS ಪದವಿ, ನಂತರ MS ಜನರಲ್ ಸರ್ಜರಿ ಮತ್ತು DCH ಪದವಿಗಳನ್ನು ಪಡೆದಿದ್ದಾರೆ. ಶಾಲಾ ದಿನಗಳಲ್ಲಿ ಪ್ರತಿಭಾವಂತ ವಿದ್ಯಾರ್ಥಿಯಾಗಿದ್ದ ಇವರಿಗೆ ಡಾರ್ಲಿಂಗ್ ಕವನಕ್ಕೆ ಸಂಕರ್ಷ ವೀಕ್ಲಿ ಏರ್ಪಡಿಸಿದ್ದ ಸ್ಪರ್ಧೆಯಲ್ಲಿ ರಾಷ್ಟ್ರಪತಿ ಚಿನ್ನದ ಪದಕ ಸಿಕ್ಕಿದೆ. ಅನಾಟಮಿ, ಜನರಲ್ ಸರ್ಜರಿ, ಜನರಲ್ ಮೆಡಿಸಿನ್ ವಿಷಯದಲ್ಲಿ ಕರ್ನಾಟಕ ವಿಶ್ವವಿದ್ಯಾಲಯ ಧಾರವಾಡ ಚಿನ್ನದ ಪದಕ. 5 ವರ್ಷ ನಿರಂತರ ಬೆಸ್ಟ್ ICDS ಮೆಡಿಕಲ್ ಆಫೀಸರ್ಸ್ ಆಫ್ ದಿ ಸ್ಟೇಟ್ ಪ್ರಶಸ್ತಿ. 1989ರಲ್ಲಿ ಬೆಸ್ಟ್ IMA ಕಾರ್ಯದರ್ಶಿ ಪ್ರಶಸ್ತಿ, IMAಯ ಫೋಕಸ್ ಸಂಪಾದಕ ಮತ್ತು ಬೆಸ್ಟ್ ಬುಲೆಟಿನ್ ರಾಷ್ಟ್ರೀಯ ಪ್ರಶಸ್ತಿ, IMA, KMG ಹಾಗೂ ಬೆಸ್ಟ್ ಬುಲೆಟಿನ್ ರಾಷ್ಟ್ರ ಪ್ರಶಸ್ತಿಯ ಭಾಜನರಾಗಿದ್ದ ಇವರು ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ IMAಯ ಸೀನಿಯರ್ ಉಪಾಧ್ಯಕ್ಷರಾಗಿ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿದ್ದಾರೆ. ವೈದ್ಯಶ್ರೀ, ವೈದ್ಯಭೂಷಣ ಪ್ರಶಸ್ತಿಗಳಿಗೆ ಭಾಜನ ಹಾಗೂ ಲೆಪ್ರೋಸ್ಕೋಪಿಕ್ಸ್ ಸ್ಟೆರಿಲೈಸೇಷನ್ಗೆ 1,75,000 ದಾಖಲೆಯ ಶಸ್ತ್ರಚಿಕಿತ್ಸೆ ಮಾಡಿದ ಸಾಧನೆ ಇವರಿಗೆ ವಿಶೇಷ ಪ್ರಶಸ್ತಿ ಸಿಕ್ಕಿದೆ. ಇಲ್ಲಿಯವರೆಗೆ 68 ಪುಸ್ತಕಗಳನ್ನು ಪ್ರಕಟಗೊಂಡಿವೆ. ಕನ್ನಡ ಸಾಹಿತ್ಯ ಪರಿಷತ್ತಿನ ಕಾವ್ಯ ಪ್ರಶಸ್ತಿ, ಸಾಹಿತ್ಯ ಪರಿಷತ್ತಿನ ದತ್ತಿ ಪ್ರಶಸ್ತಿ 3 ಬಾರಿ, ಕುವೆಂಪು ವೈದ್ಯ ಸಾಹಿತ್ಯ ಪ್ರಶಸ್ತಿ 2 ಬಾರಿ, ಮಕ್ಕಳ ಮಂಟಪ ಬನಹಟ್ಟಿ ಸಾಹಿತ್ಯ ಪ್ರಶಸ್ತಿ, ಕರ್ನಾಟಕ ರಾಜ್ಯ IMA ಶಾಖೆಯಿಂದ ಶ್ರೇಷ್ಠ ವೈದ್ಯ ಸಾಹಿತ್ಯ ಪ್ರಶಸ್ತಿ, ಬಸವಜ್ಯೋತಿ ರಾಜ್ಯ ಪ್ರಶಸ್ತಿ, 2008ರಲ್ಲಿ ಅತ್ಯುತ್ತಮ ನಾಗರಿಕ ಸೇವಾ ರಾಜ್ಯ ಪ್ರಶಸ್ತಿ. ಹೀಗೆ ಹಲವಾರು ಪ್ರಶಸ್ತಿಗಳು ಇವರಿಗೆ ಮುಡಿಗೇರಿವೆ. ಇಂತಹ ಸಾಧಕ ವೈದ್ಯರು ಇಂದು ನಮ್ಮ ಮುಂದೆ ಪ್ರತಿಷ್ಠಿತ ಡಾಕ್ಟರ್ ನಂಜುಂಡಯ್ಯ ಸ್ಮರಣಾರ್ಥ ವೈದ್ಯರ ಹಿತಾಸಕ್ತಿಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಬದ್ಧ ಎನ್ನುವ ವಿಷಯದ ಬಗ್ಗೆ ಉಪನ್ಯಾಸವನ್ನು ನೀಡಲಿದ್ದಾರೆ. ಇವರಿಗೆ ಹಾರ್ದಿಕವಾಗಿ ಸ್ವಾಗತವನ್ನು ಮಾಡುತ್ತಾ ಡಾಕ್ಟರ್ ಕರವೀರ ಪ್ರಭು ಕ್ಯಾಲಗೊಂಡ್ರವರು ತಮ್ಮ ಉಪನ್ಯಾಸವನ್ನು ನೀಡಬೇಕಾಗಿ ಕೇಳಿಕೊಳ್ಳುತ್ತಿದ್ದೇವೆ.
ಉಪನ್ಯಾಸ ನೀಡಲು ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಂತಹ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಗೂ ಹಾಗೂ ಬೀದರ್ನ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘಕ್ಕೂ ನಾನು ಯಾವತ್ತೂ ಋಣಿಯಾಗಿ ನನ್ನ ಉಪನ್ಯಾಸವನ್ನು ಪ್ರಾರಂಭ ಮಾಡುತ್ತೇನೆ. ಕರ್ನಾಟಕ ಎಂದು ನಾಮಕರಣ ಮಾಡಿ 50 ವರ್ಷವಾಯಿತು. ಈ ಸಂಭ್ರಮದ ಸಂಕ್ರಾಂತಿ ಅವಧಿಯಲ್ಲಿ ನಾನು ಕನ್ನಡದಲ್ಲೇ ಉಪನ್ಯಾಸ ಕೊಡಬೇಕು ಅಂತ ತಿಳ್ಕೊಂಡು ವಿಚಾರ ಮಾಡಿದೆ. ಅದಕ್ಕೆ ಹಲವಾರು ನನ್ನ ಮಿತ್ರರು ಮಧುಸೂದನ ಕಾರಿಂಗ್ನೂರವರು, ಯೋಗಾನಂದ ರೆಡ್ಡಿ ಅವರು ಮತ್ತು ಲಕ್ಕೋಳ್ ಅವರು ಪ್ರೋತ್ಸಾಹ ನೀಡಿದ್ದಕ್ಕಾಗಿ ಈ ಒಂದು ಪ್ರಯತ್ನವನ್ನು ಮಾಡ್ತಾ ಇದ್ದೇನೆ. ವೈದ್ಯರ ಹಿತಾಸಕ್ತಿಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಬದ್ಧ ಅನ್ನುವ ವಿಷಯವಾಗಿ ಪ್ರೊಫೆಸರ್ ಡಾಕ್ಟರ್ ನಂಜುಂಡಯ್ಯ ಸ್ಮರಣಾರ್ಥ ಸಂಘದ ಉಪನ್ಯಾಸ ಪ್ರೊಫೆಸರ್ ಡಾಕ್ಟರ್ ನಂಜುಂಡಯ್ಯನವರು ಆಗಸ್ಟ್ 1941ರಂದು ಆಗಸ್ಟ್ 12, 1941ರಂದು ಮೈಸೂರು ಜಿಲ್ಲೆಯ ಟಿ ನರಸೀಪುರ ತಾಲೂಕಿನ ಮೂಡಿಗೆರೆ ಹಳ್ಳಿಯಲ್ಲಿ ಜನಿಸಿದರು. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ದಿಗ್ಗಜ, ಅಪ್ರತಿಮ ಪ್ರತಿಭಾವಂತ ವೈದ್ಯ, ಸಂಘಟನಾ ಚತುರ, ಮುಂದಾಲೋಚನೆಯುಳ್ಳ ಕನಸುಗಾರ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಉತ್ತರೋತ್ತರ ಬೆಳವಣಿಗೆಗೆ ಮತ್ತು ವಿಕಾಸಕ್ಕೆ ಸೇವೆಯನ್ನು ಮುಡುಪಾಗಿಟ್ಟಂತಹ ಮುತ್ಸದ್ದಿ ಟೈಗರ್ ನಂಜುಂಡಯ್ಯ ಎಂದೇ ಖ್ಯಾತರಾದವರು. ಮನೆ ಪಾಠ ಹೇಳಿ ತಮ್ಮ ಶಿಕ್ಷಣ ಖರ್ಚು ವೆಚ್ಚಗಳನ್ನು ನಿಭಾಯಿಸಿ ಸ್ವಂತ ಕಾಲ ಮೇಲೆ ಹೇಗೆ ನಿಲ್ಲಬೇಕು ಎಂಬುದನ್ನು ತೋರಿಸಿಕೊಟ್ಟಂತಹ ದಿಗ್ಗಜ. ಹೀಗಾಗಿ ಅವರು ನಮಗೆಲ್ಲ ಆದರ್ಶಪ್ರಾಯರು ಮತ್ತು ಅನುಕರಣೀಯರು. ಬೆಳೆಸಿರಿ ಮೊಳಕೆಯಲ್ಲೇ ಎಂಬಂತೆ ವಿದ್ಯಾರ್ಥಿಯಾಗಿದ್ದಾಗಲೇ ನಾಯಕತ್ವದ ಗುಣವನ್ನು ಹೊಂದಿದ್ದರು. ಹಾಗೆ ನಡೆದುಕೊಂಡರೂ ಕೂಡ ವಿದ್ಯಾರ್ಥಿಯಾಗಿದ್ದಾಗಲೇ ಅವರು 10 ಬಡ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಆಶ್ರಯದಾತರಾಗಿದ್ದರು. ಅವರು ವೈದ್ಯಕೀಯ ವಿಶ್ವವಿದ್ಯಾಲಯದ ಸಂಸ್ಥಾಪಕ ಸದಸ್ಯರಾಗಿ ಡಾಕ್ಟರ್ ನರ್ಸಿಂಗ್ ಬಾಗ್ ಸಿಂಗ್ ಮತ್ತು ಡಾಕ್ಟರ್ ಚಿಕ್ಕನಂಜಪ್ಪ ಅವರ ಜೊತೆಗೆ ವಿಶ್ವವಿದ್ಯಾಲಯದ ರೂಪರೇಷೆಗಳನ್ನು ರಚಿಸಿದವರು. ಸರ್ಕಾರಿ ವೈದ್ಯಕೀಯ ಮತ್ತು ದಂತ ಕಾಲೇಜುಗಳ ಶಿಕ್ಷಕರ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಸಂಸ್ಥಾಪಕರು ಕೂಡ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘಕ್ಕೆ ಸಲ್ಲಿಸಿದ ಸೇವೆಯನ್ನು ನೋಡುವುದಾದರೆ ಇವರು 3 ದಶಕಗಳ ಕಾಲ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಆಧಾರ ಸ್ತಂಭವಾಗಿ ನಿಂತು ಕಟ್ಟಿ ಬೆಳೆಸಿದ ಕೀರ್ತಿಗೆ ಪಾತ್ರರಾದವರು. ಕರ್ನಾಟಕ ಸಾಮಾಜಿಕ ಭದ್ರತಾ ಯೋಜನೆ KSS ಇವರ ಕನಸಿನ ಕೂಸು. ಇಂತಹ ಧೀಮಂತ ಹಿರಿಯ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ನೇತಾರ ನೆನಪಿನಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ಶಾಖೆ ಪ್ರತಿ ವರ್ಷ ಜರುಗುವ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನದಲ್ಲಿ ಪ್ರೊಫೆಸರ್ ನಂಜುಂಡಯ್ಯ ಸ್ಮರಣಾರ್ಥ ಉಪನ್ಯಾಸ ಏರ್ಪಡಿಸುತ್ತಿರುವುದು ಸ್ವಾಗತಾರ್ಹ ಮತ್ತು ಶ್ಲಾಘನೀಯ. ಇತಿಹಾಸ ಗೊತ್ತಿಲ್ಲದವರಿಗೆ ಇತಿಹಾಸ ಸೃಷ್ಟಿಸಲು ಸಾಧ್ಯವಾಗುವುದಿಲ್ಲ. ಮೊದಲು ಸ್ಥಳೀಯ ಆರೋಗ್ಯ ಸಮಸ್ಯೆಗಳನ್ನು ಗುರುತಿಸಲು ಮತ್ತು ಅದಕ್ಕೆ ಪರಿಹಾರವನ್ನು ಕಂಡುಕೊಳ್ಳಲು ಬ್ರಿಟಿಷ್ ವೈದ್ಯಕೀಯ ಸಂಸ್ಥೆ ಅಸ್ತಿತ್ವದಲ್ಲಿ ಈ ದೇಶದಲ್ಲಿ ಇತ್ತು. ಇದರಲ್ಲಿ ಹೆಸರಾಂತ ಮತ್ತು ಘಟಾನುಘಟಿ ವೈದ್ಯರುಗಳು ಈ ಸಂಸ್ಥೆಯ ಸದಸ್ಯರಾಗಿದ್ದರು. 22 ಡಿಸೆಂಬರ್ 1883ರಲ್ಲಿ ಮುಂಬೈನ ಗ್ರೇಟ್ ವೆಸ್ಟರ್ನ್ ಹೋಟೆಲ್ನಲ್ಲಿ ನಡೆದ ವೈದ್ಯಕೀಯ ಸಭೆಯಲ್ಲಿ ಭಾರತದ ಮೊಟ್ಟ ಮೊದಲ ವೈದ್ಯರ ಸಂಘಟನೆ ಮುಂಬೈ ಮೆಡಿಕಲ್ ಯೂನಿಯನ್ ಎಂಬ ಹೆಸರಿನಿಂದ ಅಸ್ತಿತ್ವಕ್ಕೆ ಬಂತು. 1985ರಲ್ಲಿ ಅಖಿಲ ಭಾರತ ವೈದ್ಯಕೀಯ ಸಂಘಟನೆ ಆಯಿತು ಮತ್ತು 1995 ಮತ್ತು 1900 ಕಾಲಾವಧಿಯಲ್ಲಿ 2 ವೈದ್ಯಕೀಯ ಸಮ್ಮೇಳನ, ಒಂದು ಮುಂಬೈಯಲ್ಲಿ ಮತ್ತೊಂದು ಕೋಲ್ಕತ್ತಾದಲ್ಲಿ ಜರುಗಿದವು. 28 ಡಿಸೆಂಬರ್ 1928ರಲ್ಲಿ ಅಖಿಲ ಭಾರತ ವೈದ್ಯಕೀಯ ಸಂಸ್ಥೆಯಾಗಿ ಮುಂಬೈನ ಡಾಕ್ಟರ್ ಜಿ ನಿಮ್ಮ ವೃತ್ತಿ ರಕ್ಷಣೆಗಾಗಿ ವೈದ್ಯಕೀಯ ವೃತ್ತಿಯಲ್ಲಿ ಮೈಯೆಲ್ಲ ಕಣ್ಣಾಗಿಸಿಕೊಂಡು ಎಷ್ಟೇ ನೈಪುಣ್ಯತೆ ಹೊಂದಿದ್ದರೂ, ಪರಿಣಿತಿಯನ್ನು ಪಡೆದವರಾಗಿದ್ದರು, ಅನುಭವದ ಆಗರವಾಗಿದ್ದರು, ಕೈಯಿಂದ ಕೆಟ್ಟ ಫಲಿತಾಂಶಗಳು ಬರುವುದುಂಟು. ಇಂತಹ ಪ್ರಸಂಗಗಳಲ್ಲಿ ಹಿಂದೆ ಮಾಡಿದ ನೂರಾರು ಒಳ್ಳೆಯದೆಲ್ಲ ನೀರಲ್ಲಿ ಹೋಮ ಮಾಡಿದಂತಾಗುವುದು. ಇಂತಹ ಕೆಟ್ಟ ಫಲಿತಾಂಶಗಳೇ ಹದ್ದಿನ ಕಣ್ಣಿಂದ ಕಾಯುತ್ತಾ ಕುಳಿತವರಿಗೆ ಆಹಾರವಾಗುತ್ತವೆ. ನೆನಪಿಡಿ, ಕೆಟ್ಟ ಫಲಿತಾಂಶಗಳು ಕೆಟ್ಟ ಕಾಳಜಿಯ ಕೊಡುಗೆಗಳಲ್ಲ, ಅವು ನುರಿತ ತಜ್ಞರ ವೈದ್ಯರ ಕೈಯಲ್ಲಿಯೂ ಆಗಬಹುದು. ನೀವೇನು ತಪ್ಪು ಮಾಡಿ ಹೋದರೂ ಕೆಟ್ಟ ಪರಿಣಾಮಗಳು ಕೋರ್ಟಿನ ಕಟಕಟೆಯಲ್ಲಿ ನಿಮ್ಮನ್ನು ನಿಲ್ಲಿಸಬಹುದು. ಬಹಳಷ್ಟು ವೈದ್ಯರು ಇಂತಹ ಪ್ರಸಂಗಗಳಿಂದ ತಮ್ಮ ಘನತೆ ಗೌರವಕ್ಕೆ ಧಕ್ಕೆ ಬಂದು ಬುದ್ಧಿಮಂಕಾಗಿ ಮಾನಸಿಕ ಚಿತ್ರಹಿಂಸೆಗೆ ಒಳಗಾಗಬಹುದು. ಇಂತಹ ಸಂದಿಗ್ಧ ಪ್ರಸಂಗಗಳಲ್ಲಿ ನಿಮ್ಮ ರಕ್ಷಣೆಗೆ ಬರುವುದೇ KPPS. ಇಲ್ಲಿ ಜಯಜಿಮ್ಮದಾಗಲು ರೋಗಿಗೆ ಸಂಬಂಧಪಟ್ಟಂತಹ ಎಲ್ಲ ದಾಖಲೆಗಳನ್ನು ಸರಿಯಾಗಿ ಇಟ್ಟಿರಬೇಕು. ಯಾವುದಾದರೂ ತಪ್ಪು ಮಾಡಿ ಸಾರಿ ಹೇಳುವುದಕ್ಕಿಂತ ಸುರಕ್ಷಿತವಾಗಿರುವುದೇ ಒಳ್ಳೆಯದು. ಈ ಯೋಜನೆಯ ಪ್ರಯೋಜನ ಪಡೆಯಲು ಪ್ರವೇಶ ಶುಲ್ಕ 100 ರೂಪಾಯಿ, ಮುಂಗಡ ಭಾತೃತ್ವದ ಕೊಡುಗೆ 1000 ರೂಪಾಯಿ, ಒಟ್ಟು 3100 ರೂಪಾಯಿ, GST 18% 600 ರೂಪಾಯಿ, ಅಂತಿಮ ಮೊತ್ತ 3700 ರೂಪಾಯಿ. ವಾರ್ಷಿಕ ಕಂತು, ವಾರ್ಷಿಕ ಚಂದ 500 ರೂಪಾಯಿ ಮತ್ತು ವಾರ್ಷಿಕ ಕಾನೂನಿನ ವೆಚ್ಚಗಳು ಅದರಲ್ಲಿ ಸೇರ್ಪಡೆ ಆಗುತ್ತವೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ KPPS ಕಾಣದ ಅಪಾಯ ಎದುರಿಸಲು ಸಜ್ಜುಗೊಳಿಸುವುದು, ನಿರಾತಂಕವಾಗಿ ವೃತ್ತಿಯನ್ನು ಮಾಡಲು ಬಿಡುವುದು, ನಿಮ್ಮ ಆಸ್ತಿ ಪಾಸ್ತಿಗಳನ್ನು ಸುರಕ್ಷಿತವಾಗಿಡುವುದು, ನಿಮ್ಮ ಆತ್ಮರಕ್ಷಣೆಯನ್ನು ಹೆಚ್ಚಿಸುವುದು, ಕಾನೂನುಬದ್ಧ ಖರ್ಚು ವೆಚ್ಚಗಳನ್ನು ಭರಿಸುವುದು. ಈ ಒಂದು ಕಾರ್ಯಾಲಯ ಇರೋದು IMA KPPS, IMA ಹೌಸ್ 2ನೇ ಮಹಡಿ, ಆಲೂರು ವೆಂಕಟರಾವ್ ರಸ್ತೆ, IMA ಸರ್ಕಲ್, ಬೆಂಗಳೂರು. ವೆಬ್ಸೈಟು ಹೀಗಿದೆ. ನೀವು ಬೇಕಾದ ಮಾಹಿತಿಯನ್ನು ಆ ವೆಬ್ಸೈಟ್ ಮುಖಾಂತರವಾಗಿ ಪಡೆಯಬಹುದು. ಕರ್ನಾಟಕ ಸಾಮಾಜಿಕ ಭದ್ರತಾ ಯೋಜನೆ KSSS. ಬದುಕು ಅನಿಶ್ಚಿತ, ನೀರ ಮೇಲಿನ ಗುಳ್ಳಿ ನಿಜವಲ್ಲ ಹರಿಯ ಎಂದು ಹೇಳಿದ್ದಾರೆ. ಇತ್ತೀಚಿನ ವರದಿಯ ಪ್ರಕಾರ ಭಾರತದಲ್ಲಿ ವೈದ್ಯರ ಜೀವಿತಾವಧಿ ಕೇವಲ 59 ವರ್ಷ. ಬೇರೆಯವರು ಬದುಕುವ ವಯೋಮಾನ ಇತ್ತೀಚಿನ ವರದಿಯ ಪ್ರಕಾರ 71 ವರ್ಷ. ನಮ್ಮ ಪ್ರೀತಿಯ ಹೆಂಡತಿ ಮಕ್ಕಳು ವರದಿಗಳಿಗೆ ಬೇಕಾದಷ್ಟು ಆಸ್ತಿ ಪಾಸ್ತಿ ಮಾಡಬೇಕು. ಎಷ್ಟೋ ವೈದ್ಯರು ಕುಟುಂಬ ಬೀದಿಗೆ ಬಂದದ್ದನ್ನು ಕೊರೋನಾ ಕಾಲಘಟ್ಟದಲ್ಲಿ ನಾವೆಲ್ಲ ಕಣ್ಣಾರೆ ಕಂಡಿದ್ದೇವೆ. ಇಂತಹ ಸಂಕಟಗಳನ್ನು ದೂರ ಮಾಡಿ ಇಡೀ ಕುಟುಂಬಕ್ಕೆ ಒಂದು ರಕ್ಷಾ ಕವಚ ಒದಗಿಸಲು KSS ಜನ್ಮ ತಾಳಿದೆ. KSS ಸಂಸ್ಥೆ ಜನ್ಮ ತಾಳಿದ್ದು ಬಾದಾಮಿಯಲ್ಲಿ 1989ರಲ್ಲಿ, ಅಸ್ತಿತ್ವಕ್ಕೆ ಬಂದದ್ದು 1991-92ರಲ್ಲಿ. ಇದು ಪ್ರೊಫೆಸರ್ ನಂಜುಂಡಯ್ಯ ಮತ್ತು VD ಸಫಾರಿ ಇವರ ಕನಸಿನ ಕೂಸು. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಬಾದಾಮಿಯಲ್ಲಿ ಜರುಗಿದಂತಹ ಸಮಾರಂಭ. ಆಗ ನಾನು ಸಂಘಟನಾ ಕಾರ್ಯದರ್ಶಿ ಆಗಿದ್ದೆ. ಡಾಕ್ಟರ್ ಗೂರ್ನವರ್ ಈ ಸಮ್ಮೇಳನದ ಸ್ವಾಗತ ಸಮಿತಿಯ ಚೇರ್ಮನ್ರಾಗಿದ್ದರು. ಓದುತ್ತಿರುವವರು ಡಾಕ್ಟರ್ VD ಸಫಾರಿ, ಅವರ ಮಕ್ಕಳು ಕುಳಿತಂಥವರೇ ಪ್ರೊಫೆಸರ್ ಡಾಕ್ಟರ್ ನಂಜುಂಡಯ್ಯ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಬೆಂಗಳೂರು ಶಾಖೆ ಮೊದಲು ಡಾಕ್ಟರ್ BC ರಾಯ್ ಪ್ರಶಸ್ತಿಯನ್ನು ಕೊಡ್ತಾ ಇತ್ತು. ಆ ಸಂದರ್ಭದಲ್ಲಿ ನನಗೆ ಗ್ರಾಮೀಣ ಪ್ರದೇಶದಲ್ಲಿ ಸೇವೆ ಸಲ್ಲಿಸಿದ್ದನ್ನು ಗುರುತಿಸಿ BC ರಾಯ್ ಪ್ರಶಸ್ತಿಗೆ ಆಯ್ಕೆ ಮಾಡಿದಾಗ ರಾಷ್ಟ್ರೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರು ಮತ್ತು ಪ್ರೊಫೆಸರ್ ನಂಜುಂಡಯ್ಯ ಇವರೆಲ್ಲ ಕೂಡಿ ಸನ್ಮಾನ ಮಾಡಿದ ಸಂದರ್ಭ. ಆಗ ಬಾದಾಮಿಯಲ್ಲಿ ಈ ವೈದ್ಯಕೀಯ ಸಂಘಕ್ಕೆ ಇದ್ದಂಥವರ ಸಂಖ್ಯೆ ಕೇವಲ 10. ಹೆಚ್ಚುವರಿ ಸಾಮಾನ್ಯ ಸಭೆ ಅಂದರೆ ಎಕ್ಸ್ಟ್ರಾರ್ಡಿನರಿ ಜನರಲ್ ಬಾಡಿ ಮೀಟಿಂಗ್ ಅನ್ನು ಮಾಡಿದ್ದೆವು. ಆಗ ನಾನು ಕಾರ್ಯದರ್ಶಿಯಾಗಿದ್ದೆ. ಡಾಕ್ಟರ್ ಗೂರ್ನವರ್ ಸ್ವಾಗತ ಸಮಿತಿಯ ಚೇರ್ಮನ್ ಆಗಿದ್ದರು. ಅದಂತೂ ಅಭೂತಪೂರ್ವ ಕಾರ್ಯಕ್ರಮ ಅಂತ ನಾನು ನೆನಪಿಸ್ಕೊಳ್ತೇನೆ. ಆ ವರ್ಷ ನನಗೆ ಬೆಸ್ಟ್ ಬ್ರಾಂಚ್ ಬ್ರಾಂಚಿನ ಸೆಕ್ರೆಟರಿ ಜೊತೆಗೆ ಡಾಕ್ಟರ್ ಸುಧಾ ಕಲ್ಯಾಣ್ಪುರ್ಕರ್ ಅವರ ರೂಲಿಂಗ್ ಟ್ರಾಫಿಗೆ ನಾನು ಭಾಜನನಾಗಿದ್ದೆ. ಒಂದೇ ಅಭಿರುಚಿ ಅಥವಾ ಗುರಿ ಹೊಂದಿದ, ಒಂದೇ ವೃತ್ತಿಯಲ್ಲಿ ತೊಡಗಿದ ಗುಂಪು ಒಬ್ಬರಿಗೊಬ್ಬರು ಸಹಾಯಕರಾಗಬೇಕೆಂದು ಶೋಷಣೆಗೊಳಗಾದವರ ಕುಟುಂಬಕ್ಕೆ ಹಣಕಾಸಿನ ನೆರವು ಕೊಡುಗೆ ಮುಖಾಂತರವಾಗಿ ಕಾಂಟ್ರಿಬ್ಯೂಷನ್ ಮಾಡಿ ಮುಖಾಂತರ ನೀಡುವ ಒಂದು ಯೋಜನೆ ಇದು. ವೈವಿಧ್ಯ ಒಂದು ಕೃಪೆ ನಮಗಿರುವ ಕಷ್ಟದಲ್ಲಿ ಆವರಿಸಿದರಲ್ಲಿ ಎಲ್ಲರನ್ನೊಂದೇ ಸಮಯ ನೋವಿಲ್ಲದವರು ನೊಂದವರನ್ನು ಸಂಜಯಿಸುತ್ತರೆ ಜೀವನವು ಕಡಿಯುವುದೇ ಮಂಕುತಿಪ್ಪ ಅನ್ನುವ ಒಂದು ಅವರು ಹೇಳಿದ್ದು ನಮ್ಮ KSSಕ್ಕೆ ಹೇಳಿ ಮಾಡಿದಂಥ ಒಂದು ಚತುಷ್ಪದಿ ಆಗಿದೆ. ಅಸ್ತಿತ್ವದಲ್ಲಿರುವ ಇದರಲ್ಲಿ 2 ಪ್ರಕಾರದ ಯೋಜನೆಗಳು, ಅಸ್ತಿತ್ವದಲ್ಲಿರುವ ಹಳೆ ಯೋಜನೆ ಓಲ್ಡ್ ಸ್ಕೀಮ್, ಹೊಸ ರಜತ ಮಹೋತ್ಸವದ ಯೋಜನೆ. ಅದಕ್ಕೆ ಆ ವಯಸ್ಸಿಗೆ ತಕ್ಕಂತೆ ಎಷ್ಟೆಷ್ಟು ಹಣವನ್ನು ಕೊಡಬೇಕೆಂಬುದು ಈ ಚಾರ್ಟ್ನಲ್ಲಿದೆ. ಇದು ಪ್ರತಿ IME ಫೋಕಸ್ನಲ್ಲೂ ಬರ್ತಾ ಇರುತ್ತದೆ. ಪ್ರಸ್ತುತ ಹಳೆ ಯೋಜನೆಯವರಿಗೆ ಮರಣದ ನಂತರ ಸಿಗುವ ಹಣ 19,07,000 ರೂಪಾಯಿ. ರಜತ ಮಹೋತ್ಸವ ಯೋಜನೆಯವರಿಗೆ ಮರಣ ಹೊಂದಿದ ನಂತರ ಸಿಗುವ ಹಣ 59,90,000 ರೂಪಾಯಿ. ಈ ಯೋಜನೆಯ ಸ್ಪಷ್ಟ ಉದ್ದೇಶವನ್ನ ನೀವು ತಿಳ್ಕೊಂಡಿರ್ಬೇಕು. ಇದು ಜೀವಂತ ಇದ್ದಂತಹ ವೈದ್ಯರಿಗೆ ಉಪಯೋಜನ ಆಗದೇ ಇದ್ರೂ ಸಹ ಅವರ ಮರಣದ ನಂತರ ಅವರ ಕುಟುಂಬದ ಸದಸ್ಯರಿಗೆ ಪ್ರಯೋಜನವಾಗುವ ಉದ್ದೇಶದಿಂದ ಜಾರಿಗೆ ಬಂದಂತಹ ಒಂದು ಯೋಜನೆ. ಈ ಪ್ರತಿ ವರ್ಷ ಸಾವಿನ ಭಾತೃತ್ವ ಕೊಡುಗೆಯನ್ನು ಪಾವತಿಸಬೇಕು. ಎಷ್ಟು ಕೊಡಬೇಕಾಗುತ್ತದೆ ಅಂದರೆ, ಹಳೆ ಯೋಜನೆಯಲ್ಲಿ 1000 ಇಂಟು ಹಿಂದಿನ ವರ್ಷ ಸತ್ತವರ ಸಂಖ್ಯೆ ಸಾವಿನ ಭಾತೃತ್ವ ಕೊಡುಗೆ ಅಂದರೆ DFC. ಈ ಹೊಸ ಯೋಜನೆಯಲ್ಲಿ 2,500 ಮತ್ತು ಹಿಂದಿನ ವರ್ಷ ಸತ್ತವರ ಸಂಖ್ಯೆ ಅದು DFC ಆಗುತ್ತೆ. ಪ್ರತಿ ವರ್ಷ ಎಲ್ಲ ಸದಸ್ಯರಿಗೆ ಏಪ್ರಿಲ್ ತಿಂಗಳಲ್ಲಿ ಈ ಕುರಿತು ಸೂಚನೆಯನ್ನು ನೀಡಲಾಗುವುದು. ನೆನಪೋಡೆಗಳಿಗೂ ಸ್ಪಂದಿಸಿದ ಸದಸ್ಯರ ಹೆಸರುಗಳನ್ನು ಅನಿವಾರ್ಯವಾಗಿ ಕೈಬಿಡಲಾಗುವುದು. ಅಂಥವರು ಈ ಯೋಜನೆಯ ಪ್ರಯೋಜನಗಳಿಂದ ವಂಚಿತರಾಗುವರು. ಕಾರ್ಯಾಲಯ ಇರುವುದು IME KSS ರಿಜಿಸ್ಟ್ರೇಷನ್ ನಂಬರ್ 4791/9192 IME ಹೌಸ್ 2ನೇ ಮಹಡಿ, ಬೈಲಪ್ಪನವರ ನಗರ, ಹುಬ್ಬಳ್ಳಿ. ಇದು ಫೋನ್ ನಂಬರ್ ಮತ್ತು ಇಮೇಲ್, ಇದು ವೆಬ್ಸೈಟ್. ಇದರಲ್ಲಿ ಯಾರಾದರೂ ಹೋಗಿ ತಮಗೆ ಬೇಕಾದ ಮಾಹಿತಿಯನ್ನು ಪಡೆಯಬಹುದಾಗಿದೆ. ಕರ್ನಾಟಕ ರಾಜ್ಯ ಆರೋಗ್ಯ ಯೋಜನೆ KSHS. ಬೇರೆಯವರ ಆರೋಗ್ಯದ ಬಗ್ಗೆ ಕಾಳಜಿ ಮಾಡುವ ವೈದ್ಯರು ತಮ್ಮ ಆರೋಗ್ಯ ಅಲಕ್ಷಿಸುವುದು ಸರ್ವೇ ಸಾಮಾನ್ಯ. ವೈದ್ಯರು ಯಾವಾಗಲೂ ಆರಾಮಿರುತ್ತಾರೆ ಎಂಬ ನಂಬಿಕೆಯನ್ನು ಪ್ರಚಾರ ಮಾಡುವುದೇ ವೈದ್ಯಕೀಯ ಸಂಸ್ಕೃತಿ. ವೈದ್ಯರು ಮನುಷ್ಯರೇ, ಅವರು ಎಲ್ಲರಂತೆ ರೋಗ ರುಜಿನಗಳಿಗೆ ತುತ್ತಾಗುವುದು ಸಹಜ. ಅವರ ಆರೋಗ್ಯಕ್ಕೊಂದು ರಕ್ಷಾ ಕವಚ ಇರಲೆಂದು ಆ ಒಂದು ಸದುದ್ದೇಶದಿಂದ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ಶಾಖೆ 1/7/1921 KSHS ಅನ್ನು ಪ್ರಾರಂಭಿಸಿದೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಆಜೀವ ಸದಸ್ಯರು ಅನಾರೋಗ್ಯಕ್ಕೆ ತುತ್ತಾದಾಗ ಅವರಿಗೆ ಹಣಕಾಸು ನೆರವು ನೀಡಲು ಕರ್ನಾಟಕ ರಾಜ್ಯ ಆರೋಗ್ಯ ಯೋಜನೆ KSHS ಅನ್ನು ಹುಟ್ಟುಹಾಕಿದೆ. ಇದರ ಸದುಪಯೋಗ ಪಡೆಯಲು ಅದರ ಸದಸ್ಯರಾಗುವುದು ಅತಿ ಮುಖ್ಯ. ಇದು ಸದಸ್ಯರ, ಅವರ ಪತ್ನಿ, ಪತಿ, ಮಕ್ಕಳು ಮತ್ತು ಪೋಷಕರು ಅಂದರೆ ತಂದೆ ತಾಯಿಗಳಿಗೆ ಆಸ್ಪತ್ರೆಗೆ ಒಳರೋಗಿಯಾಗಿ ಸೇರಿಕೊಂಡು ಅಲೋಪತಿ ಚಿಕಿತ್ಸೆ ಪಡೆದವರಿಗೆ ಮಾತ್ರ ನೆರವಿನ ಹಸ್ತವನ್ನು ನೀಡುತ್ತದೆ. ಬೇರೆಯ ರೀತಿಯಲ್ಲಿ ಆಯುರ್ವೇದ ಆಗಿರ್ಬೋದು, ಹೋಮಿಯೋಪತಿ ಆಗಿರ್ಬೋದು, ಅಂತಹ ಚಿಕಿತ್ಸೆಯಿಂದ ಪಡೆದವರು ಇದಕ್ಕೆ ಅರ್ಹರಾಗುವುದಿಲ್ಲ ಅನ್ನೋದನ್ನು ನೆನಪಿಟ್ಟುಕೊಳ್ಳಬೇಕು. ನಾವು ಎಲ್ಲರಿಗಾಗಿ, ಎಲ್ಲರೂ ತಮಗಾಗಿ ಎಂಬ ತತ್ವದಲ್ಲಿ ಇದರಲ್ಲಿ ಅಡಕವಾಗಿದೆ. ಇದು ಪರಸ್ಪರ ಪ್ರಯೋಜನಕ್ಕಾಗಿ ಇರುವಂತಹ ಯೋಜನೆ. ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಎಲ್ಲ ಆಜೀವ ಸದಸ್ಯರಿಗೆ ಮತ್ತು ಕುಟುಂಬದವರಿಗೆ ಅರ್ಹತೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಆಜೀವ ಸದಸ್ಯರು, ಪತ್ನಿ ಅಥವಾ ಪತಿ, ಮಕ್ಕಳು ಮತ್ತು ಪೋಷಕರು ಇವರಿಗೆ ಮಕ್ಕಳು ಮತ್ತು ಪೋಷಕರಿಗೆ ಬೆನಿಫಿಷರೀಸ್ ಅಂತ ತಿಳ್ಕೊಂಡು ಹೇಳ್ತಾರ. 85 ವರ್ಷದೊಳಗಿನ ರಾಜ್ಯದ ಎಲ್ಲ ಆಜೀವ ಸದಸ್ಯರು ಇದಕ್ಕೆ ಅರ್ಹರಾಗಿರುತ್ತಾರೆ. ಆರೋಗ್ಯ ಯೋಜನೆಯ ಫಲಾನುಭವಿಗಳಾಗಲು ಯಾವುದೇ ವೈದ್ಯಕೀಯ ಪರೀಕ್ಷೆಯ ಅವಶ್ಯಕತೆ ಇರುವುದಿಲ್ಲ. ನೋಂದಣಿ ಮಾಡಿಕೊಂಡ ಪೋಷಕರು, ಪತ್ನಿ, ಪತಿ ಮತ್ತು ಮಕ್ಕಳು, 85 ವರ್ಷದೊಳಗಿನ ರಾಜ್ಯದ ಎಲ್ಲ ಆಜೀವ ಸದಸ್ಯರು, ವಾರ್ಷಿಕ ಚಂದ ಯಾವುದೇ ವಿಮೆ ಕಂಪನಿಗಿಂತ ಕಡಿಮೆ ಇರುತ್ತದೆ. ಈ ಯೋಜನೆಯ ಪ್ರಯೋಜನ ಪಡೆದು ಉಳಿದ ಪಾಲಿಸಿಗಳ ಕಡೆಯಿಂದಲೂ ಪ್ರಯೋಜನವನ್ನು ಪಡೆಯಲು ಅವರು ಅರ್ಹರಾಗಿರುತ್ತಾರೆ. ಅಲೋಪತಿ ಚಿಕಿತ್ಸೆ ಪಡೆದವರು ಮಾತ್ರ ಇದರ ಉಪಯೋಗವನ್ನು ಪಡೆಯಬಹುದು. ಲಾಕಿನ್ ಅವಧಿ ಸಂಸ್ಥಾಪಕ ಸದಸ್ಯರಿಗೆ ಅಂದ್ರೆ 1 ರಿಂದ 500, 6 ತಿಂಗಳು. 65 ವರ್ಷದೊಳಗಿನ ಸಾಮಾನ್ಯ ಸದಸ್ಯರು 501 ರಿಂದ ಮೇಲ್ಪಟ್ಟವರು, ಅದರ ಫಲಾನುಭವಿ ಸದಸ್ಯರಿಗೆ 12 ತಿಂಗಳು. 65 ವರ್ಷದೊಳಗಿನ ಮೇಲ್ಪಟ್ಟ ಸಾಮಾನ್ಯ ಮತ್ತು ಫಲಾನುಭವಿ ಸದಸ್ಯರಿಗೆ 24 ತಿಂಗಳು. ನೆನಪಿಡಿ, ಈ ಯೋಜನೆಯಲ್ಲಿ ಕುಟುಂಬದ ಪ್ಯಾಕೇಜ್ ಇರುವುದಿಲ್ಲ, ವೈಯಕ್ತಿಕ ಪ್ಯಾಕೇಜ್ ಮಾತ್ರ ಇರುತ್ತದೆ ಎಂಬುದನ್ನು ನೆನಪಿನಲ್ಲಿಟ್ಟುಕೊಳ್ಳಿ. ವಿಶೇಷತೆಗಳು: ಈ ಯೋಜನೆಯಲ್ಲಿ ನಗದು ರಹಿತ ಸೇವೆ ಇರುವುದಿಲ್ಲ. ಆಸ್ಪತ್ರೆಯಿಂದ ಬಿಡುಗಡೆಯಾದ 60 ದಿನಗಳೊಳಗೆ ಸಂಬಂಧಿಸಿದ ಎಲ್ಲ ಬಿಲ್ಲುಗಳನ್ನು ಮರುಪಾವತಿಗಾಗಿ ಸಲ್ಲಿಸುವುದು. 1 ವರ್ಷದ ಕಾಲಾವಧಿಯಲ್ಲಿ ಪಡೆಯಬಹುದಾದ ಗರಿಷ್ಠ ಪ್ರಯೋಜನ 2 ಲಕ್ಷ ಮಾತ್ರ. ಮಿತಿ ಬೆಲೆಯ ಕ್ಯಾಪಿಂಗ್ ಪ್ರೈಸ್ ಪ್ರತಿಶತ 75ರಷ್ಟು ಹಣವನ್ನು ಮರುಪಾವತಿಗೆ ಮಾಡಲಾಗುವುದು. ಸದಸ್ಯರು ಭಿನ್ನಾಂಕ ಪ್ರಕಾರ ಅಂದ್ರೆ ಫ್ರಾಕ್ಷನ್ಸ್ನಲ್ಲೂ ಸಹ ಹಣವನ್ನು ಮರುಪಾವತಿ ಮಾಡಿಕೊಳ್ಳಬಹುದು. ಆದರೆ 1 ವರ್ಷ ಕಾಲಾವಧಿಯಲ್ಲಿ 2 ಲಕ್ಷದ ಮಿತಿಯನ್ನು ಮೀರುವಂತಿಲ್ಲ. ಪ್ರಯೋಜನ ಪಡೆಯದಿದ್ದಲ್ಲಿ ಅದು ಮುಂದಿನ ವರ್ಷಕ್ಕೆ ಗಳಿಕೆಯಾಗುವುದಿಲ್ಲ. ಪ್ರಯೋಜನ ಪಡೆದಾಗ ವಿಮೆಯ ಕಂತು ಬರುವ ವರ್ಷಗಳಲ್ಲಿ ಹೆಚ್ಚಾಗುವುದಿಲ್ಲ. KSSಗೆ ಕೈಜೋಡಿಸಿ ನಿಮ್ಮ ಆರೋಗ್ಯವನ್ನು ಬಲಪಡಿಸಿಕೊಳ್ಳಿ. ಸದಸ್ಯರಾಗಲು ಸಂದಾಯ ಮಾಡಬೇಕಾದಂತಹ ಫೀ, ಇದನ್ನು ಪ್ರತಿ IMA ಫೋಕಸ್ನಲ್ಲೂ ಸಹ ಎಲ್ಲ ಸದಸ್ಯರ ಗಮನಕ್ಕೆ ತಂದಿರ್ತಾರೆ. ಆ ಪ್ರಕಾರ ಫೀ ಸಂದಾಯವನ್ನು ಮಾಡಿ ಈ ಯೋಜನೆಯ ಪ್ರಯೋಜನವನ್ನು ಪಡೆಯಬೇಕಾಗಿ ವಿನಂತಿ. ಕಾರ್ಯಾಲಯ ಇರುವುದು ಸದ್ಯ ಕೊಟ್ಟೂರೇಶ್ವರ್ MRI ಸ್ಕ್ಯಾನ್ ಸೆಂಟರ್, ಲಿಟಲ್ ಹಾರ್ಟ್ ಸ್ಕೂಲ್ ಸಮೀಪ, ಹೊಸಳ್ಳಿ ರಸ್ತೆ, ಗಂಗಾವತಿ. ಫೋನ್ ನಂಬರ್ನೂ ಇದೆ. ನಾನು ವೈದ್ಯನಾಗಿರುವುದಕ್ಕೆ ಹೆಮ್ಮೆ ಪಡುತ್ತೇನೆ. ಜೀವ ಉಳಿಸುವುದಕ್ಕಿಂತ ಉದಾತ್ತವಾದದ್ದು ಇನ್ನೊಂದಿಲ್ಲ. IMAಯ ಏನು ಕೊಟ್ಟಿದೆ ಎಂದು ಕೇಳುವ ಬದಲು IMAಗೆ ನೀವು ಏನು ಕೊಟ್ಟಿದ್ದೀರಿ ಎಂದು ನಿಮ್ಮನ್ನೇ ನೀವು ಪ್ರಶ್ನೆ ಮಾಡಿಕೊಳ್ಳಿ. ನೀವು ತೊಂದರೆಗೀಡಾದಾಗ IMA ಸಹಾಯಕ್ಕೆ ಬರಲಿಲ್ಲ ಅಂತ ತಿಳ್ಕೊಂಡು ಚಿಂತಿಸುವುದು ನಿಮ್ಮ ದುರದೃಷ್ಟ. ಸಂಕಟ ಬಂದಾಗ ವೆಂಕಟರಮಣ ಅನ್ನುವುದು ತಪ್ಪು. ಆದ್ದರಿಂದ ಮೊದಲು ಎಲ್ಲರೂ IMAಯ ಆಜೀವ ಸದಸ್ಯರಾಗುವುದು ಒಳ್ಳೆಯದು. ಅದರ ಪ್ರಯೋಜನ ಪಡೆಯಲು ಸಜ್ಜಾಗಬೇಕೆಂದು ತಮ್ಮಲ್ಲಿ ಕಳಕಳಿ ವಿನಂತಿ. ವೈದ್ಯರ ಜ್ಞಾನವನ್ನು ನವೀಕರಿಸಲು ಅನೇಕ CME ಕಾರ್ಯಕ್ರಮಗಳನ್ನು IMA CGP, IMA AMS ಮುಖಾಂತರ ಮತ್ತು ರಾಜ್ಯದ ಮತ್ತು ರಾಷ್ಟ್ರದ ಸಮ್ಮೇಳನಗಳಲ್ಲೂ ಸಹ ಉಪನ್ಯಾಸಗಳ ಮುಖಾಂತರವಾಗಿ ನೀಡಲಾಗುವುದು. ಅದರಿಂದ ವೈದ್ಯರ ಕ್ಷೇತ್ರದಲ್ಲಿ ಆದಂತಹ ಹೊಸ ಚಿಕಿತ್ಸೆ ತಂತ್ರಜ್ಞಾನವನ್ನು ಅರಿಯಲು ಅನುಕೂಲವಾಗುವುದು. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಫೆಲೋಶಿಪ್ಗಳನ್ನು ನೀಡುವುದು. ಅವುಗಳಿಗಾಗಿ ತಾವು ಪ್ರಯತ್ನಿಸಿ ಸದುಪಯೋಗವನ್ನು ಪಡೆಯಲು ವಿನಂತಿ. ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆಯಾದಾಗ ವೈದ್ಯರ ಮೇಲಿನ ಹಲ್ಲೆಗೆ ಹಲವಾರು ಕಾರಣಗಳು. ಮೊದಲನೇದು, ಅದಕ್ಕೆ ಕಾರಣವೇನೇ ಬೇಕಾಗಿಲ್ಲ. ಹದಗೆಟ್ಟ ರಸ್ತೆ, ತೆಗ್ಗು ತೆವರು ಇದ್ದಂತಹ ಗುಂಡಿಗಳಿದ್ದಂತಹ ದೊಡ್ಡ ಗುಂಡಿಗಳಂತ ಹೊಂದಿದಂತಹ ರಸ್ತೆ, ಕುಡುಕ ಚಾಲಕ, ಬೇಕಾಬಿಟ್ಟಿ ರಸ್ತೆಯಲ್ಲಿ ಚಾಲನೆ ಮಾಡುವುದು, ಅಪಘಾತಕ್ಕೆ ಈಡಾಗುವುದು, ಹೆಡ್ ಇಂಜುರಿಯ ಸ್ಥಿತಿಯಲ್ಲಿ ಬದುಕು ಮತ್ತು ಸಾವಿನ ನಡುವೆ ಹೊಯ್ದಾಡುವಂಥ ಸ್ಥಿತಿಯಲ್ಲಿ ಆಸ್ಪತ್ರೆಗೆ ತರುವುದು, ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಅಸುನೀಗಿದಾಗ ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆ ಮಾಡುವುದು, ಯಾವುದೋ ದಾಬಾಕೋ ಹೋಟೆಲ್ಗೆ ಹೋಗಿ ಊಟ ಮಾಡುವುದು, ಫುಡ್ ಪಾಯ್ಸನಿಂಗ್ ಆಗುವುದು, ಅಂತಹ ರೋಗಿಗಳನ್ನು ಆಸ್ಪತ್ರೆಗೆ ಕರೆದುಕೊಂಡು ಬರುವುದು, ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಕೈಮೀರಿ ಹೋದಾಗ ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆ ಮಾಡುವುದು. ಇನ್ನು ಡರ್ಟಿ ಸಿಟಿ ಎಲ್ಲೆಂದರೆ ಅಲ್ಲಿ ಸೊಳ್ಳೆಗಳು ಕಚ್ಚಿದಂತಹ ಡೆಂಗು ರೋಗಕ್ಕೆ ಇತ್ತಾದಂತಹ ಮಗುವನ್ನು ಆಸ್ಪತ್ರೆಗೆ ತರುವುದು, ಚಿಕಿತ್ಸೆ ಫಲಕಾರಿಯಾಗದಿದ್ದಾಗ ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆ ಮಾಡುವುದು ಸರ್ವೇ ಸಾಮಾನ್ಯ. ಇನ್ನು ನಮ್ಮ ಸಮಾಜದಲ್ಲಿ ಎಲ್ಲರೂ ಮದ್ಯವ್ಯಸನಿಗಳು ಮತ್ತು ಅನೇಕ ದುಶ್ಚಟಗಳಿಗೆ ಬಲಿಯಾದಂಥವರು. ಅವರಲ್ಲಿ ಹೃದಯ ಮತ್ತು ಲಿವರ್ ಫೇಲ್ ಆದಂತಹ ಪರಿಸ್ಥಿತಿಯಲ್ಲಿ ಆಸ್ಪತ್ರೆಗೆ ತಂದು ದಾಖಲೆ ಮಾಡುವಾಗ ಯಾರೋ ಬಂದಿರ್ತಾರೆ, ಕೈಕಾಲು ಹಿಡ್ಕೊಂಡು ಹೇಗಾರು ಜೀವ ಉಳಿಸ್ರಿ ಅಂತ ತಿಳ್ಕೊಂಡು ವೈದ್ಯರ ಕೈಕಾಲು ಬೀಳ್ತಾರ. ಪ್ರಸಂಗ ಕೈಮೀರಿ ಹೋದಾಗ ಬೇರೆಯವರು ಬಂದು ವೈದ್ಯರ ಹಲ್ಲೆ ಮಾಡುವುದು ಸರ್ವೇ ಸಾಮಾನ್ಯ. ಇಂತಹ ಒಂದು ಹಲ್ಲೆಗೀಡಾದಾಗ ನಾಡಿನಾದ್ಯಂತ ಇದನ್ನು ಪ್ರತಿಭಟಿಸಿ ಸರ್ಕಾರಕ್ಕೆ ಮನವಿಯನ್ನು ಸಲ್ಲಿಸಿ ರಕ್ಷಣೆಗಾಗಿ ಬಲಿಷ್ಠವಾದ ಕಾನೂನನ್ನು ತರಲು ಯಾವತ್ತೂ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಸರ್ಕಾರದ ಮೇಲೆ ಒತ್ತಡವನ್ನು ಹೇರುತ್ತಾ ಇದೆ. ಈ ನಿಟ್ಟಿನೊಳಗೆ ಕರ್ನಾಟಕ ಸರ್ಕಾರ ವೈದ್ಯರ ಮೇಲೆ ಹಲ್ಲೆ ಆಗುವುದನ್ನು, ICUದಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ತಕ್ಕಂತಹ ಸಿಬ್ಬಂದಿಗಳ ಮೇಲೆ ಹಲ್ಲೆ ಆಗುವುದನ್ನು, ಅದಕ್ಕೆ ನಿಯಂತ್ರಣ ತರುವ ಸಲುವಾಗಿ ಆಸ್ಪತ್ರೆಗೆ ಬಂದ ಗುಂಡಾಗಳು ಆಸ್ಪತ್ರೆಯ ಪರಿಕರಗಳನ್ನು, ಸಾಮಾನು ಸರಂಜಾಮುಗಳನ್ನು ಒಡೆದು ಹಾಕುವುದನ್ನು ತಡೆಯಲು ಒಂದು ಕಾನೂನನ್ನು ಈಗಾಗಲೇ 2009ರಲ್ಲಿ ತಂದಿದೆ. ಇದರ ಪ್ರಕಾರ ಹಲ್ಲೆ ಮಾಡಿದವರು ಅಥವಾ ಇಂಥ ಒಂದು ಘಟನೆಗೆ ಪ್ರಚೋದನೆ ಕೊಟ್ಟಂಥವರು 3 ವರ್ಷ ಜೈಲು ಶಿಕ್ಷೆಯನ್ನು ಅನುಭವಿಸಲು ಆ ಕಾನೂನಿನಲ್ಲಿ ಅವಕಾಶವಿದೆ. ಆದರೆ ಆ ಕಾನೂನಿನಲ್ಲಿ ಹಲ್ಲೆ ಮಾಡಿದಂಥವರು ಜಾಮೀನನ್ನು ಪಡೆಯುವ ಅರ್ಹತೆಯನ್ನು ಪಡೆದವರಾಗಿರುತ್ತಾರಿಂದ IMA ಮುಂಬರುವ ದಿನಗಳಲ್ಲಿ ಸರ್ಕಾರದ ಮೇಲೆ ಒತ್ತಡವನ್ನು ತಂದು ಆ ಶಿಕ್ಷಾ ಅವಧಿಯನ್ನು 7 ವರ್ಷಕ್ಕೆ ಹೆಚ್ಚಿಸಿದರೆ ಅದು ವೈದ್ಯರಿಗೂ ಅನುಕೂಲವಾಗುತ್ತದೆ ಮತ್ತು ಆ 7 ವರ್ಷ ಶಿಕ್ಷೆ ವಿಧಿಸಿದಂತಹ ಕಾನೂನಿಗೆ ಜಾಮೀನು ಸಿಗುವಂತಹ ಅರ್ಹತೆ ಸಹ ಇರುವುದಿಲ್ಲ. ಇಂಥ ಕೆಲಸವನ್ನು ಮುಂಬರುವ ದಿನಗಳಲ್ಲಿ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಮಾಡುತ್ತದೆ ಎಂಬ ಮಾತನ್ನು ನಿಮ್ಮಲ್ಲಿ ಹೇಳುತ್ತಾ, ಸಾರ್ವಜನಿಕ ಕ್ಷೇತ್ರದಲ್ಲೂ ಜನಜಾಗೃತಿಯನ್ನು ಉಂಟು ಮಾಡುವಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಹಿಂದೇನೂ ಬಿದ್ದಿಲ್ಲ. ಪ್ರಧಾನಮಂತ್ರಿಗಳ ಬೇಟಿ ಬಚಾವೋ ಬೇಟಿ ಪಡಾವೋ ಅಭಿಯಾನಕ್ಕಿಂತ ಮೊದಲೇ ಹೆಣ್ಣು ಮಗು ಉಳಿಸಿ ಬೆಳೆಸಿ ಎಂಬ ಯೋಜನೆಯನ್ನು IMA ಹಮ್ಮಿಕೊಂಡದ್ದು ಸ್ತುತ್ಯಾರ್ಹ. ವೈದ್ಯರ ನಡಿಗೆ ಹಳ್ಳಿಯ ಕಡೆಗೆ, ವೈದ್ಯರ ನಡಿಗೆ ಶಾಲೆಯ ಕಡೆಗೆ ಎಂಬ ಹಲವಾರು ಯೋಜನೆಗಳ ಮುಖಾಂತರ ಸಾರ್ವಜನಿಕ ಕ್ಷೇತ್ರದಲ್ಲಿ ಜನಾರೋಗ್ಯ ಜಾಗೃತಿಯನ್ನು ಮೂಡಿಸುತ್ತಿದೆ. ಶಾಲೆಗಳಿಗೆ ಅಥವಾ ಹಳ್ಳಿಗಳಿಗೆ ಹೋಗಿ ಆರೋಗ್ಯ ತಪಾಸಣೆಯನ್ನು ಮಾಡಿ, ಬೇಸಿಕ್ ಇನ್ವೆಸ್ಟಿಗೇಷನ್ಸ್ಗಳನ್ನೆಲ್ಲ ಮಾಡಿ ಅವರಿಗೆ ಬೇಕಾದಂತಹ ಆರೋಗ್ಯದ ಸಲಹೆ ಸೂಚನೆಗಳನ್ನು ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರು ನೀಡುತ್ತಾ ಬಂದಿದ್ದಾರೆ, ನೀಡುತ್ತಲೂ ಹೋಗುತ್ತಾರೆ. ಇಂಥ ಒಂದು ಇದಕ್ಕೆ ಸಾರ್ವಜನಿಕರು ಪ್ರೋತ್ಸಾಹಿಸಿ ವೈದ್ಯರಿಗೆ ರಕ್ಷಣೆಯನ್ನು ನೀಡಬೇಕು ಅಂತ ತಿಳ್ಕೊಂಡು ನಾನು ಕೇಳ್ಕೊತೇನೆ. ಮುಗಿಸುವ ಮುನ್ನ ಎಲ್ಲ ತಜ್ಞರಿಗೆ ತಾಯಿಯಾಗಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಜಗತ್ತಿನಲ್ಲಿ ಮಾನ್ಯತೆ ಪಡೆದ ದೊಡ್ಡ ವೈದ್ಯರ ಸಂಘವಾಗಿ ಕಾರ್ಯವನ್ನು ನಿರ್ವಹಿಸುತ್ತಿದೆ. ಇದರ ಸದುಪಯೋಗವನ್ನು ವೈದ್ಯರು ಪಡೆಯಲು ಮುಂದಾಗಬೇಕು. ಆಜೀವ ಸದಸ್ಯರಾಗಿ ಇನ್ನಷ್ಟು ಬಲಪಡಿಸಲು ಕೈಜೋಡಿಸಬೇಕೆಂದು ಕಳಕಳಿಯ ವಿನಂತಿ. ಸರ್ವೇ ಜನ ಸುಖಿನೋ ಭವಂತು. IMA ಚಿರಾಯುವಾಗಲಿ. ನನ್ನ ಉಪನ್ಯಾಸವನ್ನು ಮುಗಿಸುವ ಮೊದಲು ಇವನಾರವೆಂದೆನಿಸಿದರಯ್ಯ, ಇವ ನಮ್ಮವನೆಂದೆನಿಸಯ್ಯ, ಕೂಡಲ ಸಂಗಮ ದೇವ ನಿಮ್ಮ ಮನೆಯ ಮಗನೆಂದೆನಿಸಯ್ಯ ಅಂತ ತಿಳ್ಕೊಂಡು ಬಸವಣ್ಣನವರು ನೆನೆಸುತ್ತಾ, ಬಸವಣ್ಣನವರ ನಾಡಿನಲ್ಲಿ ಈ ಉಪನ್ಯಾಸವನ್ನು ನೀಡಲು ಅನುವು ಮಾಡಿಕೊಟ್ಟಂತಹ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ಶಾಖೆಗೆ ಮತ್ತು ಬೀದರ್ನ ಶಾಖೆಗೂ ನನ್ನ ಹೃತ್ಪೂರ್ವಕ ಕೃತಜ್ಞತೆಗಳನ್ನು ಸಲ್ಲಿಸಿ ನನ್ನ ಉಪನ್ಯಾಸಕ್ಕೆ ವಿರಾಮ ನೀಡುತ್ತೇನೆ. ಕೃತಜ್ಞತೆಗಳು.
ಡಾಕ್ಟರ್ ನಂಜುಂಡಯ್ಯ ಸ್ಮರಣಾರ್ಥ ಉಪನ್ಯಾಸವನ್ನು ಈಗ ತಾನೇ ನಮ್ಮ ಮಿತ್ರರಾದ ಪ್ರತಿಭಾವಂತ ಲೇಖಕರು ಡಾಕ್ಟರ್ ಕ್ಯಾಲಕೊಂಡ್ರು ಕರವೀರ ಪ್ರಭು ಕ್ಯಾಲಕೊಂಡ್ರು ಹೀಗೆ ತಾನೇ ಮಾಡಿದ್ದಾರೆ. ತುಂಬ ಚೆನ್ನಾಗಿ ಮಾಡಿದರು. ತುಂಬ ಸೊಗಸಾಗಿ IMA ಬಗ್ಗೆ ಇಂಡಿಯನ್ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಗುರಿಗಳು ಉದ್ದೇಶಗಳು ತುಂಬ ಚೆನ್ನಾಗಿ ಮಾಡಿದರು. ಅವರ ಈ ಒಂದು ಪಾಠಕ್ಕೆ ಈ ಒಂದು ಲೆಕ್ಚರರ್ಗೆ ಡೆಫಿನೆಟ್ಲಿ ನಾನು ಹುತೂಪವಾಗಿ ನನ್ನ ಕಡೆಯಿಂದ ಅಭಿನಂದನೆಗಳು ಅರ್ಪಿಸ್ತಾ ಇದ್ದೇನೆ. ಶುಭವಾಗಲಿ ಸರ್. ದಯವಿಟ್ಟು
I request our honorary chairpersons to facilitate our honorable orator, Dr. Karveer Prabhu Kalkonda, sir.
फ्रंट रो में बैठे कहीं बैठे
कौन?
खाना पाए वही है
Yeah, no, not on my first result.
पंगी पे पंगी पंगी नॉट पंगी
Angi?
डॉक्टर कन्नप्पा ही बोलते हैं
Papa. नाम का दो.
Thank you so much, sir. Moving on to our next prestigious oration, Indian Medical Association, Karnataka State Branch, Endowment Lecture, A Journey Towards Healthy Longevity. It gives me immense pleasure to invite on stage our orator, Dr. Annappa A. Pangi, sir, Senior Physician. Please give him a big hand.
ನನ್ನ ಗೆಳೆಯದನ ಮಾಡ್ತೀನಿ ಮುಂದಿನ ಇಲ್ಲ ನಾನು ಇದನ್ನ ಓದ್ತೀನಿ ನೀವು ಅದನ್ನ ಓದ್ರಿ ಸ್ವಂತ ಬರ್ದು ನೀವು It gives me immense pleasure to introduce my friend, my classmate and also my roommate, Dr. Annappa A. Pangi. Born on 11th April 1953, got his MD from Karnataka Medical College, Hubli, and is practicing internal medicine at Athene. President of Indian Medical Association, Athene, elected as alternative Central Executive Committee member for the year 2022-23 and State and Central Committee member as a now. Past member of Indian Medical Association, KSV Public Health Group. Local Building Committee Chairperson, Chairperson Ace Pangi, Medical Service and Research Trust, and they are conducting regular health checkup camps, diabetic camps, and hypertension camps. He is a member of Association of Physicians of India, CSI, RSS, DI, and IAE. He is running a BSc Nursing College recognized by RGUHS. He is regularly writing a health column for a Kannada daily Asiru Kranti. He is authored a book in Kannada titled Ahara ಹಾಗೂ ಆರೋಗ್ಯ. He has given a talk in IMA State Conference at Gadag and Bangalore. Here is Dr. Annappa A. Pangi, who is going to deliver IMA KSP endowment oration on a journey towards health longevity. Over to you, Dr. Annappa Pangi.
Dear my friend Dr. Shivanna Lakkod, as he has already told me, my dear friend, classmate, and highly esteemed friend. At the same time, Dr. Srinivas, who is going to be the IMA president from this conference onwards, Dr. Chinwalar, who is the president, who is going to be the president-elect, and the organizing committee members of this IMA State Conference, Bidar, and all the doctors who have come from all over the state of Karnataka, and ladies and gentlemen. It gives me immense pleasure to give this talk or an oration in IMA State Branch or IMA State Conference. It is indeed a great honor. I deem it as a great honor, and I thank the organizers of this particular conference, Dr. Shukumar Lakkod, and the scientific committee of Bidar Conference, who have given this honor to me to give this oration, prestigious oration of and this particular oration is an endowment oration of Indian Medical Association. I am really honored, sir, to give this oration. And see, when it's customary on the part of a speaker, whenever an oration is given, to tell something about the person who has given the endowment. So in this case, the endowment is given by the IMA State Branch. So I am very much thankful, and I would like to express my sincere thanks and appreciation for the IMA Karnataka State Branch. And IMA, or Indian Medical Association, is an organization of allopathy doctors practicing the newer system of medicine. And in this particular organization, all the doctors, whether he is a postgraduate, whether he is practicing in whether a doctor is practicing in Bangalore, or whether a doctor is practicing in a village, or whether he holds just an MBBS qualification, or whether he is a postgraduate or a super specialist, doesn't matter. All the doctors are equal in Indian Medical Association, and this equality is well exemplified in my own case. I should say, because all the doctors have got equal rights. And as a doctor practicing in a smaller place like Athani, which is a taluka place which many people may not be knowing, and as a practicing physician, where I have been practicing for the last more than 40 years, I have been chosen to speak on this endowment oration in spite amongst all the galaxy of doctors. So this is the beauty of Indian Medical Association. No, because what happens is, see, very often orations are addressed by super specialists or people who are practicing in working in a corporate hospital, and the practicing doctors in the rural areas, I feel that they are very often neglected. So my sincere suggestion to the IMA is that at least one particular oration be given to the doctors who are practicing in the rural areas. And another example, standing example that I would like to give is that of my own friend, Dr. Shukumar Lakkod. He is practicing in a place called as Roan, and probably many of you may not have heard where Rohn is. And not only he is practicing there as a general practitioner for the last, equal to me almost for the last 40 years, but he is holding the highest post in the state. There's the IMA state president. And this is, and he has been doing an exemplary work. And this is what is the beauty of Indian Medical Association. There is no distinction between a doctor who is practicing in Bangalore or whether he's practicing elsewhere. So this is what I just want to tell about Indian Medical Association, who has given me this particular endowment oration and the honor. Now let me go to the topic proper. The topic that I'm going to speak is a journey towards healthy longevity. This is a place where I have been working for the last 40 years in a place called as Athani, and I've been a physician there. Next slide. So why this particular topic? This topic I have chosen because it's quite close to my heart. And maybe that, I am already on the other side of 70. And all my friends, my classmates, obviously are also of my age, that is elderly people. Maybe that is the reason as to why I must have chosen it. And the other thing is, see, whenever we meet in some conference or whenever we meet, the discussion usually hovers around the health issues. And sometimes, we feel so sad that we already lost around, say, 10% of our friends or even more than that. And many of our friends are already suffering from diabetes, hypertension, and many of them have undergone coronary artery bypass, CABG, angioplasty, and more than 50% of them are diabetics and hypertensives, and many have osteoarthritis. They have undergone knee replacements. So then I thought that why not give an address on a topic which should be of interest not only to the people who are elderly, but also who are in the middle ages and who are going to step into an elderly category. So this particular topic will be of help not only people who are old or elderly, but also to all the people in the audience. Now, this is a journey. Life is a long journey. See, whenever we speak of lifespan or longevity, we usually, whether you do any exercise or not, otherwise also one would definitely live for, say, 60 years or more. So it's a long, long journey, unlike the journeys that we undertake. So this journey is divided into childhood, youth, middle age, and old age. Old age is further subdivided as early old age between 60 to 70 years, middle old age 70 to 80 years, old age beyond 80 years. And sometimes we call, refer them to a senior citizen, which is a refined way of addressing. You can't say that, hey, old man. So senior citizen, government has chosen to call them senior citizen, starts in our country often at the age of 60, and it coincides with the retirement age. So is that the beginning of the old age, 60? I think it's too early, because do you like yourself to be called as old? Probably, I think many of us would definitely tell that let us not be called as old at this particular age, because at 60, many people are perfectly fit, they are in a good health, and they are as fit as young people also. Now, let me tell you the system of aging. So there are 4-5 kinds of ages. One is chronological age. Chronological age is nothing but a number wherein this particular age starts from date of birth to the number of years that are spent. So that is chronological age. The appearance age, very crude assessment. It is highly subjective. It depends upon person who says, no, he looks, though he is around, say, 50, 60, but he still looks young. So that is appearance age. And then we go to what is called as psychological age. Again, crude assessment, because psychological is, see, what one feels about himself or herself. Maybe some people who are young, they may feel old, or they behave like old people. And some people who are old, but yet behave like young people. And functional age. So this is a little better way of addressing because functional age is assesses the functional capacity of a person. That is, it correlates with healthy aging. Because I think the entire talk will be around, healthy aging and the lifespan. So it is related to the quality of life, functional aging, and activity of daily living. Now, most important amongst all these is biological age. What is this particular biological age? Biological age indicates the health of our cells. So, it is a better predictor of your health span and lifespan. And what are the parameters that you look into for biological age? One is the clinical parameters, the blood chemistry as markers of aging, and age predictors based on molecular and genetic markers. Want to measure your biological age? It is possible. How do you do or how do you measure your biological age? That is, it is done by you send your samples, blood, urine, and saliva to certain organizations or certain laboratories which do this assessment. You send them to what is called as a pheno age, a laboratory, or a bio age, and you receive your report within 6 weeks. And what do the tests do? It is done by demethylation test of the chromosomes, the epigenetic clock, and what is called as a telomere length assessment. And not only that, there is a website which is called as artificial aging AI. In this particular website, if you key in certain parameters, that is, a questionnaire is there. In that particular question, you give the history, you give all your lab parameters, and then some of the lab parameters are almost like 30 parameters, 40 parameters, or 20 parameters. Depending on that, once you complete that particular questionnaire, at the end of that questionnaire, you will be given your biological age. So that is what you can get it. But the best thing would be to send your samples to the laboratory, and these 3 tests that I have already told you, that would give a better representation or that would give a better result. Now, one more thing I'd just like to tell is biological age. For example, if your chronological age is 60, and if you send your blood sample and if your biological age comes to be 50, so your cells are young and your health is good. Reverse is the case. Supposing your biological age is 60 and if your chronological age is biological is 60, chronological is 50, then it would suggest that your cells are older and you need to take certain actions in order to do improve upon your biological aging. And this particular report, I would like to tell you that they not only mention the biological age, but they will also give you what are the steps you should take. Whether you should take dieting, whether you should take exercise, and all the things. So this is regarding biological age. Now, because this particular topic is on longevity, lifespan, and health span. So let us know what is longevity. So longevity is the number of years you live beyond the average life. Supposing the average life is in India, the average lifespan is around 70 years. Supposing you stay healthy for more than 75 years, you're already exceeded your average lifespan. And what is the lifespan? Total lifespan, total number of years one has lived, healthy or otherwise. Maybe you are still living with certain diseases. Now let us see, this is the most important thing. Health span. Health span is number of years lived in good health without any physical dependence on others and with mental alertness and cognition. So this is very important because see, an individual could be living for maybe 80 years, but supposing he is bedridden or supposing he is moribund and supposing his cognition is not good, there is no point in living at all. So supposing one lives a healthy life, I think it is acceptable. So in this particular example, if first example, you would see that the health span, that's the one which is shown by blue light, and red light is age-related diseases. See, during about say 100 years back, the health span, total lifespan was less. Maybe it was 50 years. And most of the time, the people used to be healthy. But now, the lifespan has increased. And that's the reason as to why the total lifespan, though it is increased, the health span, you will see that the red light, that is a red shaded area, is a little more than what is there. So, our intention should spend more of your life in a very good health. So this is the same thing is shown in this particular diagram. Again, see, till middle age, you complete your middle age, you are still healthy. But during the last phase of your life, after about 60 years, you continue to develop many age-related diseases like hypertension, diabetes, all those things start at the age of 60. Supposing you take care at that particular thing, you should see to it that the area which is shown as green and both arrows are there, it should be smaller. So very important is that you should increase your health span rather than just the lifespan. Now let me take you through a journey. See, supposing you undertake a journey, in that particular journey, you see that there are so many obstacles, there are so many road is topsy-turvy, curvy, there are so many bumps. And so if you want to have in this particular a smoother journey, you don't want to have all these bumps, and you should have if you want a smoother journey, then I think we should probably ask a person who has already undertaken the journey. A person who has undertaken the journey knows the road better. He will be able to guide you. So who are these people who are going to guide you throughout this particular journey? So they are old people, elderly people who have undertaken the journey already. And what the elderly people say, respect us when we tell you something. Remember, we did not use Wikipedia, Google to graduate. We used our brains. So that is what is this particular elderly people are telling. That is, who are centenarians. Centenarians are those people who have lived beyond 100 years. And they lived in good health. They did not depend on anyone for their daily activities. Mentally alert with intact mental functions. And who are super centenarians? Super centenarians are those who live beyond 110 years. Probably many of you must have recognized this particular old man in the picture. He is Shivananda Swami of Varanasi, who claims to be 127 years, but I think the Guinness Book of World Records has not accepted his claim. Next. And maybe many people may have recognized this particular old lady, that is Jeannie Calment, who is the person who has lived longest. Till now, the Guinness World Book Record goes with her only. She has lived for 122 years and 164 days. And maybe you'll all be surprised that, she is holding a cigarette in her mouth. And she continued to smoke till the age of 117 years. And even during her 117 years, she was still continuing to smoke. And all these people who are centenarians or super centenarians, you will be surprised to know that they continue to their habits. Many people continue to smoke, many people continue to consume alcohol, and none of them went to the gym, none of them exercised, but still they continue to live those many years. Maybe that was because the other lifestyle change they had, or maybe that they had very good genes. And I'll just like to tell you about pockets of areas wherein people, more number of centenarians are concentrated. These are the 5 areas of the world which was recognized by Dan Buettner, who is a National Geographic writer, and he in 2007, I think, came across these particular areas, recognized these particular areas, and he has written around, say, 5 books only on these particular areas, blue zones. What are they? One is situated Loma Linda in California, Costa Rica in Central America, Sardinia in Italy, Icaria in Greece, and Okinawa in Japan. So these are the areas wherein more number of centenarians are located. Why I'm just telling you this is because they had certain habits which made them, because that in those areas only centenarians are concentrated. So those particular habits I'd like to just summarize as to what all they did that made them live longer. Common habits which made them live longer is they moved naturally, worked in the fields, they did not go to the gym, they did not run, they did not exercise, but they worked in the fields. Food intake, only 50% of their capacity. What is the food type that they ate? Locally grown vegetables, fruits, and fish. And they belong to a particular faith, non-atheist. Still they believed on God. They all had a purpose of living, what is called as ikigai amongst the Okinawan islanders in Japan. They all had a purpose. What is the next thing that, the morning you get up from the bed, why I am living? What should I be doing? So that is the purpose of life. And they all stayed in joint families. Parents stayed with their children, or maybe reverse you can say, the children stayed with their parents. And they had good social and community support. So all these things made them live longer. And very often, you all know that there are more number of women centenarians than the men. And very often, women outlive men. And non-communicable diseases like hypertension, diabetes, cancers are not commonly seen in amongst these centenarians or super centenarians. Now, let's go to this particular branch of science, which is called as longevity science. It's a different branch of medicine. We have not learned about this particular in our day-to-day curriculum, or probably it is still not being taught in any of the medical colleges, in which prolonging the duration of health span, it is also called a geroscience or life extension science. What is the aim of this particular science? Aim is to study the biology of aging and senescence of cells and strategies to prevent them at various stages. And what are the diseases that are associated with aging? See, very often you have a set of diseases as you grow older. What are these diseases? They have aches and pains, they have got joint deformities, they have got osteoarthritis, they have got deformity of the spine, they have chronic joint pain and things like that. And they lose their teeth, they don't see, or visual dimness is there, hearing loss is there, and mental ailments are also pretty common. Depression, cognitive impairment, anxiety, memory diseases, bipolar disorder. And the other thing is non-communicable diseases like heart disease, cancer, diabetes, hypertension, and chronic lung diseases. So what all we have done so far is that we have only conquered the communicable diseases, and non-communicable disease have increased. So non-communicable disease have increased. That's the reason as to why our lifespan has increased. Now the next question is death inevitable? The person all who are born, should they necessarily die? Well, yes, the answer for the present and for many more decades is yes. I think a man who is born needs to be dead probably at some time, maybe 110, 120, but he is necessarily going to die. But these particular answers may not hold after some particular years. Maybe after the turn of the century, I'll go to that. And who is that? Jellyfish and hydra are the only organisms which do not die. In the last few years, the average lifespan has increased in most countries. Can death be conquered? So, what is the answer? It could be maybe, yes, no. But after about, say, at the turn of the century, say when we end of this particular century or the next century, maybe the answer is yes. But definite answer yes is, can we increase our healthy longevity? Can we increase the duration of life in which we stay healthy? The answer is a definite yes. Now, the question is, old age, is it a disease or is it a natural process? What the WHO says is that, WHO considers it as a disease now. From when? That is, in 2019, they proposed to include it as a disease in International Classification of Diseases 11, and in 2022, it was accepted. Then now let us see as to why we age. Why should we age at all? What is the why at all we are aging? That is because the basic unit of anybody's is the body is there. We are all constituted of multiple millions and billions of cells in our body, and aging of the cells results in aging of the body. So the cells age, and that's the reason as why our body also ages. Why we age? What is the reason that, why should our cells also age? That is called a cell senescence, or they become senile, or they become old. While aging of the body, cells become senile or old, they no longer divide. Once the cells are senile, they no longer divide and stop their normal functioning. Why we age? What is the reason as to why you should age? Apart from senescence, it is what is called as inflammaging. So this is a new term which includes inflammation and aging. So it is a chronic low-grade inflammation due to old age, affects all organ systems of our body. Mainly senescent cells are responsible for this. Senescent cells induce senility in the neighboring cells. Not only that particular cell is senile or senescent, but it affects the neighboring cells also and makes them old. Now, this is the why should we study aging at all? What is the reason that we should be studying aging? Study of the aging cell may give a clue to the management. So, how we are going to treat these particular cells? Halting this process or reversing may suggest management strategies. So, in order to know the management strategies, we do it. Now, since we are going with the cells as to why we are aging, we should also know what are the different important parts of a cell which age and whether can it be prevented. So now the most important part of our cell is DNA. You all agree and you all know that it's a DNA. Most important part of any cell, DNA is affected because of the oxidative stress. I think, free radicals, oxidation and all that, you all know. And is DNA repair possible? Yes. DNA can be repaired, or DNA has got the inherent capacity to get itself repaired. How do you do it? By diet, exercise, and lifestyle modifications and antioxidants. Where are the antioxidants? I think I'll tell you in the next few this thing. And what are the other different parts or cell parts? And so once we know the DNA, now comes the chromosomes and the telomere and aging. So cell nucleus is there, telomere is there, DNA. So what are telomeres? So telomeres, I think the red cap that you are seeing in the first figure is the telomere. So protective caps to the chromosomal ends are telomeres. And what are the functions? They protect the terminal portions of the chromosome. With each cell division, the telomeres shorten, and cell division arrests once the telomere reach a critical length, and telomere shortening is associated with aging. The first figure that we see, the telomere is intact. The lower figure, you can see that the telomere is cut off. It's of course a diagrammatic representation. Telomere is shortened. And what is telomerase? Or telomerase is an enzyme that elongates the telomeres. Telomerase enzyme reduces with aging, reactivation of this particular enzyme arrests and prevents aging. Telomerase reactivation is also possible. So telomerase reactivation is due because of we can do it with healthy food, exercise, and lifestyle change. And what are the other parts of the chromosome? So chromosome contains genes, and what are the genes do when aging is there? Can the genes be changed? No, we cannot change our genes. We cannot change our parents. So we are born with certain genes and we continue to have those particular genes. The answer is a definite no. Can they be modified? Yes, the gene, we can modify the genes, but we cannot change them. So these are called as epigenetic changes. We can alter the gene expression. We can switch on the good genes. Lifespan is determined by the genetic constitution only to the tune of 25%. Other 75% depends upon our daily behavior and lifestyle to the tune of 75%. So don't be under the impression that, whatever, how many years we live, it only depends on the genes that we have. Some people say that, whatever I do, I will not live beyond 50 years or 60 years because my genes are not good. My parents have all expired at an early age. No, not necessarily. So 75 years, 80 years, whatever, it all depends upon the lifestyle that you lead. And the other important part of a cell is mitochondria. And what happens? Mitochondria are affected during aging, dysfunction, and death leads to defective energy production. Can they be revived, mitochondria? Yes, they can be revived. How? By what is called as autophagy, which is triggered by calorie restriction and fasting. We'll go to what is autophagy in the next slides. So, and there are certain important proteins which are released. These particular proteins are secreted by ribosomes on the instruction of the DNA by the RNA to the ribosomes. So these three proteins are very, very important, but only because of short of time, I'll not be able to give you all the details, but I'll just mention them. What are these particular proteins? Because these are the three proteins which increase autophagy, and autophagy is one which is going to increase our healthy longevity. So the proteins are these are protein kinases, sirtuins, AMPK, or it is activated protein kinase, and mTOR, it's also known as mammalian target of rapamycin. I think I'll be mentioning about rapamycin a little later. All these stimulate autophagy and prevent aging. The most important step in healthy longevity is autophagy. What is autophagy? Autophagy, as the name itself indicates, it is self-swallowing of the cellular parts. So it the cell swallows its own parts, it devours the cell, and it reuses the bits and pieces that it has swallowed. So all are not driven out or excreted, and these renews itself from the junk that is there and functions efficiently. So it uses its own parts and prevents itself, and it's one of the main agenda in preventing aging. This particular, see, autophagy you are already seeing in this particular figure. Lysosome it lyses the cell parts and then it reuses. Can you induce autophagy? Yes, we can induce autophagy. And how can we do it?
Sir, time up, sir.
Okay. Can we reduce calorie restriction, switching on high carb diet and all that? Now, I think the most important part of the talk is, what are the interventions to arrest aging? So these are very important because these are the interventions we need to undertake for aging to arrest. So what are the diet? Most important is dietary intervention. So what are the dietary interventions? Dietary interventions is, supposing we have, we know that, diabetes, hypertension, pre-diabetes, we need to reverse them. And then low calorie diet, low carbohydrate diet have been successful to some extent in reducing weight and insulin resistance. Ideal body weight management is also necessary. And now most important is the use of fruits and vegetables in the diet. What is the WHO recommendation? The recommendation is 400 grams of fruits every day, out of which 300 grams need to be vegetables and 100 grams of fruits. So fruits of different colors are necessary because they give you a lot of antioxidants, minerals and other things.
Sir, time is short, sir. Excuse me. Sir.
Kindly give me another 5 minutes because now the main talk has just started. It's the main talk has just started, and if you cut me short here only, probably the entire purpose is defeated. Kindly. Okay. Now, what are the poisons that we take in our daily life? Don't think that these are poisons in the literal sense. No, because I think these are, we call them as poisons only because we continue to swallow them, eat them every day in our day-to-day life, and as long as we keep on eating, it definitely is going to act as poison. So what are they? Sugar, refined wheat flour, white polished rice, salt, bakery products, fast food, saturated fatty acids, tobacco on all its forms, polluted water, and then fasting. Fasting, what does it do? It increases the autophagy. Types of fasting, prolonged fasting and intermittent fasting. This particular fasting is very commonly practiced, 16 hours and 8 hours, 16 hours the fasting duration, 8 hours the fed time. And now coming to the most important intervention that is necessary, this is exercise and longevity. So exercise is the single most effective intervention. No drug can do this particular magic. Reduces mortality by 14%. Little exercise is much better than nothing at all. Those who are sedentary, their mortality risk is equivalent to those who have long-standing diabetes. Exercise and longevity. So you need to have good muscle mass. So to have a good muscle mass, you need to exercise and you need to be trained in exercise. And exercise in what are the recommendations for exercise? The recommendation is moderate intensity aerobic exercise for 150 minutes per week and muscle strength building exercise, balance activities. Yoga is another type of exercise. Meditation, I just don't want to go because already I think so much of disturbance is going on here. What is the importance of sleep? This is most important, as important as exercise. You need to have shorter the sleep, shorter the lifespan. So you have good sleep. Good sleep is essential. Sleep deprivation leads to hypertension, insulin resistance, diabetes, obesity. Sleep hygiene, all these things you need to practice. I don't want to go into the details, but at least early to bed, early to rise, maintain some, most important is no electronic gadgets near the bed. Mobile phones and your laptop should be switched off at least 1 hour before you go to the bed. The chronic stress has ill effects. It leads to hypertension, diabetes, and many other problems. And you need to have a very good, strong relationships to have good family relations. You should have community relations and then social relations. Prevention of falls is as important, because I think as old age progresses, falls are quite common. You may have fractures and may be bedridden. And this particular drug, rapamycin, is the most important promising life extension drug. Unfortunately, I cannot tell anything. And the other important drug is metformin, is a miracle drug. You all know that it's only used for diabetes, but it has been approved by the WHO, not for using day to day, but for longevity studies. There's a study called as TAME trial, which is ongoing. The results are likely to be out not till 2026. Till such time, it is still not given any approval. These are the other drugs which are there. These are the vaccines: influenza vaccine, pneumococcal vaccine, herpes zoster vaccine. and you need to undergo periodical health checkups, and then you need to age gracefully. You should have positive attitude and all that. What I just want to wish to stay upon these two particular slides. That is what is the take-home message? Most important is diabetes, then number one killer. Whatever you do, please prevent it. Reverse pre-diabetes, diabetes, and insulin resistance, because this is the one which is going to affect your longevity. Maintain ideal body weight, BMI, don't be obese, no abdominal obesity. Main reason for all metabolic ills is obesity. Measure your abdominal circumference at least once a year. Exercise is the most important item in the list of healthy life. Recommendation of 150 minutes per week, maybe less, but doing something is better than nothing. Try your best to be fit for your age, or even a little more. Adequate rest and relaxation is must. Sleep a minimum duration of 7 to 8 hours. Keep harmonious relations with the family, friends. Know your risk factors and keep them under check. Periodical checkups. Keep yourself updated about your health status. Most important, I would like to impress upon you all once again that begin all these in the early part of the midlife, not when you become old. Even people who are, say, for 35, 40, you start your, take care of your health so that definitely you reach the target. Accept old age gracefully and enjoy it with dignity and grace. Be the guiding spirit to the younger generation. So, with this, I think all this, I would only tell that, with whatever talk so far I have given, maybe I think, because you are all young people who are sitting here, are the torch bearers who are going to continue these advice in the
Please,
community.
sir.
Okay, finish.
Thank you very much. And I thank Dr. Annappa A. Pangi. He has done very wonderful now. Just now he spoke very well. It is an endowment, that IMAKSP endowment oration on a journey towards healthy longevity. I'll appreciate, I acknowledge, I thank you very much, sir.
Thank you, sir. Now I request our own chairpersons felicitate our honorable orator, Dr. Annappa A. Pangi.
We sincerely apologize for shortage of time. Please do not be.
We sincerely apologize for the shortage of time. Thank you so much, Dr. Annappa Pangi, sir. Can we have a big round of applause, please?
ಈ ನಾಡಗೀತೆ ಹಾಡತ್ತಲ್ರಿ ಹಾಡನ್ನ ಮಾತಾಡ್ಸ್ಕೊಳ್ಳೋದು ಮತ್ತೆ ಮತ್ತೆ ಎರಡು ಹಾಡಬೇಕು ಮೂರು ಹೋಲ್ಸೇಲ್ ಹೆಚ್ಚಿಲ್ಲ ಇಲ್ಲಿ ಮಾಡ್ಕೊಂಡು
Thank you, sir. Thank you, our honorable chairpersons, for their presence.
Good afternoon. Good afternoon, everyone. There's a small announcement. 90th MEDICON 2024 will be hosted by IME Yelahanka branch on 25, 26 and 27th of October 2024. Early bird registration, please contact the reception counter at the ground floor. Welcome you all to Yelahanka for MEDICON 2024. Distance, is it? Okay. Yeah, welcome you all to IMA Yelahanka for 90th MEDICON 2024, which will be hosted by Yelahanka branch on 25th, 26th and 27th of October 2024. For early bird registration, please contact the reception counter at ground floor, Bidar Medical College, Bidar. Thank you.
Yeah, sir, sure. Where are they?
ಎಸ್ಕಾರ್ಟಿಂಗ್ ನೀವು ಅನೌನ್ಸ್ ಮಾಡಬೇಕು. ಅದು ಬ್ರೀಫ್ ಆದ್ಮೇಲೆ ಎಸ್ಕಾರ್ಟಿಂಗ್ ಚಂದ್ರಕಾಂತ್ ಪಂಚಾಯತಿ ಸರ್ ರೆಡಿ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ರಿ.
Namaste and a very good afternoon to all. I'm Dr. Sudhira Sulgante, Assistant Professor from Community Medicine Department.
And I am Dr. Sanchita, Postgraduate Student of Physiology Department.
We take this privilege to extend a warm welcome to our distinguished guests and the beloved participants who have assembled here to inaugural function of the scientific session of the 89th Annual Medical Conference, MEDICON 2023, which is organized by the Indian Medical Association, Karnataka State Branch. We take this pride as this event is being hosted by the IMA Bidar branch in our very own institute, BRIMS. This conference is aimed to foster a collaborative environment for the exchange of ideas and advancement in medical science and to provide a forum for the fruitful discussion and networking opportunities among participants.
Throughout the course of this event, you can expect engaging presentations and interactive sessions led by renowned experts in their respective fields. Whether you're a seasoned professional or a budding researcher or a dedicated student, this event has been curated to cater a diverse audience with varied interest in the medical domain. So I welcome you all to enjoy a mesmerizing day. Thank you.
We are honored to have among us the distinguished array of personalities who have played pivotal roles in the areas of healthcare, medical education, and administration.
Their presence has amplified the significance of this event. I would like to extend a warm invitation to the following dignitaries to grace the dais.
I invite Dr. Shivkumar Lakkol sir, President IMA Karnataka State Branch, who will preside over the function. I invite Dr. S. Srinivas, incoming President IMA Karnataka State Branch.
I invite Dr. Vijayashri Bashetty ma'am, Senior Consultant, Obstetrics and Gynecology, the organizing chairperson of the conference, to kindly come on stage.
I invite Dr. V.V. Chinnivalar, President-elect, IMA Karnataka State Branch, to come over the dais.
I invite Dr. Chandrakant Gudge sir, Senior Physician and the organizing chairperson, to kindly come on stage. I invite guest of honor, Dr. Shivkumar Shetkar sir, the director of BRIMS, to kindly come up on stage. I invite Dr. Mallikarjun Panshetty sir, Assistant Professor, Anesthesia Department of BRIMS, and the organizing secretary of this conference, to kindly come up on the stage. I invite Dr. Shantala Kaujalgi ma'am, Professor and Head of Department of Pediatrics Department, BRIMS, and the Scientific Committee Chairperson, to kindly come up on the stage.
I kindly request Dr. Shivkumar Shetkar sir to escort our chief guest, Dr. Sharan Prakash Patil sir and Shri Bhagwan Koba sir over the dais. Shri Bhagwan Koba is the Honorable Minister of State for Chemical and Fertilizers, New and Renewable Energy in the Government of India. Welcome, sir. Dr. Sharan Prakash Patil sir is the Honorable Minister for Medical Education and Skill Development, Government of Karnataka.
I request Dr. Mallikarjun Panshetty sir to escort on stage both our chief guests, Mr. Rahim Khan and Dr. Chandrasekhar Patil sir, on stage. Mr. Rahim Khan is the Honorable Minister of Municipal Administration and Hajj, Government of Karnataka. We welcome you, sir. Dr. Chandrasekhar Patil sir is MLC Humnabad. We welcome you, sir.
A prayer.
Let us warmly welcome our dignitaries with a loud round of applause. I request Dr. Mallikarjun Panshetty sir to escort Mr.
Tell about the Rahim Khan, sir, about his what is
Mr. Rahim Khan is the Honorable Minister of Municipal Administration and Hajj, Government of Karnataka. We welcome you, sir.
I request Dr. Vaijnath Madna sir, IMA President, Bidar branch, to come over the stage. Welcome, sir. A prayer is not merely asking, it is an act of putting oneself in the hands of God. Let us formally commence the event with the blessings of the Almighty. I now invite Mr. Shivkumar Panchal to sing an invocation song.
ಸೂರ್ಯನುದಯ ತಾವರೆಗೆ ಜೀವಾಳ ಚಂದ್ರಮನುದಯ ನೈದಿಲೆಗೆ ಜೀವಾಳ ಕೂಪರ ಠಾವಿನಲ್ಲಿ ಕೂಟ ಜೀವಾಳ ವಲಿದ ಠಾವಿನಲ್ಲಿ ನೋಟ ಜೀವಾಳ ಕೂಡಲ ಸಂಗನ ಶರಣರ ಬರವೆಮಗೆ ಪ್ರಾಣ ಜೀವಾಳ ಪ್ರಾಣ ಜೀವಾಳ ಸೂರ್ಯನುದಯ ತಾವರೆಗೆ ಜೀವಾಳ ಚಂದ್ರಮನುದಯ ನೈದಿಲೆಗೆ ಜೀವಾಳ ಜೀವಾಳ ಜೀವಾಳ. ಧನ್ಯವಾದ. ನಾಡಗೀತೆ ತಾವೆಲ್ಲರೂ ಎದ್ದು ನಿಲ್ಲಬೇಕು. जय भारत जननीय तनु जाते जय हे कर्नाटक माते जय सुंदर नदी वनಗಳ ನಾಡೆ ಜಯ ಹೇ ರಸ ಋಷಿಗಳ ಬೀಡೆ ಭೂದೇವಿಯ ಮಕುಟದ ನವಮಣಿಯೇ ಗಂಧದ ಚಂದದ ಹೊನ್ನಿನ ಗಣಿಯೇ ರಾಘವ ಮಧುಸೂದನರವತರಿಸಿದ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜನನಿಯ ಜೋಗುಳ ವೇದದ ಘೋಷ ಜನನಿಗೆ ಜೀವವು ನಿನ್ನಾವೇಶ ಹಸುರಿನ ಗಿರಿಗಳ ಸಾಲೆ ನಿನ್ನಯ ಕೊರಳಿನ ಮಾಲೆ ಕಪಿಲ ಪತಂಜಲ ಗೌತಮ ಜಿನನುತ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಶಂಕರ ರಮನುಜ ವಿದ್ಯಾರಣ್ಯ ಬಸ ಪಂಪಲ ಕುಮಿಪತಿ ಜನ್ನ ಕುಮಾರ ವ್ಯಾಸರ ಮಂಗಳಧಾಮ ಕವಿ ಕೋಗಿಲೆಗಳ ಪುಣ್ಯಾರಾಮ ನಾನಕ ರಾಮಾನಂದ ಕಬೀರರ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ತೈಲಪ ಹೊಯ್ಸಳರಾಳಿದ ನಾಡೆ ಡಂಕಣ ಜಕಣರ ನೆಚ್ಚಿನ ಬೀಡೆ ಕೃಷ್ಣ ಶರಾವತಿ ತುಂಗಾ ಕಾವೇರಿಯವರ ರಂಗಾ ಚೈತನ್ಯ ಪರಮಹಂಸ ವಿವೇಕರ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಸರ್ವ ಜನಾಂಗದ ಶಾಂತಿಯ ತೋಟ ರಸಿಕರ ಕಂಗಳ ಸೆಳೆಯುವ ನೋಟ ಹಿಂದೂ ಕ್ರೈಸ್ತ ಮುಸಲ್ಮಾನ ಪಾರಸಿಕ ಜೈನ ರುದ್ಯಾನ ಜನಕನ ಹೋಲುವ ದೊರೆಗಳ ಧಾಮ ಗಾಯಕ ವೈಣಿಕರಾರಾಮ ಕನ್ನಡ ನುಡಿ ಕುಣಿದಾಡುವ ಗೇಹ ಕನ್ನಡ ತಾಯಿಯ ಮಕ್ಕಳ ದೇಹ ಭಾರತ ಜನನಿಯ ತನುಜಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ ಜಯ ಹೇ ಕರ್ನಾಟಕ ಮಾತೆ. ಧನ್ಯವಾದ.
Thank you for such a melodious performance.
Let's all rise once again for IMA prayer led by Dr. Madhusudan Kariganuru, past president of IMA Karnataka State Branch. Everybody please rise for IMA prayer. Dr. Madhusudan Karigan.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜನೆಗೆ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸತಕ್ಕಂಥ ಫ್ಲಾಗ್ ಸ್ಯಾಲ್ಯೂಟೇಷನ್. We the members of Indian Medical Association stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited member of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Thank you, sir.
We shall now proceed to our tradition of watering the plant and seek the blessing of Mother Earth. I request all the dignitaries to please do the honor of watering the plant. Speech, welcome speech.
Bye.
Welcome speech. She's here only. Yeah. She's on stage. That's sitting on stage.
Thank you, everyone. I request all the dignitaries to please take their seat.
It is my distinct honor to invite Dr. Vijayashree Bashetti ma'am, Senior Consultant in Obstetrics and Gynecology and the organizing chairperson of this conference, to deliver the welcome speech. She is a visionary woman and a source of inspiration to all of us. Without any further ado, I welcome ma'am.
ಜ್ಞಾನದ ಬಲದಿಂದ ಅಜ್ಞಾನದ ಕೇಡು ನೋಡಯ್ಯ, ಜ್ಯೋತಿಯ ಬಲದಿಂದ ತಮಂದದ ಕೇಡು ನೋಡಯ್ಯ, ಸತ್ಯದ ಬಲದಿಂದ ಅಸತ್ಯದ ಕೇಡು ನೋಡಯ್ಯ, ಪರುಷದ ಬಲದಿಂದ ಅವಲೋಹದ ಕೇಡು ನೋಡಯ್ಯ, ಕೂಡಲ ಸಂಗನ ಶರಣರ ಅನುಭವದಿಂದ ಎನ್ನ ಭವದ ಕೇಡು ನೋಡಯ್ಯ. ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಎವ್ರಿಬಡಿ. Indian Medical Association of Karnataka State, Bidar branch and branches from Basavakalyan and Humnabad have immense pleasure to welcome you all for the 89th Annual Medical Conference, MEDICON 2023, at the northernmost district, crown of Karnataka, Sharanara Bidar. I welcome Dr. Shri Bhagwant Khuba, Sir, Honorable Minister of State and Chemical and Fertilizers, New and Renewable Energy under Government of India. I welcome you, sir. I welcome Dr. Chandrasekhar Patil, MLC. Thank you, sir. Welcome you, sir. I welcome Dr. Shri Sharan Prakash Patil, Honorable Minister of Medical Education and Skill Development, Government of Karnataka. Sir, as you came all the way from Bangalore to Bidar in your busy schedule to grace the occasion, I welcome you, sir. I welcome Shri Rahim Khan, Honorable Minister for Municipal Administration and Hajj, Government of Karnataka, as we feel proud that you are from Bidar and you spared your valuable time to grace the occasion. I welcome Dr. Ajay Singh, Chairman, AKRDB Kalburgi, as you come to be there to magnify the beauty of 89th MEDICON 2023. I welcome our beloved President, Dr. Shivkumar Lakol, President IMA Karnataka State, as you guided us to make the event graceful, and your presence is a bliss for us. Welcome you, sir. I welcome Dr. Shivkumar Shetkar, Director BRIMS, Bidar. With your cooperations and guidance, the event is possible. Welcome you, sir. I welcome Dr. Srinivas, President-elect, IMA Karnataka State Branch, as you. I welcome Dr. Chiniwalar, the next President-elect, IMA Karnataka State Branch. I welcome Dr. Chandrakant Gudge, Organizing Chairperson, as you guided in every step to make the event cheerful, and welcome you, sir. I welcome Dr. Shantala Kausalgi, HOD Pediatrics, Department of BRIMS, Bidar. As you worked day and night for organizing scientific sessions with your team, welcome you, ma'am. I welcome Dr. Mallikarjun Panshetti, Secretary IMA Bidar, dynamic, young and energetic doctor, worked day and night to make the event graceful. Welcome you, sir.
We welcome Mr. Gauss, CMC Chairman, Bidar, over the dais. Welcome, sir. Apologies for the delay in welcome.
It's not complete till I welcome all the delegates from all over the Karnataka, traveled all the way to Bidar to make the event wonderful, as you are the backbone of the occasion. Once again, I welcome all the doctors from Bidar, worked hard to make the event to happen. Event to communicate the auspicious medical knowledge to the public. Thank you, one and all. Thank you.
Thank dignitaries present over the dais. I request Dr. Shivkumar Lakol, sir, to felicitate Sri Bhagwan Kubba, sir. I request Dr. S. Srinivas to felicitate Dr. Sharan Prakash Patil, sir. I request Dr. V. Chinniwalar, sir, to do the honors to Mr. Rahim Khan.
I request Dr. Chandrakant Gudge sir to hand over the memento to Dr. Chandrasekhar Patil sir. I request Dr. Mallikarjun Panshetty sir to felicitate Dr. Shivkumar Shetkar sir.
I request Dr. Vijayashree Bashetti ma'am to honor Dr. Shivkumar Lakol sir. I request Dr. Shantala Kaujalgi ma'am to felicitate Dr. S. Srinivas sir. I request Dr. Vaijanath Madhu sir to felicitate Dr. Gauss sir, the CMC chair. So we are very thankful to you as you have helped us in keeping our BRIMS campus very clean. Thank you, sir. I invite Dr. Veer Bhadraya, sir, KMC member on the dais. Welcome, sir. I request Dr. Mallikarjun Panshetty, sir, to felicitate Dr. Veer Bhadraya, sir. I request Dr. Chandrakant Gudge, sir, to felicitate Dr. V.V. Chinniwala, sir. On this occasion, we would like to take this opportunity to introduce an official publication of IMA Karnataka State Branch, the Karnataka Medical Journal. We request our chief guest, Dr. Sharan Prakash Patil sir, to release the journal. I would like to invite Dr. S.Y. Mulki Patil, the chief editor of this journal, on the dais.
Dr. B.P. Karnakaras, Honorary Secretary, IMA KSB, please.
Good afternoon, respected dignitaries on the dais, Honorable Medical Education Minister Sharan Prakash sir, Honorable Central Minister Kuba sir, Khan sir, and all the dignitaries on the dais of the dais. Myself, Dr. Mulki Patil, Associate Professor, KIMS Hubli, and working as a Chief Editor, the most awaited IMA KSB journal, that is Karnataka Medical Journal. Due to various reasons, the journal has been stopped since many years. Now, it is the era of evidence-based medicine, as IMA's objective is to taking care not only the doctors, but also update on the medical education by means of medical research. It is important for the person who are working in the medical colleges like us as a part of the curriculum to have the publication. Equally, it is important for other colleagues, medical doctors working in a rural setup, because we have a lot of material in the day-to-day practice. Unless we keep a data, update, publish it, our work is not recognized globally. In this regard, IMA Central Branch, that is JIMA, Journal of Indian Medical Association, it is publishing almost more than 90 years, and the famous journal, it is indexed as per NMC. Sir. In this, releasing the most, our defaulted journal, that is IMA KMJ, that is Karnataka Medical Journal. So this journal is we are planning to index internationally. Our editorial board members are from the USA and from UK, and also our own members from Karnataka and across India. So it is proud moment for us to release this on this special occasion in the ಬಸವಣ್ಣನ ನಾಡು ಆದ ಬೀದರ್ದಲ್ಲಿ ಇದು ರಿಲೀಸ್ ಮಾಡಲಿಕ್ಕೆ ನಮ್ಮೆಲ್ಲರಿಗೂ ಕೂಡ ಹೆಮ್ಮೆಯ ವಿಷಯ. For the sake of members, all the scientific journals, they are charging the publication charges, sir, but the KMJ, we are not charging for any publication of a scientific material. So it is free for the members for their academic work. Kindly take use of this. Without wasting much time, I just want to quote in one Kannada, ಬಸವಣ್ಣನ ನಾಡಿನಲ್ಲಿ MEDICON 23ಯಲ್ಲಿ ಶಿವಕುಮಾರನ ಅಧ್ಯಕ್ಷತೆಯಲ್ಲಿ ಶ್ರೀ ಶರಣ ಪ್ರಕಾಶ್ ಪಾಟೀಲ್ ಸಾಹೇಬರ ಒಂದು ಹಸ್ತದ ಮುಖಾಂತರ ತಮ್ಮೆಲ್ಲರ ಸಮ್ಮುಖದಲ್ಲಿ ನಮ್ಮ KMJ ಬರ್ತಾ ಇದೆ. I request the dignitary to release the journal. Thank you.
ಏನಂತ ಬಾಗಲಿದ್ರೆ ನೀವೇ ಆ ಗ್ಯಾಂಗ್ದಾಗ ಹೋಗಿ ಗುಚ್ಚಾಕ ನಾನು ತಿಳ್ಕರಬೇಕು. ನೆಕ್ಸ್ಟ್ ಬುಕ್ ರಿಲೀಸ್
I now request Dr. Shivkumar Lakol sir to release a book, Aharadinda Arogyadedege. The author of this book is Dr. Pangi. I invite Dr. Naz, General Surgeon, Senior Consultant Hospital, to brief us about Breast Cancer Awareness Month.
Pens, please. Thank you. Yeah, ಕೊಡ್ತೀನಿ. Yeah, you put.
A very good afternoon, ladies and gentlemen, respected dignitaries on the dais and off the dais. At the outset, I would like to thank IMA Bidar branch, the organizers of MEDICON 2023, for giving me this wonderful opportunity. October is the pink month, the month to spread about breast cancer, awareness for breast cancer. Breast cancer, all of you know, is emerged as the #1 cancer in our country, and the incidence is increasing every day. Every 4th minute, one breast cancer is being detected, and this is the tip of the iceberg. And it is important for all of us to detect breast cancer at an early stage, because the longevity is better and the treatment is better when it is detected early. Our women colleagues, that is our FOXY members, have done a wonderful job by screening for cervical cancer and have brought the incidence of cervical cancer drastically. So this, if they join hands with us, we can all detect breast cancer early through screening for breast cancer. And that can be done by a monthly self-breast examination, a yearly clinical breast examination, and screening mammography for every woman above 45 years every 2 years. So that is the way we detect breast cancer early, and this is how each one of us can participate. We can tell every woman who comes across us to go for this pattern of examination. And one more thing is, anybody who finds a lump in the breast should never ignore the breast lump, and it has to be, they have to undergo a triple test, that is a clinical breast examination, imaging, and followed by a biopsy. See, these things have to be done for every breast lump, and each one of us will pledge today to spread the message of breast cancer. And through this MEDICON in Bidar, IMA KSB takes the opportunity to spread the awareness of breast cancer and early detection through screening. Spread the message of awareness of breast cancer, spread the pink of health far and near. Thank you once again. Thank you one and all.
Now I request Class 1 contractor Dr. Sri Gurunath Kollur sir to come on the dais, please, sir, for his generous contribution for the conference. Please come on the stage. Chair. I request our Central Minister Kuba sir and Shan Prakash Patil sir to fill the stage.
सर एक रिक्वेस्ट है यहाँ पर कहने में पूरे पूरा बैकग्राउंड अच्छा नहीं आ रहा तो यहाँ पर सकते हैं पूरा बैकग्राउंड साथ में
Thank you, sir. I also welcome the backbone of the conference who are giving wide coverage throughout the Karnataka and throughout the nation, the press, the print and the electronic media to this conference. I welcome all of them. I also thank restless support from the police department who's supporting for this conference. I thank the police department also. Now I request Dr. Shweta Kunikeri to welcome Dr. P. Karunakar sir, Secretary IMA KSB. I also request Dr. Shweta to welcome Dr. Chandrakant Budge sir, Chairman of this conference. I also request Dr. Shweta to welcome Dr. Bashatti Madam, Organizing Chairperson of this conference. I request Dr. Shweta Kunikari to welcome the scientific chairman, the backbone of the conference, the scientific feast, Dr. Shantala Kojalgi Madam. Dr. Shweta Madam to welcome the secretary of the organizing secretary of the conference, Dr. Panchatti sir. I request Dr. Shweta to welcome the President IMA, Dr. Vaijanath Madna sir.
Now I would like to welcome Shri Bhagwat Kuba sir. Esteemed participants, we are delighted to have Shri Bhagwat Kuba sir, the Honorable Cabinet Minister, today with us. Sir, I request you to speak a few words.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆ 89ನೇ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನ MEDICON 2023 ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದ ಮುಖ್ಯ ಅತಿಥಿಗಳಾದಂಥ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಹಾಗೂ ಕೌಶಲ್ಯ ಅಭಿವೃದ್ಧಿ ಸಚಿವರು ಆತ್ಮೀಯರಾದಂಥ ಡಾಕ್ಟರ್ ಶರಣ್ ಪ್ರಕಾಶ್ ಪಾಟೀಲ್, ಇನ್ನೋರ್ವ ಮಾನ್ಯ ಪೌರಾಡಳಿತ ಹಾಗೂ ಹಜ್ ಖಾತೆಯ ಸಚಿವರಾದಂಥ ಆತ್ಮೀಯರಾದಂಥ ಶ್ರೀ ರಹೀಂ ಖಾನ್ ಅವರೇ, MLCಗಳಾದಂಥ ಸೋದರ ಚಂದ್ರಶೇಖರ್ ಪಾಟೀಲ್ ಅವರೇ, ನಗರಸಭೆ ಅಧ್ಯಕ್ಷರಾದಂಥ ಗೌಸುದ್ದೀನ್ ಅವರೇ, ಸಮಾರಂಭದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸಿದಂಥ ಮಾನ್ಯ ಅಧ್ಯಕ್ಷರು IMA ಕರ್ನಾಟಕ ಶಾಖೆ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಲಕ್ಕೋಳಲ್ ಅವರೇ, ಬ್ರಿಮ್ಸಿನ ನಿರ್ದೇಶಕರಾದಂಥ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಶೆಟ್ಕಾರ್ ಅವರೇ, ಚುನಾಯಿತ ಅಧ್ಯಕ್ಷರಾದಂಥ ಡಾಕ್ಟರ್ S ಶ್ರೀನಿವಾಸ್ ಅವರೇ, ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷರಾದಂಥ ಡಾಕ್ಟರ್ ಚಂದ್ರಕಾಂತ್ ಗುದ್ಗೆ ಅವರೇ, ಕಾರ್ಯದರ್ಶಿಯಾದಂಥ ಡಾಕ್ಟರ್ ಮಲ್ಲಿಕಾರ್ಜುನ್ ಪನ್ಶೆಟ್ಟಿ ಅವರೇ, ಡಾಕ್ಟರ್ ವಿಜಯಶ್ರೀ ಬಶೆಟ್ಟಿ ಅವರೇ, ವೇದಿಕೆ ಮೇಲಿದ್ದಂಥ ಎಲ್ಲ ಗಣ್ಯ ಮಾನ್ಯರೇ, ಈ ಒಂದು ಸಮ್ಮೇಳನದಲ್ಲಿ ಭಾಗವಹಿಸಿದಂಥ ನಾಡಿನ ಮೂಲೆಯಿಂದ ಬಂದಿದಂಥ ಹಾಗೂ ದೇಶದ ಅನೇಕ ರಾಜ್ಯಗಳಿಂದ ಬಂದಿದಂಥ ಎಲ್ಲ ನನ್ನ ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ಅಭೂತಪೂರ್ವವಾದಂಥ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿದಂಥ ಡಾಕ್ಟರ್ ಸಹೋದರ ಸಹೋದರರೇ ಮತ್ತು ಮಾಧ್ಯಮದ ಮಿತ್ರರೇ, ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದ ಸೇವೆಯನ್ನ ಮಾಡ್ತಿರುವಂತ ತಾರೆಯರ ಮಧ್ಯದಲ್ಲಿ ಇಂದಿನ ಈ ಸಮಾರಂಭದ ಉದ್ದೇಶಿಸಿ ಮಾತನಾಡುತ್ತಿರುವಂಥದ್ದೇ ನನಗೂ ಒಂದು ಸಂತೋಷದ ವಿಷಯ ಅನ್ನುವಂಥದ್ದನ್ನ ಸ್ಪಷ್ಟವಾಗಿ ಹೇಳ್ತೀನಿ. ಡಾಕ್ಟರ್ ಅಂದ್ರೆ ನಮ್ಮ ಮಧ್ಯದಲ್ಲಿರುವಂತ ದೇವರ ಸಮಾನವಾಗಿರುವಂತ ನಮ್ಮೆಲ್ಲರ ಭಾವನೆಗಳು. ಆ ಭಾವನೆಗಳಿಗೆ ಕಾರಣವು ಬಹಳಷ್ಟು ಸ್ಪಷ್ಟವಾಗಿದೆ. ರೋಗಗಳು ಬರುವುದು ಸಹಜವಾಗಿ, ಆದರೆ ರೋಗಕ್ಕೆ ತುತ್ತಾಗಬಾರದು. ರೋಗವನ್ನ ಗುಣಮುಕ್ತರಾಗಿ ನಮ್ಮ ಬದುಕು ಸುಂದರ ಬದುಕಾಗ್ಬೇಕನ್ನುವಂಥದ್ದು ಎಲ್ಲರ ಆಸೆ ಆಗಿರ್ತದೆ. ಆದರೆ ಗುಣಮುಖ ಆಗ್ಲಿಕ್ಕೆ ವೈದ್ಯರ ಸೇವೆ ಅವಶ್ಯಕತೆ ಮತ್ತು ಅನಿವಾರ್ಯತೆ. ಹೀಗಾಗಿ ನಾವು ದೇವರ ನಂತರ ಯಾರಿಗಾದರೂ ಪೂಜಿಸುವುದು, ಗೌರವದಿಂದ ನೋಡುವುದಾದರೆ ಅದು ವೈದ್ಯರನ್ನ ಮಾತ್ರ. ಇಂತಹ ಸೇವೆಯಲ್ಲಿ ಸದಾ ಅನೇಕ ಸಂಶೋಧನೆಗಳು, ಅನೇಕ ರೀತಿಯ ಹೊಸ ಹೊಸ ರೋಗಗಳು, ಇವೆಲ್ಲವೂ ಕಾಲ ಕಾಲಕ್ಕೆ ಬದಲಾಗುತ್ತಾ ಅನೇಕ ವಿಷಯಗಳ ಗಮನಕ್ಕೆ ಬರ್ತವೆ. ಆದರೆ ಅಪ್ಡೇಟ್ ಆಗುವುದು ಕೂಡ ಅಷ್ಟೇ ಅವಶ್ಯಕತೆವಾಗಿರ್ತದೆ ಎಲ್ಲ ಕ್ಷೇತ್ರದಲ್ಲಿ, ಕೇವಲ ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರ ಅಂತಲ್ಲ. ಪ್ರತಿಯೊಂದು ಕ್ಷೇತ್ರದಲ್ಲಿ ಹೊಸ ಸಂಶೋಧನೆಗಳಿಗೆ ನಮ್ಮ ಗಮನಕ್ಕೆ ತಗೊಂಡು ಬಂದು ಅದನ್ನ ಇಂಪ್ಲಿಮೆಂಟೇಷನ್ ಮಾಡುವುದು ಕೂಡ ಅಷ್ಟೇ ಅತ್ಯವಶ್ಯಕವಾಗಿರ್ತದೆ. ಹೀಗಾಗಿ ಇಂತಹ ಒಂದು ಸಮ್ಮೇಳನದ ಮುಖಾಂತರ ಅನೇಕರ ಅನುಭವಗಳು, ಅವರ ಮಾಡಿದಂಥ ಪ್ರಯೋಗಗಳು ಇಂತಹ ಸಮ್ಮೇಳನ ಮುಖಾಂತರ ಪ್ರತಿಯೊಬ್ಬರಿಗೆ ಹಂಚಿಕೊಳ್ಳಿಕ್ಕೆ ಒಂದು ಅವಕಾಶವನ್ನ ಸಿಕ್ಕಿರ್ತದೆ. ಈ ಸಮ್ಮೇಳನದ ಲಾಭವನ್ನ ಪ್ರತಿಯೊಬ್ಬರು ಪಡ್ಕೊಳ್ಳಿಕ್ಕೆ ಈ ವೇದಿಕೆ ಅವಕಾಶವನ್ನ ಮಾಡಿಕೊಟ್ಟಿರ್ತದೆ. ನಿನ್ನೆ, ಇಂದು ಮತ್ತು ನಾಳೆ ಈ ಒಂದು 3 ದಿವಸದ ಸಮ್ಮೇಳನದಲ್ಲಿ ಅತ್ಯಮೂಲ್ಯವಾದಂಥ ವಿಷಯಗಳು, ಚರ್ಚೆ, ಸಂವಾದ, ಮತ್ತು ವೇದಿಕೆಯ ಮುಖಾಂತರ ವಿಷಯಗಳನ್ನು ತಿಳಿಸುವುದರಲ್ಲಿ ಬಹಳಷ್ಟು ಅನುಕೂಲಕರವಾಗಿದೆ ಅನ್ನುವಂಥದ್ದನ್ನ ಭಾವನೆ ನನ್ನಲ್ಲಿ ಮೂಡಿರ್ತದೆ. ಬಂಧುಗಳೇ, ಈ ಕ್ಷೇತ್ರ ಬಹಳಷ್ಟು ಮಹತ್ವಪೂರ್ಣವಾದಂಥ ಕ್ಷೇತ್ರ. ಅದರಲ್ಲಿ ಭಾರತ ಸುಮಾರು 140 ಕೋಟಿ ಜನಸಂಖ್ಯೆ ಉಳ್ಳುವಂತ ದೇಶ. ಒಂದಾನೊಂದು ಕಾಲದಲ್ಲಿ ಇಲ್ಲಿನ ಶ್ರೀಮಂತರು ತನ್ನ ರೋಗವನ್ನು ಗುಣಮುಕ್ತ ಮಾಡಲಿಕ್ಕೆ ಅನೇಕ ಹೊರ ದೇಶಗಳಿಗೆ ಹೋಗುವಂತ ಪರಿಸ್ಥಿತಿಯನ್ನ ನಾವೇ ಅನೇಕರು ನೋಡಿದ್ದೀವಿ. ಆದರೆ ಕಳೆದ 1-2 ದಶಕಗಳಿಂದ ಭಾರತದಲ್ಲಿ ಆದಂತ ಅತ್ಯಮೂಲ್ಯವಾದಂಥ ಪರಿವರ್ತನೆ ನಿಧಾನವಾಗಿ ಈಗ ಅನೇಕ ದೇಶದ ಪ್ರಜೆಗಳು ಭಾರತಕ್ಕೆ ಬಂದು ಆರೋಗ್ಯದ ಚಿಕಿತ್ಸೆಯನ್ನು ಪಡೆದುಕೊಂಡು ಹೋಗುವಂಥ ದಿನಗಳನ್ನ ಈಗಾಗಲೇ ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಈಗಾಗಲೇ ಭಾರತ ಸರ್ಕಾರ ಹೆಲ್ತ್ ಟೂರಿಸಂ, ಭಾರತ ಮುಂದಿನ ದಶಕಗಳಲ್ಲಿ ಅನೇಕ ರಾಷ್ಟ್ರದಿಂದ ಜನ ಭಾರತಕ್ಕೆ ಬರಬೇಕು, ಆ ಗುಣಮಟ್ಟದ ಸೇವೆಯನ್ನು ಭಾರತದಲ್ಲಿ ಸಿಗಬೇಕು. ಅದಕ್ಕೆ ಇವತ್ತು ಭಾರತ ಸರ್ಕಾರ ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ಅಭೂತಪೂರ್ವವಾದಂತಹ ಸಾಧನೆಗಳನ್ನ ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಅದೇ ರೀತಿ ಈ ಒಂದು ಕ್ಷೇತ್ರಕ್ಕೆ ಮೂಲಭೂತ ಸೌಕರ್ಯಗಳ ಅಭಿವೃದ್ಧಿಗಾಗಿ ಅನೇಕ ಹೆಜ್ಜೆಗಳನ್ನು ರಾಜ್ಯ ಸರ್ಕಾರಗಳು, ಕೇಂದ್ರ ಸರ್ಕಾರಗಳು ಎಲ್ಲವೂ ಆ ಒಂದು ಪೂರಕವಾಗಿ ನಿರ್ಣಯಗಳನ್ನು ತಗೊಂಡಿದ್ದರ ಪರಿಣಾಮವಾಗಿ ಇವತ್ತು ಭಾರತದಲ್ಲಿ ಕಡಿಮೆ ವೆಚ್ಚದಲ್ಲಿ ಗುಣಮಟ್ಟದ ಸೇವೆನ ಸಿಗ್ತಾ ಇರುವುದಕ್ಕೆ ಅದೇ ಕಾರಣವಾಗಿದೆ. ತಾವು ನೋಡಿರ್ಬೋದು, 2014ಕ್ಕಿಂತ ಮುಂಚೆ ದೇಶದಲ್ಲಿ ಪ್ರತಿ ವರ್ಷ ಸುಮಾರು 47,000 ಚಿಲ್ಲರೆ MBBS ಸೀಟ್ಗಳನ್ನಿದ್ದು, ಆದರೆ ಜನಸಂಖ್ಯೆಯ ಅನುಗುಣವಾಗಿ ಕೇವಲ ಪ್ರತಿ ವರ್ಷ 47,000 MBBSಗಳ ಅಡ್ಮಿಷನ್ ಆಗಿದ್ರೆ ಜನಸಂಖ್ಯೆ ಏರ್ತಾ ಇದೆ, ಅದರ ಅನುಪಾತದಲ್ಲಿ ಇಲ್ಲ ಅನ್ನುವಂಥದ್ದನ್ನ ಕಾರಣಕ್ಕಾಗಿ ಭಾರತ ಸರ್ಕಾರ 9 ವರ್ಷದಲ್ಲಿ 61,000 ಸೀಟ್ಗಳನ್ನು ಹೆಚ್ಚು ಮಾಡಿದೆ. ಅಂದರೆ ಇವತ್ತ 47,000 ಸೀಟ್ಗಳಿಂದ ಸುಮಾರು 1,10,000 ಸೀಟ್ಗಳಿಗೆ ಪ್ರತಿ ವರ್ಷ ಇವತ್ತು MBBS ಸೀಟ್ಗಳಿಗೆ ಇವತ್ತು ಲಭ್ಯವಾಗಿದೆ. 9 ವರ್ಷದಲ್ಲಿ 2014ಕ್ಕಿಂತ ಮುಂಚೆ 395 ಮೆಡಿಕಲ್ ಕಾಲೇಜುಗಳಿದ್ದು ದೇಶದಲ್ಲಿ. ಆ 395 ಮೆಡಿಕಲ್ ಕಾಲೇಜುಗಳಿಗೆ ಜೋಡಿಸಿ 311 ಕಾಲೇಜುಗಳನ್ನ, ಹೊಸ ಕಾಲೇಜುಗಳನ್ನ ಪ್ರಾರಂಭವನ್ನ ಮಾಡಿದೆ. ಅದೇ ರೀತಿ PG ಕೋರ್ಸ್ಗಳಲ್ಲಿ ಕೂಡ ಸೀಟ್ಗಳನ್ನು ಹೆಚ್ಚಾಗಿ ವೃದ್ಧಿಯನ್ನ ಮಾಡಲಾಗಿದೆ. ಬಂಧುಗಳೇ, ಇನ್ನು ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಇನ್ನಷ್ಟು ಹೆಚ್ಚೆಚ್ಚಾಗಿ MBBS ಸೀಟ್ಗಳಾಗಲಿ, PG ಸೀಟ್ಗಳಾಗಲಿ ಮಾಡಿದಾಗ ಮಾತ್ರ ನಮ್ಮ ಜನಸಂಖ್ಯೆಯ ಏರಿಕೆಯ ಅನುಪಾತದಲ್ಲಿ ಡಾಕ್ಟರ್ಸ್ಗಳನ್ನ ಹೊರಗೆ ತರಲಿಕ್ಕೆ ಸಾಧ್ಯವಾಗ್ತದೆ. ಇವತ್ತು ನಾವು ಹೆಮ್ಮೆಯಿಂದ ಹೇಳ್ಬೋದು, ಇಡೀ ವಿಶ್ವದಲ್ಲಿಯೇ ಅತಿ ದೊಡ್ಡ ಯಾವುದಾದ್ರೂ ಆರೋಗ್ಯ ವಿಮೆ ಯಾವುದಾದ್ರೂ ದೇಶದಲ್ಲಿದೆ ಅಂದ್ರೆ ಅದು ನಮ್ಮ ಭಾರತದಲ್ಲೇ, ಅದು ಆಯುಷ್ಮಾನ ಭಾರತ ಇದೆ. ಅದು ಸುಮಾರು 55 ಕೋಟಿ ಬಡವರಿಗೆ. ಬಡವರು ಸಾಮಾನ್ಯವಾಗಿ ರೋಗ ಬಂದಾಗ ಸಾಲದ ಸುಳಿಯಲ್ಲಿ ಸಿಕ್ಕಿ ಸಾಯುವುದು ಒಂದು ರೀತಿ, ಇಲ್ಲ ಹಣದ ಕೊರತೆಯಿಂದ ಜೀವವನ್ನೇ ಕಳ್ಕೊಂಡಿದ್ದಂಥ ಅನೇಕ ಉದಾಹರಣೆಗಳನ್ನ ನಾವು ನೋಡಿದ್ದೀವಿ. ಆದರೆ ಜೀವ ಶ್ರೀಮಂತರಿಗಷ್ಟೇ, ಮಧ್ಯಮ ವರ್ಗದರಿಗಷ್ಟೇ, ಬಡವರಿಗಷ್ಟೇ. ಆ ವ್ಯಕ್ತಿಯ ಕುಟುಂಬಕ್ಕೆ ಅವಶ್ಯಕತೆ ಮತ್ತು ಅನಿವಾರ್ಯತೆ. ಅಂತವರ ಒಂದು ಜೀವ ಕಳೆದುಕೊಳ್ಳೋದು ಬೇಡ ಅನ್ನುವಂಥ ಸದುದ್ದೇಶದಿಂದ ಮಾನ್ಯ ಪ್ರಧಾನಮಂತ್ರಿಗಳು ಇವತ್ತು ಸುಮಾರು 22 ಕೋಟಿ ಜನರಿಗೆ ಆಯುಷ್ಮಾನ್ ಭಾರತ ಕಾರ್ಡ್ ಅನ್ನ ವಿತರಣೆಯನ್ನ ಮಾಡಿ ಇವತ್ತು ಕಳೆದ 3 ವರ್ಷಗಳಲ್ಲಿ ಸುಮಾರು 50,000 ಕೋಟಿ ಹಣವನ್ನ ಬಡವರ ಚಿಕಿತ್ಸೆಗೆ, ಬಡವರ ಪಾಕೆಟ್ನಿಂದ ಏನು ಖರ್ಚಾಗ್ತಿತ್ತೋ ಅದು ಉಳಿಸಿದಂಥದ್ದು ಇವತ್ತು ಕೇಂದ್ರ ಸರ್ಕಾರ ಮತ್ತು ರಾಜ್ಯ ಸರ್ಕಾರ ಎರಡು ಸೇರಿಕೊಂಡು. ಇದೇ ರೀತಿ ಕೇಂದ್ರ ಸರ್ಕಾರ 2014ರಲ್ಲಿ ನಮ್ಮ ಜನೌಷಧಿ ಕೇಂದ್ರಗಳು, ಜನರಿಕ್ ಔಷಧ ಏನಂತೀವಿ ನಾವು, ಕಡಿಮೆ ದರದಲ್ಲಿ ಗುಣಮಟ್ಟದ ಪ್ರತಿಯೊಬ್ಬರಿಗೆ ಲಭ್ಯವಾಗಿರ್ಬೇಕನ್ನುವಂಥ ಸದುದ್ದೇಶದಿಂದ ಕೇವಲ 2014ಕ್ಕಿಂತ ಮುಂಚೆ ಕೇವಲ 80 ಕೇಂದ್ರಗಳ ಮಾತ್ರ ಇದ್ದು, ಈ ಒಂದು 9 ವರ್ಷಗಳ ಕಾಲದಲ್ಲಿ ಇವತ್ತು ಭಾರತದಲ್ಲಿ 9,385 ಕೇಂದ್ರಗಳು ಬಡವರಿಗೆ ಸೇವೆಯನ್ನು ಮಾಡ್ತಿದ್ದೇವೆ. ಸುಮಾರು ಆ ಒಂದು ಕೇಂದ್ರಗಳಿಂದ ಲಭ್ಯವಾಗುವ ನಮ್ಮ ಜನರಿಕ್ ಔಷಧಗಳು ಮಾರ್ಕೆಟ್ನಲ್ಲಿರುವಂತಹ ಜನರಿಕ್ ಔಷಧ ಬ್ರ್ಯಾಂಡೆಡ್ ಔಷಧಿಗಳಿಗಿಂತ ಸುಮಾರು 80-90% ಕಡಿಮೆ ದರ. ಹೀಗೆ ಸುಮಾರು ಒಂದು 25,000 ಕೋಟಿ ಹಣವನ್ನ, ಬಡವರ ಹಣವನ್ನ ಉಳಿತಾಯವನ್ನಾಗಿದೆ. ಅಷ್ಟೇ ಅಲ್ಲ, ಫಾರ್ಮಸಿ ಲಾಬಿ, ಇಂಟರ್ನ್ಯಾಷನಲ್ ಫಾರ್ಮಸಿ ಲಾಬಿ ಎಷ್ಟು ಸ್ಟ್ರಾಂಗ್ ಇರ್ತದೆ ಅಂದ್ರೆ, ಅಭಿವೃದ್ಧಿ ಹೊಂದುವಂತಹ ದೇಶಗಳು ಮತ್ತು ಬಡ ದೇಶಗಳ ಮೇಲೆ ಯಾವಾಗಲೂ ಹೇರುವಂತ ಅವರ ಒಂದು ಸ್ವಭಾವ ಮತ್ತು ಅವರ ಒಂದು ನಿರ್ಣಯಗಳು. ಆದ್ರೆ ಇತ್ತೀಚಿನ ದಿನಗಳ ಒಂದು ಉದಾಹರಣೆ ನಾನು ನಿಮ್ಮನ್ನು ಹೇಳ್ತೀನಿ. ಭಾರತ ಯಾವಾಗಲೂ ವ್ಯಾಕ್ಸಿನೇಷನ್ ಅನ್ನು ಉತ್ಪಾದನೆಯನ್ನು ಮಾಡಿಲ್ಲ, ಸಂಶೋಧನೆಯನ್ನು ಕೂಡ ಮಾಡಿರಲಿಲ್ಲ. ಆದರೆ ಕೊರೋನಾ ಮಹಾಮಾರಿ ಭಾರತಕ್ಕೆ ಒಂದು ಅವಕಾಶವನ್ನು ತಂದುಕೊಡ್ತು. ಭಾರತದ ವಿಜ್ಞಾನಿಗಳಿಗೆ, ವಿಶೇಷವಾಗಿ ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದಲ್ಲಿರುವಂತಹ ವಿಜ್ಞಾನಿಗಳಿಗೆ 2 ವ್ಯಾಕ್ಸಿನೇಷನ್ಗಳ ನಮ್ಮಲ್ಲೇ ಉತ್ಪಾದನೆಯನ್ನು ಮಾಡಿ ನಮ್ಮ ದೇಶದ ನಾಗರಿಕರಿಗೆ ಸುಮಾರು 220 ಕೋಟಿ ಡೋಸ್ಗಳನ್ನು ಅಡ್ಮಿನಿಸ್ಟ್ರೇಷನ್ ಮಾಡಿದೀವಿ. ಸುಮಾರು 92 ಕೋಟಿ ಕೊರೋನಾ ಟೆಸ್ಟ್ಗಳನ್ನು ಮಾಡಿದೀವಿ. ಆದರೆ ಇಂಗ್ಲೆಂಡ್ ದೇಶದವರು ಆ ಒಂದು ಕೊರೋನಾ ಸಮಯದಲ್ಲಿ ನಮ್ಮ ಪ್ರಜೆಗಳಿಗೆ ಆ ದೇಶಕ್ಕೆ ವಿಸಿಟ್ ಮಾಡುವಂಥ ಸಂದರ್ಭದಲ್ಲಿ, ಇಲ್ಲ, ನಿಮ್ಮ ದೇಶದ ವ್ಯಾಕ್ಸಿನೇಷನ್ಗೆ ನಾವು ಒಪ್ಪುವುದಿಲ್ಲ ಅನ್ನುವಂಥದ್ದನ್ನ ಹೇಳಿದಾಗ, ನನ್ನದೇ ಮಂತ್ರಾಲಯ ಇರುವಂಥ ನನ್ನ ಆರೋಗ್ಯ ಸಚಿವರಾದಂಥ ಮನ್ಸುಖ್ ಭಾಯ್ ಮಾಂಡವಿಯ, ನಮ್ಮ ವ್ಯಾಕ್ಸಿನೇಷನ್ಗೆ ನೀವು ಒಪ್ಪುವುದಿಲ್ಲ ಅಂದ್ರೆ ನಾವು ನಿಮ್ಮ ವ್ಯಾಕ್ಸಿನೇಷನ್ಗೆ ನಾವು ಒಪ್ಪುವುದಿಲ್ಲ. ನಮ್ಮ ಪ್ರಜೆಗಳಿಗೆ ನೀವು ಅವಕಾಶ ಮಾಡಿಕೊಡಲ್ಲ ನಿಮ್ಮ ದೇಶಕ್ಕೆ, ಅಂದ್ರೆ ನಿಮ್ಮ ಪ್ರಜೆಗಳಿಗೆ ನಾವು ನಮ್ಗೆ ಅವಕಾಶ ಮಾಡಿಕೊಡಲ್ಲ ಅನ್ನುವಂಥ ಸರ್ಕಾರದ ನಿಲುವು ತಗೊಂಡಾಗ ಕೇವಲ 24 ತಾಸುಗಳಲ್ಲಿ ನಮ್ಮ ವ್ಯಾಕ್ಸಿನೇಷನ್ ಪಡೆದಂತ ನಮ್ಮ ನಾಗರಿಕರನ್ನ ಆ ದೇಶಕ್ಕೆ ಬರಲಿಕ್ಕೆ ಅವಕಾಶವನ್ನು ಮಾಡಿಕೊಟ್ರು. ನಾ ಹೇಳುವ ತಾತ್ಪರ್ಯ, ಅಭಿವೃದ್ಧಿ ಹೊಂದಂತ ದೇಶಗಳು ಈ ಒಂದು ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ಯಾವ ರೀತಿಯ ಮೊನೊಪೊಲಿ ಮತ್ತು ಲಾಬಿ ಮಾಡ್ತು ಅಂತ ಒಂದು ಉದಾಹರಣೆ ಮಾತ್ರ ಹೇಳಿದ್ದೇನೆ. ಅದಕ್ಕೆ ಸ್ವಾತಂತ್ರ್ಯ ಸಿಕ್ಕಿ 75 ವರ್ಷಗಳ ಕಾಲದಲ್ಲಿ ನಾವು ಬೆಸ್ಟ್ ಫಾಲೋವರ್ಸ್ ಆದೀವಿ ಹೊರತಾಗಿ ಬೆಸ್ಟ್ ಲೀಡರ್ಸ್ ಆಗಲಿಲ್ಲ ನಾವು ಜಗತ್ತಿನ. ಆ ಸಾಮರ್ಥ್ಯ ನಮ್ಮ ಜನರಲ್ಲಿತ್ತು. ಆದರೆ ಇವಾಗ ಸಮಯ ಬಂದಿದೆ, ಭಾರತೀಯರಲ್ಲಿರುವಂಥ ಸಾಮರ್ಥ್ಯ, ಭಾರತೀಯರಿರುವಂಥ ಕಠಿಣ ಪರಿಶ್ರಮ ಇವತ್ತು ಅನೇಕ ದಶಕಗಳಿಂದ ನಮ್ಮ ದೇಶದಿಂದ ವಿದ್ಯಾಭ್ಯಾಸವನ್ನು ಮಾಡಿ ನಮ್ಮದೇ ನಾಗರಿಕರು ಬೇರೆ ಬೇರೆ ಅಭಿವೃದ್ಧಿ ಹೊಂದ ದೇಶಗಳಲ್ಲಿ ಕೆಲಸ ಮಾಡ್ಲಿಕ್ಕೆ ಹೋಗ್ತಾ ಇದ್ರು. ಕಾಲ ದೂರ ಇಲ್ಲ, ರಿವರ್ಸ್ ಮೈಗ್ರೇಷನ್ ಆಗಲಿಕ್ಕೆ ನನ್ಗನ್ನಿಸ್ತಿದೆ 1 ದಶಕ ಸಾಕು. ಈಗ ನಮ್ಮ ದೇಶದ ನಾಗರಿಕರನ್ನು ಬೇರೆ ಬೇರೆ ದೇಶದಲ್ಲಿ ಹೋಗಿ ಆರೋಗ್ಯ ಕ್ಷೇತ್ರ ಇರ್ಬೋದು, ಬಾಹ್ಯಾಕಾಶ ಕ್ಷೇತ್ರ ಇರ್ಬೋದು, ಇನ್ನಿತರ ಯಾವುದೇ ಕ್ಷೇತ್ರ ಇರ್ಬೋದು, ಹೊಳ್ಳಿ ನಮ್ಮ ದೇಶಕ್ಕೆ ಬಂದು ಸೇವೆಯನ್ನು ಮಾಡಲಿಕ್ಕೆ. ಹೀಗಾಗಿ ಇವತ್ತು 311 ಹೊಸ ಕಾಲೇಜುಗಳು ಕೇವಲ 9 ವರ್ಷದಲ್ಲಿ, 16 ಹೊಸ ಏಮ್ಸ್, ಪ್ರತಿಯೊಂದು ರಾಜ್ಯದಲ್ಲಿಯೂ ಕೂಡ ಏಮ್ಸ್ ಕಾಲೇಜನ್ನು ತೆಗಿಬೇಕನ್ನುವಂಥದ್ದನ್ನು ಇವತ್ತು 16 ಈಗಾಗಲೇ ಪ್ರಾರಂಭವನ್ನಾಗಿದೆ. ಇದ್ರ ಜೊತೆಯಲ್ಲಿ ನಮ್ಮ ಡಾಕ್ಟರ್ ಕ್ಷೇತ್ರಗಳಿಗೆ ಸಂಬಂಧಪಟ್ಟಂಥದ್ದು ಇವತ್ತು ಮೆಡಿಸಿನ್ ಕ್ಷೇತ್ರ, ಇವತ್ತು ಅನೇಕ ಮೆಡಿಸಿನ್ಗಳಿಗೆ ನಾವು ವಿದೇಶಗಳ ಮೇಲೆ ಅವಲಂಬಿತರಾಗಿದ್ದೇವೆ. ಆ ಎಲ್ಲ ಔಷಧಗಳನ್ನು ನಮ್ಮ ದೇಶದಲ್ಲಿಯೇ ಉತ್ಪಾದನೆ ಆಗಬೇಕು, ವಿದೇಶ ಉತ್ಪಾದನೆಗಳ ಮೇಲೆ ಅವಲಂಬಿತವನ್ನು ಕಡಿಮೆ ಆಗಬೇಕು ಅನ್ನುವಂಥ ಉದ್ದೇಶದಿಂದ ಈಗ ಅನೇಕ ನಮ್ಮ PLI ಸ್ಕೀಮ್ಗಳು ತಂದಿದ್ದ ಕಾರಣಕ್ಕಾಗಿ ಸುಮಾರು 80 ಕ್ರಿಟಿಕಲ್ ಔಷಧಗಳನ್ನು ನಮ್ಮ ದೇಶದಲ್ಲಿ ಉತ್ಪಾದನೆಗೆ ಪ್ರಾರಂಭವನ್ನಾಗಿದೆ. ಮೆಡಿಕಲ್ ಡಿವೈಸಸ್ ಕೂಡ ಇವತ್ತು ನಾವು ಬಹುತೇಕ ಮೆಡಿಕಲ್ ಡಿವೈಸಸ್ಗಳು ಅನೇಕ ಅಭಿವೃದ್ಧಿ ಹೊಂದಿದ ದೇಶಗಳ ಮೇಲೆ ನಾವು ಅವಲಂಬಿತರಾಗಿದ್ದೀವಿ. ಅದಕ್ಕೆ ಮೆಡಿಕಲ್ ಡಿವೈಸಸ್ ಪಾರ್ಕ್ಗಳನ್ನು ಕೂಡ ನನ್ನ ಮಂತ್ರಾಲಯಕ್ಕೆ ಬರುವುದರಿಂದ ವಿಸ್ತಾರವಾಗಿ ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ನಮ್ಮ ದೇಶದಲ್ಲಿ ಗೊತ್ತಾ ಹಣ ಸಹಾಯವನ್ನು ಮಾಡಿ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಉತ್ಪಾದನೆಯಾಗಬೇಕು ಮತ್ತು ಕಡಿಮೆ ದರದಲ್ಲಿ ಆ ಒಂದು ಮೆಡಿಕಲ್ ಡಿವೈಸಸ್ಗಳು ನಮ್ಮ ಜನರಿಗೆ ಲಭ್ಯವಾಗಬೇಕನ್ನುವಂಥ ಉದ್ದೇಶದಿಂದ ಇವತ್ತು ಅದರಲ್ಲಿ ಕೂಡ ಬಹಳಷ್ಟು ಸರ್ಕಾರ ಒಂದು ಸಹಾಯವನ್ನು ಮಾಡ್ತಾ ಇದೆ. ಇವೆಲ್ಲವೂ ನಿಮಗೆ ಸೇವೆ ಮಾಡಲಿಕ್ಕೆ ಪೂರಕವಾದಂಥ ವಿಷಯಗಳನ್ನು ನಿಮ್ಮ ಎದುರಿಗೆ ಮಂಡನೆ ಮಾಡಿದ್ದೀನಿ. ಇನ್ನಷ್ಟು ನಿಮ್ಮ ಸಲಹೆ ಸೂಚನೆಗಳಿದ್ದರೆ ತಾವು ದಯಮಾಡಿ ಭಾರತ ಸರ್ಕಾರಕ್ಕೆ ಒಂದು ಚಿಟ್ಟಿ ಬರೆದಿ ಅಥವಾ ಮೇಲ್ಗಳನ್ನು ಕಳಿಸಿ ತಿಳಿಸಿದರೆ ಮತ್ತಷ್ಟು ಅದರಲ್ಲಿ ಸುಧಾರಣೆ ತರುವಂಥ ಅವಕಾಶಗಳಿರ್ತವೆ. ಯಾವುದು ಮಾಡಿದ ತಕ್ಷಣ ಇಲ್ಲಿಗೆ ಮುಗೀತು ಅಂತೇನಲ್ಲ, ಯಾವಾಗಲೂ ಎಲ್ಲ ಕ್ಷೇತ್ರಗಳಲ್ಲಿಯೂ ಸುಧಾರಣೆ ಮತ್ತು ಅಭಿವೃದ್ಧಿ ಮಾಡಲಿಕ್ಕೆ ಸಾಕಷ್ಟು ಅವಕಾಶಗಳಿರ್ತವೆ. ಅದಕ್ಕೆ ಜನರಿಂದ ಪಡೆದಂಥ ಸಲಹೆ ಸೂಚನೆಗಳು ಬಹಳಷ್ಟು ಉತ್ತಮವಾಗಿ ಸುಧಾರಣೆ ಮಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಇರ್ತವೆ ಅನ್ನುವಂಥದ್ದನ್ನು ಹೇಳಿ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ವಿಶೇಷವಾಗಿ ಬೀದರ್ ಜಿಲ್ಲೆ ಐತಿಹಾಸಿಕ ನಗರ, ಈ ಒಂದು ಐತಿಹಾಸಿಕ ನಗರದಲ್ಲಿ ಇಡೀ ರಾಜ್ಯದಿಂದ ಮತ್ತು ರಾಷ್ಟ್ರದಿಂದ ಅನೇಕ ರಾಜ್ಯಗಳಿಂದ ಬಂದಿದ್ದಂಥ ಎಲ್ಲ ಅತಿಥಿಗಳಿಗೆ ನಾನು ಹೃತ್ಪೂರ್ವಕವಾದಂಥ ಸ್ವಾಗತ ಮತ್ತು ನಿಮಗೆ ಅಭಿನಂದನೆಗಳ ಸಲ್ಲಿಸಿ ನನ್ನ ಮಾತಿನ ವಿರಾಮನ ಕೊಡ್ತೀನಿ. ಜೈ ಹಿಂದ್.
Thank you, sir, for your wise words. It is our privilege to have with us Dr. Sharan Prakash Patil, sir. Sir's dedication to Karnataka's medical education has been transformative, and we are eager to know his insights on this occasion. Sir, please share a few words.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಎನ್ನ ವಾಮಕ್ಷೇಮ ನಿಮ್ಮದಯ್ಯ, ಎನ್ನ ಹಾನಿ ವೃದ್ಧಿ ನಿಮ್ಮದಯ್ಯ, ಎನ್ನ ಮಾನ ಅಪಮಾನ ನಿಮ್ಮದಯ್ಯ, ಕೂಡಲ ಸಂಗಮ ದೇವ ಬಳ್ಳಿಗೆ ಕಾಯಿ ದಿಮ್ಮಿತ್ತೆ ಎಂಬುವಂತೆ 12ನೇ ಶತಮಾನದ ಬಸವಾದಿ ಶರಣರ ಕಲ್ಯಾಣ ನಾಡಿನಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ 89ನೇ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನದಲ್ಲಿ ಮೊಟ್ಟ ಮೊದಲಿಗೆ ನಾನು ನಿಮ್ಮೆಲ್ಲರಿಗೆ ಇಲ್ಲಿ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತೀನಿ. ಇವತ್ತು ವಿಶೇಷವಾಗಿ ನಮ್ಮ ಬೀದರ್ ಜಿಲ್ಲೆ ಅಂತಂದರೆ ಇದು ಅಣ್ಣ ಬಸವಣ್ಣನ ನಾಡು, 12ನೇ ಶತಮಾನದ ಬಸವಾದಿ ಶರಣರ ನಾಡು. ಇದು ಇಡೀ ವಿಶ್ವಕ್ಕೇ ಇವತ್ತು ಮೊಟ್ಟ ಮೊದಲನೆಯ ಪಾರ್ಲಿಮೆಂಟನ್ನು ನಮಗೆ ಪರಿಚಯ ಮಾಡಿಸಿರ್ತಕ್ಕಂಥ ಪ್ರಜಾಪ್ರಭುತ್ವದ ಬುನಾದಿ ಹಾಕಿರ್ತಕ್ಕಂಥ ನಾಡಿದು. ಸಮಾಜದಲ್ಲಿ ಸಮಾನತೆ ಸಾರಿರ್ತಕ್ಕಂಥದ್ದು, ಎಲ್ಲರೂ ನಮ್ಮವರು ಅಂತಕ್ಕಂಥ ಭಾವನೆಯನ್ನು ಕೇವಲ ಮನುಷ್ಯರಿಗಷ್ಟೇ ಅಲ್ಲ ಸಕಲ ಜೀವಾತ್ಮಗಳಿಗೆ ಲೇಸನ್ನು ಬಯಸಿರ್ತಕ್ಕಂಥ ಬಸವಾದಿ ಶರಣರ ನಾಡಿದು. ಹಾಗಾಗಿ ವಿಶೇಷ ನಾಡಿಗೆ ತಾವೆಲ್ಲರೂ ಬಂದಿದ್ದೀರಿ. ಕರ್ನಾಟಕ ರಾಜ್ಯಾದ್ಯಂತ ತಮ್ಮೆಲ್ಲರಿಗೂ ನಾನು ಸ್ವಾಗತವನ್ನು ಕೋರ್ತೀನಿ. ಮತ್ತು ವಿಶೇಷವಾಗಿ ಯಾಕಂದರೆ ಇವತ್ತು ನಮ್ಮ ಬೀದರ್ ಜಿಲ್ಲೆ ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಇವತ್ತು ತುದಿಯಲ್ಲಿದೆ. ಇವು ನಾವು ತೆಲಂಗಾಣ ಮಹಾರಾಷ್ಟ್ರ ಬಾರ್ಡ್ರಲ್ಲಿದ್ದರೂ ಕೂಡ ಇವತ್ತು ರಾಜ್ಯಾದ್ಯಂತ ಎಲ್ಲ ವೈದ್ಯರು ಇಲ್ಲಿ ಬಂದು ಸುಮಾರು 700ಕ್ಕಿಂತ ಜಾಸ್ತಿ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಆಗಿದೆ ಅಂತ ಹೇಳಿದ್ರು. ಹಾಗಾಗಿ ಇಷ್ಟೊಂದು ದೊಡ್ಡ ಸಂಖ್ಯೆಯಲ್ಲಿ ಬಂದು ಈ ಕಾರ್ಯಕ್ರಮ ಯಶಸ್ವಿ ಮಾಡಿದ್ದಕ್ಕೆ ತಮ್ಮೆಲ್ಲರಿಗೂ ಅಭಿನಂದಿಸಿ, ಮತ್ತು ವಿಶೇಷವಾಗಿ ಇಲ್ಲಿ ಮಲ್ಲಿಕಾರ್ಜುನ್ ಪನ್ಶೆಟ್ಟಿ ಕಾರ್ಯದರ್ಶಿಗಳು ಮತ್ತು ಚಂದ್ರಕಾಂತ್ ಗುದ್ಗೆ ಅಧ್ಯಕ್ಷರು ಮತ್ತು ವಿಜಯಶ್ರೀ ಬಶೆಟ್ಟಿ ಅವರು ಮತ್ತು ಶಿವಕುಮಾರ್ ಶೆಟ್ಕಾರ್ ಅವರು, ಯಾಕಂದರೆ ಇಲ್ಲೆಲ್ಲ ವ್ಯವಸ್ಥೆ ಮಾಡೋದು ತಾವೆಲ್ಲ ಭಾಳ ಶ್ರಮ ವಹಿಸಿದಿರಿ. ತಮ್ಮೆಲ್ಲರಿಗೂ ಅಭಿನಂದನೆಗಳು. ಯಾಕಂದರೆ ಇವತ್ತು ಬೆಂಗಳೂರಲ್ಲಿ, ಹುಬ್ಬಳ್ಳಿಯಲ್ಲಿ, ದೊಡ್ಡ ದೊಡ್ಡ ನಗರಗಳಲ್ಲಿ ಕಾನ್ಫರೆನ್ಸ್ ಮಾಡೋದು ಸುಲಭ. ಆದರೆ ಇವತ್ತು 40 ವರ್ಷಗಳ ನಂತರ ಬೀದರ್ ಜಿಲ್ಲೆಯಲ್ಲಿ ಮೊದಲನೇ ಬಾರಿಗೆ ಈ ಒಂದು ಕಾನ್ಫರೆನ್ಸನ್ನು ಹೋಸ್ಟ್ ಮಾಡಿದ್ದಕ್ಕೆ ಅವರಿಗೆಲ್ಲರೂ ಅಭಿನಂದನೆ ಸಲ್ಲಿಸಿ, ಈ ಒಂದು ಸಮಾರಂಭದಲ್ಲಿ ಉಪಸ್ಥಿತಕ್ಕಂಥ ಮಾನ್ಯ ಕೇಂದ್ರ ನವೀಕರಿಸಬಹುದಾದ ಇಂಧನ ಮೂಲ ಹಾಗೂ ರಾಸಾಯನಿಕ ರಸಗೊಬ್ಬರ ಖಾತೆ ಸಚಿವರಾಗಿರ್ತಕ್ಕಂಥ ಭಗವಂತ್ ಖೂಬಾಜಿ ಅವರೇ, ಮತ್ತು ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿರ್ತಕ್ಕಂಥ ಕರ್ನಾಟಕ ಸರ್ಕಾರದ ಮಾನ್ಯ ಪೌರಾಡಳಿತ ಮತ್ತು ಹಜ್ ಖಾತೆ ಸಚಿವರಾಗಿರ್ತಕ್ಕಂಥ ಸ್ನೇಹಿತರಾಗಿರ್ತಕ್ಕಂಥ ರಹೀಮ್ ಖಾನ್ ಅವರೇ, ಮತ್ತು ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿರ್ತಕ್ಕಂಥ ವಿಧಾನ ಪರಿಷತ್ತಿನ ಸದಸ್ಯರು ಮತ್ತು ಮಿತ್ರರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಚಂದ್ರಶೇಖರ್ ಅವರೇ, ಮತ್ತು ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿರ್ತಕ್ಕಂಥ IMAನ ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಲಕ್ಕೋಳೆ ಅವರೇ, ಮತ್ತು ಹೊಸದಾಗಿ ಅಂದರೆ 23-24ಗೆ ಎಲೆಕ್ಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಡಾಕ್ಟರ್ ಎಸ್ ಶ್ರೀನಿವಾಸ್ ಅವರೇ, ಮತ್ತು ಬೀದರ್ ವೈದ್ಯಕೀಯ ಸಂಸ್ಥೆಯ ನಿರ್ದೇಶಕರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಅವರೇ, ಮತ್ತು ನಮ್ಮ 24-25 ಎಲೆಕ್ಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ಪ್ರೆಸಿಡೆಂಟ್ ಎಲೆಕ್ಟ್ ಆಗಿರ್ತಕ್ಕಂಥ VV ಚಿನ್ನೇವಾಲರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ಶಾಂತ ಕೌಜಿಲ್ಗೆ ಅವರೇ, ಕೌಸ್ ಅವರೇ, ಮತ್ತು ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳೇ, ಇವತ್ತು ವಿಶೇಷವಾಗಿ ಎಲ್ಲ ವೈದ್ಯರು ಕರ್ನಾಟಕ ರಾಜ್ಯಾದ್ಯಂತ ಇವತ್ತು ತಾವೆಲ್ಲ ಬೀದರಿಗೆ ಬಂದಿದ್ದೀರಿ. ಇವತ್ತು ವಿಶೇಷವಾಗಿ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಅನೇಕ ವರ್ಷಗಳಿಂದ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಒಳ್ಳೆಯ ಗುಣಮಟ್ಟದ ಚಿಕಿತ್ಸೆ ಜೊತೆಗೆ ವೈದ್ಯರ ಹಿತವನ್ನು ಕಾಪಾಡ್ತಕ್ಕಂಥ ಕೆಲಸನೂ ಕೂಡ ಮಾಡ್ಕೊಂಡು ಬಂದಿದೆ. ಇವತ್ತು ಯಾವುದೇ ಸಂಘ ಆಗಿರ್ಬೋದು, ಮೂಲ ಉದ್ದೇಶ ಇವತ್ತು ಸಂಘದ ಸದಸ್ಯರ ಹಿತಾಸಕ್ತಿ ಜೊತೆಗೆ ಸಾರ್ವಜನಿಕ ಹಿತಾಸಕ್ತಿ ಮತ್ತು ದೇಶದ ಸಾಮಾನ್ಯ ಜನರು ವಿಶೇಷವಾಗಿ ಇವತ್ತು ಎಲ್ಲರ ಆರೋಗ್ಯವನ್ನು ಕಾಪಾಡ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ಅನೇಕ ವರ್ಷಗಳಿಂದ ಸಲಹೆ ಸೂಚನೆಗಳನ್ನು ಕೊಡ್ತಾ ಇವತ್ತು ನಮ್ಮ ದೇಶದಲ್ಲಿ ಭಾರಿ ಇವತ್ತು ಬದಲಾವಣೆಗಳನ್ನು ಈ ವೈದ್ಯಕೀಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ಕೊಡೋದ್ರಲ್ಲಿ IMAನ ಭಾಳ ದೊಡ್ಡ ಪಾತ್ರ ಕೂಡ ಇದೆ. ಕಾಲಕ್ಕೆ ಸರ್ಕಾರಗಳಿಗೆ ಸಲಹೆ ಸೂಚನೆಗಳನ್ನು ಕೊಡ್ತಾ ಮತ್ತು ಅನೇಕ ಸಾರಿ ಸರ್ಕಾರಗಳು ಎಡವಿದಾಗ ಸರ್ಕಾರಕ್ಕೆ ಸರಿಯಾಗಿರ್ತಕ್ಕಂಥ ಮಾರ್ಗದರ್ಶನ ಮಾಡಿ ಅವರಿಗೆ ಇವತ್ತು ಸಲಹೆ ಸೂಚನೆಗಳನ್ನು ಕೊಡ್ತಾ ಇವತ್ತು IMA ಅನೇಕ ವರ್ಷಗಳಿಂದ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಕಾರ್ಯನಿರ್ವಹಿಸ್ತಾ ಇದೆ. ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲೂ ಕೂಡ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಭಾಳ ಆ್ಯಕ್ಟಿವ್ ಆಗಿದೆ ಮತ್ತು ಇಲ್ಲಿ ಒಳ್ಳೆಯ ರೀತಿಯಿಂದ ಕೆಲಸನೂ ಕೂಡ ಮಾಡ್ಕೊಂಡು ಬಂದಿದೆ. ಇವತ್ತು ವಿಶೇಷವಾಗಿ ನಮ್ಮ ಸರ್ಕಾರದ ಗುರಿನೂ ಕೂಡ ಅದೇ ಆಗಿದೆ. ಏನಂದರೆ ನಾವು ಸಾಮಾನ್ಯ ಜನರಿಗೆ ನಾವು ಗುಣಮಟ್ಟದ ಚಿಕಿತ್ಸೆ ಅಟ್ ಎನ್ ಅಫೋರ್ಡಬಲ್ ಕಾಸ್ಟ್, ಇದು ಭಾಳ ಮುಖ್ಯ. ಯಾಕಂತಂದರೆ ಇವತ್ತು ನಾವು ವೈದ್ಯರು ಇವತ್ತು ಭಾಳಷ್ಟು ನಮ್ಮ ವೈದ್ಯರನ್ನು ಕೂಡ ಇವತ್ತು ಭಾಳ ಚಾಲೆಂಜಸನ್ನು ಫೇಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ಇಂದಿನ ದಿನಮಾನದಲ್ಲಿ. ಹಿಂದಿಗೆ ಮತ್ತು ಕಳೆದ 16 ವರ್ಷಗಳಲ್ಲಿ ಸಾಕಷ್ಟು ಚಾಲೆಂಜಸ್ಸು ಇವತ್ತು ಡಾಕ್ಟರ್ಸ್ ಫೇಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಆದರೆ ಬದಲಾವಣೆ ಕೂಡ ಸಾಕಷ್ಟಾಗಿದೆ. ಯಾಕಂದರೆ ಈ ಕಾನ್ಫರೆನ್ಸಸ್ ಮಾಡ್ತಕ್ಕಂಥ ಉದ್ದೇಶ ಇವತ್ತು ಏನು ರಿಸರ್ಚ್ ಆಗಿರ್ಬೋದು, ಹೊಸ ಯಾಕಂದರೆ ದಿನನಿತ್ಯ ಇವತ್ತು ನಮ್ಮ ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟೆಲಿಜೆನ್ಸು ಮತ್ತು ಮಾಹಿತಿ ತಂತ್ರಜ್ಞಾನದ ಉಪಯೋಗದಿಂದ ಇವತ್ತು ಅನೇಕ ಬದಲಾವಣೆಗಳನ್ನು ಇವತ್ತು ನಮ್ಮ ಚಿಕಿತ್ಸಾ ವ್ಯವಸ್ಥೆಯಲ್ಲಿ ಆಗ್ತಾ ಇದೆ. ಅದನ್ನು ನಾಲೆಜ್ ಅಪ್ಡೇಟ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದು ಭಾಳ ಮುಖ್ಯ. ಅದರ ಜೊತೆಗೆ ಇವತ್ತು KMJನೂ ಕೂಡ ಭಾಳ ವರ್ಷಗಳಿಂದ ಇತ್ತು, ಅದನ್ನು ಬಂದಾಗಿತ್ತು, ಅದನ್ನು ಪುನರ್ಚಾಲನೆ ಇವತ್ತು ಕೊಟ್ಟಿದ್ದಾರೆ. ಅವ್ರಿಗೂ ಕೂಡ ಅಭಿನಂದನೆ ಸಲ್ಲಿಸಬೇಕು. ಯಾಕಂತಂದರೆ ರಿಸರ್ಚ್ ಪಬ್ಲಿಷ್ ಮಾಡೋದಕ್ಕೆ ಒಂದು ಪ್ಲ್ಯಾಟ್ಫಾರ್ಮ್ ಫ್ರೀ ಆಫ್ ಕಾಸ್ಟಾಗಿ ಇವತ್ತು ಒದಗಿಸಿದ್ದಕ್ಕೆ ಎಲ್ಲರೂ ಅದರ ಲಾಭನೂ ಕೂಡ ಪಡಿಬೋದು. ಹಾಗಾಗಿ ಅದನ್ನು ಕೂಡ ತಾವು ಮಾಡ್ತಾ ಇದ್ದೀರಿ, ಭಾಳ ಸಂತೋಷ. ಇವತ್ತು ವಿಶೇಷವಾಗಿ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಇಡೀ ದೇಶಕ್ಕೆ ಒಂದು ಮಾದರಿಯಾಗಿದೆ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣದಲ್ಲಿ ಮತ್ತು ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದಲ್ಲಿ. ತಮಗೆಲ್ಲ ಗೊತ್ತಿರೋ ಹಾಗೆ ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಿ ಬಹುಶಃ ತಮಿಳುನಾಡು ಆದಮೇಲೆ ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಿ ಅತ್ಯಂತ ಹೆಚ್ಚು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳಿವೆ. ಇವತ್ತು ನಮ್ಮ ಸರ್ಕಾರ ವಿಶೇಷವಾಗಿ ನಾವು 2013ರಲ್ಲೂ ಕೂಡ ನನಗೆ ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಸಚಿವನಾಗಿ ಕೆಲಸ ಮಾಡ್ತಕ್ಕಂಥ ಅವಕಾಶ ಹಿಂದಿನ ಸರ್ಕಾರದಲ್ಲೂ ಕೂಡ ಮಾನ್ಯ ಮುಖ್ಯಮಂತ್ರಿಗಳಾಗಿರ್ತಕ್ಕಂಥ ಸಿದ್ದರಾಮಯ್ಯನವರು ನಮ್ಮ ಸರ್ಕಾರ ಕೊಟ್ಟಿತ್ತು. ಆಗಲೂ ಕೂಡ ನಾವು ಜಿಲ್ಲೆಗೊಂದು ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಸ್ಥಾಪನೆ ಮಾಡಬೇಕು ಅಂತಕ್ಕಂಥದ್ದು ಇದು ನಮ್ಮ ಸರ್ಕಾರದ ಒಂದು ಪಾಲಿಸಿ ಆಗಿತ್ತು. ಆ ಪಾಲಿಸಿ ಆಮೇಲೆ ಕೇಂದ್ರ ಸರ್ಕಾರ ಕಾಪಿ ಮಾಡಿದ್ರು, ಅಂದರೆ ಅದನ್ನು ಇಡೀ ದೇಶಕ್ಕೆ ವಿಸ್ತಾರ ಮಾಡಿದ್ರು. ಆದರೆ ಇಡೀ ಜಿಲ್ಲೆಗೊಂದು ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಮಾಡಬೇಕು ಅಂತಕ್ಕಂಥದ್ದನ್ನು ನಾವು ಪ್ರಾರಂಭ ಮಾಡಿದ್ದು 2013ರಲ್ಲಿ. ಅದಕ್ಕಿಂತ ಮುಂಚಿತ ಇವತ್ತು ಸಿದ್ದರಾಮಯ್ಯನವರು ಇವತ್ತು ಉಪಮುಖ್ಯಮಂತ್ರಿ ಆಗಿದ್ದಾಗ, ಧರಮ್ಸಿಂಗ್ ಜಿ ಅವರು ಮುಖ್ಯಮಂತ್ರಿ ಆಗಿದ್ದಾಗ ಕಲಬುರಗಿ ನಮ್ಮ ಬೀದರ್ ಜಿಲ್ಲೆಗೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಕೊಟ್ಟಿದ್ದು. ಕೇವಲ ನಮ್ಮ ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಿ 4 ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳಿತ್ತು. 2004ರಲ್ಲಿ ಏನು ಧರಮ್ಸಿಂಗ್ ಜಿ ಅವರು ಮುಖ್ಯಮಂತ್ರಿ ಆಗಿದ್ದರು, ಸಿದ್ದರಾಮಯ್ಯನವರು ಉಪಮುಖ್ಯಮಂತ್ರಿ ಆಗಿದ್ದರು. ಆವಾಗ 6 ಹೊಸ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳನ್ನು ಸ್ಥಾಪನೆ ಮಾಡಿದರು. ಅದರಲ್ಲಿ ಬೀದರ್ ಒಂದಿದೆ ಅಂತಕ್ಕಂಥದ್ದು ಬೀದರ್ ಜನತೆ ಎಂದು ಮರ್ತಿಲ್ಲ ಅಂತ ಅಂದ್ಕೊಂಡಿದ್ದೀನಿ ನಾನು. ಯಾಕಂತಂದರೆ ಆಗ ನಮ್ಮ ಉದ್ದೇಶ ಏನಾಗಿತ್ತು ಅಂತಂದರೆ, ಇವತ್ತು ನಾವು ವಿಶೇಷವಾಗಿ ಸಾಕಷ್ಟು ಪ್ರೈವೇಟ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇದ್ದರೂ ಕೂಡ ಸರ್ಕಾರ ಮಟ್ಟದಲ್ಲಿ ನಾವು ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ಸ್ಥಾಪನೆ ಮಾಡ್ತಕ್ಕಂಥ ಸದುದ್ದೇಶ ಏನಿತ್ತು ಅಂತಂದರೆ ಎರಡು ಉದ್ದೇಶಗಳಿತ್ತು. ಮೊದಲನೇದು, ನಾವು ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ಪ್ರಾರಂಭ ಮಾಡಿದ್ರೆ ಆ ಎಲ್ಲ ಸೀಟು ಮೆರಿಟ್ ಕೋಟಾಗಿ ಹೋಗ್ತದೆ ಮತ್ತು ಈ ರಾಜ್ಯದ ಪ್ರತಿಭಾವಂತ ಯುವಕರಿಗೆ, ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಇವತ್ತು ಗೌರ್ಮೆಂಟ್ ಸೀಟು ಸಿಕ್ಕರೆ ಅವರಿಗೆ ಯಾವುದೂ ಆರ್ಥಿಕ ಹೊರೆ ಆಗೋದಿಲ್ಲ. ಮತ್ತು ಇವತ್ತು ಗೌರ್ಮೆಂಟ್ ಕಾಲೇಜಲ್ಲಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಸೀಟ್ಗಳು ಇವತ್ತು ಮೆರಿಟ್ ಕೋಟಾಗಿ ಹೋಗೋದ್ರಿಂದ ಈ ರಾಜ್ಯದ ಬಡವ್ರ ಮಕ್ಕಳು ಕೂಡ ಡಾಕ್ಟರ್ ಆಗ್ಬೋದು ಅಂತಕ್ಕಂಥ ಒಂದು ಉದ್ದೇಶದಿಂದ ನಾವು ಗೌರ್ಮೆಂಟ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ಪ್ರಾರಂಭ ಮಾಡಿದ್ವಿ. ಮತ್ತು ಎರಡನೇ ಉದ್ದೇಶ ಏನಂತಂದರೆ, ಎಲ್ಲಿ ಟೀಚಿಂಗ್ ಆಸ್ಪತ್ರೆ ಇರ್ತದೆ, ಅಂದರೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜಿಗೆ ಅಟ್ಯಾಚ್ ಇರ್ತಕ್ಕಂಥ ಏನು ಆಸ್ಪತ್ರೆ ಇರ್ತದೆ, ಅದರಲ್ಲಿ ಎಲ್ಲ ರೀತಿಯ ಒಂದು ಡಿಪಾರ್ಟ್ಮೆಂಟಿನ ಸ್ಟಾಫ್ ಇರ್ತಾರೆ. ಅಲ್ಲಿ ಎಲ್ಲ ವೈದ್ಯರು ಸಿಗಲಿಕ್ಕೆ ಸಾಧ್ಯ, ಎಲ್ಲ ಸ್ಪೆಷಲಿಸ್ಟು ಇರೋಕ್ಕೆ ಸಾಧ್ಯ ಇದೆ. ಹಾಗಾಗಿ ಗುಣಮಟ್ಟದ ಚಿಕಿತ್ಸೆ ನಾವು ಒಂದು ಜಿಲ್ಲೆಯಲ್ಲಿ ಮಾಡಿದ್ರೆ ಆ ಜಿಲ್ಲೆಯಲ್ಲಿರ್ತಕ್ಕಂಥ ಬಡವರು ಯಾರು ಖಾಸಗಿ ಆಸ್ಪತ್ರೆಗೆ ಹೋಗೋಕ್ಕೆ ಆಗೋದಿಲ್ಲ, ಅವರನ್ನು ನಾವು ಒಳ್ಳೆಯ ಗುಣಮಟ್ಟದ ಚಿಕಿತ್ಸೆ ಕೊಡ್ಬೋದು ಅಂತಕ್ಕಂಥದ್ದು ಉದ್ದೇಶ ಆಗಿತ್ತು. ಹಾಗಾಗಿ 2004ರಲ್ಲಿ 6 ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳನ್ನು ಪ್ರಾರಂಭ ಮಾಡಿದ್ವಿ. ಮತ್ತು 2013ರಲ್ಲಿ ನಾನು ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣ ಸಚಿವನಾದಾಗ ಮತ್ತೆ 7 ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ನಾವು ಸರ್ಕಾರಿ ಮಟ್ಟದಲ್ಲಿ ಪ್ರಾರಂಭ ಮಾಡಿದ್ವಿ. ಅದಾದಮೇಲೆ ಮತ್ತು ನಮ್ಮ ಈ ಸರ್ಕಾರ ಬಂದ ಮೇಲೆ ಮತ್ತೆ ಇವತ್ತು ಚಿತ್ರದುರ್ಗ ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ಪ್ರಾರಂಭ ಮಾಡಿದ್ದೀವಿ. ಉದ್ದೇಶ ಏನಂತಂದರೆ, ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಿ ಇವತ್ತು ಸುಮಾರು 23 ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜು ಮತ್ತು ಮಲ್ಲಿಕಾರ್ಜುನ್ ಖರ್ಗೆ ಸಾಹೇಬರು ಕೇಂದ್ರದ ಕಾರ್ಮಿಕ ಸಚಿವರಾಗಿದ್ದಾಗ 2 ESI ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ಸ್ಥಾಪನೆ ಮಾಡಿದರು, ಒಂದು ಕಲಬುರಗಿಯಲ್ಲಿ, ಒಂದು ಬೆಂಗಳೂರಲ್ಲಿ. ಇವತ್ತು ಸುಮಾರು 25 ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳು ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಿ ಯಾವ ರಾಜ್ಯದಲ್ಲಿ ಇವೆ ಅಂತ ನಾನು ಅನ್ಕೊಳಕ್ಕೆ ಹೋಗೋದು ಇರಲಿಕ್ಕಿಲ್ಲ ಅಂತ ನನ್ನ ಭಾವನೆ. ಒಂದು ತಮಿಳುನಾಡು, ಒಂದು ಕರ್ನಾಟಕ ಬಿಟ್ಟರೆ ಈ ದೇಶದ ಯಾವ ರಾಜ್ಯದಲ್ಲೂ ಕೂಡ ಇಷ್ಟು ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳಿಲ್ಲ. ಮತ್ತು ವಿಶೇಷವಾಗಿ ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಸಾಕಷ್ಟು ಪ್ರೈವೇಟ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ಸು ಕೂಡ ಇದೆ. ಇದರ ಶ್ರೇಯಸ್ಸನ್ನು ನಾವು ಯಾರಿಗೆ ಕೊಡಬೇಕು ಅಂತಂದರೆ, ನಮ್ಮ ಪೂರ್ವಜರಿಗೆ ಯಾರು ನಮ್ಮ ಲೀಡರ್ಸು ಯಾರು 70ಸಲ್ಲಿ 60ಸಲ್ಲಿ ನಿಜಲಿಂಗಪ್ಪ ಅವರು, ದೇವರಾಜ ಅರಸ್ ಅವರು ಭಾಳ ಮುಂದಾಲೋಚನೆಯಿಂದ ನಮ್ಮ ರಾಜ್ಯ ಇವತ್ತು ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದಲ್ಲಿ ಇಷ್ಟು ದೊಡ್ಡದಾಗಿ ಬೆಳೆದಿದೆ. ಅದು ನೀವು ಇಂಜಿನಿಯರಿಂಗ್ ಕ್ಷೇತ್ರ ಆಗಿರ್ಬೋದು ಅಥವಾ ಮೆಡಿಕಲ್ ಕ್ಷೇತ್ರ ಅಂತಂದರೆ ನಮ್ಮ ಹಿಂದಿನ ನಾಯಕರು ಇರ್ತಕ್ಕಂಥ ದೂರದೃಷ್ಟಿ ಅಂತಕ್ಕಂಥದ್ದು ನಾವು ಯಾರೂ ಮರಿಬಾರ್ದು. ಆಗಿನ ಕಾಲದಲ್ಲಿ ಇಂಜಿನಿಯರಿಂಗ್ ಕಾಲೇಜಸ್ಸನ್ನು, ಪ್ರೈವೇಟಲ್ಲಿ ಇಂಜಿನಿಯರಿಂಗ್ ಕಾಲೇಜಸ್ಸನ್ನು ಪ್ರಾರಂಭ ಮಾಡಲಿಕ್ಕೆ ಇವತ್ತು ಅವಕಾಶ ಕೊಟ್ಟಿದ್ದರು. ಹಾಗಾಗಿ ಇವತ್ತು ಇಡೀ ದೇಶಕ್ಕೆ ಇವತ್ತು ಸಿಲಿಕಾನ್ ವ್ಯಾಲಿ ಅಂತ ನಮ್ಮ ಬೆಂಗಳೂರು ಯಾಕೆ ಅನಿಸ್ಕೊಳ್ತಾ ಇದೆ ಅಂದರೆ, ನಮ್ಮಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ಇಂಜಿನಿಯರಿಂಗ್ ಕಾಲೇಜ್ಲಿಂದ ಬಂದಿರತಕ್ಕಂಥ ವಿದ್ಯಾರ್ಥಿಗಳು ಇವತ್ತು ಬೆಂಗಳೂರು ಸಿಲಿಕಾನ್ ವ್ಯಾಲಿಯನ್ನು ಮಾಡಲಿಕ್ಕೆ ನಮ್ಮ ಕಲ್ಯಾಣ ಕರ್ನಾಟಕದ ಭಾಗದ ಮಕ್ಕಳು ಭಾಳ ದೊಡ್ಡ ಸಂಖ್ಯೆಯಲ್ಲಿದ್ದಾರೆ. ಇವತ್ತು ಆಗಿನ ಕಾಲದಲ್ಲೇ ಪ್ರೈವೇಟಲ್ಲಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜನ್ನು ಸ್ಥಾಪನೆ ಮಾಡಲಿಕ್ಕೆ ನಮ್ಮ ನಾಯಕರು ಅಲೌ ಮಾಡಿದ್ರಿಂದ ಇವತ್ತು ಪ್ರೈವೇಟ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ ಬಂದು ಇಷ್ಟೊಂದು ಜನ ವೈದ್ಯರು ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿದ್ದಾರೆ. ಪ್ರತಿ ವರ್ಷ 12,000 ಸುಮಾರು ಡಾಕ್ಟರ್ಸು ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಪಾಸ್ಔಟ್ ಆಗ್ತಾ ಇದ್ದಾರೆ. ಇದು ಸಾಮಾನ್ಯ ಮಾತಲ್ಲ, ಇದು 8-10 ವರ್ಷದಲ್ಲಿ ಆಗಿರ್ತಕ್ಕಂಥದ್ದಲ್ಲ. ಇದು ಭಾಳ ವರ್ಷಗಳಿಂದ ನಿರಂತರವಾಗಿ ನಡ್ಕೊಂಡು ಬಂದಿರತಕ್ಕಂಥ ನಮ್ಮ ರಾಜ್ಯದ ಪರಂಪರೆ ಇದೆ ಇದು. ಹಾಗಾಗಿ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಇವತ್ತು ಆರೋಗ್ಯ ಕ್ಷೇತ್ರದಲ್ಲಿ, ವೈದ್ಯಕೀಯ ಶಿಕ್ಷಣದಲ್ಲಿ ವಿ ಆರ್ ದ ಲೀಡರ್ಸ್. ವಿ ಹ್ಯಾವ್ ಶೋನ್ ದ ವೇ, ವಿ ಆರ್ ನಾಟ್ ಫಾಲೋಡ್ ದ ಪಾತ್, ವಿ ಹ್ಯಾವ್ ಶೋನ್ ದ ವೇ ಟು ದ ಕಂಟ್ರಿ ಆ್ಯಂಡ್ ಕಂಟ್ರಿ ಈಸ್ ಫಾಲೋಯಿಂಗ್ ಇಟ್, ವಾಟ್ ಐ ಬಿಲೀವ್ ನಾವು. ಇವತ್ತು ನಿಮಗೆಲ್ಲ ಗೊತ್ತಿರೋ ಹಾಗೆ ಮೊನ್ನೆ ಒಂದು ಸರ್ಕ್ಯುಲರ್ ಬಂತು NMCಯಿಂದ, ಏನಂತಂದರೆ ಪ್ರತಿ 10 ಲಕ್ಷ ಜನಸಂಖ್ಯೆಗೆ 100 ಮೆಡಿಕಲ್ ಸೀಟನ್ನು ಮಾತ್ರ ಸೀಮಿತಗೊಳಿಸಬೇಕು ಅಂತಕ್ಕಂಥ ಒಂದು ಆದೇಶ ಹೊರಡಿಸಿದ್ರು. ಎಲ್ಲ ನಮ್ಮ ವೈದ್ಯರಿಗೆ ಗೊತ್ತಿದೆ. ನಾನು ಅದನ್ನು ವಿರೋಧ ಮಾಡಿದೆ, ಯಾಕಂದರೆ ಇಟ್ ಈಸ್ ಅ ವೆರಿ ರಿಡಂಡೆಂಟ್ ಸರ್ಕ್ಯುಲರ್ ಆ್ಯಂಡ್ ಇಟ್ ಇಸ್ ನಾಟ್ ಅಕ್ಸೆಪ್ಟಬಲ್ ಟು ದ ಸ್ಟೇಟ್ಸ್ ಅಂತ. ಯಾಕಂದರೆ ನಮ್ಮ ರಾಜ್ಯ ಮತ್ತು ದಕ್ಷಿಣ ಭಾರತದ ಏನು ರಾಜ್ಯಗಳಿವೆ, ಇಲ್ಲಿ ಸಾಕಷ್ಟು ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ ಇವೆ, ಇಲ್ಲಿ ಸಾಕಷ್ಟು ವೈದ್ಯರಿದ್ದಾರೆ. ಇಡೀ ಭಾರತ ದೇಶಕ್ಕೆ ಅತಿ ಹೆಚ್ಚು ಪ್ರಮಾಣದಲ್ಲಿ ಇಂಜಿನಿಯರ್ಸು ಮತ್ತು ಡಾಕ್ಟರ್ಸನ್ನು ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥದ್ದು ಯಾರು ಅಂತಂದರೆ ದಕ್ಷಿಣ ಭಾರತದ ರಾಜ್ಯಗಳು. ಅದು ತೆಲಂಗಾಣ, ಅದು ಆಂಧ್ರ ಪ್ರದೇಶ ಇರ್ಬೋದು, ಅಥವಾ ಕರ್ನಾಟಕ ಇರ್ಬೋದು, ಅಥವಾ ನಮ್ಮ ತಮಿಳುನಾಡು ಇರ್ಬೋದು, ಕೇರಳ ಇರ್ಬೋದು, ಮಹಾರಾಷ್ಟ್ರ ಟು ಸಮ್ ಎಕ್ಸ್ಟೆಂಟ್. ಈ ರಾಜ್ಯಗಳಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ಸು, ಈ ರಾಜ್ಯದಲ್ಲಿರ್ತಕ್ಕಂಥ ಏನು ಇಂಜಿನಿಯರಿಂಗ್ ಕಾಲೇಜಸ್ಸು ಇಡೀ ದೇಶವನ್ನು ಕಟ್ತಕ್ಕಂಥ ಕೆಲಸ ಮಾಡಿವೆ. ಹಾಗಾಗಿ ಇವತ್ತು NMC ಏನು ಹೊರಡಿಸಿದಾರಲ್ಲ, ಇದು ಹೊಸ ಒಂದು ಸರ್ಕ್ಯುಲರ್, ಇಟ್ ಈಸ್ ಅಗೇನ್ಸ್ಟ್ ದ ಸದರ್ನ್ ಸ್ಟೇಟ್ಸ್. ನಮ್ಮ ರಾಜ್ಯಗಳಲ್ಲಿ ಹಾಗಾದರೆ ಮುಂದೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜೇ ಪ್ರಾರಂಭ ಮಾಡೋಂಗಿಲ್ಲ ನಾವು. ಅದಕ್ಕೆ ವಿ ಹ್ಯಾವ್ ಅಪೋಸ್ಡ್ ಇಟ್. ವಿ ಆರ್ ಗೋಯಿಂಗ್ ಟು ರೈಟ್ ಎ ಲೆಟರ್ ಟು ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಆ್ಯಂಡ್ ಆಲ್ಸೋ ಟು NMC ದಟ್ ನೀವೇನಿದೆ ನಿರ್ಧಾರ ಮಾಡಿದ್ದೀರಲ್ಲ, ಇಟ್ ಇಸ್ ಎ ವೆರಿ ರಿಸ್ಟ್ರಿಕ್ಟಿವ್ ಆರ್ಡರ್ ಆ್ಯಂಡ್ ಯು ಕಾಂಟ್ ಇಂಪೋಸ್ ಆನ್ ದ ಸ್ಟೇಟ್ಸ್ ಬಿಕಾಸ್ ಇಟ್ಸ್ ಎ ಫೆಡ್ರಲ್. ನಮ್ಮ ಪ್ರಜಾಪ್ರಭುತ್ವ ಇದೆಯಲ್ಲ, ಇದು ಒಂದು ಫೆಡ್ರಲ್ ಸ್ಟೇಟ್ ಇದೆ. ವಿತೌಟ್ ಟೇಕಿಂಗ್ ದ ಒಪಿನಿಯನ್ ಆಫ್ ದ ಸ್ಟೇಟ್ಸ್, ಸೆಂಟ್ರ್ ಕಾಂಟ್ ಇಂಪೋಸ್ ಇಟ್ಸ್ ಡಿಸಿಷನ್ಸ್ ಆನ್ ದ ಸ್ಟೇಟ್ಸ್. ದಟ್ಸ್ ವಾಟ್ ಐ ಟೋಲ್ಡ್ ವೆರಿ ಕ್ಲಿಯರ್ಲಿ. ನಮ್ಮ ಮಾನ್ಯ ಕುಬಾ ಅವರು ಇದನ್ನು ಅವ್ರ ಗಮನಕ್ಕೆ ತರಬೇಕು. ಯಾಕಂದರೆ ದಕ್ಷಿಣ ಭಾರತದ ರಾಜ್ಯಗಳಿಗೆ ಇದೊಂದು ಭಾಳ ಮಾರಕವಾಗ್ತದೆ. ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಡಾಕ್ಟರ್ ಆಗ್ತಕ್ಕಂಥ ಅವಕಾಶ ಕಮ್ಮಿ ಆಗೋಕ್ಕೆ ಶುರು ಆಗ್ತದೆ. ಹಾಗಾಗಿ ಇಟ್ಸ್ ವೆರಿ ರಿಸ್ಟ್ರಿಕ್ಟಿವ್ ಆರ್ಡರ್. ಐ ಡೋಂಟ್ ನೋ ವಾಟ್ ಪ್ರಿವೇಲ್ ದೆಮ್ ಆರ್ ವಾಟ್ ಕಂಪೆಲ್ ದೆಮ್ ಟು ಡೂ ದಿಸ್. ಒಂದು ವೇಳೆ ಉತ್ತರ ಭಾರತದಲ್ಲಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಅವರು ಮಾಡಿಲ್ಲ ಅಂದರೆ ಅದು ನಮ್ಮ ತಪ್ಪ. ಅದು ದೇ ಶುಡ್ have done long back, and even they can do it now, but they should not restrict the southern states to do so. This is my frank opinion, and I am going to write to Government of India about this also. ಮತ್ತು ಇನ್ನೊಂದು ಭಾಳ ಕೆಲವೊಂದು ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ನಮ್ಮ ಸರ್ಕಾರ ವಿಶೇಷವಾಗಿ ಇವತ್ತು ವೈದ್ಯರು ಫೇಸ್ ಮಾಡ್ತಾ ಇರ್ತಕ್ಕಂಥ ಚಾಲೆಂಜಸನ್ನು ನಾವು ಅದನ್ನು ಹೇಗೆ ಅಡ್ರೆಸ್ ಮಾಡಬೇಕು ಅಂತಕ್ಕಂಥದ್ದು ಭಾಳ ನಮ್ಮ ಸರ್ಕಾರ ಬದ್ಧವಾಗಿದೆ. ಮತ್ತು ವಿಶೇಷವಾಗಿ ವೈದ್ಯರ ಮೇಲೆ ಆಗ್ತಕ್ಕಂಥ ಹಲ್ಲೆಗಳನ್ನು, ಅವರಿಗೆ ರಕ್ಷಣೆ ಕೊಡ್ತಕ್ಕಂಥದ್ದನ್ನು, ಮತ್ತು ನಮ್ಮ ಮಕ್ಕಳೇನು ಇವತ್ತು ಪಾಸ್ಔಟ್ ಆಗ್ತಾ ಇದ್ದಾರಲ್ಲ ಇವತ್ತು ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ಗಳಿಂದ, ಅವರಿಗೆ ಗುಣಮಟ್ಟದ ಶಿಕ್ಷಣ ಸಿಗ್ತಾ ಇದೆಯಲ್ಲ ಅಂತಕ್ಕಂಥದ್ದನ್ನು ಕೂಡ ನಾವು ಗಮನಿಸ್ತಕ್ಕಂಥ ಅವಶ್ಯಕತೆ ಇದೆ ಅಂತಕ್ಕಂಥದ್ದು ಕೂಡ ರಾಜ್ಯ ಸರ್ಕಾರ ಗಮನಿಸ್ತಾ ಇದೆ. ಯಾಕಂದರೆ ಇವತ್ತು ಏನಾಗ್ತಾ ಇದೆ, ಇವತ್ತು ವಿಶೇಷವಾಗಿ ಇವತ್ತು ಸರ್ಕಾರಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳಲ್ಲಿ ಮತ್ತು ಖಾಸಗಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳಲ್ಲಿ ಅನೇಕ ಇವತ್ತು ಏನು ನಮ್ಮ ಸ್ಕಿಲ್ ಲ್ಯಾಬ್ಸನ್ನು ಸ್ಥಾಪನೆ ಮಾಡೋದ್ರ ಜೊತೆಗೆ ಇವತ್ತು ನಮ್ಮ ವಿಶೇಷವಾಗಿ ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಇವತ್ತು ಅಲಾಂಗ್ ವಿತ್ ಈಗೇನೆಂದರೆ ಅವರಿಗೆ ಪ್ರಾಕ್ಟಿಕಲ್ ನಾಲೆಜು ಕೂಡ ಇರಬೇಕು ಅಂತಕ್ಕಂಥದ್ದಕ್ಕೆ ಇವತ್ತು ಅನೇಕ ಸ್ಕಿಲ್ ಲ್ಯಾಬನ್ನು ಕೂಡ ಸ್ಥಾಪನೆ ಮಾಡ್ತಕ್ಕಂಥದ್ದು ನಮ್ಮ ಸರ್ಕಾರ ಮಾಡ್ತಾ ಇದೆ. ಮತ್ತು ಜೊತೆಗೆ ಇವತ್ತು ನಾವು ಏನು ವೈದ್ಯರ ಜೊತೆಗೆ ಇವತ್ತು ಇನ್ನೊಂದು ಅನೇಕ ಚಾಲೆಂಜಸ್ IMA, ಯಾಕಂದರೆ ನಾನು ನೋಡ್ತಾ ಇದ್ದೆ ಈಗ IMA ಏನು ಸ್ಟ್ಯಾಂಡ್ ತೊಗೊಂಡಿದೆ ಕೆಲವೊಂದು ಇಶ್ಯೂಗಳಲ್ಲಿ ಅಂಥೇಳಿ. ಯಾಕಂದರೆ ಈಗ ನಮ್ಮ ಮಾನ್ಯ ಸಚಿವರು ಹೇಳ್ತಾ ಇದ್ರು ಏನಂತಂದರೆ ಜನೌಷಧಿ ಕೇಂದ್ರಗಳು ಅಂದರೆ ಜೆನ್ರಿಕ್ ಡ್ರಗ್ಗನ್ನು ಪ್ರಿಸ್ಕ್ರೈಬ್ ಮಾಡ್ತಕ್ಕಂಥ ಒಂದು ರಿಸ್ಟ್ರಿಕ್ಷನ್ನು ಕೂಡ ಕೇಂದ್ರ ಸರ್ಕಾರ ಸರ್ಕ್ಯುಲರ್ ಇಶ್ಯೂ ಮಾಡಿದೆ. ಅದಕ್ಕೆ ನಮ್ಮ IMA ಹ್ಯಾಸ್ ಅಪೋಸ್ಡ್ ಇಟ್. ರೀಸನ್ ಈಸ್ ದ್ಯಾಟ್ ಈಗ ಜನೌಷಧಿ ಕೇಂದ್ರಗಳಲ್ಲಿ ಇವತ್ತು ನಮ್ಮ UPA ಸರ್ಕಾರ ಇದ್ದಾಗ ಪ್ರಾರಂಭ ಆಗಿದ್ದು ಜನೌಷಧಿ ಕೇಂದ್ರಗಳು ಈಗ ದೊಡ್ಡ ಪ್ರಮಾಣದಲ್ಲಿ ಆಗ್ತಾ ಇವೆ. ಆದರೆ ನಂದೊಂದು ರಿಸ್ಟ್ರಿಕ್ಷನ್ ಇದೆ ಅದರಲ್ಲಿ, ನಂದೊಂದು ಆಕ್ಷೇಪ ಇದೆ. ಏನಂದರೆ ಜನೌಷಧಿ ಕೇಂದ್ರಗಳು ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ಆಗಬಾರ್ದು. ಐ ಆಮ್ ನಾಟ್ ಅಲೌಡ್ ಇನ್ ಮೈ ಲಾಸ್ಟ್ ಟರ್ಮ್ ಆಲ್ಸೋ. ಬಟ್ ಕಳೆದ ಸರ್ಕಾರದಲ್ಲಿ ಕೆಲವೊಂದು ಅಲೌ ಮಾಡಿದ್ದಾರೆ. ನಿಮ್ಗೆ ಯಾಕೆ ಅಲೌ ಮಾಡಲ್ಲ ಅಂತಂದರೆ, ನನ್ನ ಹತ್ರ ಭಾಳಷ್ಟು ಜನ ಫೋನ್ ಮಾಡಿದ್ರು. ಏನಂದರೆ ನಮ್ಮ ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ ಜನೌಷಧಿ ಕೇಂದ್ರ ಪ್ರಾರಂಭ ಮಾಡಿ ಅಂತ. ಐ ಆಮ್ ನಾಟ್ ಫಾರ್ ಇಟ್. ಐ ಆಮ್ ವೆರಿ ಫ್ರ್ಯಾಂಕ್ಲಿ ಟೆಲಿಂಗ್ ಇಟ್. ಯಾಕಂತಂದರೆ ನಾವು ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಗಳಿಗೆ ಫ್ರೀ ಆಫ್ ಕಾಸ್ಟ್ ನಾವು ಡ್ರಗ್ಸ್ ಕೊಡ್ತಾ ಇದ್ದೀವಿ, ಔಷಧಿಗಳನ್ನು ಕೊಡ್ತಾ ಇದ್ದೀವಿ. ಮತ್ತು ಅಲ್ಲಿ ಮಳಿಗೆ ಇಡ್ತಕ್ಕಂಥ ಅವಶ್ಯಕತೆ ಏನಿದೆ? ನೀವು ಮಳಿಗೆ ಬೇಕಿದ್ದರೆ ಬಾಜಾರಲ್ಲಿ ಮಾಡಿ, ಕಾಂಪಿಟೇಷನ್ನು ನೀವು ಬೇರೆ ಕಡೆ ಮಾಡ್ಬೋದು. ನಮ್ಮ ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ನಾವು ಮಾಡಿದರೆ ಮತ್ತು ನಾವು ಅವರಿಗೆ ಪ್ರಿಸ್ಕ್ರೈಬ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದು ಪ್ರಾರಂಭ ಆಗ್ತದೆ. ನಮ್ಮ ಡಾಕ್ಟರ್ಸ್ ಅಲ್ಲಿ ಪ್ರಿಸ್ಕ್ರೈಬ್ ಮಾಡೋದು ಪ್ರಾರಂಭ ಮಾಡ್ಬೋದು ಅಂತಕ್ಕಂಥ ಉದ್ದೇಶದಿಂದ ನಾನು ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ಎಲ್ಲೂ ಜನೌಷಧಿ ಕೇಂದ್ರಗಳಿಗೂ ಕೂಡ ಅವಕಾಶ ಮಾಡಿಕೊಡ್ತಾ ಇಲ್ಲ. ಹೊರಗಡೆ ಮಾಡಿ ನೀವು. ಕಾಂಪಿಟೇಷನ್ ಈಸ್ ಇನ್ ದ ಮಾರ್ಕೆಟ್, ನಾಟ್ ಇನ್ ದ ಹಾಸ್ಪಿಟಲ್. ದಿಸ್ ಹಾಸ್ಪಿಟಲ್ ವಿ ಹ್ಯಾವ್ ಕ್ರಿಯೇಟೆಡ್ ಟು ಗಿವ್ ಫ್ರೀ ಆಫ್ ಕಾಸ್ಟ್. ನಮ್ಮ ಉದ್ದೇಶ ಏನಿದೆ ಅಂದರೆ ನಾವು ಫ್ರೀ ಆಫ್ ಕಾಸ್ಟ್ ಕೊಡಬೇಕು, ಎಲ್ಲ ಡ್ರಗ್ಸು ಫ್ರೀ ಆಫ್ ಕಾಸ್ಟ್ ಕೊಡಬೇಕು ಅಂತಕ್ಕಂಥ ಉದ್ದೇಶ ಇದೆ. ಮತ್ತು ಜೆನ್ರಿಕ್ ಡ್ರಗ್ ಬಗ್ಗೆನೂ ಕೂಡ ಕೇಂದ್ರ ಸರ್ಕಾರ ತೆಗೆದುಕೊಂಡಿರ್ತಕ್ಕಂಥ ನಿರ್ಧಾರದ ಬಗ್ಗೆ ಇವತ್ತು IMA ಯಾಕೆ ಇವತ್ತು ಇದನ್ನು ವಿರೋಧ ಮಾಡ್ತಾ ಇದೆ ಅಂತಂದರೆ, ನಿಜ ಇವತ್ತು ಮಾರ್ಕೆಟಿನಲ್ಲಿ ಸಾಕಷ್ಟು ಇವತ್ತು ನಮ್ಮ ಡ್ರಗ್ ಪ್ರೈಸ್ ಭಾಳಷ್ಟು ಜಾಸ್ತಿ ಆಗಿದೆ. ಇವತ್ತು ಜೆನ್ರಿಕ್ ಡ್ರಗ್ಗು ಭಾಳ ಚೀಪಾಗಿ ಸಿಗ್ತದೆ, ಅದು 10% ಕಾಸ್ಟಲ್ಲೂ ಸಿಗ್ತದೆ. ಆದರೆ ಇವತ್ತು ಕೆಲವು ಕಂಪ್ನಿಗಳು, ಬ್ರ್ಯಾಂಡೆಡ್ ಕಂಪ್ನಿಗಳು ಭಾಳ ದುಬಾರಿಯಾಗಿ ಮಾರ್ತಾ ಇವೆ ಅಂತಕ್ಕಂಥದ್ದನ್ನು ಇವತ್ತು ಕೇಂದ್ರ ಸರ್ಕಾರ ಇದನ್ನು ಗಮನಿಸಿ ಇದನ್ನು ಒಂದು ರಿಸ್ಟ್ರಿಕ್ಷನ್ ಹಾಕಿದೆ. ಆದರೆ ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ನಾವು ಮುಂಚೆನೇ ಮಾಡಿದ್ದೀವಿ ಇದನ್ನು. ಏನಂದರೆ ನಮ್ಮ ಆಲ್ ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ಸಪ್ಲೈಸ್ ಆಲ್ ಜೆನ್ರಿಕ್ ಡ್ರಗ್ಸ್, ನೋ ಬ್ರ್ಯಾಂಡೆಡ್ ಡ್ರಗ್ಸ್ ಸಪ್ಲೈಡ್. ನಾವು ಟೆಂಡರ್ ಕರಿತಕ್ಕಂಥದ್ದು ಜೆನ್ರಿಕ್ ಡ್ರಗ್, ಯಾಕಂದರೆ ಚೀಪ್ ಕಾಸ್ಟಲ್ಲಿ ಸಿಗ್ತದೆ ಅಂತಕ್ಕಂಥದ್ದು. ಬಟ್ ಓನ್ಲಿ ಇಶ್ಯೂ ಈಸ್, ನಾವು ಒಂದು ವೇಳೆ ಹಿಂಗೆ ರಿಸ್ಟ್ರಿಕ್ಷನ್ ಡಾಕ್ಟರ್ಸಿಗೆ ಹಾಕಿಬಿಟ್ರೆ ಇದರಿಂದ ಪರಿಣಾಮ ಏನಾಗ್ತದೆ ಅಂತಂದರೆ, ದೆನ್ ಫಾರ್ಮಸಿಸ್ಟ್ ಯಾರು ಈ ಏನು ಶಾಪ್ಸ್, ಮೆಡಿಕಲ್ ಶಾಪಲ್ಲಿ ಡಿಸೈಡ್ ಮಾಡ್ತಾರೆ. ನೀವು ಯಾರಿಗಾದರೂ ನೀವು ಒಂದು ವೇಳೆ ನಾರ್ಫ್ಲಾಕ್ಸಿಲಿನ್ ಅಂತ ನೀವು ಪ್ರಿಸ್ಕ್ರೈಬ್ ಮಾಡಿಬಿಟ್ರೆ ಯಾವ ಕಂಪ್ನಿ ಡ್ರಗ್ ಕೊಡಬೇಕಂತ ಹಿ ವಿಲ್ ಹ್ಯಾವ್ ದ ಡಿಸ್ಕ್ರಿಷನ್. ಸೊ ಕ್ವಾಲಿಟಿ ಈಸ್ ಆಲ್ಸೋ ಅನ್ ಇಶ್ಯೂ. ಅದಕ್ಕೆ ಕೇಂದ್ರ ಸರ್ಕಾರ ಇದನ್ನು ಪರಿಶೀಲನೆ ಕೂಡ ಮಾಡಬೇಕು. ಇಫ್ ಯು ವಾಂಟ್ ಟು ಬ್ರಿಂಗ್ ಡೌನ್ ದ ಪ್ರೈಸ್ ಆಫ್ ದ ಡ್ರಗ್ಸ್, ಯು ಶುಡ್ ಪುಟ್ ಎ ಕ್ಯಾಪ್ ಆನ್ ದ ಪ್ರೈಸಿಂಗ್ ಆಫ್ ದ ಡ್ರಗ್. ದಟ್ ಕ್ಯಾನ್ ಬಿ ಡನ್ ಬೈ ದ ಗೌರ್ಮೆಂಟ್. ನೀವು ಪ್ರೈಸಿಂಗ್, ಯು ಪುಟ್ ಎ ಪ್ರೈಸಿಂಗ್ ಆನ್ ದ ಡ್ರಗ್ಸ್, but don't restrict people from writing what drugs they want. You see, it quality also matters. So ಇದನ್ನು ಇನ್ನೂ ಪರಿಶೀಲನೆ ಮಾಡ್ತಕ್ಕಂಥದ್ದು, ಇದು ಮಾಡಿರ್ತಕ್ಕಂಥದ್ದು ಇವತ್ತು ಸಾರ್ವಜನಿಕ ಹಿತಾಸಕ್ತಿಯಿಂದ ಕೂಡಿರ್ಬೋದು. ಆದರೆ ವಿ ನೀಡ್ ಟು ಟೇಕ್ ಅವರ್ ಡಾಕ್ಟರ್ಸ್ ಇನ್ ಟು ಕಾನ್ಫಿಡೆನ್ಸ್. ಯಾಕಂದರೆ ಯಾವುದೇ ನಮ್ಮ ನಿರ್ಧಾರ ಯಾವಾಗ ಅದು ಕಾರ್ಯಗತ ಆಗಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇದೆ ಅಂದರೆ ವಿ ನೀಡ್ ಟು ಟೇಕ್ ದ ಸ್ಟೇಕ್ ಹೋಲ್ಡರ್ಸ್ ಇನ್ ಟು ಕಾನ್ಫಿಡೆನ್ಸ್. ಅವ್ರಿಗೂ ಕೂಡ ಕಾನ್ಫಿಡೆನ್ಸಲ್ಲಿ ತೆಗೆದುಕೊಂಡು ಹೌ ವಿ ಕ್ಯಾನ್, ಯು ಸಿ, ಎಲ್ಲ ಸರ್ಕಾರಗಳು ಕೆಲಸ ಮಾಡ್ತಕ್ಕಂಥದ್ದು ಸಾರ್ವಜನಿಕ ಹಿತಾಸಕ್ತಿಯಿಂದ. It should be in public interest. Whatever we do in the public interest, we need to take the stakeholders in confidence. ಹಾಗಾಗಿ ಅದು ಮಾಡ್ತಕ್ಕಂಥ ಅವಶ್ಯಕತೆ ಇದೆ ಅಂತಕ್ಕಂಥದ್ದು ನನ್ನ ಭಾವನೆ. ಮತ್ತು ನಮ್ಮ ವಿಶೇಷವಾಗಿ ಇವತ್ತು ಕೋವಿಡ್ ಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಿ ಇವತ್ತು ಗೌರ್ಮೆಂಟ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ ಇರಲಿಲ್ಲ ಅಂತಂದರೆ ಏನೋ ಅದರ ಪರಿಣಾಮ ಆಗ್ತಿತ್ತು ಅಂತ ಊಹಿಸೋಕ್ಕೂ ಕೂಡ ಆಗೋದಿಲ್ಲ. ಒಂದು ವೇಳೆ ಬೀದರಲ್ಲಿ ಬೀದರ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇರಲಿಲ್ಲ ಅಂದರೆ, ಕಲಬುರಗಿಯಲ್ಲಿ ಕಲಬುರಗಿ ಮೆಡಿಕಲ್ ಕಾಲೇಜು, ESI ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಇರಲಿಲ್ಲ ಅಂದರೆ, ಟ್ರಾಮಾ ಸೆಂಟರ್ ಇರಲಿಲ್ಲ ಅಂದರೆ ಏನು ಪರಿಸ್ಥಿತಿ ಆಗ್ತಾಯಿತ್ತು? ದಿಸ್ ಆರ್ ಆಲ್ ಥಿಂಗ್ಸ್ ವಿ ನೀಡ್ ಟು ಸಿ ಫಾರ್ ದ ಫ್ಯೂಚರ್. ನಾವು ಈಗ ಎತ್ಕೊಳ್ಳೋದಲ್ಲ. ಇವತ್ತು ನಮ್ಮ ಸರ್ಕಾರ ಭಾಳ ಮೊದಲಿನಿಂದ ವಿ ಆರ್ ಪ್ಲ್ಯಾನಿಂಗ್ ಫ್ರಮ್ ದ ಬಿಗಿನಿಂಗ್. ಯು ಸಿ, ನಾನು 2004ರಲ್ಲಿ ಶಾಸಕನಾಗಿದ್ದೆ. 2004ರಿಂದನೇ ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಭಾಳ ಪ್ರಗತಿಪರವಾಗಿರ್ತಕ್ಕಂಥ ಚಿಂತನೆ ನಡೆದಿದೆ ಆರೋಗ್ಯ ಇಲಾಖೆಯಲ್ಲಿ ಮತ್ತು ಬೇರೆ ಬೇರೆ ಇಲಾಖೆಗಳಲ್ಲಿ. ಹಾಗಾಗಿ ಇವತ್ತು ರಾಜ್ಯ ಸರ್ಕಾರಗಳು, ಕೇಂದ್ರ ಸರ್ಕಾರ ಪಾಲಿಸಿ ಡಿಸಿಷನ್ಸ್ ಮಾಡ್ಬೋದು, ಬಟ್ ಕೇಂದ್ರ ಸರ್ಕಾರ ಇವತ್ತು ಸಂಸ್ಥೆಗಳನ್ನು ಸ್ಥಾಪನೆ ಮಾಡೋಕ್ಕಾಗೋದಿಲ್ಲ. ಕೇಂದ್ರ ಸರ್ಕಾರ, ನಮ್ಮ ಮಾನ್ಯ ಮಂತ್ರಿಗಳು ಹೇಳ್ತಾ ಇದ್ರು, ಮೆಡಿಕಲ್ ಕಾಲೇಜಿಗೆ ಅವರು ಕೆಲವೊಂದು ಉತ್ತರ ಭಾರತದ ಭಾಗದಲ್ಲಿ ಅವರು ಸಪೋರ್ಟ್ ಮಾಡಿರ್ಬೋದು. ನಮ್ಮ ರಾಜ್ಯದಲ್ಲೂ ಕೂಡ 4 ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಸಪೋರ್ಟ್ ಮಾಡಿದ್ದಾರೆ ಅವರು. ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಸರ್ಕಾರದಿಂದ ಸ್ಥಾಪನೆ ಆಗಿರ್ತಕ್ಕಂಥದ್ದು 25 ಇದೆ. ಅದರಲ್ಲಿ 4 ಕಾಲೇಜ್ಗೆ ಅವರು ಸಪೋರ್ಟ್ ಮಾಡಿದ್ದಾರೆ ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ. ಇನ್ನೂ 4 ಕಾಲೇಜ್ ಅಂದರೆ ಹಾವೇರಿ, ಒಂದು ಚಿಕ್ಕಬಳ್ಳಾಪುರ, ಒಂದು ನಮ್ಮ ಇನ್ನೊಂದು ಚಿಕ್ಕಮಗಳೂರು, ಆಮೇಲೆ ಯಾದಗಿರಿ. ಇವು 4 ಮೆಡಿಕಲ್ ಕಾಲೇಜಿಗೆ ಕೇಂದ್ರ ಸರ್ಕಾರ ಸಪೋರ್ಟ್ ಮಾಡಿದೆ. ಮಿಕ್ಕಿದ್ದೆಲ್ಲ ರಾಜ್ಯ ಸರ್ಕಾರ ಮಾಡಿದ್ದೇ ಇದೆ. ಹಾಗಾಗಿ ಇವತ್ತು ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ ಖಾಸಗಿಯವ್ರದ್ದು ಕೂಡ ನಾವು ಅಪ್ರಿಷಿಯೇಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಭಾಳಷ್ಟು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳು ಖಾಸಗಿ ಇವತ್ತು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ಗಳು ಭಾಳ ಗುಣಮಟ್ಟದ ಶಿಕ್ಷಣ ಕೂಡ ಕೊಡ್ತಾ ಇವೆ. ಅದರಲ್ಲಿ ಕೆಲವೊಂದು ಹೊಸದಾಗಿ ಪ್ರಾರಂಭ ಆಗಿರ್ತಕ್ಕಂಥದ್ರಲ್ಲಿ ಚಾಲೆಂಜಸ್ ಇರ್ಬೋದು. ಆದರೆ ಇವತ್ತು ದಕ್ಷಿಣ ಭಾರತದಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ಮೆಡಿಕಲ್ ಕಾಲೇಜು ಭಾಳ ಮುಂಚೆನೇ ಪ್ರಾರಂಭ ಆಗಿವೆ. ಮತ್ತು ಒಂದು ವಿಶೇಷ ಏನಂತಂದರೆ ಇವತ್ತು ನಮ್ಮ ಕೆಲವೊಂದು ಚಾಲೆಂಜಸ್ ನಾವು ಫೇಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಈಗ ಕೇಂದ್ರ ಸರ್ಕಾರ ಹೊಸದಾಗಿ ಬಂದ ಮೇಲೆ ಒಂದು ಆ್ಯಕ್ಟನ್ನು ಮಾಡಿದರು, ಏನಂದರೆ NMC ಆ್ಯಕ್ಟ್, ನ್ಯಾಷನಲ್ ಮೆಡಿಕಲ್ ಕಮಿಷನ್ ಆ್ಯಕ್ಟನ್ನು ಮಾಡಿದರು. ಹಿಂದೆ IMC ಇತ್ತು, MCI ಇತ್ತು. ಮೆಡಿಕಲ್ ಕಮಿಷನ್ ಆಫ್ ಇಂಡಿಯಾ ವಾಸ್ ಆನ್ ಎಲೆಕ್ಟೆಡ್ ಬಾಡಿ. ಅವಾಗ ಹೇಗಿತ್ತು ಕಾನ್ಸ್ಟಿಟ್ಯೂಷನ್ ಅಂತಂದರೆ ಹೌ ವಾಸ್ ಅನ್ MCI ಕಾನ್ಸ್ಟಿಟ್ಯೂಟೆಡ್? ಇದೆಲ್ಲ ನಾನು ಯಾಕೆ ಹೇಳ್ತಾ ಇದ್ದೀನಿ ಅಂದರೆ ಮಾನ್ಯ ಸಚಿವರು ಹೇಳಿದ್ರಿಂದ ಸ್ವಲ್ಪ ಕ್ಲಾರಿಟಿ ಇರಲಿ ಅಂತ ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಇವತ್ತು ನಮ್ಮ ದೇಶದಲ್ಲಿ ರೆಗ್ಯುಲೇಟರಿ ಬಾಡೀಸ್ ಶುಡ್ ಬಿ ಇಂಡಿಪೆಂಡೆಂಟ್ ಬಾಡೀಸ್. ವಿ ಡಾಕ್ಟರ್ ಶುಡ್ ಆಲ್ವೇಸ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ದಿಸ್. ಹಿಂದೆ ಸರ್ಕಾರ ಏನು ವಿಚಾರ ಮಾಡಿತ್ತಂದರೆ MCI ಮೆಡಿಕಲ್ ಕೌನ್ಸಿಲ್ ಆಫ್ ಇಂಡಿಯಾ ಹೇಗೆ ಕಾನ್ಸ್ಟಿಟ್ಯೂಟ್ ಆಗಿತ್ತಂದರೆ ಪ್ರತಿ ರಾಜ್ಯದಿಂದ 2 ಡಾಕ್ಟರ್ಸು ಎಲೆಕ್ಟ್ ಆಗಿ ಹೋಗ್ತಿದ್ರು. ಒನ್ ವಾಸ್ ಫ್ರಮ್ ಆಲ್ ದ ಏನಂತಂದರೆ ನಮ್ಮ ಎಲ್ಲ ರಾಜ್ಯದಲ್ಲಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ರಿಜಿಸ್ಟರ್ಡ್ ಪ್ರಾಕ್ಟೀಷನರ್ಸ್ಗೆ ಒಬ್ಬ MCI ಮೆಂಬರನ್ನು ಎಲೆಕ್ಟ್ ಮಾಡ್ತಿದ್ರು. ಇನ್ನೊಂದು ಸಿನೇಟ್ ಯೂನಿವರ್ಸಿಟಿಯಿಂದ ಒಬ್ಬರು ಎಲೆಕ್ಟ್ ಆಗಿ ಹೋಗ್ತಾ ಇದ್ರು ಥ್ರೂ ಸಿನೇಟ್. 2 members from each state, they used to get elected and go to MCI. And amongst them, there used to be one elected as a chairman and other office bearers. But now, with the new law, this is all bureaucratized. ಈ ಎಲೆಕ್ಷನ್ ಪದ್ಧತಿ ಎಲ್ಲ ಕೈ ಬಿಟ್ಟು ಹೋಗಿದೆ. ಈಗ ಏನಾಗ್ಬಿಟ್ಟಿದೆ, ಇಟ್ ಹ್ಯಾಸ್ ಬಿಕಮ್ ಅನ್ ಬಾಡಿ ಆಫ್ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ. ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಇವತ್ತು ಅವ್ರದ್ದು ಇರ್ಬೋದು, ನಾಳೆ ಬೇರೆಯವ್ರದ್ದು ಬರ್ಬೋದು. ದಿಸ್ ಇಸ್ ಡಿಫ್ರೆಂಟ್ ಕ್ವಶನ್. ಐ ಆಮ್ ನಾಟ್ ಕ್ರಿಟಿಸೈಸಿಂಗ್ ದ ಗೌರ್ಮೆಂಟ್ ಫಾರ್ ದ್ಯಾಟ್. But what happens, when some body which is supposed to be regulatory body and independent body and to be elected amongst the doctors, now it has become bureaucratic. I am not against bureaucrats. You see, we are working in a system where bureaucracy is one of the pillars of a democracy. But who is the head of the government? Head of the government should always be an elected person. That is what is envisaged in our constitution, and that was what our freedom fighters had thought of and given a direction to this country. Always it should be headed by elected representatives. ಹಾಗಾಗಿ ಇವತ್ತೇನಾಗಿದೆ, NMC ಇವತ್ತು ಬ್ಯೂರೋಕ್ರಾಟಿಕ್ ಆಗಿಬಿಟ್ಟಿದೆ ಅಂತಕ್ಕಂಥ ಭಾವನೆ ಜನರಲ್ಲಿ ಬಂದುಬಿಟ್ಟಿದೆ. ಯಾಕಂತಂದರೆ ಇಲ್ಲಿ ಎಲೆಕ್ಟೆಡ್ ಇದು ಕಮ್ಮಿ ಆಗಿ ಈಗೇನಾಗ್ಬಿಟ್ಟಿದೆ, ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾದಲ್ಲಿ ಇವತ್ತು ಅದೇನು ಪಾಲಿಸಿ ಏನು ಮಾಡಿದಾರಲ್ಲ, ಕೆಲವು ಅದರಿಂದ ಒಳ್ಳೆಯದೂ ಇದೆ, ನಾನು ಎಲ್ಲೂ ಕೂಡ ಏನಂತಿಲ್ಲ, ಒಳ್ಳೆಯದೂ ಇದೆ. ಆದರೆ ಇದೇನು ರೆಗ್ಯುಲೇಟರಿ ಬಾಡಿಗೆ ಇಂಡಿಪೆಂಡೆನ್ಸ್ ಇರಬೇಕಾಗಿತ್ತು, ಅದು ಸ್ವಲ್ಪ ಡೈಲ್ಯೂಟ್ ಆಗಿದೆ ಅಂತಕ್ಕಂಥದ್ದು. ಆ್ಯಸ್ ಎ ಡಾಕ್ಟರ್ ಐ ಆಮ್ ಟಾಕಿಂಗ್, ಬಿಕಾಸ್ ಐ ಆಮ್ ಆಲ್ಸೋ ಎ ಡಾಕ್ಟರ್, ನಾಟ್ ಓನ್ಲಿ ಎ ಮಿನಿಸ್ಟರ್, ಐ ಆಮ್ ಆಲ್ಸೋ ಎ ಡಾಕ್ಟರ್. ದಟ್ಸ್ ವಾಟ್ ಐ ಫೀಲ್. ಬಿಕಾಸ್ ಯು ಸಿ, ಈಚ್ ರೆಗ್ಯುಲೇಟರಿ ಬಾಡಿ ಶುಡ್ ಬಿ ಇಂಡಿಪೆಂಡೆಂಟ್, ಬಿಕಾಸ್ ಗೌರ್ಮೆಂಟ್ಸ್ ಹ್ಯಾವ್ their agenda. All governments have their agenda. Either it might be political or whatever. But you see, a regulatory body should be independent from all the clutches of the bureaucracy and the governments, because they should be independent thinking, so that then only can quality thrive. Then only can good things come into the society, is what I personally feel. ಹಾಗಾಗಿ ಇವತ್ತು ಇಷ್ಟೊಂದು ದೊಡ್ಡ ಸಂಖ್ಯೆಯಲ್ಲಿ ತಾವು ಬಂದಿದ್ದೀರಿ. ಇದು ಬಸವಣ್ಣನ ನಾಡಿದೆ, ಇಲ್ಲಿ ಹತ್ರ ಬಸವ ಕಲ್ಯಾಣ ಇದೆ. ದಯವಿಟ್ಟು ಎಲ್ಲರೂ ಬಸವ ಕಲ್ಯಾಣಕ್ಕೆ ಹೋಗಿ ಅಣ್ಣ ಬಸವಣ್ಣನ ಮಾಡಿರ್ತಕ್ಕಂಥ 12ನೇ ಶತಮಾನದ ಬಸವಾದಿ ಶರಣರು. ಯಾಕಂದರೆ ಇವತ್ತು ಬಸವ ಕಲ್ಯಾಣ ಬಸವಾದಿ ಶರಣರ ಬಸವಣ್ಣ ಅಂತಂದ್ರೆ ಬಸವಣ್ಣ ಒಬ್ಬರೇ ಮಾಡಿಲ್ಲ, ಇದು ಎಲ್ಲ ಬಸವಾದಿ ಶರಣರು. ಈ ಒಂದು ಭಾಗದ ಒಂದು ವಿಶೇಷತೆ ಏನಿದೆ ಅಂತಂದರೆ, ಇಲ್ಲಿ 12ನೇ ಶತಮಾನದಲ್ಲಿ ಕುಲಕ್ಕೊಬ್ಬ ಶರಣರನ್ನು ಗುರುತಿಸಿ ಅವರಿಗೆ ಅನುಭವ ಮಂಟಪಕ್ಕೆ ಕರೆತಂದು ಅವರಲ್ಲಿರ್ತಕ್ಕಂಥ ಪ್ರತಿಭೆ ಮತ್ತು ಆ ವಚನ ಸಾಹಿತ್ಯ, ಖಂಡಿತವಾಗಿ ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ ವಚನ ಸಾಹಿತ್ಯನೂ ಓದಬೇಕು, ನಿಮ್ಮ ಮಕ್ಕಳಿಗೂ ಪರಿಚಯ ಮಾಡಬೇಕು. ಯಾಕಂದರೆ ವಚನ ಸಾಹಿತ್ಯದಲ್ಲಿ ಇರ್ತಕ್ಕಂಥ ವಚನ ಸಾಹಿತ್ಯ ಇದು ಸಾಮಾನ್ಯ ಸಾಹಿತ್ಯ ಅಲ್ಲ. ಇದು ವಚನ ಸಾಹಿತ್ಯಕ್ಕೆ ಬೇರೆ ಸಾಹಿತ್ಯಕ್ಕೆ ಇರ್ತಕ್ಕಂಥ ವ್ಯತ್ಯಾಸ ಏನಂತಂದರೆ, ಬೇರೆ ಸಾಹಿತ್ಯ ಏನೋ ಫಿಲಾಸಫರ್ಸ್ ಬರಿಬೋದು, ಏನೋ ಕಲ್ಪನಾ ಲೋಕದಲ್ಲಿ ಇದು ಬರ್ತಕ್ಕಂಥದ್ದು ಬೇರೆ. ಆದರೆ ವಚನ ಸಾಹಿತ್ಯದ ವಿಶೇಷತೆ ಏನಂದರೆ, ನುಡಿದಂತೆ ನಡೆದಿದ್ರು ಶರಣರು. ಅವ್ರು ಏನು ತಮ್ಮ ಜೀವನದಲ್ಲಿ ನಡೀತಿದ್ರಲ್ಲ ಅದು ಮಾತ್ರ ಬರಿತಿದ್ರು ಅವರು. ಮತ್ತು ವಚನ ಸಾಹಿತ್ಯದಲ್ಲಿ ಅನುಭವ ಮಟ್ಟದಲ್ಲಿ ಇವತ್ತು ಯಾವುದೇ ಶರಣ ಯಾವುದೇ ವಚನ ಬರಿಬೇಕಾದ್ರೆ ಅದನ್ನು ಹೊರಗಲಿಗೆ ಹಚ್ಚಿ ನೋಡ್ತಿದ್ರು, ಈ ಶರಣ ಆ ವಚನದಂತೆ ನಡೀತಾನ ಇಲ್ಲೋ ಅಂತಕ್ಕಂಥ ಮಾತನ್ನು ಇವತ್ತು ಅದನ್ನು ಖಾತ್ರಿ ಪಡಿಸ್ಕೊಂಡೇ ಆ ವಚನಕ್ಕೆ ಅಂಕಿತ ಬೀಳ್ತಿತ್ತು. ಇದು ನಮ್ಮ ಈ ನಾಡಿನ ವಿಶೇಷತೆ ಇದೆ, ಈ ಅನುಭವ ಮಂಟಪದ ವಿಶೇಷತೆ ಇದು. ಮೊದಲನೇ ಪಾರ್ಲಿಮೆಂಟ್. ಯಾಕಂತಂದರೆ ಎಲ್ಲ ಸಮಾಜದ ಜನರಿದ್ದರು, ವಿಶೇಷವಾಗಿ ಮಹಿಳೆಯರಿಗೆ ಸಮಾನತೆ ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ನಾಡಿದು. ವಚನ ಸಾಹಿತ್ಯದಲ್ಲಿ ನಮ್ಮ ಹೆಣ್ಣು ಮಕ್ಕಳ ಭಾಳ ದೊಡ್ಡ ಪಾಲಿದೆ. ಅಕ್ಕ ಮಹಾದೇವಿಯ ವಚನಗಳು ಇವತ್ತು ಎಲ್ಲರಿಗಿಂತ ಶ್ರೇಷ್ಠ ಅಂತಕ್ಕಂಥ ಒಪ್ಕೊಂಡಿರ್ತಕ್ಕಂಥವ್ರು ನಮ್ಮ ಬಸವಾದಿ ಶರಣರು. ನಮ್ಮ ಒಂದು ವಚನ ಬರ್ತದೆ, ಚನ್ನಬಸವಣ್ಣವ್ರು ಹೇಳ್ತಾರೆ, ಆದ್ಯರ 60 ವಚನಕ್ಕೆ ದಂಡನಾಯಕರ 20 ವಚನಗಳು, ದಂಡನಾಯಕರ 20 ವಚನಕ್ಕೆ ಪ್ರಭುದೇವರ 10 ವಚನಗಳು, ಪ್ರಭುದೇವರ 10 ವಚನಕ್ಕೆ ಅಜಗಣ್ಣನ 5 ವಚನಗಳು. ನಮ್ಮ ಅಕ್ಕ ಮಹಾದೇವ 1 ವಚನ ನಿರ್ವಚನ ಕಾಣ ಅಂತ ಹೇಳಿದ್ದಾರೆ ಚನ್ನಬಸವಣ್ಣನವರು. ಅಂದರೆ ಅಕ್ಕ ಮಹಾದೇವಿಗೆ ಶ್ರೇಷ್ಠ ಸ್ಥಾನ ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ನಾಡಿದು. ಹಾಗಾಗಿ ತಾವೆಲ್ಲರೂ ಬಸವ ಕಲ್ಯಾಣಕ್ಕೆ ಹೋಗಿ ಅಲ್ಲಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಬಸವಾದಿ ಶರಣರು ಮಾಡಿರ್ತಕ್ಕಂಥ ಕ್ರಾಂತಿ, ಇದು ಸಾಮಾನ್ಯ ಕ್ರಾಂತಿಗಳ ಇಡೀ ವಿಶ್ವಕ್ಕೇ ಒಂದು ದಾರಿ ತೋರಿಸಿರ್ತಕ್ಕಂಥದ್ದು. ಮತ್ತು ವಚನ ಸಾಹಿತ್ಯದಲ್ಲಿ ಎಷ್ಟು ಶಕ್ತಿ ಇದೆ ಅಂದರೆ ಅದನ್ನು ಓದಿ ಅರ್ಥ ಮಾಡಿಕೊಂಡು ನಿಮ್ಮ ಜೀವನದಲ್ಲಿ ಅಳವಡಿಸ್ಕೊಂಡ್ರೆ ನಿಮ್ಮ ಜೀವನ ಪರಿವರ್ತನೆ ಆಗ್ತದೆ. ಅಷ್ಟೊಂದು ಶಕ್ತಿ ವಚನ ಸಾಹಿತ್ಯದಲ್ಲಿ ಇದೆ ಅಂತಕ್ಕಂಥದ್ದು ನಾವು ವಚನ ಓದಿ ನಮ್ಮ ಮಕ್ಕಳಿಗೂ ವಚನ ಪರಿಚಯಿಸಿ ಆ ವಚನದಂತೆ ನಾವು ನಡ್ಕೊಳ್ತಕ್ಕಂಥ ಪ್ರಾಮಾಣಿಕ ಪ್ರಯತ್ನ ಎಲ್ಲರೂ ಮಾಡೋಣ ಅಂತ ಹೇಳಿ ತಮ್ಮೆಲ್ಲರೂ ಒಂದೇ ಸೈಡ್ ಮಾತು ಮುಗಿಸಿ ನಮಸ್ಕಾರ.
Thank you, sir, for sharing your insight on reforms in medical science. Thank you, sir, for your wise words. Respected guests, it's our honor to invite Shri Rahim Khan. Sir's commitment to public service is commendable, and we are privileged to have him share his thoughts with us. Thank you, sir.
ತಮ್ಮೆಲ್ಲರಿಗೆ ನಮಸ್ಕಾರ. ನಾನು ಶಾರ್ಟ್ನಲ್ಲಿ ಮುಗಿಸ್ಬಿಡ್ತೇನೆ. ಆಲ್ರೆಡಿ ಸೆಂಟ್ರಲ್ ಮಿನಿಸ್ಟರ್ ಖೋಬಾ ಸರ್ ಅವರು ಮಾತಾಡಿದ್ದಾರೆ. ಹೀಗೆ ಮೆಡಿಕಲ್ ಎಜುಕೇಷನ್ ಮಿನಿಸ್ಟರ್ ಶ್ರೀಪ್ರಕಾಶ್ ಪಾಟೀಲ್ ಅವರು ಮಾತಾಡಿದ್ದಾರೆ. ಜೊತೆಗೆ ನಮ್ಮ MLC ಶ್ರೀನಾಥ್ ಪಾಟೀಲ್ ಅವರು ಇದ್ದಾರೆ. ಮತ್ತು ಕರ್ನಾಟಕ ಅಸೋಸಿಯೇಷನ್ ಅಧ್ಯಕ್ಷ ಅವರು ಮತ್ತು ಅವ್ರದ್ದು ಟೀಮ್ ಮತ್ತೆಲ್ಲ ಡಾಕ್ಟರ್ಸ್ ಮತ್ತು ಇಡೀ ನಮ್ಮ ಬೀದರ್ನಲ್ಲಿ ಏನು ಆರ್ಗನೈಸೇಷನ್ ಮಾಡಿದ್ದಾರೆ, ತುಂಬ ಒಂದು ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿಲಿಂದ ಸ್ಟಾರ್ಟಿಂಗ್ ಬೀದರ್ನಲ್ಲಿ ಅಷ್ಟು ದೂರಲಿಂದ ಈ ಸಮ್ಮೇಳನ ಒಳ್ಳೆ ರೀತಿಯಿಂದ ಆಗ್ತದೆ ಅಂತ ನಾನು ಕೇಳಿದಾಗ, ಇಲ್ಲಲ್ಲ ಸರ್ ನಾವು ವಿ ಟೇಕ್ ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿ ಮಾಡ್ತಾರಂತ ಹೇಳಿ ಅವರು ಮಾಡಿದ್ದಾರೆ. ಅದರ ಸಲಗೆ ಇಡೀ ಟೀಮ್ಗೆ, ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ಗೆ ಬೀದರ್ದು ಎಲ್ಲರಿಗೆ ನಾನು ತುಂಬ ತುಂಬ ಧನ್ಯವಾದ ಹೇಳ್ತೇನೆ. ದಟ್ ಈಸ್ ಎ ಗ್ರೇಟ್ ಜಾಬ್. ಈ ಸಮ್ಮೇಳನ ಬೀದರ್ನಲ್ಲಿ ಆಗಿರ್ಲಿಂದ ಸುಮಾರು ಸ್ಟೇಟ್ ಆಗಲಿ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಆಲ್ ಇಂಡಿಯಾ ಲೆವೆಲಿಂದ ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್, ಪ್ರೊಫೆಸರ್ಸ್ ಎಲ್ಲರೂ ಬಂದು ಈಚ್ ಗೆಟ್ ಟುಗೆದರ್ನಲ್ಲಿ ಆಗಲಿ ಡಿಸ್ಕಸ್ ಆಗಲಿ ಸುಮಾರು ಸಬ್ಜೆಕ್ಟ್ನಲ್ಲಿ ಏನೇನು ಡಿಸ್ಕಸ್ ಆಗಿದೆ. ಎಸ್ಪೆಷಲಿ ಬೀದರ್ ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ಗೆ ಅವ್ರದ್ದು ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಅದು ಎಲ್ಲ ಗೆಟ್ ಟುಗೆದರ್ ಆಗಿದೆ. ಅದ್ರ ಸಲಗೆ ನಾನು ತುಂಬ ತುಂಬ ಧನ್ಯವಾದ ಹೇಳ್ತೇನೆ. ಡಾಕ್ಟರ್ಸ್ ಬಗ್ಗೆ ಎಷ್ಟು ಹೇಳಿದ್ರು ಕಡಿಮೆ ಇದೆ. ಲಾಸ್ಟ್ ಟೈಮ್ ಕೋವಿಡ್ನಲ್ಲಿ ಎಲ್ಲ ಒಂದು ಎಕ್ಸಾಂಪಲ್ ಎಲ್ಲರಿಗೆ ದೇವರು ಸ್ವಲ್ಪ ತೋರಿಸಿದ್ದಾರೆ. ಅದರಲ್ಲಿ ಡಾಕ್ಟರ್ ಎಷ್ಟು ರೆಸ್ಪಾನ್ಸಿಬಿಲಿಟಿಯಿಂದ ಕೆಲಸ ಮಾಡಿದ್ದಾರೆ ಮತ್ತು ಎಲ್ಲರೂ ಎಷ್ಟು ಸೀರಿಯಸ್ ಆ ಟೈಮ್ ಡಾಕ್ಟರ್ ಹೆಲ್ಪ್ ಮಾಡಿದ್ದಾರೆ. ಅದ್ರ ಸಲಗೆ ನಾನು ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ಗೆ ಧನ್ಯವಾದ ಹೇಳ್ತೇನೆ. ಈಗ ಶ್ರೀಪ್ರಕಾಶ್ ಪಾಟೀಲ್ ಅವರು ಹೇಳತ್ತಿದ್ರು, ನಮ್ಮ ಮೆಡಿಕಲ್ ಕಾಲೇಜಸ್ ಆಗಲಿ ಇಂಜಿನಿಯರಿಂಗ್ ಕಾಲೇಜಸ್ ಆಗಲಿ ನಮ್ಮ ಇಡೀ ನಮ್ಮ ಸ್ಟೇಟ್ ಮೋಸ್ಟ್ಲಿ ನಂಬರ್ 1 ಇದೆ ಅಂತ. ಅದು ನಿಜವಾಗ್ಲೂ ನಮ್ಮ ಸ್ಟೇಟ್ನಲ್ಲಿ ಯಾವಾಗಲಿಂದ ಇದು ಫೌಂಡೇಶನ್ ಆಗಿದೆ, ಅದರಿಂದ ಬರೀ ಎಜುಕೇಷನ್ ಅಂತ ಇಲ್ಲ, ಈವನ್ ನನ್ನ ಪ್ರಕಾರ ಡಾಕ್ಟರ್ ಆಲ್ಸೋ ನಮ್ಮ ದೇಶದಲ್ಲಿ ನಂಬರ್ 1 ಇರ್ಬೋದು. ಕರ್ನಾಟಕನಲ್ಲಿ ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ ಒಳ್ಳೆ ರೀತಿಯಿಂದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಆಗಿ ಬೆಂಗಳೂರು ಆಗಲಿ ಗುಲ್ಬರ್ಗ ಆಗಲಿ ದೊಡ್ಡ ದೊಡ್ಡ ಪ್ಲೇಸ್ನಲ್ಲಿ ಸುಮಾರು ಗುಡ್ ಸರ್ವಿಸ್ ಕೊಟ್ಟು ಇಡೀ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಈವನ್ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಲೆವೆಲ್ ಆಲ್ಸೋ ಕರ್ನಾಟಕ ಹೆಸರಿದೆ, ಬೆಂಗಳೂರದು ಹೆಸರಿದೆ. ಸುಮಾರು ಬೇರೆ ಬೇರೆ ಕಡೆ ಸುಮಾರು ಜನ ಇಲ್ಲಿ ಬಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ತಗೋತಾರೆ. ಅದ್ರ ಸಲುವಾಗಿ ನಾನು ಇಡೀ ಡಾಕ್ಟರ್ಸ್ಗೆ ಮತ್ತು ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಯಾರ್ಯಾರು ಸಪೋರ್ಟರ್ ಮಾಡಿದ್ದಾರೆ, ಮೀಡಿಯಾ ಆಗಲಿ, ಮುನ್ಸಿಪಾಲ್ಟೀಸ್ ಆಗಲಿ, ಪೊಲೀಸ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಗಲಿ, ಆ ಎಲ್ಲರಿಗೂ ತುಂಬ ತುಂಬ ಧನ್ಯವಾದ ಹೇಳ್ತೇನೆ. ನಮ್ಮ ಸುಮಾರು ಜನರು CMC ಅಧ್ಯಕ್ಷ ಅವರು ಬಂದಿದ್ದಾರೆ, ಬ್ರಿಮ್ಸ್ ಡೈರೆಕ್ಟರ್ ಇದ್ದಾರೆ. ಅವ್ರು ಯಾರ್ಯಾರು ಇದರಲ್ಲಿ ಇನ್ವಾಲ್ವ್ ಆಗಿದೆ ಅವರಿಗೆ ನಮ್ಮ ಸರ್ಕಾರದಿಂದ ನಮ್ಮಲಿಂದ ಫುಲ್ ಸಪೋರ್ಟ್ ಇದೆ. ಮತ್ತು ಮುಂದೆ ತಾವು ಏನು ಹೇಳ್ತೀರಿ, ಸಜೆಷನ್ ಕೊಡ್ತೀರಿ, ವಿ ಆರ್ ರೆಡಿ ಟು ಡೂ. ಧನ್ಯವಾದ, ನಮಸ್ಕಾರ.
Thank you, sir, for appreciating our work and extending your support and helping us out. As we reach the conclusion of this significant gathering, I would like to invite Dr. Shantala Kaujalgi ma'am to address the vote of thanks.
Thank you, Sudhira. Respected dignitaries on the dais and respected dignitaries off the dais, my dear colleagues, all my dear students and friends. On this auspicious day, as we have come together to celebrate the commencement of 89th Annual Conference of Indian Medical Association State Branch, MEDICON 2023, which is hosted by IMA Bidar at Bidar Institute Medical Sciences. I, Dr. Shantala Kaujalgi, am profoundly honored to express my heartfelt appreciation to all those who have graced this occasion. Our deepest gratitude extends to our esteemed chief guest, whose presence enriches the significance of this event. Shri Bhagwant Kuba, Honorable Minister for Chemical and Fertilizers, Government of India, Dr. Sharan Prakash Patil sir, Honorable Minister for Medical Education and Skill Development, Government of Karnataka, Shri Rahim Khan, Honorable Minister for Municipal Administration and Hajj Government of Karnataka, Dr. Ajay Singh, Chairman Kalyana Karnataka Regional Development Board. Sir, your esteemed presence underscores your commitment to the advancement of healthcare and medical education. We are honored to have Shivkumar Lakol sir here, the President of IMA Karnataka branch. Your leadership is indispensable, sir. Our heartfelt appreciation extends to the distinguished guests on the dais and Dr. Shivkumar Shetkar sir, the Director, BRIMS Medical Education. Sir, we extend our thanks for helping the IMA in all the ways. I would like to thank Dr. Srinivasa sir and Chinivalar sir of IMA Karnataka State Branch Presidents. Everybody's presence symbolizes the unity and collaboration with the medical community. We cannot overlook the tireless effort of MEDICON Organizing Committee, the organizing chairman, Dr. Chandrakant Gudge sir, and Dr. Vijayshri Bashetti ma'am for their unwavering dedication in bringing the conference to the fruition. Our sincere thanks extends also to Dr. Mallikarjun Panshetti sir, who is the organizing secretary, whose meticulous planning and dedication have played a pivotal role in the success of this event. I extend my heartfelt appreciation to the esteemed faculty members who have shared their medical expertise through their talks, IMA members of Bidar branch and the district, as well the IMA members coming over here throughout the Karnataka state. My gratitude also goes to all my colleagues, seniors, juniors, ministerial staff, event managers, and dedicated press and media personals. I convey my best wishes for the successful and fruitful MEDICON 2023 at Bidar here. Thank you one and all and wish the success for the scientific session.
one important announcement to be made. The next scientific session will start in 15 minutes. There is a gap of 15 minutes for lunch break. The next scientific session will start in 15 minutes in both the halls. There is a lunch break of only 15 minutes.
male patients, and in our study what we found that 67% of the patients were of chest injuries and abdomen corresponded to 11.4 of it. In our study what we found that most them common was of 4 to 8 ribs. That's the reason why the splenic injuries were not, the liver injuries were not common, even though the right-sided chest injuries were very common. The conclusion part, the majority of it was the driven vehicles. Blunt injury, chest common, followed by abdominal injuries. That's four-wheeler was more common than compared to that of the two-wheelers and three-wheelers and the heavy vehicles. Splenectomy was required only in 18% of the patient, and bile leak in the hepatic injury was seen in 4 of 82 patients. The prevalence again of the chest injury was 67 as compared to that of the abdomen injuries, which was only 14%. Considering the fact that road-related accidents are quite predictable and controllable, the quality promotion of the traumatic patients' care and the road safety should be noted as a problem associated with the public health. These are my references. These are the few cases which has been published in the paper. Thank you, sir.
Thank you. Any questions?
Dr. Bashir, how common were the renal injuries?
So it was only in the, what we have seen, it was only seen around 10% of the patients. Most of them were of the data what we have. It's only 10% of the patients, and in that only grade 1 and grade 2 were there, sir. And the patients who required nephrectomy was only 2%, 2 patients, sir. In the 10, only 2 patients required nephrectomy, sir.
Okay, but what was the indication for nephrectomy?
It was actually shattered, this thing, sir, and urinoma formation was there. And continuously urine leak was there, which was not getting controlled. And associated injury was also there with the patient. Splenectomy was done to the patient. That's why associated nephrectomy was to be done, because it was again on the left-sided injury, sir. So that was the reason for the patient to go for nephrectomy. Otherwise, the patient with the grade 4 renal injuries who had a localized collection, even though the vascularity was absent, still nephrectomy was not done to the patient because the patient was stable.
And how commonly were the urethral injuries associated with pelvic fractures?
Yes, sir. Because I didn't cover the patients who are associated with the orthopedic and the neurosurgery part. That's why I had not included the urethral injuries, sir. Again, if I say like the percentage of the patients with the pelvic fractures, if there are 10% of 10 patients are there who has admitted with the pelvic fractures of say like around 3 to 4% of the patients used to have the associated urethral injuries, sir. And we were supposed to like manage them with only SPC at that point of time. And later then, if the patient was stable quite enough, then intra-op catheterization was done. Only few patients needed this thing, sir, definitive procedure in the later part of time. But most of the patients were managed with the intra-op catheterization, and those patients responded well, sir.
Nice. Nice presentation. Any questions, please?
I still remember about one of the cases, sir, which I had spoken to. He had a run over by a heavy vehicle over the abdomen, and all the viscera were out. Even the bladder was out, and it was been sutured. And somehow the patient developed wound infection, and still the abdominal wound discents were there. And through the SPC side, the urine was continuously leaking. We can see the bladder outside, and in spite of taking multiple bites over it, every time we take again after 2 days, 3 days, those sutures were gave up. So I called up, sir, to ask like how to manage it. That you cannot do anything to it. Wait for it. In presence of inflammation, it is not going to take. And believe me, like after 3 months when he came up, everything.
Thank you. Thank you, Dr. Bashir.
Thank you, sir.
Thank you so much, sir, for your wonderful presentation. That was indeed detailed and beautiful. We are honored to have you here, sir. I thank our chairpersons for chairing this session. Please give them a big hand. Moving on to the next session on rational use of antibiotics in office practice. I welcome upon stage the honorable chairpersons for the session, Dr. Sharan Gowda Patil sir, Dr. Sharan Mulla sir on the stage. Please give them a big hand. I welcome our honorable chairperson, Dr. Vasant Pawar sir on the stage. It gives me immense pleasure to invite upon stage our honorable speaker, Dr. Mallesh Gowda sir, senior pediatrician. Please give him a big hand.
Dr. Mallesh Gowda is a senior pediatrician at Raichur. He runs his own hospital along with a team of pediatricians at New Amruta. His area of interest being infectious disease, computers, and finance of doctors. And then he has served the IAP in different capacities, and he is a trainer at the national programs in various pediatric programs. He did his basic education of MBBS at JMC Davangere and DCH at AFMC Pune. I present you Dr. Mallesh Gowda for his presentation.
Good evening, friends and seniors. At the outset, I'll thank my organizers, IMA State and IMA Bidar branch, and Dr. Shantala Madam, and Dr. Kamale and Dr. Adarth, all Bidar team of pediatrics and IMA. Today, I am going to talk on the rational use of antibiotic in office practice. Though I am a pediatrician, but it generally fits to all the practitioners, irrespective of the branch. Hence, please listen carefully. By just following few samples, 90% or if your practice of antibiotic practice or usage of antibiotic in your private practice is going to be stopped. These are the objective of my talk. Why antibiotics selection should need some thought. What is the antibiotic is needed? If it is needed, what is the dose, duration, and how many days you have to give? And if you use, whether it is effective or not effective, how to analyze. First thing is remember, there is no fever, there is no acute infection. That is why there is no antibiotics. That is why you have to think that whether is there any infection. Then only you think of antibiotic, otherwise no antibiotic. If infection, you remember, is it community acquired? It is a nosocomial. Whether it is viral, bacterial, parasitic, fungal, or opportunistic, obviously antibiotic only works in a bacterial. It doesn't work in other causes of fever. If bacterial, you think the most probable offending pathogen, whether it is gram positive and gram negative, host factors where waiting is not safe. Other conditions you can wait, and few conditions straight away you have to start an antibiotic. What is lower, we will discuss in the next slides. When to use? Ideal is definitive antibiotic. There are two types. One is definitive, one is what is called as a presumptive or empirical use of. Definitive is you do a culture sensitive, get a reports and treat accordingly, but it is very rare, less than 10%. 90% what we use is empirical use. Empirical use means calculated guess of probable organism depending upon the age and the system involved, and then you will use an antibiotic. That is called as a empirical antibiotic. That is what we are going to talk today. For all the things you need is what is a provisional diagnosis. This is a must. Before writing your antibiotic, please think what is provisional diagnosis. Many of us, we don't write up is our name, down is the signature, in between nothing will be there. Why? Because we are afraid that you will make a mistake. But you please, provisional indicates itself that you can be wrong. But still it shows that what is your thought process, why you are using antibiotic. Please try to write. And other steps we already discussed. If you go through all, you can use a narrowest possible antibiotics and with the least side effect, with the least cost. That happens when you follow all steps what I tell. If you don't, that is we try to use a largest, longest, broadest antibiotic, costliest antibiotic. Because we don't know we never thought we want to cover everything. It is like what I call Sanjeevani. He could not recognize what is a fortune. There is Jambavanta to recognize what is Sanjeevani. For us, we are only Sanjeevani, we are only Hanuman. We have to recognize before. You cannot hit hard and every in the OPD practice depends upon curative therapy or a comfort therapy. Comfort is just talking nicely, explaining the natural illness of the course. It is possible in all the diseases, irrespective of the condition. But curative therapy is only possible when there is a bacterial organism that to tend to usage has to be only 10 to 15%. If you are using more than 50, 60, 70%, means that you are using unnecessarily without thinking of it. Skin and soft tissue infection, respiratory infection, gastrointestinal and genitourinary. If you remember in these groups and few antibiotics, you will be out. See, skin and soft tissue caused by Staphylococcus and Streptococcus. These are the drugs: cefadroxil, cephalexin, cefuroxime, and amoxicillin. These are the only 3 drugs or 4 drugs which is enough for treat a skin infection of whatever type, bacterial type. Lymphadenitis is caused by again the same organism, same group of antibiotic is needed, nothing else. Don't try to use a fancy antibiotics. Bites, including all the animals, including the humans, amoxicillin is the drug of choice because it has anaerobes along with these 2 organisms. Remember, amoxicillin above the diaphragm, anaerobic infection, below the diaphragm is the ornidazole, metronidazole, anything. Above amoxicillin, below the diaphragm is the ornidazoles. The simple rule. Respiratory conditions. Remember, these are the 3 organisms in all the types of respiratory infection. Sinusitis, whether it takes, pharyngitis, if it takes, and parasinusitis, ASM, all organisms in few addition and deletions in other conditions. Pneumococcus, H. influenza, and Moraxella. These are the drug of use, same antibiotics in most of the conditions. And this group A beta hemolytic staphylococcus, how to diagnose? 70%. Remember, pharyngitis, sore throat is 70% is viral, only in 30% is bacterial. How to recognize? By applying a Santoros criteria. There is a follicles on the tonsil, tender cervical lymph nodes, no running nose, no cold, no cough. Then straight away you can nose, never think of a bacterial. These are the drug of choice. You have to use these drugs for that conditions. Because I am running, time is less, you can ask the slides if at all, I will give afterwards. Next is a pertussis. The drug of choice is azithromycin. You can recognize by a classical oof. Anybody can recognize. Pneumonia. These are the organisms, as I told, same organism except their staphylococcus. These are the drugs. It will be used only in a resistance organism. Community acquired, these only drugs are enough. GIT and a GUT, genitourinary, CL, acute dysentery in pediatrics, 90% it is a bacillary, 10% is in a amoebic. In adolescent, it is maybe 50 or 70, 30%. That is why, especially in pediatrics, don't use a combined drugs. Only use only antibiotic, that in the form of cefixime, quinolones, only beyond 12 years. Don't use below 12 years. And no colistin aminoglycosides acid. Please don't use a colistin aminoglycosides acid. I have seen left and right, these will be used by general practitioners, surgeons and other, because it will never penetrate below the mucosa. It won't kill the bacteria. If at all you want to use a IV, you have to use a ceftriaxone, not those 2 drugs. Enteric fever, drug of choice is cefixime, quinolones, azithromycin, ceftriaxone if the child is sick. Don't use a combination of azithromycin, ofloxacin, cefixime, ofloxacin. So many combinations, they are useless and should not be used. UTI, 90% is caused by E. coli. Hence, the cefixime, cefadroxil, cephalexin, and quinolones are the drugs. If child is admitted, use a ceftriaxone. Aminoglycosides will never be first choice. If at all you want to use along with other drugs, because it is a bacteriostatic and it causes a lot of kidney damage. You have to remember 90% of it accumulates in the kidney corticals and only 10% in the blood. It can cause oliguric renal failure. You may not be able to recognize because we are happy they will never come. We won't do a urea creatinine. And it can cause irreversible hearing loss. That is why please don't use aminoglycoside. If at all you want to use it in different forms, you have to have other options. These are the rational combination. If antibiotic combination, only these are the rational antibiotic combination. You remember, even among these 5, if you remember only top 2 and down last one, these are the only antibiotic combination which is irrational. Please don't, there is hundreds of irrational antibiotic combination. Please don't use. Secondary super infections are very, very rare. What we think, many of friends, they'll use that viral infection, but they will add antibiotic because they tell that it is a secondary infection. It is never happens. Secondary infections are very rare. Only it happens in the immunocompromised condition like a severe acute malnutrition, burns, atypical, post-measles, chickenpox, or a congenital immunodeficiency conditions. Another thing is they will start using a higher antibiotic at the OPD practice. I am afraid that in my center receives on the first day antibiotic meropenem and the periphery itself. It is a very deadly situation because for our own kids and grandsons, you may not have any antibiotic. Last 10 years, there are no new antibiotics. Organisms developing resistance very fast. They may die because of small infection. Please don't use. Resistance organisms are very, very rare in office practice. Use a basic antibiotics. When not to use, I have discussed till now. When to use, when not to use, these are the conditions. Fever, cough, cold, diarrhea are viral unless otherwise proved. 90% them are, we are using antibiotics. How to differentiate, we'll see. Fever, there is a most of the time, it's like no fever, no antibiotic. Even one rule you can apply, you will avoid an antibiotic. If it is a viral fever, you have to think whether it is viral or bacterial. Few conditions, if you follow, it is enough. If the viral fever, you have a high fever at the beginning, start decreasing, in between child is playful, responds beautifully to the paracetamol, it is a viral. And one person, multiple person in a multiple system in a person, multiple person in a family, multiple family in a society, it is a viral 90%. And if the one system is involved, one person in a family is involved, child is sick, not responding to paracetamol easily, and play in between interfebrile child is not good, that is a bacteria for you. For even for adult. For these are the conditions where you should not wait less than 3 months. If you suspect that at the beginning itself the meningeal features, abdominal features, sick, septicemic shock, you should use an antibiotic at the beginning and then think of and get a bacteria investigation and then revise your antibiotics. These are the approaches common. Then cold, cough, fever. So you remember 6 to 8 attacks in a cold is a common, is all adults and you even if you make a glass house, you live, there are 6 to 8 attacks of common cold in a person. For us, we have seen that many of our ENT colleagues and surgeon colleagues will use antibiotic, but it is not needed because 90% it is a viral. Only in 10% when you suspect is when it is spread to the parallel like a ASM or the sinusitis. That is the only condition where you have to use the antibiotics. How to recognize? See, this is a classical history. Cold, fever is there at high at the beginning, start decreasing, and the cough will be there 10 to 15 days. For that, you don't use an antibiotic. For 30% of the children, in a cough, an adult also, cough can last 1 month also. That doesn't need antibiotics. But the problem is we'll use antibiotic at the beginning of the fever and then for a thick secretion for 2-3 days, then cough, third antibiotic will use. Please avoid that. Cough is another, is a airway disease. Cough is not an indicative of a parenchymal disease. More the severe the cough, more the reason you don't need an antibiotic. What are the 3 conditions where to use a cough is, you can remember the first one is a dotted one, is an acute cough with a delayed recovery, 15 to 20 days, that's the most common. Second one is cough comes and goes, in between child is alright, cough, adult comes and goes. This is a valvular or the allergic disorder, it can be asthma for you. And third one is you see the consistent, persistent cough with a history of weight loss for 5 to 10%, mild fever, that is a TB. Persistent cough is not a tuberculosis. I have seen many of our colleagues, we have started 20-30% of our OPD practice will have a ATT. If you apply simple rules, never tuberculosis never cause intermittent cough, never in between all right. It will be persistent for 2-3 weeks with a weight loss. Diarrhea, you remember, if only has a diarrhea, loose motion with the blood, then only you have to use an antibiotic. That too, visible blood. Microscopic blood is not a reason for today antibiotic. 90% of pediatric diarrhea is a viral, don't use. No blood at all, no antibiotics. But we have seen ofloxacin, ornodazole, all combination used left and right for a diarrhea. When you use an antibiotic, only these 3 conditions. Visible blood, when you suspect a cholera, when you have a parental die, a child has a septicemia along with the loose motion. These are the only 3 conditions where your antibiotic is needed. Don't use any antibiotics in any type of loose motions except these 3 conditions. What happens if at all if you use irrational? This is what happens. Circulation of resistant organism, partial treatment leads to brain absorption empyema, increased cost of therapy, heading for pre-antibiotic era, doomsday. And I told person can die with a simple infection if you use an antibiotic left and right. Take home message for last 2 slides. Only 10 to 15% and less of our patients need antibiotic. Benign bacterial condition like ASM and dysentery. Let us familiar with these conditions and think twice before we write antibiotic for remaining 80 to 90%, which are mostly a viral origin. These last slide, if you remember, this is enough. Respiratory tract infection, use only amoxicillin. Please don't use a cefixime. I have seen my other colleagues, other specialty, they use their own cefixime for cough and cold. And they will call, Gowda, what I have to do? My child is not responding. Don't use a cefixime. GIT and GUT, Cefix is the drug of choice. No aminoglycoside, no quinolones, no metronidazole. Skin and soft tissue infection, only use a cephalexin or cephadroxil. No linezolid or no vancomycin. Other things are. Thank you, Taring, for patience hearing. If I'm hurried up and made a confusion, I'm sorry. You can ask if any afterwards.
Thank you so much, sir. We're grateful. We're grateful to you for sharing your knowledge. We are honored to have you on the stage, sir. Thank you so much. Can we hear it for sir, please? I also thank our chairpersons for their honorable presence on the stage. Please give them a big round of applause. Delegates, please collect your certificate and I request our chairpersons to please collect your mementos and certificates at the selfie point. Moving on to our next session, panel discussion on antenatal anomalies, screening and counseling. I welcome our honorable chairpersons for the session, Dr. Jyotsana Hanam Shetty ma'am, Dr. Nirmala Hirimat ma'am. Please give them a big hand. It gives me immense pleasure to welcome stage our panelists, Dr. Megha Kamlapur ma'am, Dr. Arundhati ma'am, Dr. Seema Anand ma'am, Dr. Aarti R. Krishnamurthy ma'am. Please give them a big round of applause.
They will need a mic, chairpersons. Okay. Please start, madam.
Hello, good afternoon, everybody. After a beautiful, delicious lunch, we are now heading towards the infertility workshop. Antenatal screening workshop. Panel discussion is there. First, I am going to introduce Megha Kamlapur. She is from Gulbarga, trained, very much trained sonologist, and Dr. Seema, one of the most leading ultrasonologists,
Dr. Aarti Raghu, madam. She is also sonologist practicing in Bidar. So we all welcome you, ma'am. Start.
Thank you very much for allowing yourself to be rich with knowledge compared to the other hall where people are waiting to be rich with money, the wealth con. So thank you for sparing your time for this wonderful topic. Can we have the first slide, please? I'm the moderator of the session, and we'll be focusing today about premarital and pre-pregnancy counseling, which is a part of antenatal anomaly screening and counseling. So can we have the slide, please? So
till we get our first slide, I would like to introduce our moderator, Dr. Arundhati Patil. She is a pediatric neurologist, very passionate about pediatric neurology from Gulbarga.
Thank you, madam. We wanted to drive past one important topic, which is actually a major lacuna in India, that is premarital counseling and pre-pregnancy counseling, more so premarital counseling. So I would ask this question for Dr. Aarti. What are the opportunities for a physician to do premarital counseling?
Ma'am, whenever a girl or woman comes to us for any other complaints, like menstrual complaints, maybe hair fall, skin problems, acne, obesity, anything, the girl is brought by a mother, then we should take this opportunity to counsel regarding her wellness. Then any nutritional deficiencies we can correct to vaccination, especially rubella vaccination, we can tell. And if the girl is married already and she's pursuing for pregnancy, thinking of pregnancy, then we should give folic acid supplementation. That is most important, I feel, in this.
Yes. So seizing an opportunity, every opportunity to interact with especially an adolescent girl, especially the one reaching about 21 years. And two most important interventions, rubella vaccine and folic acid. Can we have the next slide, please? The presentation has not yet started. IT team, please. IT team. Yeah, we are running out of time. And this one is not opening.
And in this counseling, ma'am, actually we can ask her, like if the woman is planning for pregnancy in the next year, we can take the history related to what medical complications she has, any problem, diabetes mellitus, hypertension, hypothyroidism, or any thrombophilias, anything she is already suffering from. These all diseases should be optimized before she become pregnant. Whatever medicine she is taking, maybe prescribed or not prescribed medicines, just herbal medicines and all, we should review all those medicines, whether she is taking optimal doses or not. Then what all immunization she has taken, tetanus, diphtheria, cellular pertussis, rubella, mumps, measles, and even we can stress upon cervical screening and HPV vaccination in this age group.
Okay. Thank you. Thank you, Dr. Aarti. Now that we have counseled, we've made the woman ready for pregnancy, and then she comes to us pregnant. What is the time that the first scan should be done, Dr. Megha?
Okay, as soon as the girl comes to us with history of amenorrhea or a urine pregnancy test done at home and which is positive, first thing we should do is put the probe and confirm the pregnancy. Ultrasound is must during first visit. We need to locate where is the pregnancy. Is it intrauterine or extrauterine? And we need to date also.
Great. Dr. Seema, what is an NT scan?
NT scan, first we should understand what is NT. NT is a nuchal translucency. It is a fluid which is there behind the nape of the neck of the fetus. And we measure that in millimeters. If it is increased, it just tells us that the fetus is, this is a triaging, this is a screening test where we need to triage the fetuses which are at high risk and subject them for further investigations. So I would want to reiterate the fact that NT scan is not a diagnostic test. It is just a screening test which can help us pick up fetuses at high risk of having aneuploidy. And as far as the importance of NT scan, it is the most important scan, should not be missed. This is a most important scan which has to be, every lady, pregnant lady has to be offered NT scan. And increased NT doesn't mean that the fetus is absolutely abnormal. It just tells us that there is a high risk.
So, practice of, asking for pregnancy to be terminated should be discouraged.
Yeah.
Because NT scan is not 100%.
Yes, it is not 100% because it's just a screening test as any other screening test is. Next is why should we do an NT scan? NT scan is an opportunity, it's a window of opportunity where we get an opportunity to look at screen for aneuploidy, as well as with new machines, we can look at the anatomy as well. So diagnosis of multi-gestation pregnancy, mentioning the chorionicity, all this comes under NT scan, not just aneuploidy. And we also screen the lady for pre-eclampsia screening.
Okay. Seema, what are the anomalies that are always detectable?
So the anomalies which are always detectable are acrania, anencephaly, encephalocele, lobar holoprosencephaly, iniencephaly. These are some CNS abnormalities which are lethal, and these have to be picked up at 12 weeks.
Okay, next slide, please.
Yeah, as I said, the limitations of NT scan is we cannot come to a definitive diagnosis, and she has to be subjected for few more examinations, and it is very difficult in obese patients. So that is one limitation of NT scan. And the consultant should always counsel the patient that this test definitely takes more time. You might have to go to the doctor for once or twice because there are a lot of criteria to get an ideal NT. So that is what I want to reiterate.
Right.
Yeah.
Oh my God. मेरी शादी में इतना नहीं घूमी हूं मैं. Okay, right. Can we have the next slide, please? Next slide. Next. 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 Okay. Dr. Aarti, can you throw some light about aneuploidy screening?
Aneuploidy screening is basically the genetic testing that identifies chromosomal anomalies, especially trisomy 21, trisomy 18, and trisomy 13. Am I audible?
A bit, I think a bit louder. Yeah, that's good.
Aneuploidy screening is a genetic test where we screen for trisomy 21, trisomy 18, and trisomy 13. Into this, we take into account maternal age, because age, if it is more than 30, aneuploidy risk increases. Then ultrasonography marker, as Seema told about nuchal translucency, nasal bone, tricuspid regurgitation, and reverse AO in DV Dopplers, along with other anatomical factors, anatomical structural anatomy of the fetus. Along with this, we do testings. In this, there are two types of tests: first trimester and second trimester. First trimester is double marker test, and second trimester is quadruple marker test. And again, it is backed up by non-invasive testing, that is cell-free fetal DNA. Irrespective of age of the woman, all women should be advised or counseled about biochemical screening, because most of the cases of trisomy 21 we are seen in low risk women, less than 30.
Okay, so your message that triple marker test should no longer be done.
Yes, ma'am. Its
Needs to go
sensitivity is
down.
very less, between 60 to 65%, whereas we are getting 80 to 85% of sensitivity with double and quadruple marker. And one thing should be remembered in this: always this report should be in multiples of medium. That is, MOM values should be given in the report, and risk is assessed as low risk, intermediate risk, or a high risk. If the cutoff value is higher than the for that age and for that population, then it is high risk. And always a high risk test should be backed up with invasive testings. And if it is low risk, then we should go with normal antenatal checkups with anomaly scan and all. And if it is in between, like intermediate risk, then we should go for cell-free DNA, that is non-invasive prenatal testing, NIPT, after 10 weeks of gestation. And it gives the sensitivity of more than 99% for detection of T21. But still, it is a screening test, not a diagnostic test. So if it is high risk in biochemical screening or cell-free DNA, we should not be terminating the pregnancy. It should be backed up with invasive testing.
Thank you, Dr. Aarti. Dr. Megha, this question is for you. Suppose we have a raised nuchal translucency. What next?
Yeah, as Aarti has rightly pointed out that with just raised NT report, the patients, they come for termination of pregnancy. And it is the duty of physician treating her to tell and counsel them that it's not an abnormality, it's just their high risk for certain diseases, and we need to investigate that, first one. And second, if that NT scan is done, we have to just confirm the accuracy, the person who has done that, and how is the image. Preferably, the person who is doing ultrasound should give an image of proper NT, which we have seen in previous slides. If at all NT is raised, then first thing we have to just go for confirmation of karyotype. Karyotype, if it is normal, or we can offer microarray depending upon the affordability of the patient, because karyotype will not pick up single gene disorders. So we need to extend our investigation panel to microarray. And if it is normal, then this patient should undergo early TIFA, detailed TIFA scan, and fetal echo. And we know that despite of raised NT, there are still 70% of the babies who will be normal at the end of the pregnancy. And that is the reason we need to spend a little more time for our patients to tell that raised NT is not an answer for termination of pregnancy.
Right, thank you. What are the prenatal invasive tests that you want to do, Dr. Megha?
Yeah, the test blood sampling. So we know that the chorionic villus sampling, or CVS, where we'll be testing for trophoblastic cells, and that is done after 10 weeks of pregnancy. If it is done before that, then there are chances of oromandibular hypoplasia and limb reduction defect. The procedure-related risk for CVS is very less, even less than 1% or 1 to 1.9%. Whereas amniocentesis, we test for amniocytes, which are obtained from the amniotic fluid, and that has to be done only after 16 weeks of pregnancy. If it is done before that, then the baby may develop talipus, and the procedure-related risk for this is also 1%. If NT scan is raised, rather than offering CVS, I would definitely ask her to go for early TIFA. If any structural marker is seen in that, then we can offer her a better option of amniocentesis.
Seema, what is a genetic sonogram?
Genetic sonogram again is offered for the patients who are high risk and intermediate risk, or with previous history of some structural abnormality in the previous pregnancy, as for example some cardiac abnormality or open neural tube defect. And this is what is a reassessment scan. The risk is reassessed depending upon the presence or absence of the soft markers. It's just that it is a reassessment scan. The risk is reassessed and reassigned. So if it is high risk, again, as madam said, we have to go for some invasive testings. If not, we can just look at all other structures in this scan in detail and go ahead with it. And the genetic sonogram is only 56% efficient in detecting Down syndrome. So again, stress upon NT scan in every lady. Thank you.
Do you want to now tell us about an anomaly scan?
Yeah, anomaly scan basically is a scan which will, in here we are going to look at the anatomy in detail and pick up anomalies.
What is the ideal time to do an anomaly scan?
Yeah, ideal time is 20 to 22 weeks. The minimum time required is 23 minutes. So again, I would request the consultants, the referring physicians, to just tell the patient that this definitely takes time because we have to look at each and every part. So counseling of the patient before sending for the scan is very, very important. Otherwise, the patients feel that they're taking long time because we are not able to see the structures.
And what anomalies can be missed, Dr. Seema?
Yeah. The first question after the scan is over is, Madam, everything is all right. No. So there are many developing, evolving anomalies in CNS because CNS will evolve throughout. So CNS abnormalities like migrational disorders of brain, microcephaly, then isolated cleft palate, ASDs in cardia, and PAPVC, that is pulmonary anomalous venous connection partial, and tracheoesophageal fistula. This is the most common thing where we have to understand the fact that we can't diagnose tracheoesophageal fistula antenatally. We can just pick up the indirect signs. So tracheoesophageal fistula is one thing which I would want to stress upon, that it can't be picked antenatally at anomaly scan.
What are
And
the
so on and
limitations
so
of an anomaly scan?
Yeah, it depends on the fetal position. As I said, that's why it takes more time for us to scan the patient. And amniotic fluid, if there is oligohydramnios since the beginning, it makes our job difficult. If it is obese patient, again, she might have to come again for review scans. And despite careful examination, there are many evolving abnormalities. So anomaly scan doesn't mean 100% structurally and chromosomally normal fetus. So this has to be understood. And pickup rates depends again on the expertise, and improper counseling can lead to unnecessary terminations. So polydactyly is there. So they might think there will be some congenital heart disease and terminate. So single kidney, we have seen many babies terminating for single kidneys. So these are some things where counseling is very, very important once the scan is over.
My next question is for Dr. Aarti. Yeah? Behind. Yes, sorry. What are the anomalies that can be detected only in the third trimester, Dr. Megha?
Yeah, this is very important to understand. As Seema has already told that normal anomaly scan or normal TIFA scan doesn't guarantee normal baby, because because of the disease process, there are certain evolving anomalies which are detected only during third trimester or even after the delivery. So these abnormalities, as we are seeing very well in this slide, that these abnormalities which are mostly seen in third trimester, like mild ventriculomegaly, arachnoid cyst, or rhabdomyomas, or bowel obstructions. Whereas anomalies which are seen exclusively in third trimester, they are like microcephaly, ovarian cysts, or achondroplasias or dacrocystocele. What is important is the labor room surprises. Many abnormalities like isolated cleft palate, polydactyly, syndactyly, ambiguous genitalia, and tracheoesophageal fistulas, they are not detected always by prenatal ultrasound. And here is the role of team with a neonatologist and our pediatrician friends. I would like to highlight one point is that the 1 in 200 pregnancies, we may come across an abnormality in third trimester, and that is why, despite of second trimester scan, we need to offer a third trimester scan to rule out fetal abnormalities.
Thank you, Dr. Megha. Dr. Aarti, would you be quick and tell us what are the things that you would do to screen for fetal growth? We just have 30 seconds.
Ma'am, growth assessment is very essential part of antenatal care, and ultrasonography is very important in this. First important thing I can tell about growth is it is a dynamic process. So assessment of gestational age is very important, and dating should be done by CRL before 14 weeks of pregnancy. If the dating is not done properly, then we cannot assess growth later on. And every scanning, each and every scanning, we cannot give estimated the expected date of delivery. It should be given only, it should be assigned in the first trimester. And after that, we will follow growth by biometry like BPD, HC, AC, FL, and estimated fetal weight. It should be backed up with Likert assessment, AFI or single deepest vertical pool, fetal Dopplers like umbilical Doppler, then uterine artery Dopplers, MCA Dopplers, and CPR, along with biophysical profile. We are doing growth scans at 32 weeks and later between 36 to 37 weeks to know the growth restriction, if it is early onset or late onset. Previously, it was symmetric and asymmetric. Now we are using early onset if it is detected less than 32 weeks, and if it is after 32 weeks, then it is late onset IUGR.
Okay, thank you so much. We just started from premarital counseling to pre-pregnancy counseling to first trimester and second trimester and third trimester. And finally, a last word, because the pregnancy is not complete without reaching its logical end. So what do we do with the baby that is born? We know that we are short of time. Just two things. I just put these two things here. One is the ear, another is the blood spot. It is a crime if we are not screening for babies for hearing as soon as they are born. And please let us be mindful that it is universal newborn hearing screening. Because if a child is not screened for his newborn hearing, then this is what happens. This is a normal synapse. This is a synapse which is lacking stimulation. And if you can see here, the more time we allow for hearing loss to continue, the more Valerian degeneration occurs here at the left end of the slide. And lastly, it is a simple procedure, costs about 100 rupees. So hardly anything, just about enough to feed one person for a breakfast. And newborn screening is for at least for two diseases, congenital hypothyroidism and for congenital adrenal hyperplasia. There are other investigations also done. Kerala is one state which has instituted this in their government health program, and it's about time we all do it in our state as well. If not, at least please do it in your practices. Allow for hearing screening, allow for newborn screening, and we cannot ensure that we can treat everything, but at least we can prevent whatever we can. Thank you so much for your patient hearing. Thank you to the panelists and the chairpersons and the organizers for giving us this wonderful opportunity to see how we can prevent and see that we have a healthy confinement. Thank you.
I thank our honorable panelists for the wonderful and detailed discussion on such an important matter. We are honored to have you all here, ma'am. Please give them a big round of applause for the panelists, please. I thank our honorable chairpersons. I request them to collect the certificate and mementos from the selfie booth. Thank you. Moving on to our next session, robotics and joint replacement. Please welcome our chairpersons, Dr. Anand Japshetty, Dr. Salia Dharmayat. It gives me immense pleasure to invite upon stage our honorable speaker for this session, Dr. Kushal Hippal Goankar, orthopedic and joint replacement surgeon, KIMS Hospital, Hyderabad. Please give him a big hand. I welcome our honorable chairperson, Dr. Vaibhav sir, on the stage.
I'm a consultant orthopedic surgeon at Sunshine Bone and Joint Institute, Hyderabad. It used to be called Sunshine Hospitals. Now we call it KIMS Sunshine Hospitals. Can we have the slides, please? Yeah. So this is our label now. That is Sunshine Bone and Joint Institute, which is a enterprise of KIMS Hospital. So my topic is robotics and joint replacement. And just to give you an idea, I'm not going to go into the specifics of the robotics, but just an overview of what it is looking like. This is what our robot looks like. This one's not working. Can I? Yeah, so we currently have 3 robots, 2 from the company Stryker called Mako and 1 Cubis. Next slide, please. Is this working? Okay. So in a nutshell, robotics doesn't mean that you're going to enter and leave everything for the robot to do. It's not like that. It's a robot assisted surgery. So as you can see, that's the robot there. This pointer, it'll be nice if someone gives me. But then the hand of the surgeon is still there. We have to do the cutting, the opening up of the joint. And then after that, it's the robot which is going to precisely make the cuts which we need to replace and put metal over there. So in joint replacement, the essence is that we replace the worn out bone and cartilage with metal. So that assistance is done by the robot, and therefore it is a robotic assisted joint replacement. Next, please. So these are some of the techniques how to do it. These are 2 videos. Can you play them, please? You can directly play the second video. Yeah, you can see here that the hand of the surgeon in the first video is being guided by the robot. And in the second one, the second video, please. Yeah, after setting up everything, it's only the cuts that are going to be done directly by the robot. This is called an autonomous robot. So it's this is the one by Cubis, that is a Merrill company, which is going to do a job on its own. You can see it over there. Pointer, please. Next, please. Yeah, this is our main robot, the Stryker robot. It's a video. Play this, please. So it's going to take a position where we want the bone to be cut, because the worn out cartilage and bone has to be cut and then replaced by metal. So this cutting part, it doesn't allow our hand to go away from the boundary, that is called a haptic boundary, so that the soft tissues around are not damaged. So then this helps in adding to the safety of the procedure, right? So next, please. Now, this robot can do all the 3. Joint replacements are many in the body, including shoulder, elbow, ankle, but we are going to focus on the knee and the hip. In knee, there's a total knee replacement and a partial knee replacement. So these 2, and then the hip replacement, all are possible with this robot. Next, please. So this is basically what we get. In before robotic surgery, we would just take an X-ray of the patient and start doing our surgery. So the only information we had is how does the knee joint look like, hip joint look like on the X-ray. But here we take a CT scan and then we do what is called enhanced planning. So that planning in terms of exact size of the implant to match that particular patient's size is done pre-op, and then intra-op, what is called a dynamic joint balancing, that is possible, and then finally the bone preparation, which is done by the row. Next, please. These are the 3 main advantages. And just to give you an example of how this happens, so we take a CT scan of the patient before the surgery starts. Once the CT scan is taken, this is something called a segmentation. That means we build the entire model of the patient's anatomy, and then we get an accurate understanding of what is the size of the femur, the tibia, and therefore we are able to do this job better. So that's the idea of the accuracy. Next, please. Yeah, this is just a technical information that we get inside while doing the surgery, which we never had before. Now we're able to assess what kind of gaps we have in the knee and therefore do a better job of balancing the knee while we are putting in the implants. Next, please. And there you go. You can see the green boundary over there, both on the screen over here, which is the boundary for our instruments, our cutting instruments, so that they violate those boundaries. So the robot doesn't allow my hand to go beyond the boundary. So that adds to the safety, because there are so many soft tissue structures, including ligaments, around the knee joint, which should not be injured, and sometimes they are because of the proximity of those ligaments. You can see the MCL, how close it is. So this way we are safe. Next, please. Yes, a similar concept. I'll skip this slide in for want of time. Next, please. Next. Yeah. So just in case you thought it's a very new technology that just came in 1-2 years ago, that's not the case. It's just that in India, the acceptance of robotics is now much better all over the country because of the last 3 to 4 years in which this spurt has happened. But in the world, this has been going on. You can see the numbers there, 13 years or so since the time this is here, 130 peer-reviewed studies, 3 lakh more procedures and about 1,000 installations. So lots of data already available on this. So it's not new, it's not like experimental. Next, please. So now this is just a comparison of robotic surgery with manual surgery. You can see the purple slide being manual surgery and the blue one being robotic surgery. And yeah, this is the graph is showing basically on the x-axis the days after the procedure, and on the y-axis how much pain the patient is suffering from. You can notice the clear difference between the two. Though they equalize after a certain point of time, 3 to 6 months, it's that initial phase which is very much beneficial to the patient. Next, please. And at 2 years, you can see the quantum of the patient satisfaction. Now, patient satisfaction after knee replacement especially is somewhere around 80%. But you can see how that enhances, and even at 5-year follow-up, the percentages are very high. Next, please. Again, less is everything. Less bone and soft tissue damage, as I said. Less need for opiate analgesics because the pain is overall less. Less time to hospital discharge because the pain is less, so the patient is happy to go home early. And physiotherapy sessions are less, post-op pain is less. Next, please. So this is our little journey. I don't want to go into the specifics of the robotics, so I'll just touch upon what we did, how we adopted this technology. In 2019, just before COVID, we went and did a survey of what all the types of robots are around the world. And we went to Australia, at St. Vincent's, St. Epworth. These are the 2 places I visited. And then next, please. This was like a eye-opener for us. We've seen and felt the robots over there. And then again, we had to travel because this robotic certification requires you to first do what is called an observership, and then you need to do it on a cadaver, and then finally you need to get in a proctor to do it in your hospital. Next, please. This is in the cadaver center at Mahwah in the US. Next, please. And then finally on 1st February 2020, next please. This is our team. We got the designation as a designated global center of excellence in robotic joint replacements. This was given to us by the company, the Stryker, and that was a proud moment for us. Next please. This is when we launched it. And now we have a big team. There's about 12 of us who are trained in robotic surgery and certified for the same. Next please. Immediately once we got the robot, we made certain achievements. This, if you can see it over here, fastest 200 joint replacements all over the world. Ours was the center that accomplished that. Next, please. And despite 2 lockdowns in the last 3 years, we were able to do 5,550 surgeries just until last week. This is the calculation. And the average procedure time is about the same as a manual procedure. So this is the kind of experience our institute has for robotic joint replacement surgeries. Next, please. And now, because of all this experience, what has happened is, because we had to travel all over the world to just understand what a robot does and then emulate it and then learn it over here, we've become proctors for the same. So we are able to now train the surgeons from India in how to do that. That is our team going to Bangalore, Pune, Chennai to do these cadaver courses for other surgeons so that they get certified in the same. Next, please. Yeah, and then surgeons, this is our hospital. So a lot of surgeons from all over India are coming to our hospital to learn this art. Next, please. Next, please. Now, what does it mean for our patient? You can just see a robotic replacement, the partial knee replacement. You can see how comfortably on first day or second day post-op, the patient doesn't need a walker. She's just able to walk on her own and have a conversation casually, just sitting on the floor, bending the knee fully and walking. That is the kind of confidence that the patient achieves after this kind of a procedure. Next, please. And you can see this person 1 week after surgery. He's not 40, 50 or 60. He's a 80-year-old gentleman. Next, please. Who is walking comfortably. And this is next video, please. This is a video of a patient just 4 hours after surgery. Despite, I mean, of course, the spinal effect after it wears off, you can see the bending that is possible in this patient. Next, please. And all over the world, the simple knees, because the Western world, patients come in quickly, so they are asked to do the knee replacements quickly. But in not for this audience, but I'll show you the paper which we published. Next, please. Next, please. So these are again some horrendous deformities. Play the videos, please. Yeah. You can see this person with a hyperextension knee, a valgus knee. And can you play the video? Video, please. Yeah. It's not playing? Okay. That's okay. Next slide. That's fine. Yeah. Yeah, you can see the valgus recurvatum knee, which immediately with the post-op, next please. Yeah, the knee becomes straight, next please. And then you can see the patient, next please. Yeah, this is the same patient on the 10th day. The knee looks straight, there is no recurvatum or valgus, and therefore that's the advantages we have. Next please. Yeah, so it's not just some new technology that we're bringing in. We are also trying to understand how we can apply this to especially the gross deformities. So you can see the first title, Enhanced Mid-Resection Workflow Technique for Severe Varus using Robotic. This was the first paper on gross deformities that is done worldwide. And we from Sunshine Bone and Joint Institute published this last year in July. And several more such papers have been published. And now we have a grand total of 101 research articles in peer-reviewed journals. Next, please. So next, one more slide. So thank you for the patient listening. This is just, can you increase the volume? This is our new setup, which is going to start next month. It's a 350-bedded hospital, KIMS Sunshine Hospital. So for those of you who are confused about the name, Sunshine is what was started in 2009 by Dr. Gurva Reddy. And now we have merged with the KIMS Hospital. So it's KIMS Sunshine Hospital. And then the new one is going to start off. As I said, we are the only robotic center in India endorsed by Vatikuti and Stryker. These are the two which have given us the tag of a global center of excellence, because we are able to train more surgeons and perform a certain level of number of procedures. Yeah, thank you so much. I thank the organizers, and if there's any questions, I'll be happy to take them.
Kushal, excellent presentation.
Thank you, sir. Thank you.
I just wanted to know one thing. What is your criteria to select the patient for robotic replacements?
So there is no different medical indication for the same. Currently in India, because the insurance companies don't give you that excess amount for the robotic, and a robotic comes with a cost. So there is an extra burden on the patient. So right now, it's as simple as whether they are willing to pay, then that's okay, and they can come ahead and do it. And if not, then definitely. But if you ask me, is there any specific indication for a robotic surgery which a manual cannot be done? No, there is no such. Would I prefer to do robotic in a grossly deformed knee? Yes, because it's giving me a lot of information. I can do a more predictable surgery.
And one more thing is, you spoke more of pros of the robotic surgery.
Yes, yes.
But whereas the cons of the robotic surgery
Yes.
are not highlighted.
So the
Because
cons
there
are
cons are there.
except for the cost, there is no other con, because it doesn't. These are, as I said, these are still very much under the surgeon's control. It's not like we have left the robot to do anything it wants and it is going to cause any further damage. In our 5,550 knees, there is no error done by the robot. Maybe a small snag here which takes 20 minutes to rectify, and that's it. But except for the cost, which over a period of time is going to go down. In fact, when we bought our first robot in 2020 till now, in 3 years, the cost has significantly lowered. That will be a continuing trend over the next few years, because robots will become very common, and so the cost will further come down, but no other con.
No other complications.
No, not
like
at all.
While feeding the arm, there may be some misfits or then
No, not at all.
unfits.
No, not at all. It is a very safe technology and
Thank you.
it's proven. Yeah.
Hello.
Yes.
Good afternoon, sir.
Good afternoon.
Very good presentation.
Thank you.
Any prerequisites for robotic surgery?
So the one thing is the CT scan in some systems. So these are called image-based systems. So unlike a manual surgery where you don't need anything, you just need an X-ray, you can start the case. Here you need a CT scan. And two robots in the market right now are CT-based robots. So you need to do it. And the other couple of robots are not CT-based. So in those you don't even need the CT scan. There's just a different, it's a very technical thing. So that's why I didn't present it here. But that is the prerequisite, if anything.
So when it comes to the surgery, anatomical versus kinematic versus robotic.
Yes.
Which one do you feel is superior?
No, so
when it
are you
comes to
asking
the
about
functional outcome.
alignments?
Yes, sir.
So alignment can be chosen. So again, there's a misconception that the robotic will do a anatomic or a different kind of alignment. But with the robot, you have the capability to do a mechanical alignment, a kinematic alignment, a restricted kinematic alignment, an inverse kinematic alignment, a functional alignment. Whatever you want, you can choose. So it's really the surgeon who chooses. I'm a surgeon who is comfortable with one type of alignment. My friend is comfortable with another. So the robot lets you do that. Unlike a manual case, manual you just have to do mechanical alignment or a fully kinematic. You cannot do restricted kinematic. So that's the difference. So there's nothing like robotic and mechanical. Robotic can do all the types.
Just for common people, sir.
Yeah.
Why would someone want to go for a robotic when it compared to a manual or a conventional knee replacement or hip replacement?
Yeah. So it's more accurate. There's a 100% accuracy in terms of the cuts you take and the angles at which you cut the bone, the angles at which you place the implant, and what is called balance in the knee. It gives you that perfect balance. What you want, it gives you. So that's one thing. The second thing is it's safe because I showed you the boundaries. So you work within those boundaries. Though in manual also, it's not like you're going to go and bugger the knee and cause a lot of soft tissue damage. No, but still that risk is also eliminated. The third thing is that you are, because the soft tissue dissection is less, the immediate post-op pain is much less. So the patients recover faster. So these are the three major advantages of the robot.
Thank you, sir. Thank you so much.
Thank you so much.
Thank you so much, sir. Thank you for sharing with us your vast knowledge and experience. It was indeed a wonderful presentation. Can we have a big round of applause for Dr. Kushal, sir, please? I thank our chairpersons for chairing the session. Moving on to the next session, My Journey in Cardiovascular and Thoracic Surgery. I welcome upon stage our Honorable Chairpersons for the session, Dr. Vishwanath Nembur, sir, Dr. Vaidyanath Tugave, sir, Dr. Rakesh Kamtekar, sir, Dr. Shivkumar CR, sir, ex-director BRIMS. Please give them a big hand. I am absolutely honored to welcome upon stage our speaker for this session, Padma Shri Dr. Gopi Chand, CVTS surgeon, Star Hospital, Hyderabad. Please give him a big round of applause.
Good afternoon to all. To this August gathering, I'm having the pleasure of introducing a Padma Shri person who is a faculty amongst us. It's a real pleasure to have such a distinguished person in this conference, which will highlight our conference and the conference reaches to a very high level. With pleasure and pride, I would like to introduce Dr. Gopichand Mannam, Senior Consultant Cardiothoracic Surgeon. In 2016, the Government of India awarded the fourth highest civilian award, that is the Padma Shri for him. He is graduated from the Guntur Medical College in 1981. He did his FRCS Edinburgh in the year 1986 with a fellowship in general surgery, fellowship in Royal College of Physicians and Surgeons, Glasgow, specialization in cardiothoracic surgery. He has multiple achievements and awards. To highlight a few, he has been associated with the global organization like Mending Kids International USA, International Children's Heart Foundation USA, founders of Rudelia, Cure Little Heart Foundation that has been ascribed with the benevolence of having extended cardiac procedures and cardiothoracic procedures more than 3,000 children. Extended cardiac surgery services to children in developing countries like Ethiopia, Libya, received an award of appreciation for the year 2001-2 by the then Chief Minister, Mr. Chandrababu Naidu. Awarded the Best Doctor of the Year 2005 by former Director NIMS, honored with a doctorate in science for his excellence from Dr. MGR University, Tamil Nadu by Roshia Garu, who was awarded the TVS Business Leader of the Year in 2013 by Nallari Kiran Kumar Reddy. His expertise in the field of cardiothoracic surgery, having performed more than 25,000 cardiac surgeries, the essence of beating heart coronary bypass surgery and donor heart transplantation in India is accredited to him. Pioneer in minimally invasive arterial septal defect closures and mitral valve replacements in the country. Great pleasure, I introduce Dr. Gopichand Mannam to the gathering. Get a great round of applause for.
Thank you very much. First of all, I want to thank the organizers of this great meeting. I believe this is a very rare occasion. 34 years ago, this kind of meeting was conducted in this city. I have Vipin Goyal to thank for inviting me here. Thank you very much for the chairpersons and the IMA organizers. Now, next slide, please. So it's a difficult topic. You see that they asked me to talk on my journey in CT surgery. Thank you. So it's a difficult task for me, but I looked at it, my life in the last 30 years or maybe 40 years. And it's all full of twists and turns, unusual opportunities, that kind of thing. So I kind of reflected on them. So very important is that there are a lot of complex cases. Since I started practicing in 95, complexity of cardiac surgery has gone up. There are no more simple bypasses or valve replacements. There are 100 different unique signature operations that are taking place now across the country or across the world. There are a lot more possibilities. There's better outcomes. Quality assurance is much, much better now because of intraoperative imaging techniques, follow-ups, and publication of results in the literature. So I thought I would share some of my complex cases first and then go into how my journey took me from my early days of elementary school till standing here today in front of all of you. This is called type A dissection. For people who are not familiar with the not functioning. Okay. So this is the aorta, ascending aorta coming out of the heart all the way down to the, showing here but not there. Can you? So you can clearly see that the aorta is
ballooned here, and it's reasonably normal size here, and again dilated because it has dissected, its lost its wall strength. So basically it's called type A dissection because it started in the ascending aorta. You can see it here. It started there and going all the way into the, especially left side, into the iliacs and the femorals. So it's probably the most complex operation any cardiac surgery team has to handle. Yeah, thanks. So, hello. Okay, so in '93, when I when I first introduced digital technology to my boss, who was 65, and I was 32 or something like that, and he said, "Digital technology fails me. I always rely on small slides, and it has failed me today." Unfortunately, I communicated with them that I'm bringing my computer. They said yes, but looks like it's not working. No, videos are not working. This is the video. Next is video. That's not working. What can I do? You're supposed to show me. Anyway, the point is that it's about 7 or 8 hours of operation. We had to replace the root, saving the aortic valve, although it was leaking, because it's leaking due to stretch of the aorta. Once we removed that, we could save the aortic valve, so we didn't have to replace the aortic valve. And then, of course, we had to use the tube to replace the arch, and we used a special stent graft called a frozen elephant trunk for the descending aorta. So all this, it took about 8 hours, and the patient is now extubated. The biggest problem is that his brain was at risk, his kidneys were at risk, and entire viscera is at risk. So we have to mitigate that by cooling the patient to 24 degrees, selectively perfusing the brain while we starve the kidneys. So this is possible today in our journey. 20 years ago, it's not that much possible. Today, it is possible. So this is a ventricle. Can you advance it? This is a left ventricle after a heart attack. You can see it's all stretched out in the apex and became like a ball. And after repairing it, can you put the next slide? Next one, please. So you can see by taking out that balloon and a patch, you can actually, next slide, please. Don't bother. I don't think you can run the videos. Can you go to next slide? Slide, please. Bhaiya, go to the next slide. Yeah. So you can see very clearly after the repair. This is before. You can see how thinning of this left ventricle, and this has now become like a normal ventricle. The patient went from 28% ejection fraction, now currently at 45 ejection fraction. We always do bypasses also along with the repair of this ventricle. Next slide. So this is a computer generated image before and after. You can see the size of the ventricle has come down. This is again a video. So what is important here in the journey is that it can sound like self-boasting. It can also be self-aggrandization that I'm a great guy, you all bow to me and that kind of thing. But in reflection, it's important to understand how you got here. Next slide. This is my background, my social background. This is my father's house in the village, and he's the only guy who graduated from this village in 1950s, and this is where we used to live till my 10th grade. And after that, we moved into even a smaller house. We used to live, 15 people used to live in that house. And that's the elementary school that I studied. It still surprisingly exists, slightly upgraded version now. So from there, we're a very low middle class family, first generation educated, father out of agricultural background, deeply rooted in agriculture. I actually went to fields till my intermediate, in fact. Next slide. So, average student, second class in my intermediate. I just passed English. Otherwise, I wasn't qualified for writing entrance exam. I didn't get the seat first time. I got it second time. I got into Guntur Medical College. I was talking to Vipin. Once we get into medical college, everything is world opens up for you. You enjoy yourself. You have lots of friends. Till you get into house agency, you didn't know how the time passed. And then you are all scared after that. So that's what happened to me. Second class student out of medical school. Went to Jamaica thinking that I would go to US. After going there, there's a huge world opened up for me. So what I have been doing to what is ahead of me. I'm alone there, nobody there. And I have to make it. The only thing that I'm 100% sure is that I was going to do surgery, only surgery, nothing else. So why? Next slide. I thought I lost ChatGPT. All of you know now, artificial intelligence is the only thing that will give answers for everything. So I asked ChatGPT, an average person like me or people like out there in the society, why would they become very high achieving individuals at a later part of their lives? And these are the answers. Hard work, which I used to do only for surgery. I used to be there 24 hours in the wards, even in house agency. And then learning from failures. As you see, I didn't get my medical college seat first time. And then after that, I never failed. Every ECG, FMG, USC, MELI, you name it, every exam I passed first time. So learn from the failures, opportunities in adversity. I had tough time getting jobs because I'm competing in surgery in the UK. And that's a tough place. So I've tried working hard in adversity and got good places. The rest of the things. So these are all very relevant for all people who are average people or even hardworking people to get to some place. These are very, very important things, and they worked for me. Next slide. If you look at the person who, I know everybody knows IQ test, 100% IQ, 90% IQ, 20% IQ. It's all real sham. Basically, the guy, a French guy, Alfred Binet, he invented IQ test. He himself said, if you read from here, with practice, training, above all, method, we managed to increase our attention, our memory, our judgment, literally to become more intelligent than we started. So this is the guy who actually invented IQ test. So you don't have to be intelligent born. You don't have to be endowed with wealth, parents with connections, access. No. All you need is determination and hard work. You will get there. You may not get there first time. You may get the second time. It doesn't matter. But you will get there. That's a lesson I've learned in my journey. Next slide. There's a saying called becoming is better than being. You are already somebody. The chances are that you don't have initiative because you're already somebody. But if you can become somebody through your hard work, you have some qualities which will carry you further. Which means that success cannot be, once you achieve certain position, you can't sit and say that I'm successful. It's a journey that is more important than the destiny or destination, whatever. And subject is obviously subjective. Somebody thinks of, huge amount of money is successful. Somebody gets good name is successful and other things. You can define your own way of success, but it is not important as long as you believe you are successful. Next. So these are the people who actually inspired me to become surgeon. My father, he was a medical practitioner, although he did BSc mathematics. He went into medical field, helping a doctor, and then he learned in the process. He made me do surgeries by the end of the medical school, and this gentleman, Mr. Yogiram, he still teaches people. He was a postgraduate when I was a medical school, and he still teaches. He's a successful practitioner. He taught me how to throw knots, surgical knots, in my first clinical year, because I insisted that you should teach me. That gentleman is a great human being. Professor E.N.V. Sharma was our second unit professor at Guntur Medical College. He's probably the most pious doctor I have ever seen in the midst of corruption. In 1980, he used to do 13, 14 surgeries free. Nothing. I used to run the list, and I used to assist him first assistant. Postgraduate assistants have another table, and I used to assist him. He's the most, I guess you can call him as a rishi. Fortunately, passed away with pancreatic cancer. And Mr. Ramchandra Reddy taught me surgery in Jamaica. His father was a renowned principal of Guntur Medical College, DJ Reddy, and subsequently he was vice chancellor of Tirupati University. So these people had great influence in shaping my psyche and my determination to go forward in surgery. Next. Which I told you about the family background. Next, please. Why cardiac surgery? One second. After finishing general surgery, I wasn't thinking much. I was going to go back to India and then do practice. At the time of my final year, my sister passed away with mitral stenosis, rheumatic heart disease. She had a closed mitral valvotomy, it didn't work, and she passed away. So that memory stayed in my mind, and when I wanted to do super specialty, cardiac surgery was the direct option for me. But it was tough to get into cardiac surgery. Next slide. So these are the people who helped me in the UK. Professor William Bain at Glasgow Western Infirmary gave me the first job in '89. And Mr. Ken Davidson, who taught me bypasses, valve replacements, and all those things. Mr. Roger Kirby was my first job giver in '82, '83 at general surgery. And Mr. In the UK, we call them Mr. Lincoln, Christopher Lincoln, is a pediatric cardiac surgery. He taught me pediatric cardiac surgery. These people had so much in the form of influencing my journey. Next slide, please. Next slide. So, what's current landscape in cardiac? So, I've arrived. I've done some work. And from '95, I moved 3 hospitals before starting Star Hospitals in 2008. And Bipin, the son of the land, is also part of that now. At the time, it was cardiac surgery alone. By this time, we grew to a reasonable size of 15 people in our team. As we moved on, we only added, nobody left us. Now we're about 25, 10 surgeons, about 11 anesthetists, 4 or 5 technicians, that kind of thing. Cardiac surgery has become much more complex now, and it cannot be performed alone. You need to have a huge team of people, a heart team approach with multi-speciality. A lot of patients come with renal disease, carotid disease, and other forms of disease. So it is important that we have a collaborative atmosphere, and we are happy to say that in our hospital that exists. Next. You can see this is the journey of cardiothoracic surgery in the last 10 years in India. You can see here 20 years ago, this is the total 25,000, total 42,000. Today, 10 times more. And I'm told 5 years, that 2,000, that 2,80,000 will become close to 6 lakhs, and by 30, it will be 1 million. That's probably going to be the highest in any country that may be barring China. Next. So this is our experience. Somebody was introducing me as 25,000 heart operations. In fact, it's 33,600 as of last month. Basically, adults is a large amount, and 80% of, or 75% of the work is coronary artery disease and its complications, both the left ventricular, poor left ventricle, repair of left ventricles, mitral valve repairs along with bypass and all kinds of things. 20% is the valve work, and then you have pediatric cardiac surgery. We've initiated pediatric cardiac surgery in 95 when there was no pediatric surgeries being done in Hyderabad, and slowly grew to a point where there's so much of poverty in these parents. So we started what's called Hridaya Foundation in 2005, and out of those 7,600 pediatric surgeries that we did, close to 7,100 are free surgeries. We raise funds to support these parents so they don't have to pay anything. And the hospital also started because we wanted to give these people, these children, a chance to live. Otherwise, they will not get treatment. Our results in pediatric cardiac surgery is now 2.5% overall mortality. So that's including all complex transpositions, arch repairs, and single ventricles and all kinds of things. So very happy that this is our team. What 7 of them are dedicated only to pediatrics. Next one. That's excluding intensive care patients. This is how I see my journey. Used in 95 when I came, standard cardiac surgeries or simple bypasses, on pump, valve replacements, at the most sometimes repair of mitral valves. Then it became much more complex meaning multi-level coronary arteries blockages, because all the cardiologists have taken away simpler coronary interventions through stenting. And then multi-valve problems like 2 valves, 3 valves, advanced valve disease, right ventricular dysfunctions and all those things. And then of course mitral valve repairs. And now we're also doing aortic valve conservative surgery. And then of course added re-operations, because even in India now, our cardiac surgery history is about 35, 40 years old. So there are people who will come back for second time surgeries because people are living much longer. Our expected lifespan is about 71 now officially. A lot of people have to live above 80 years. So aortic surgery was started by us in Hyderabad, and now that's going on, and even including robot was bought when I was at Care Hospital. Very early on in 2006, we did some work on that. And mainly currently that we've added MICS, minimally invasive coronary artery surgery, and all standard of care, which means the first option is minimally invasive. If not, then we go for a standard operation. Next. No video. Look at this guy. He's about 128 kilos and is refused by a lot of hospitals for aortic valve surgery. Next. So that's the small incision through a vertical right thoracotomy, second space, and this is the minimally invasive cardiac surgery. Unfortunately, I can't show you any videos. He did extremely well, and the 4th day they went home. All these patients, either 3rd day or 4th day, can go home. 2nd day they get mobilized. So it's a joy to see these patients recover and go home much faster, and then they can go back to work. Next slide. So this is a standard approach, is midline standard sternotomy. Unfortunately, we can't show you the video. So if you cut that, the problem with this, the advantage with sternotomy is that you have access to the full heart. Unfortunately, next slide. They'll have more bleeding, they have infections, they have sternal breakdown, and they may suffer 2-3 months. Advantage mix is excellent cosmetic results, less pain, around 40% of them don't even get blood, and minimization of infections of the wound. Sometimes with the coronary artery bypass, heart and lung bypass also need not be used. We can do that on beating heart. Next slide. So, because of reduced post-op morbidity and pain, the hospitals, in fact, ICU length of stay gets reduced, hospital stay reduced, and they can go back to work much faster. In fact, a lot of the 40s, 50-year-olds, they actually do work from home. If they're on a computer work or some other office work, they start working from home. Next slide. Disadvantages are is technically very demanding. The learning curve is very steep, not appropriate for every patient, certainly not appropriate for every surgeon. Next slide. And this is, I don't know, this will play. That's a video. No, okay. So we use access of the groin to basically to start the heart-lung machine for valves. So femoral artery and femoral vein are used for the heart-lung machine. Next slide. This is also a video. Does it run? Can you go back and try run that video? Let's see. One slide back. Can you run this? No? This is a pediatric ASD, it's a small incision. Next slide. So you can put all the cannulae in the same thing. This is the arterial cannula. This is cardioplegic cannula. So I can't see it. Two venous cannulas, and everything goes through that small 3 centimeters. Next slide. Forward. So if you see these girls with ASD is the simplest cardiac operation. But if you have to do sternotomy, the girls especially get scarred for life. And in India, it's a social stigma. If you look at this, from sides, you can't see it. From the front, from the back, you can't see it. Unless you lift the arm, you can't see it. So it's an excellent way of performing a standard operation which is inside, and they are very, very happy. Next slide. And this is not going to work. All these things are slides. Next. So coronary artery bypass is much more complicated than valve surgery in the minimally invasive setting, because we need a lot of extraction, lot of pulling and all those things. That's the mammary artery is being taken here, internal mammary artery, and that's proximal we've already done. So that's a vein attached already to the aorta through that small hole. Next slide, please. And this is again video. Go forward. Next. So some of the miscellaneous operations through MICS. I mean, the fundamental is that all operations are amenable for MICS except for maybe aortic surgery. Even that, we're descending thoracic aorta, we did through a minimally invasive operation by doing what's called debranching, and then doing what's called TVAR. TVAR is trans aortic endovascular surgery. Next. I just want to introduce a topic. I don't want to go through this. Robotics is a great way of coming. You heard orthopedics using extensively the robotic work. Cardiac surgery also has robotics. Now we're doing mitral valve repairs, replacements, and not so much of aortic work. It's a work in progress. Coronary artery surgery is also single vessel internal mammary artery to left anteri descending is being done, but not quality assured as of now. But it's again, as I said, work in progress. Just show the slides, please. Next. So this is a forearm. When we bought it was 3-arm. Now it is 4-arm. Next. It's a Da Vinci system. It's like a wrist. It works very well, and the surgeon doesn't have to be with the patient. We sit at the console, and then we move the instruments and perform the same surgery that we do normally. Next. And this is how the single vessel is being performed. Next slide, please. It's all slides. Unfortunately, we can't do anything. Next. So this is a single vessel. That's the endo stabilizer, which is coming out here, and that's the needle holder. And you can see at the bottom, this is the mammary artery. Next slide. I'm so sorry that we didn't have the videos. So currently, the scope of the work is it's safe, it's patient friendly, and you can discharge the patients in a day or two. But unfortunately, it takes a very long time, 4 to 6 hours, and then it's prohibitively expensive equipment cost. Next slide. So I have to stop here. I'm so sorry that I couldn't show you some of the videos. Cardiac surgery continues to be a very exciting surgery, and innovations are every day being done. And the technology has helped us a lot, both in terms of imaging, preoperative preparation for a better outcome of surgery, a performing of the surgery, hard work and dedication. Anyone, as you can see me, anyone can achieve the heights that they never imagined before, and all the interventions are now currently quality assured, and outcomes of the diseases are very predictable. But unfortunately, the society is very demanding and expectations are huge. Patients who are moribund are expected to walk home in the next day or two with as little cost as possible. That is something unique for our society. We may have to deal with that kind of situation. Thank you very much for this opportunity.
Thank you so much, sir. We're absolutely honored to hear and learn from you today. You truly are an inspiration for all of us. It was indeed a wonderful presentation, and we sincerely apologize for the technical difficulties faced. Can we have a big round of applause for Dr. Gopi Chand, sir, please? Sir, I request you to please join the next session as a chairperson. I thank our honorable chairpersons for the presence on the stage, and I request them to collect the mementos and certificates from the selfie point.
Average man, you are number one. Average person. You are super. I wanted to say it.
Moving on to our next session, MEDICON Scientific Keynote Address. I welcome us honorable chairpersons for the session, Dr. P.S. Shankar, pioneer in the field of medicine, Padma Shri Dr. Gopi Chand sir, Dr. Shiv Kumar Lakol sir, President IMA KSB. Please give them a big round of applause.
I'll announce it. Sir. Sir, I'll call the speaker on stage. We are talking.
It gives me immense pleasure to invite upon stage our speaker for this session, Padma Shri Professor Dr. C.N. Manjunath, Director, Sri Jayadeva Institute of Cardiovascular Sciences and Research Center, Bangalore. Please give him a big round of applause.
Disadvantage ಅಂದ್ರೆ we don't have laptop on the podium ಅಲ್ಲ. Good afternoon to everyone. It gives me immense pleasure to introduce the eminent, well-known Dr. C.N. Manjunath sir. He is born in 1957. Age, as you all know, very well known personality. Dr. C.N. Manjunath is a senior cardiologist and director of Jayadeva Institute of Cardiovascular Science and Research, Bangalore. He has recorded 300% overall growth, and the brain's bed strength has been increased from 330 to 640 beds exclusively for the cardiac care under his leadership. Sri Jayadeva Institute of Cardiovascular Science and Research has introducing the practicing the treatment first, payment next concept. He has very exclusively implemented every needy patient should be given quality treatment irrespective of financial affordability. Sir, it is a great honor to have you here, sir. Please, sir.
Good evening. I'm very thankful to the organizers of 89th annual conference of Indian Medical Association for this invitation to be amongst you to deliver this keynote address. In fact, it's a unique conference for a simple reason. We have, for the first time, I am seeing Honorable Minister for Health, Government of Karnataka, Mr. Gundu Rao, Dinesh Gundu Rao is among the audience. That shows his concern. Normally, ministers come for inauguration, but not for lecture. So that is the uniqueness of Mr. Dinesh Gundu Rao. So with this, so I have chosen a topic. In fact, just before me, you heard a scintillating journey of cardiothoracic surgeon Dr. Gopi Chand. He is working as head of the Department of Cardiothoracic Surgery in a star hospital. In fact, he himself is a star of cardiothoracic surgery in this part of this world. And see, another interesting thing, he comes from a humble background and he has shown he is from an agriculture family. And see, this is how stars are not born, stars are made through commitment. So my hearty congratulations, sir, with this. So I have chosen a topic, just a correction, because whatever little bit of introduction was done, the bed strength of Jaideva Institute of Cardiology is not 640, it is 2,000 cardiac beds. Makes it one of the largest heart care destination in the world. That's fine. Today I have chosen a common topic, heart attack or a coronary artery disease. So, what are the risk factors and management of acute coronary syndrome? In India, 65% of deaths is due to lifestyle diseases. The important players of lifestyle diseases, one is cardiovascular disease, second is diabetes, third is high blood pressure, fourth is stroke, fifth is cancer. And to this group, we have added one of the latest lifestyle disease, what is called screen addiction. This is because of our digital age, the medical landscape has changed totally. So today screen addiction is a lifestyle disease because of mobile phones, laptops, iPads, etc. So another important thing here, so coronary artery disease, in common man's perspective, heart attack related disease is currently the most common non-communicable disease in India. 4 to 6% of Indians in rural areas, 8 to 10% in urban areas have coronary artery disease. Rural-urban divide is narrowing because lifestyle in rural area is also like an urban area because of digitalization and also a lot of migration have taken place from villages to the cities. They also have a mobile phone, you also have a mobile phone. They also play on social media, you also play on social media. So that is the reason lifestyle in villages is also getting urbanized. And grave complication of coronary artery disease is ST elevation myocardial infarction, or in common man's term, heart attack. So this is a little, because this lecture is attended by other than medical profession also. So heart is a great, great structure. Although it is size of the fist, normally on an average, heart beats about 1 lakh beats per day and pumps about 6 to 7 liters of blood every day. It's also a great philanthropic organ because it uses only 5% of its blood for its own nourishment, and 95% of the blood it distributes among various organs of the body. As a result, heart is not just important for the existing of human life, it is a great philanthropic organ, it's a great donor. And also we always, look at the heart for a cardiologist, heart is different. And for a physician, it is different. For a poet, it is different. For the teenagers, it is different. For the, so that's how we always talk about art as the center stage in many occasions. So this is the cardiovascular disease burden. Nearly 19 million cardiovascular death occurs globally. Unfortunately, 60% of this global cardiovascular deaths occurs in Asia. Globally, we have 195 countries. In Asia, we have 48 countries. These 48 countries have contributing to nearly 60% of cardiovascular deaths. It's really alarming. Cardiovascular disease affects 10 years earlier in India as compared to Europeans. And before the age of 70 years, 52% death occurs in India as compared to only 23% in Western population. It's really alarming. The heart attack related disease is going down in Europe, is coming down in United States, but unfortunately in India, it is rising at an alarming speed. So this is some data. You can see here, there is a fourfold increase in the prevalence of coronary artery disease in India during the past 40 years. And you look at the death rate, it is 272 per 1 lakh population in India, while death rate is 235 per 1 lakh population in Western population. So for a given case of heart attack, the death rate for Indians is higher compared to the Western counterparts. By 2030, if the same trend continues, highest number of heart attacks will be in India. So India is a global capital of heart attack. India is a world capital of diabetes. India is a world capital of hypertension. So for all wrong reasons, we have taken a top spot. So 4 people die of heart attack every minute in India. You look at our population is 140 crores. So you look at the burden of cardiovascular disease. So in fact, many a times I have taken, for example, cancer has been declared as a disease of national importance. But most number of deaths in India is due to cardiovascular disease. In my opinion, cardiovascular diseases should be declared as a disease of national importance so that government of India should fund the straight run the cardiac hospital. So that is the reason behind that. What are the unique features of heart attack in India? Higher mortality, higher death rate, and premature. And also there is a regional variation also. It's more in the south as well as in western part of India compared to the eastern part of India. So what are the top 10 causes of mortality or death? So even in 2030, cardiovascular disease continued to occupy number 1 place, followed by cancers, chronic respiratory disease, and respiratory infections and diabetes mellitus. So this is going to be so I think a lot of intervention need to be done both at a preventive level as a community program. So what are the risk factors for heart attack or coronary artery disease? We have non-modifiable risk factor. You can't change. Age you can't change. You can change age on certificates, but chronologically, biologically, you cannot change age. Age more than 45 years. What is this sound? So there are no cockroaches. Okay, fine. See, when I was a medical student, age more than 65 used to be a independent risk factor for heart attack. Today, age more than 45 has become a risk factor, age alone. And age more than 55 years in women is an independent risk factor. In fact, we have made a study at Jaideva Institute of Cardiovascular Sciences because there was a feeling, and it was true also, heart attack related diseases are extremely rare in premenopausal women, that is before the age of 50. But now what is happening, the landscape of heart attack in the female in this digital age has changed significantly. In our study, among the young heart attack, 8% were women between the age group of 20 to 45. I think because nowadays women are also working like men, what we call it as menish women. For example, for all practical purposes, they are working. And also, today, children education has become mother's examination. That is one of the reasons. In fact, I have seen a couple of mothers coming to me, doctor, I'm having chest pain, I'm having headache. And yes, then we looked into all those things. Everything was normal. Then I was asking, why you are having all this stress and all? no, my son did not get good marks in the examination. I was wondering, probably she might be referring to 10th standard or 12th standard. Then I asked, what is your son doing? Which grade he is studying? LKG. So this is where children education has become mother's examination. Of course, we have our minister here. At least for in bigger cities where travel time is more, the LKG, UKG, first standard, up to first standard, the timing of school should be changed. Somewhere it should start at 10 o'clock and leave them by 12:30. That is very, very important because we are stealing their childhood, and we are waking them up early morning 5 o'clock, and they are not able to eat, they are not able to take milk, and they are getting bad dreams, which children never used to get. And we are putting these children early morning 6 o'clock into the buses as animals, and that is the reason stress is building up from very small age group. This is where probably the policymakers have to take a call, at least up to first standard. At least up to first standard, the timings has to be changed. Start somewhere around 10 o'clock. Otherwise, child health suffers, mother health also suffers. Then family history. I think I will show my data, the family history of heart attack, because many a time a lot of people come to us, I am not a smoker, I am not a diabetic, I don't have any other bad habits. Why did I get heart attack at the age of 35, 40 years? Family history. See, always in our Indian customs, in our religious practices, always children ask parents, particularly father, how much of bank account you have transferred to my account, how much of property you have transferred to my account. If mother and father have lived up to 80 years, that is the best genetic balance sheet they are transferring to the children. That is the best genetic balance sheet that is being transferred to the children. So what is a strong family history? If somebody in the family suffers an heart attack before the age of 50, it is considered to be one of the strongest risk factor for heart attack. If somebody develops heart attack at the age of 80, it is not considered as a family history. So these are some of the important non-modifiable. Age you can't change, sex you can't change, and family history, you can't choose your parents, you can't change. Then coming back to modifiable risk factors. Smoking, unquestionably, smoking is an important independent risk factor for cardiac disease. Then diabetes mellitus. See, today in India, 7 crores are now, I think latest data has come. The diabetic population in India now is 10 crores. Another 10 crores are pre-diabetic. So whether patients are diabetic or pre-diabetic, risk for cardiovascular disease continues to be same. Even a pre-diabetic, or what you call it as borderline diabetic, they also have an equal risk for cardiovascular disease, so they have to be taken care of. And coronary artery disease is 5 times more common among diabetics than non-diabetics. Then elevated cholesterol. I think there is a strong relationship between cholesterol. For every 1% increase in total cholesterol, there is 2% increase in the prevalence of coronary artery disease. I think this is where the social media is really confusing. This WhatsApp University is creating a lot of problems. We see WhatsApp messages, latest information coming from WHO, latest information coming from Nobel laureate. You can eat any amount of fat. Cholesterol is nothing to do with the heart. I think we should not listen to unfortunately, WhatsApp University are becoming stronger than our regular universities. Then high blood pressure. High blood pressure, again, in India, nearly 30% of Indians above the age of 50 have high blood pressure. We have 2 types of high blood pressure. One is what is called white coat high blood pressure. That means when they come to the hospital, their blood pressure recorded is high. At home, it is normal. Then we have another type of blood pressure, what is called masked high blood pressure, where blood pressure is high at home, and it is normal in when they come to the hospital. That means problem is at home. So problem is at home, and there could be heaters at home, and probably one has to put a air conditioner to really take care of that blood pressure. Then obesity is also an important risk factor. Lack of exercise. According to ICMR data, 52% of Indians are physically inactive. In fact, you ask some of the people, what is your job? They always immediately say, not doing a job is their profession. So physical inactivity is one of the important risk factor. Always we keep telling, because there is a strong evidence, if you walk for nearly 45 minutes a day, their average lifespan increases by 10 years. That's very, very important. That is the reason walking is any sort of, even standing is an exercise. Standing is an exercise. And again, if you are sitting for a longer time, I will talk about this particular problem a little later. Then in India, not all heart attack patients are obese. Nearly 50% of Indians who suffer heart attack are not obese. We have what is called thin fat individual substrate. Overall weight is not much. They are just weighing about 60 kg, 65 kg, but they have a central obesity. Abdomen is protuberant. A central obesity is an important risk factor. And also regarding cholesterol, there is no correlation between your body weight and your cholesterol. People can be thin, they may be underweight, but their cholesterol can be high. So because 70% of the cholesterol is metabolized in the liver, synthesized in the liver, and 30% only comes through eating your cholesterol-rich food. Many patients ask, I don't eat any fatty food, and also I don't eat non-vegetarian or red meat. Why my cholesterol is high? Yes, this is because metabolically, genetically, changes have taken place in the liver. Indians produce more cholesterol compared to the Western part naturally. Then our attitude, behavior, our personality also directly affects our cardiovascular health. What is called type A personality. What is type A personality? Type A personality people are the one, they are eccentric. They are sadistic. They don't like others being happy. And they are also jealous. And they always keep shouting without any reason. So these are all type A personality. That is the reason, particularly in bigger organization, health of the employees depends on the attitude of their boss. In my opinion, there's a difference between boss and also a leader. Boss is one who troubles others. And leader is one who inspires, who motivates. This is the reason workplace wellness and a working atmosphere has got a lot of impact on the cardiovascular health, whether it is heart problem, whether it is high blood pressure or diabetes. That is the reason workplace wellness is very, I think there's a very popular saying, with stress, there will be more pimples. With worries, there are more wrinkles. With smile, there will be dimples. So this is where it happens. So I think type A personality people are very, I think whenever you get into, within 30 seconds of talking, you will come to know whether this person is a type A personality or not. Then if you feel if he is very arrogant, if he is eccentric, if he is not listening, and if he is a troublemaker, I think one of the best way is stop talking to them. I think that is how we should modify our stress. That is very, very important. Then alcohol in excess. There are some studies. Alcohol in small doses is okay for cardiovascular health. As doctors, we never give alcohol as a prescription. This is because what people remembers is doctor did say alcohol in small doses could be taken, but conveniently they forget the dose doctor has mentioned. So this is the reason alcohol in high doses definitely increases high blood pressure, increases heart attack, And also alcohol, just in a later vein, is a device. Alcohol alcohol is also a device which converts actually the silence into speech. And just in a later vein, wife is also a device, converts actually speech into silence. So these are a little bit later vein because it's already, we are the fag end of the day, just to keep you active. And alcohol definitely increases the cardiovascular risk, it increases the hypertension risk, and stress and lifestyle. Unquestionably, stress is nothing but, nowadays, stress is considered to be a new tobacco. Because stress, it could be a family stress, professional stress, it could be career stress, because I will come to this particular thing, what is the importance of stress as far as doctors are concerned. That is a very important, because stress is unquestionably an important risk factor. Stress is nothing but a gap between your expectations and performance. Your expectations are more than performance, ultimately it results in stress. So stress is one of the important thing. And many people are unhappy today because they are always worried others are happy. So I think stress is an important risk factor. Then we have what is called sitting disease. See, if somebody is sitting for 4 to 5 hours continuously, it is equivalent to smoking 5 cigarettes. So it is called sitting disease. Yes, for some people it is a professional hazard, and that is the reason sitting is particularly, it's common both among some profession and also getting pretty common among women, because many of these women are glued to these TV serials. And one after the other, some this thing, you believe me, some TV series do not end in this generation. So this goes on and on. So sitting disease is also a very important risk factor, and you can see. Yeah, then why stress is more? Why all lifestyle diseases are more? You look at this. See, disintegration of giant families and breaking away of giant families is also one of the important emerging risk factor and enhancing risk factor for all those things. What was happening? Of course, I don't advocate our family size should be as big as it was in 1960. You look at in 1960, 1980, of course, the best is in 2000. You can see earlier, giant family was acting like an emotional cushion. It used to be a counseling center, and it used to be, a community center, everything. And even if there is a small problem, they used to settle, and there used to be. So now what is happening? You look at 2022, 2023. What is the definition of giant family? Husband and wife living together is a giant family. Husband and wife living together is a giant family. Plus, they are physically connected, but mentally they are not connected. So looking at, this is where real problem, not only they are facing a lot of these problems such as heart disease, high blood pressure, and also it is adversely affecting the children too. It is adversely affecting the children. So, for example, I will tell you, in a giant family, if one of them is hurt, if they go and sleep, normally they go and sleep, and some other member will wake them up and ask them to take lunch or dinner, whatever. Even they will also be waiting. If somebody calls, let me go and eat something. So I think all those things, breaking away of nuclear, the joint family is also one of the reasons for all increase in lifestyle diseases. So this is how lifestyle has changed. See, earlier, it's only the beggars used to wear torn clothes. Now, elite class, rich class. So this beggar is totally confused. She is also a beggar, might be competing with him. So she is telling, you go to some other area, this is my area. So today, wearing torn clothes has become a status symbol. And many of these teenage girls wearing all these torn clothes are not going to their grandma houses because they might stitch this whole thing. So what is this premature? I think I'm both academic and also because this is fag end of the day, I just wanted to keep you awake. That is the reason I'm making some jokes. Please don't think otherwise. See, this is the largest documentary register cum follow-up clinic in patients with premature heart attack. We at Jaideva Institute of Cardiovascular Sciences, in the last 5 years, we have studied more than 500 young patients in the age group between 18 to 45. You look at the risk factors, age distribution, 45% of heart attack patients were in the age group of 36 to 40, and 17% were between 26 to 30 years of age bracket, then 33% between 31 to 35. Then we studied the risk factors. 51% were smokers. Then diabetes, 11%. Then hypertension, 9%. And high cholesterol in 14%. Family history, look at that. Family history was present in 16%. And no conventional risk factors in nearly 33%. 33% of young heart attack patients presented to us did not have any of the conventional risk factors. No diabetes, no blood pressure, no smoking. This is where probably more research and more thought process should get in, and we need to really investigate what are the new emerging risk factors which are not listed till now in the standard textbook. This is where, so in fact, family history is extremely important. I have seen father who has suffered an heart attack as a blockage in one of the artery, son or daughter has developed heart attack, a blockage in the same artery in the same location. So that is the influence of genetics and heart attack. So with rapid urbanization and industrialization, nutritional transition is occurring in India, and era of refined foods, including refined flour, maida, sugar, hydrogenated oils. These are some of the things we are looking at it. Traditionally, high complex carbohydrate, high fiber, low fat diet has been replaced by a diet rich in fats, readily absorbed, so less of vegetables and fruits. In fact, in one of our study, only 11% of Indians are consuming adequate amount of fruits and vegetables. So this is where we have to really look at, these are some of the interventions we need to take. So these are some of the important emerging or newer risk factors. Pre-diabetes. Some people say, no, my blood sugars are just borderline and I don't want to take. So at least we need to have a lifestyle intervention. Then pre-hypertension and a low vitamin D level, fatty liver, polycystic ovary, subclinical hypothyroidism, microalbuminuria, and also systemic inflammation, South Asian dyslipidemia, and higher levels of uric acid, abdominal obesity, and homocystinemia, accelerated atherosclerosis. So these are some of the important risk factors, emerging risk factors we are looking at it. Yes, air pollution, because most of us know air pollution basically linked to respiratory disease. It causes bronchitis, it causes, of course, Dr. P.S. Shankar has done a lot of work on that, and it can cause precipitate bronchial asthma, and basically it is connected with the lungs. It is interestingly, air pollution is an emerging risk factor for cardiovascular disease. Particularly because if you look at Indian cities, air pollution is very high in Nagpur, Delhi. Sometimes airports are closed even up to 11 o'clock in the morning, Nagpur, then so many places. So because today the vehicular pollution is one of the important risk factor for air pollution, apart from construction, this thing and all. Air pollution, what happens? Particulate matter less than 2.5 microns, when we inhale, it bypasses it filters through the lung and gets into these arteries, causing inflammation and clot formation, resulting in heart attack. Last year, in India, 22 lakhs have died because of air pollution. So this is a very important thing. This is an area where we need to really bring down the air pollution through traffic decongestion and all those mechanisms. So work stress increases the heart attack risk by 23%. Employees with very demanding jobs, not much freedom to make decisions, have a much higher risk of having a heart attack compared to other people of their age whose jobs are less stressful. Research, this is from University of London. We have our Indian study. Average lifespan of a modern day doctor has come down by 10 years. Sorry to say this. Average lifespan of a modern day doctor has come down by 10 years. And this is a very serious matter, particularly doctors working in government hospitals, government institutions. Some of them see 100 patients, some of them see 150 patients daily. And also, okay, doctors, our responsibility is to provide a quality care or a timely treatment. And despite all these things, if patient dies, the doctors are blamed. And there is a, in many places, there is a continuous physical abuse, verbal abuse, verbal assault, you can take it as a result, stress level for doctors, and all the more in semi-urban and rural hospital, these stress levels are very high. And the expectations of the people is also very high. There is pressure of the media and pressure of the other areas. So doctors under stress, unfortunately, doctors and paramedical staffs are becoming patients. How many doctors and paramedical staff we are treating for heart attack? How many we are treating for high blood pressure? Because, see, for example, whenever, this is what I have seen, doctors coming from other countries, NRIs coming from England, I have seen in our own institution, they are extremely happy. Same day they are getting reports. Oh, doctors, you are giving same day reports, same day consultation, same day angio report, same day CT report. But our own people, they come at 10 o'clock, 11 o'clock, because it takes some time, they pick up the quarrel with the doctors and medical profession, because this is where doctors are under tremendous stress, paramedical staff is under tremendous stress, and the expectation of the people, patients, attenders is very high. They want even a dead patient walk home. I think this is one area we need to really address. So because nobody is, see, we always conduct health camps for general public. We conduct health camps for various segments. A time has come, we need to conduct annually health checkup camp for doctors and paramedical staff. This is very, very important because there is a very high prevalence of all diseases among doctors. So because always people ask, no, we should not ask doctors, how are you, you will be always healthy. No, because doctors are more stressed than the patients and attenders. So this is the role of work stress. But one important thing, of course, this is my advice, 3 C's are very important for doctors: communication, counseling. Because we do a lot, we work day and night, and might have seen patient, but that communication is important. The language we use is important. Okay, we are under stress, might have seen a lot of patient, but we have to communicate in a very polished, in a very kindness. Kindness is very important. Kindness actually is the language. Kindness is the language. A deaf can hear, blind can see. Most important, because many time, I think some of the younger generation doctors use, you might have done a wonderful operation, you might have seen everything, but a slip of the tongue, if you tell little rudely, then these problems will crop up. So I think stress management is very important. One thing I am telling, because normally every one of us receive call from ministers, call from MLAs, you look after the patient. For the same patient, 10 calls will come. Normally you get irritated. Don't get irritated. Then no point in, are we not seeing this patient? Are we not giving this thing? Then going to the patient telling, why are you bringing so much of pressure? See how much? It took 45 seconds. See, make this story short. You just tell, sir, yes, we'll look after. And you tell the patient, so and so has called about you, inquired about you. They will be happy. This is how this sort of a protocol. So I think this is how, say many times, so I think we have to have this sort of an approach towards the patients. Even it's not just confined to the doctors, even to other profession also. Otherwise, we'll get stressed and unfortunately, then whatever good work you have done, that will be lost in this thing. So there is an association between work-related stress and coronary artery disease. This is data from one of the foreign university. Stressful jobs are associated with a higher risk of heart rhythm disorders. Particularly, there can be fast heart rate resulting in atrial fibrillation. These are some of the, so work stress and reduced health in young physicians, prospective evidence from Swiss residents. In fact, there is a study conducted in Kerala recently. The average lifespan, according to their study, has been reduced by 11 years. So I think doctors should take care of their health, and stress management is extremely important. So coming to acute coronary syndrome. We have three subsets of acute coronary syndrome. One is unstable angina. Patient has chest pain, and there are some ECG changes, but troponin is normal. Then we have a non-ST elevation MI. There are some ECG changes. Troponin is positive, but there is no ST elevation. Then third category is a classical heart attack where there is an ST elevation MI. So I think most of us are well aware of this. The cascade of heart attack is there is a thrombus, clot formation, there is an underlying obstruction, and also there is an underlying inflammation. So these are the three categories of acute coronary syndrome. So one is thrombus. When a patient presents with acute myocardial infarction or a heart attack, there is a thrombus or a clot. Then there is an underlying obstruction. Third, there is a microvascular dysfunction. Fourth is vascular inflammation. It's very simple here. You can see here, thrombus. Yes, we have to dissolve the thrombus. That is the reason we give thrombolytic therapy, whether it is streptokinase, whether it is tenecteplase, whatever it is. Our Honorable Health Minister is there. I will come to that because we have taken up this project across the state. And underlying obstruction. So for an underlying obstruction, clot dissolving medicine alone is not sufficient. You have to open up with a angioplasty and a stent procedure. Then we have vascular inflammation. For this, we give high dose of statins. So what are the symptoms of an heart attack? Normally, yes, every one of us know when a patient develops heart attack, they will have a left-sided chest pain, or there can be heaviness in this middle of the chest, or a burning sensation in the chest. This is where many times the doctors also can make a mistake, patient also can make a mistake. Even a pain in the central port, burning sensation in the chest. Burning sensation in the chest, sometimes they mistake it for gastritis and hyperacidity. So sometimes when patient develop heart attack, they may not get left-sided chest pain. They may get pain in the stomach region with vomiting and sweating, and it mimics like a gastritis and acidity, but it could be an heart attack. So heart attack can masquerade as an acidity or a gastritis. That one should keep in mind. Then, yes, some patients, when they develop heart attack, they may not get left-sided chest pain. They get pain in the jaw. They get pain in the throat, or they might get pain in the upper back. So these are some of the atypical locations. And elderly people, particularly those with long-standing diabetes, silent heart attack can be there. That means no chest pain, but they have a sudden onset of breathlessness or sudden onset of weakness, and also sweating and all those things. So these are some of the important things you should keep in mind. Always, the less ignorant people come to the hospital faster than the intelligent patients. Then intellectuals always, they keep talking to others, no, it is not chest pain, it's just a gastritis. I have taken some spicy food in the previous night, and so that's how. So, and also it is also true, it is less ignorant patients get a correct treatment than what you call intellectuals. So we have two syndromes particularly bothering us in bigger cities. One is idiot syndrome. What is idiot syndrome? Internet-derived information obstructing treatment. This is one of the real problem. See, they come with lots of information downloaded from the net, and they want us to treat according, that means they only say you have to treat like this. So that is the reason many times some people say, if you want treatment according to our guideline, the consultation is less. If you want treatment according to your guideline, then consultation is more, something like that. So this is the problem, but of course we have to live with that, this sort of a thing. Then we have another syndrome, what is called CAPI syndrome in bigger cities. Children abroad, parents in India. Children abroad, parents in India, they keep talking every half an hour, every half an hour. Ultimately, they never come and see at any point of time. So this puts physicians and our surgeons under tremendous stress. So these are some of the important things. So certainly, not every patient of heart attack will get a pain in the left side of the chest. It could be a burning sensation, heaviness, and most important thing, can a patient have a premonitory symptoms before heart attack? Only 50% of patients who develop heart attack have premonitory symptoms. That means a few weeks prior to heart attack, they get chest pain on walking, particularly after taking food. While walking uphill, if they get chest pain or burning sensation in the chest or jaw pain while walking, it is connected with the heart. And it's also other way around is very informative. If somebody has got neck pain or left shoulder pain, that's where people get confused. Left shoulder pain, at rest they have a shoulder pain or a chest pain. While walking, they are absolutely comfortable. Then it's not from the heart. These are some of the simple clues we get to know about this thing. See, we see every night at Jaideva Institute of Cardiovascular Sciences, every night 80 to 100 patients, 8 p.m. to 8 a.m., 80 to 100 patients visit. Out of them, nearly 50% are admitted for acute coronary syndrome. So, how do you diagnose heart attack? Of course, most of you know that. One is symptom, and second is ECG. Third is the laboratory blood test, cardiac markers. See, nowadays we are not doing CPKMB actually. We are not doing LDH. Okay, fine. So, we are not doing all those things. So, troponin is an important biomarker. So, patient has chest pain. Even if ECG is not showing changes, if troponin is high, that patient is consistent with the diagnosis of acute coronary syndrome. But troponin can be high even in some other than heart attack. Sepsis, infections, it can be high, or even in cerebrovascular accident, it can be high. After heavy exercise, it can go high. So this is one thing. Maybe another important thing, not every patient, first ECG can be normal. Despite heart attack, first ECG can be normal in 50%. So that's the reason if there is a high index of suspicion of heart attack, even if ECG is normal, you repeat an ECG after 1 hour and repeat your troponin level. Many a time it has happened. ECG is normal, patient has chest pain, and they have been sent home. On the way, they have died. They have died in auto rickshaw, they have died in car, all those things. I think of course, this is an angiogram. This patient has got a non-ST elevation MI. This is an echocardiogram. These are the usual things we do. This is to assess the heart function and which segment is not moving. And most important is, yes, the time, heart attack treatment is time driven. That is the reason I'm showing the clock. For every 30 minutes of delay in initiating treatment for heart attack, risk of death increases by 7%. So that is the reason we have to take heart attack treatment to the doorsteps of the common people, and heart attack treatment should be, initial treatment should be given in taluk hospitals and primary health centers. So we have introduced Health and Family Welfare Department, Government of Karnataka and National Health Mission and Jaideva Institute of Cardiovascular Sciences. We have introduced what is called hub and spoke model of heart attack treatment. So we have mapped 45 taluks in the state at this point of time. Basically what happens, a patient develops heart attack, trying to shift him to a tertiary care, it may take 2 hours, 3 hours, 4 hours. By that time, precious time is lost and heart muscle is significantly damaged. So under this scheme, what we have is already operational, and we have chosen 15 taluks in Kalburgi division, 15 taluk hospitals in Bangalore division, and 15 taluks in Mysore division. And all these taluk hospitals have been given a training how to treat heart attack by thrombolysis, because there a clot dissolving medicine called either a streptokinase. Next, probably shortly, we are introducing tenecteplase. Tenecteplase is highly potent and fibrin specific, and reactions are less. And streptokinase has to be given in infusion over 1 hour. So doctors are little hesitant to give because side effects are more, and infusion takes about 1 hour. Tenecteplase, 30 milligram, just one shot in 1 minute you can give for a patient of heart attack. How the scheme works means, moment ECG is taken, and through the app system, it is transferred to the tertiary care center. Then when diagnosis is confirmed, that medicine is given in that taluk hospital. Then after few hours of stabilization, they are shifted to tertiary care hospital, Jaideva Kalburgi, Jaideva Mysore, Jaideva Bangalore. Or we are also going to add some private tertiary care hospital to reduce the delay. So by this, we can save life. And also another thing, by this, the patients also, I think, let me make it very clear, the medical treatment of heart attack is not the domain of cardiologist. Even an MBBS doctor, other MD doctor who has been, can treat. One should, because there is an apprehension and anxiety among the doctors in the taluk and peripheral hospital. I am not a cardiologist, how can I treat heart attack? No. The medical treatment of heart attack, any qualified doctor can treat that. And this scheme also brings a lot of confidence to the patient also. That means we have been receiving treatment under the guidance of specialists. So this is how it works. So this is just to show that how, see, earlier when we did not have ICU, the death rate due to heart attack is 30%. Now because of all these things, death rate from 30% has come down to 6%. Of course, now it has been reduced to less than 5%. I think I will skip this slide because we are going to have an inauguration function. So these are the medicines to be given. You have to give 325 milligram of aspirin, 80 milligram of atorvastatin, and 300 milligram of clopidogrel to be given. Then you give thrombolysis. Then you can always shift these patients to tertiary care center. See, what happens, oxygen should not be given if patient is stable, if saturation is normal, don't give oxygen. Giving too much of oxygen can be hazardous to patient, uncomplicated acute MI. Don't give oxygen unless patient is breathless or if saturation is less than 90%. So these are the medicines I was talking about. And I think these are all given in textbooks. I will not get into that. So only thing is, streptokinase, yes, is given over a period of 45 minutes to 1 hour, and your tenecteplase is likely to be given. It is going to be supplied by Government of Karnataka to all taluk hospitals for treating heart attack. In fact, my hearty congratulations and also appreciation to Honorable Minister for taking this decision, because we know that cost of tenecteplase is somewhere around 23,000. So that medicine, it saves life, and doctors also will be very happy to give because it's a just bolus, just given in about 10 seconds intravenously. Then you can shift them to a tertiary care for an angioplasty. So you look at the difference between streptokinase and tenecteplase. The success rate is almost more than 75 to 80%, while with streptokinase it's just 50%. So that's where this is going to be useful. So I think the most, because not every center not every small place has got a cath lab facility to do a primary angioplasty. You give a thrombolysis. If clot dissolving medicine is given within the first 3 hours or the first 3 hours, golden hours of heart attack, then if you do an angioplasty after within 24 hours, it's as good as doing the angioplasty directly. So this is the message that is going out of this. So I think this is all we know. We just do these procedures and then we put a stent. And so this is called pharmacoinvasive approach. That's what the theme of this hub and spoke model. That means give clot dissolving medicine, stabilize, then shift. And this whole program is monitored by an agency called a TRICOG agency, and they are going to monitor the transfer of this patient. They will alert the tertiary care center, look, in next 45 minutes, this patient is going to reach your hospital. So that means entire system is in place. So, in fact, we want to extend this facility to another 45 taluks. Already, it has been before the Honorable Minister. Another 45 taluks will be added to this scheme, hub and spoke model of treating heart attack. 15 taluks in Davangere, Chitradurga division, and 15 taluk hospitals in Mangalore Udupi division, another 15 taluks in Hubli, Belgaum division. So that going to cover 90 taluks. This patient had a heart attack and mid-RCA has 90% lesion. This was done, angioplasty balloon has been done. I think this is all technical. Another important area is, I think this is one every doctor, whether any specialty, you should, it's not just doctors, paramedical staff, even non-medical staff should be also aware of cardiopulmonary resuscitation. If somebody develops a cardiac arrest, you should be able to already, AED machines, automatic external defibrillator have been supplied, because this can save life when once patient develops, but it should be done within the first 3 to 5 minutes of cardiac arrest. Cardiac arrest means pulseless, patient unconscious, breathing has stopped, but it should be done within the first. And every doctor, whether it is physician or ENT, or whether it is connected with the heart or not, in their clinic they should have a defibrillator, because we don't know which patient will develop heart attack. And this should be also done, I think should be introduced in college levels also, and all community apartments should be there, railway station it should be there, bus stops, wherever there is pub, because this can save life. But make sure that patient has cardiac arrest. Otherwise, if patient is alive or still doing, then you may be penalized. See, this is how you should do, vigorously. It cannot be superficial. It should be as deep as 5 centimeter. It should depress. Even you don't mind breaking the ribs also, nothing will happen. Sometimes, of course, if it doesn't recover, but understanding is important. Despite all these things, patient doesn't recover, then one should not book a case that that fellow has deliberately killed the patient. I think this is the take-home prescription after heart attack. Aspirin lifelong, clopidogrel for at least 1 to 2 years, beta blockers, and statin should be given lifelong. Even if cholesterol is normal, after an heart attack, the statin drugs, atorvastatin or rosuvastatin should be given lifelong. Then smoking cessation. See, if you abstain from smoking, if you stop smoking, that is bigger than any medicines. I think these are the taluk hospitals that have been covered under hub and spoke. I'm cluster 1 Bangalore division, Mysore division, and Gulbarga division. In fact, under Bidar we have also included 3 taluk hospitals. So this is just a pleasant piece of information according to 2022 survey by Cardiological Society of India. Among the top 5 centers, Jaideva is ranked number 1 in this country, and followed by Mediterranean, UN Mehta Hospital, GB Pant Hospital, and PGI Chandigarh is in 5th place. So this is just a pleasant piece of information. And workplace rule for happy life. Trust no one but respect everyone. This is for all of us. What happens in office, remain in office, never take office gossips to home and vice versa. This is to reduce stress and have this thing. Enter office on time, leave on time. Your desktop is not helping to improve. Never make relationship. Expect nothing. If somebody helps, feel thankful. If not, you will learn to know things. Never rush for a position. If you get promoted, congrats. If not, it doesn't matter. You will always be remembered for your knowledge, politeness, not for your designation. Never run behind the office stuff. You have better things to do in life. Avoid taking everything on your ego. Your salary matters, yes. It doesn't matter how people treat you. Be humble. You are not everything's cup of tea. In the end, nothing matters except family, friends, home, inner peace, and patience. And yes, time to reperfusion is a critical determinant of heart attack management. And government-sponsored health scheme has included this tenacity place. It's likely to be available shortly. And yes, lastly, there is no happiness in medicine, but there is medicine in happiness. Thank you.
Thank you so much, sir, for coming here today and enlightening our minds with your vast experience and knowledge. We are truly honored to have you here. Ladies and gentlemen, please give him a big round of applause. I welcome Dr. Madhusudan to take over.
ಹಲೋ ಆತ್ಮೀಯರೇ, ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪರವಾಗಿ ನಮ್ಮ ಈ 89ನೇ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನಕ್ಕೆ ಆಗಮಿಸಿರತಕ್ಕಂಥ ನಮ್ಮ ಮುಖ್ಯ ಉಪನ್ಯಾಸಕರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ CN ಮಂಜುನಾಥ್ ಅವರನ್ನು ಸನ್ಮಾನಿಸುವುದು ನಮ್ಮ ಕರ್ತವ್ಯ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ನಮ್ಮ ಕರ್ನಾಟಕ ಸರ್ಕಾರದ ಸನ್ಮಾನ್ಯ ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣ ಸಚಿವರಾಗಿರ್ತಕ್ಕಂಥ ಶ್ರೀ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಅವರು ವೇದಿಕೆಗೆ ಬಂದು ನಮ್ಮ ವೈದ್ಯ ವೃತ್ತಿಗೆ ಮುಕಟಪ್ರಾಯರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ CN ಮಂಜುನಾಥ್ ಅವರನ್ನ ಸನ್ಮಾನಿಸಬೇಕಾಗಿ ಕೇಳ್ಕೊತೇನೆ. ಹಾಗೇನೆ ನಮ್ಮ ರಾಜ್ಯ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಶ್ರೀ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಬಿ ಲಕ್ಕೋಳ್ ಅವರು ಅವರಿಗೆ ಕೈ ಜೋಡಿಸ್ಬೇಕಂತ ಕೇಳ್ಕೊತೇನೆ. ಹಾಗೇನೆ ಮಾನ್ಯ ಅರಣ್ಯ ಜೈವಿಕ ಮತ್ತು ಪರಿಸರ ಖಾತೆ ಸಚಿವರಾಗಿರ್ತಕ್ಕಂಥ ಶ್ರೀ ಈಶ್ವರ್ ಖಂಡ್ರೆ ಸರ್ ಸಹ ವೇದಿಕೆಗೆ ಬಂದು ಈ ವೈದ್ಯರನ್ನ ಸನ್ಮಾನಿಸಬೇಕಾಗಿ ಆತ್ಮೀಯವಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ತೇವೆ. ನಮ್ಮ ರಾಷ್ಟ್ರೀಯ ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ RV ಅಶೋಕನ್ ಅವರನ್ನು ಸಹ ನಾನು ವೇದಿಕೆಗೆ ಬರಮಾಡಿಕೊಳ್ತೇನೆ. ಹಾಗೆ ತಮ್ಮ ವೈದ್ಯಕೀಯ ಜ್ಞಾನವನ್ನು ನಮಗೆ ಹಂಚಿಕೊಂಡಿರತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಗೋಪಿಚಂದ್ ಹಾಗೂ ನಮ್ಮ ವೈದ್ಯಕೀಯ ವೃತ್ತಿಗೆ ಮುಕಟಪ್ರಾಯರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ PS ಶಂಕರ್ ಇವರನ್ನು ಸಹ ನಾನು ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪರವಾಗಿ ಆತ್ಮೀಯವಾಗಿ ಸನ್ಮಾನ ಮಾಡಬೇಕಾಗಿ ವೇದಿಕೆ ಮೇಲಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಗಣ್ಯರನ್ನ ವಿನಂತಿಸಿಕೊಳ್ತೇನೆ.
ಹಲೋ 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 ಹಲೋ
ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ರಾಜ್ಯ ಕಾರ್ಯದರ್ಶಿಗಳಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕರುಣಾಕರ್ BP ಅವರು ಹಾಗೂ ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ S ಅವರು ಕೈ ಜೋಡಿಸಬೇಕಾಗಿ ಕೇಳ್ಕೊಳ್ತೇವೆ. ವೃತ್ತಿಯಲ್ಲಿ ವೈದ್ಯರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ PS ಶಂಕರ್ ಅವರು ಹಲವಾರು ಕನ್ನಡ ಪುಸ್ತಕಗಳಿಗೆ ಕರ್ತೃಗಳು. ವೃದ್ಧಾಪ್ಯದಲ್ಲಿನ ಕಾಯಿಲೆಗಳು, ಹೃದಯ ಜೋಪಾನ, ಕ್ಯಾನ್ಸರ್, ಹೃದಯ ರೋಗ ತಡೆಗಟ್ಟಿ, ಡಾಕ್ಟರ್ ವಿಕ್ರಮ್ ಸಾರಾಭಾಯಿ ಮುಂತಾದ ಕೃತಿಗಳನ್ನು ರಚಿಸಿದ್ದಾರೆ. ಹಾಗೆಯೇ ಸೋವಿಯತ್ ಲ್ಯಾಂಡ್ ನೆಹರು ಪ್ರಶಸ್ತಿ, ರಾಕ್ ಫೆಲ್ಲರ್ ಸ್ಕಾಲರ್ ಇನ್ ರೆಸಿಡೆನ್ಸಿ ಗೌರವ, ಭಾರತ ಸರ್ಕಾರದ ವಿಜ್ಞಾನ ತಂತ್ರಜ್ಞಾನ ಇಲಾಖೆ ಶ್ರೇಷ್ಠ ವಿಜ್ಞಾನ ಪ್ರಶಸ್ತಿ, ಸಾಹಿತ್ಯ ಅಕಾಡೆಮಿ ಪುಸ್ತಕ ಬಹುಮಾನ, ಮೈಸೂರಿನ ವಿಶ್ವ ಮಾನವ ಪ್ರಶಸ್ತಿ, ಕರ್ನಾಟಕ ರಾಜ್ಯೋತ್ಸವ ಪ್ರಶಸ್ತಿ, ನುಡಿಸಿರಿ ಪ್ರಶಸ್ತಿ, ಹೀಗೆ ಮುಂತಾದ ಹಲವು ಪ್ರಶಸ್ತಿಗಳು ಇವರ ಮುಡಿಗೇರಿವೆ. ನಮ್ಮ 23ನೇ ನುಡಿ ಹಬ್ಬದಲ್ಲಿ ಕನ್ನಡ ವಿಶ್ವವಿದ್ಯಾಲಯವು ಪ್ರತಿಷ್ಠಿತ ನಾಡೋಜ ಗೌರವ ಪದವಿಯನ್ನ ಪ್ರದಾನ ಮಾಡಿ ಇವರನ್ನು ಗೌರವಿಸಿದೆ. ಎಲ್ರಿಗೂ ಧನ್ಯವಾದಗಳು. ಮಾನ್ಯ ಸಚಿವರು, ದಯವಿಟ್ಟು ವೇದಿಕೆ ಮುಂಭಾಗದಲ್ಲಿ ಆಸನಗಳಲ್ಲಿ ಆಸನರ ಬಗ್ಗೆ ಕೇಳ್ಕೊತೇನೆ. ಸರ್, ಎಸ್ ಸರ್, ವಿಲ್ ಅರೇಂಜ್ ದಿಸ್.
Hello. Check, check. Hello, hello. Check, check. Hello.
चलो हेलो
Hello, hello.
हेलो check mic check hello mic check
ಆಗುತ್ತಾ? ಬಂದ್ರೆ ಲೊಕೇಶನ್ ಆಡ್ಸೋದು.
hello check hello check hello
Hello, hello. Check.
ಸರ್ ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಸರ್ ಸರ್ ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ ಇಲ್ಲಿ ನೆರೆದಿರುವ ಎಲ್ಲರಿಗೂ ಶುಭ ಸಂಜೆಯ ನಮನಗಳು. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ 89ನೇ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನವು IMA ಬೀದರ್ ಶಾಖೆಯ ಆತಿಥ್ಯದಲ್ಲಿ ನಮ್ಮ ಬೀದರ್ ವೈದ್ಯ ವಿದ್ಯಾಲಯದಲ್ಲಿ ನಡೆಯುತ್ತಿರುವುದು ನಮಗೆಲ್ಲರಿಗೂ ಸಂತಸದ ವಿಷಯ. ತನ್ನ ಸದಸ್ಯರ ಹಿತಾಸಕ್ತಿಯನ್ನು ಕಾಯುವುದರ ಜೊತೆಗೆ IMA ನಡೆ ಹಳ್ಳಿಯ ಕಡೆ, IMA ನಡೆ ಶಾಲೆಯ ಕಡೆ, IMA ನಡೆ ಸೈನಿಕರ ಕಡೆ ಹಾಗೂ IMA ನಡೆ ಜೀವ ಉಳಿಸುವ ಕಡೆ ಎನ್ನುವ ಕಾರ್ಯಕ್ರಮಗಳ ಮುಖಾಂತರ ಸಮಾಜದ ಸೇವೆಗೆ ಸಿದ್ಧ ಮತ್ತು ಬದ್ಧ ಎಂದು 90 ವರ್ಷಗಳಿಂದ IMA ಸಾಬೀತುಪಡಿಸುತ್ತಾ ಬಂದಿದೆ.
Ladies and gentlemen, esteemed doctors, a very warm good evening. We welcome you all to the IMA Karnataka State Branch 89th Annual Conference MEDICON 2023, hosted by IMA Bidar at our prestigious Bidar Institute of Medical Sciences. We, the student of BRIMS, are honored to present this beautiful inaugural function to you. Myself, Dr. Shreyash Reddy.
Myself, Dr. Anjali.
Myself, Swati Biradar.
I am Dr. Vaishnavi Gumme.
I am Dr. Uday.
Today, we have gathered here as a community of dedicated healthcare experts to share knowledge, discuss innovations, and collaborate for betterment of healthcare in India. We welcome you all to the inaugural function of this wonderful conference.
We take this opportunity to welcome today's dignitaries onto the stage. First, we request our IMA KSB State President, Dr. Shivkumar B. Lakol sir, to come onto the stage.
Next, we request IMA KSB incoming President, Dr. Srinivasa S. sir, to come onto the stage.
We request IMA KSB President-elect, Dr. V.V. Chiniwala sir, to come onto the stage.
Next, we request IMA KSB Honorary Secretary, Dr. Karunakar BP sir, to come onto the stage.
We request MEDICON 23 Organizing Chairman, Dr. Chandrakant Gudge sir, to come onto the stage.
We request MEDICON 23 Organizing Chairman, Dr. Vijayshri Bashetti Madam, to come onto the stage.
We request MEDICON 23 Organizing Secretary, Dr. Mallikarjun Panshetty sir, to come onto the stage.
We request IMA Bidar President, Dr. Vaijinath Madana sir, to come onto the stage.
We request IMA Bidar President, Dr. Vaijinath Madana sir, to come onto the stage. We request our today's guest of honor, IMA National President-elect, Dr. R.V. Ashokan sir, to come onto the stage.
We request our Director of BRIMS, Dr. Shivkumar Shetkar sir, to escort today's inaugurator, Honorable Minister for the Departments of Forest, Ecology and Environment, Shri Ishwar Khandre sir. And today's chief guest, Minister of Health and Family Welfare, Shri Dinesh Gundurao sir, onto the stage. We welcome you, sir. And we also request Vijay Dharam Singh sir to please come on to the stage. We request our Director of BRIMS, Dr. Shivkumar Shetkar sir, to escort IMA KSB Senior Vice President, Dr. Prasanna Shankar Shivappa, Vice Presidents, Dr. Narayan Murthy C, Dr. Shailesh Amarkhet, Dr. Rajashri Anugol, Honorary Treasurer Dr. Vijay Sarthi, Joint Secretary Dr. Anita D, Public Relation Officer Dr. Pavan Kumar Patil, Assistant Secretary Dr. Lakshman D. Bakle, and the MEDICON 23 Protocol Officer Dr. Yogananda Reddy YC sir to come on to the stage.
Next, we request IMA KSB incoming Vice Presidents Dr. Kiran Deshmukh sir, Dr. Pavan Kumar Patil sir, Dr. Rajgopal Shetty sir, PRO Dr. Devadas sir to come onto the stage. We request IMA National Joint Secretary Dr. Venkatachalapati M sir, IMA Headquarters Dr. AKN Sinha Institute Director Dr. Prabhakara GN, IMA KSB Gauda Nagaraj, Dr. Madhusudana Kariganuru, Dr. R.S. Bellari, Dr. Suresh Kudua, Dr. G.B. Bidinal, Dr. Annadinimiti to come onto the stage. We request all other past presidents of IMA KSB to come onto the stage and occupy their respective chairs. Now, we would like to call upon Dr. Ganga ma'am to lead us into the prayer. May this prayer resonate within each one of us, giving us peace, strength, and courage to handle the challenges ahead.
गजाननं भूतगणातिसेवितम् कपित्तजम्बूफलसारभक्षितम् उमासुतं शोकविनाशकारणम् नमामि विघ्नेश्वरपादपङ्कजम् या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवे सदा वन्दिता सा मा पातु सरस्वती भगवती निशेषजाडयापहा सा मा पातु सरस्वती भगवती निशेषजाडयापहा. Thank you.
Thank you, Dr. Gamanga ma'am, for that soulful prayer.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ ಮತ್ತು ಧ್ವಜವಂದನೆಯನ್ನು ಸಲ್ಲಿಸಲು ನಮ್ಮ ಮುಂದೆ ಈಗ ಬರುತ್ತಿದ್ದಾರೆ IMA ರಾಜ್ಯ ಶಾಖೆಯ ಜಂಟಿ ಕಾರ್ಯದರ್ಶಿಗಳಾದ ಡಾಕ್ಟರ್ ಅನಿತಾ ಅವರು.
I request everybody to stand for the IMA prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವನ್ನು ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನು ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ.
ಧನ್ಯವಾದಗಳು ಮೇಡಮ್.
We request the organizing chairman of this MEDICON 23, Dr. Chandrakant Gudge sir, to give his welcome note.
A warm good evening to one and all. On behalf of IMA Bidar, I take this opportunity to thank IMA Karnataka State Branch for giving us the chance to host this scientific conference, MEDICON 89-2023. It is my pleasure to invite all of you and the dignitaries to this function. First of all, I would like to invite Sri Ishwar Khandreji, inaugurator of this conference, Honorable Minister for Forest, Ecology and Environment. Sri Dinesh Gundurauji, Chief Guest of this conference, Honorable Minister for Health and Family Welfare. KSB State President Dr. Shivkumar B. Lakol. KSB Incoming President Dr. Srinivas S. President-elect Dr. V.V. Chiniwalar. Honorary Secretary Dr. Karunakar BP. MEDICON 23 Organizing Chairman Dr. Vijayshri Bashetti. MEDICON Organizing Secretary Dr. Mallikarjun Panshetty. IMA Bidar President Dr. Madana Vajnath. Our beloved ex-MLC Sri Vijay Singh ji. Guest of honor for MEDICON 23, our National President-elect Dr. R.V. Ashokan. Director of BRIMS Dr. Shivshankar Shetkar. Shivkumar Shetkar. KSB Senior Vice President Dr. Prasanna Shankar Shivappa. Vice Presidents Dr. Narayan Murthy C, Dr. Shailesh Amarkhed, Dr. Rajsri Anugol, Honorary Treasurer Dr. Vijay Sarathi A, State Joint Secretary Dr. Anita D, PRO Dr. Pawan Kumar Patil, Protocol Officer Dr. Yoganand Reddy Ballari, Incoming Vice Presidents Dr. Kiran Deshmukh, Dr. Pawan Kumar Patil, Dr. Raj Gopal Shetty, Incoming PRO Dr. Devidas Bandila, National Joint Secretary Dr. Venkat Chalpati M, IMA Headquarters Dr. AKN Sinha Institute of Director Dr. Pravakar GN, Assistant Secretary Dr. Lakshman D. Bakle, Past Presidents Dr. Honnegowda, Dr. Annegowda Nagaraj, Dr. Madhusudan Karignur, Dr. R.S. Bellari, Dr. Suresh Kudwa, Dr. G.B. Bidinal, Dr. Annadani Meti, Dr. P.V. Kanchi. I welcome all other past presidents of IMA, KSB to this conference. I welcome Dr. Geeta Khandre, Mrs. Sri Ishwar Khandre. I take this opportunity to invite all the staff and students and support staff of BRIMS, delegates, all the members of the IMA Bidar, print and visual media people to this wonderful conference. Once again, welcome all the police people who have supported this conference and all the people who are directly, indirectly supported this conference. Thank you and all.
Thank you for welcoming all of us to the wonderful conference, sir.
ಈ ಸಮ್ಮೇಳನಕ್ಕೆ ಗಣ್ಯರು ಕಳುಹಿಸಿರುವ ಶುಭ ಸಂದೇಶಗಳನ್ನು ನಮ್ಮ ಮುಂದೆ ಪ್ರಸ್ತುತಪಡಿಸಲು ಬೀದರ್ ಶಾಖೆಯ ಡಾಕ್ಟರ್ ವೈಜನಾಥ್ ಮದ್ನ ಇವರನ್ನು ವಿನಂತಿಸಿಕೊಳ್ಳುತ್ತೇವೆ.
This is message from Sri Tawarchand Gehlot, the Honorable Governor of Karnataka. I am happy to know that the Indian Medical Association Karnataka is organizing the MEDICON 2023 at Bidar Institute of Medical Sciences, Bidar. The work done by the IMA over all these years in the field of public health education and updating the latest development in the medical field to its members is praiseworthy. It is essential that the medical profession should give priority to the needs of our rural people, and its aim should be of healthy India while planning for the medical education. I wish and pray God abundant blessing always be upon you and IMA, and I wish the organizers and the participants Sri Siddaramaiah, Honorable Chief Minister of Karnataka, his message. Please accept my sincere congratulations to all the delegates and organizers of the MEDICON 2023 conference to be held in Bidar on 28th-29th of October 2023. The Indian Medical Association resourcefulness and the sheer brilliance has made a positive difference to the thousands of lives of doctors around the country. I am confident that IMA will raise to meet any future challenges as it has done since inception. I wish all the delegates and the organizers very success in the many decades that are yet to come. Please accept my best wishes for a productive conference. Next, Sri D.K. Shivkumar, Honorable Deputy Chief Minister of Karnataka. I want to offer my congratulations to the Indian Medical Association of Karnataka on their annual medical conference, MEDICON 2023. A good conference is always more than just an exchange of papers and ideas. Looking at the history, many changes were started by committed and critical doctors taking an initiative for the common good. The IMA is for sure one of those groups committed to build a better world for all. I wish you an inspiring conference. Sir Dinesh Gundurao, Honorable Okay. Sri Sharad Prakash Patil, Honorable Minister of Medical Education, on Okay. Thank you. Thank you.
ಧನ್ಯವಾದಗಳು ಸರ್.
We are privileged to welcome IMA KSB Honorary State Secretary Dr. Karnakar BP sir to give his annual report.
So good evening everybody. Myself Dr. Karnakar. I'm privileged to stand in front of you to give the Secretary's report of IMA Karnataka State Branch. We took over from the previous team at Mudbidre MEDICON 2022. Since then till today, the team has done extremely well in addressing the issues related to the IMA case and its members actually. We had regular working committee meetings and council meetings to take up stock of the issues, and resolutions were passed accordingly. We had about 9 state working committee meetings related to various issues. The important ones includes award guidelines. We remember we had to set a standard guidelines for giving awards at various activities like Doctors' Day, Teachers' Day, and MEDICON, and we were able to put in a wonderful guidelines. Accordingly, this year's awards were given to most deserving by eligible members of the IMA KSB. We take pride in doing extraordinary work from the award committee. We also had meeting related to membership drive, Doctors' Day, and beside that, we had most important meeting related to GST related issue with the Government of India issuing notice to the IMA KSB to pay GST. Retrospectively, we had a major issue in our hand requiring crores of monies to be paid at the GST. We had a series of meetings, including working committee meeting, council meeting to address, and ultimately we decided to pay the GST as per the guidelines and suggestions from the legal authorities with protest to the Government of India. And that's been an extraordinary work done by the IMA KSB. We also take this chance to appreciate the support given by all the local branches in reaching these milestones and also to generate the resources to pay the GST of IMA KSB and its branches. Friends, we know that there is a kind of continuous changes happening with medical educations. There was an issue with date initially. We could able to convey our opposition to the issue in the month of April, May, and also from the headquarters. Ultimately, the dates were scheduled in accordance with the need of the students. Then came the 0% for the NEET eligibility recently. That has been one of the biggest challenges to the medical fraternity. Although Government of India and its people suggested that it was in the interest of filling the seats left vacant and also in the interest of giving the seats to the students. But we realized that, as we understand, the seats cannot be given just like that to anybody. It should be based on the merit. IMA KSB as the one branch possibly took the major step in taking a stand in the working committee, counseling. We passed a resolution to write to the Indian Medical Association headquarters. We also wrote to the PMO and Health Minister of Government of India. And the impact wasn't seen immediately when we wrote the letter to the Government of India. The counseling was supposed to happen on 29th and 30th of October was kept in the abeyance with a direction the NMC does. Wait, you don't go further. That's the impact that's been made. I'm sure the effort taken by the IMA KSB is going to ensure that transparency in the process and the eligibility is taken care of. Merit is the possibility, only criteria for allotting the seats to the student. It could be also be considered that merit should be spread across all the categories of the students. The seat left over, the tune of 2,000 or 3,000, cannot be sold in the open market for the benefit of the private medical institutions and other things. We are extremely proud of our work done by IMA KST in this issue actually. Friends, we also realize that with digitalization across the world and also the country and the Government of India is also insisting the introduction of digital mechanisms for providing healthcare service. We developed our own hospital software in the last 1 year, and we are happy to announce that we have come to the stage where it's going to be released today, and the cost of the product is basically less than 1/10 of the market price. We are looking forward. Our members will benefit both at clinic level, hospital level, and even big hospital level. We're looking forward to a serious and very active participant and encouragement from the members in this issue actually. We had issues with the SSVNI scheme where the payment for the service provided by the private sector was a concern. We took up the issue. We are able to reach out to the Government of Karnataka in the previous government and the current government. Both the government responded positively. We could able to recreate what is the need for survival of the private hospitals. Accordingly, we have our Honorable Health Minister here. They all took a decision to revert back to the previous the pay at least, and then they decided to relook at and adjust the rates according to the ABY scheme as the time comes. It's another major relief to the members of our community hospital providers in the last year actually. Friends, we also had 5 council meetings ratifying all the decisions. We also had regular president secretary meetings with the headquarters, office bearers of the local branches, and we also had multiple interesting meetings in the interest of the MEKSP. We also like to take at this point of time, our President Dr. Shivkumar Lakkol could able to visit 156 branch of 179 branches. That's been a record in the recent times for the members of IMA KSB. It's not easy to travel across the state to visit about 156 branches. It's been an exhaustive visit, and Dr. Lakkol deserves all the appreciation for that. We had our another interesting aspect of our the year was President Speak. We had a fixed day on 23rd of each month where our president spoke and interacted with the members, highlighted the work done, took the suggestion and used to do work based on subsequent month. That was been an extraordinary new initiative of our IMA KSB in the 2023 under Dr. Shivkumar Lakkol sir. We had the privilege of our national president, Dr. Sharad Agrawal, visiting a state branch, and he visited Mysore branch and visited medical colleges in Mysore, Bangalore, and also the state headquarters. He was happy to look at the facility provided at the IMA KSP to the students as a library and teaching facilities and the assets, and he has been well appreciative of the work and done by IMA KSP, and he also appreciated the various schemes that's been done by IMA KSP in the interest of the members actually. And we all know that the KSS security scheme is one of the best in the country. Our health system is also one of the outstanding one. Of course, the professional security scheme provides a benefit up to 1 crore rupees to each member at a nominal cost of about 500 rupees per month. You don't get any other insurance companies actually. Friends, we had plethora of academic activities in the IMA headquarters in the last 1 year. We had multiple conferences like Medical Legal Conference in Bangalore, AMS Conference in Tumkur, Women's Wing Conference at Gangavati, Kannada Sahitya Conference Sammelan at Shivamogga, CGB Conference at Gadag. We also had a wonderful MEDICON 2022 at Moodbidre. We had innumerable CMEs, talks, public health programs, health camps, and many more happened regularly at this last 1 year actually. President also represented in various conferences meeting, and all the committees worked wonderfully. In the presence of our president, incoming president Ashokan sir, would like to highlight that IMA KSB actively took the interest in implementing all the activities of the IMA headquarters actually. We have been able to take up the issues, and the one which stands out to highlight at this point is IMA KSB on the call of IMA headquarters actively participated in the protest of Rajasthan Health Bill actually. Across the countries, members participate from various branches. 3 to 4 lakh doctors assembling in a Maidan to protest against the RTH Rajasthan bill was an extraordinary for a medical fraternity. We represented IMA KSB, and we remember that with the presentation of the mammoth presentation of the doctors, Rajasthan government withdrew the bill immediately after 2-3 days of protest, and it's been modified to meet the suits of the facilities providers actually. We celebrated World Health Day celebration as per the headquarter directions. Aavo Gaon Chalo Pav. Aavo Gaon Chalo program is one of the major program of our President Dr. Agarwal. We also took up interest in running that program across the state. We also participated in blood transfusion, organ donation program, and all the other activities. We observed all the national days, important days like Doctors' Day, Teachers' Day, Independence Day, Republic Day, and everything. Our publications were fantastic in this year. IMA Focus was one of the best year for IMA Focus with self-sustaining finances and a very colorful presentation. Vaidya Sampada, another Kannada version of our publication, was another excellent work done by the Kannada literary unit of IMA KSB. Friends, for the work we have done, we had a very smooth year working all through the year. There were issues, but we never made it as an issue. We've addressed everything as coolly as possible with an impressive results and outcome in the last 1 year, and the credit goes to the leadership of Dr. Shivkumar Lakkol. And I also take at this stage that IMA KSP stood for the issues relevant to the doctors. As I told already, we took a solid stand with respect to zero eligibility, GST related issues, and also the NEET examination issues. And we coordinated and discussed with Government of Karnataka and Government of India and IMA headquarters in getting suitable solution. At this stage, I would like to acknowledge an extraordinary help and support given by our Honorable Health Minister Sri Gundu Rao ji, Sri Sharan Prakash Patil ji, and Dr. H.K. Patil. We remember we took all the issues related to KPME, hospital-related issues, NOCs were filed. Everything was done, including much required changes to the healthcare facility provided in Karnataka. Dr. H.K. Patil sir listened to all of these things. He also looked at that positively, that will be implemented in the days to come. Also possibly certain legislation will also be brought in to ensure that these things here are taken up actually. Friends, it's my privilege once again to express my sincere thanks to the team of Dr. Lakkol and all the members of IMA KSB. We take pride in our efforts and work in serving the interest of the organization in the last 1 year. We are very thankful for being cooperative with us. Thank you so much. Jai Hind, Jai Karnataka, and IMA Chirayavagali. Thank you so much.
Thank you for the report filled with wonderful achievements, sir.
ಆತ್ಮೀಯರೇ, ತಮ್ಮೆಲ್ಲ ಕೆಲಸಗಳನ್ನು ಬದಿಗಿಟ್ಟು ಈ ನಮ್ಮ ಸಮ್ಮೇಳನದಲ್ಲಿ ಭಾಗವಹಿಸಲು ಬಂದಿರುವ ಗಣ್ಯರಿಗೆ ನಮ್ಮ ಅಭಿಮಾನಪೂರ್ವಕ ಸನ್ಮಾನ ಕಾರ್ಯಕ್ರಮ. ಮೊದಲಿಗೆ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿರುವ ಸನ್ಮಾನ್ಯ ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣ ಖಾತೆ ಸಚಿವರಾದ ಶ್ರೀ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಇವರನ್ನು ಸನ್ಮಾನಿಸಬೇಕಾಗಿ ವೇದಿಕೆ ಮೇಲಿರುವ ಎಲ್ಲಾ ಗಣ್ಯರಲ್ಲಿ ಮನವಿ ಮಾಡಿಕೊಳ್ಳುತ್ತೇವೆ.
ಹಾಗೆಯೇ ಈ ನಮ್ಮ ಸಮ್ಮೇಳನಕ್ಕೆ ಮುಖ್ಯ ಉದ್ಘಾಟಕರಾಗಿ ಆಗಮಿಸಿರುವ ನಮ್ಮವರೇ ಆದ ಸನ್ಮಾನ್ಯ ಅರಣ್ಯ ಮತ್ತು ಪರಿಸರ ವಿಜ್ಞಾನ ಖಾತೆ ಸಚಿವರಾದ ಶ್ರೀ ಈಶ್ವರ್ ಖಂಡ್ರೆ ಇವರನ್ನು ಸನ್ಮಾನಿಸಬೇಕಾಗಿ ವೇದಿಕೆಯ ಮೇಲಿರುವ ಗಣ್ಯರನ್ನು ಕೋರುತ್ತೇವೆ.
ಹಾಗೆಯೇ ಈ ನಮ್ಮ ಸಮ್ಮೇಳನಕ್ಕೆ ಗೌರವ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿರುವ ನಿಯೋಜಿತ IMA ರಾಷ್ಟ್ರ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ RV ಅಶೋಕನ್ ಇವರನ್ನು ಸನ್ಮಾನಿಸಬೇಕಾಗಿ ವೇದಿಕೆ ಮೇಲಿರುವ ಎಲ್ಲಾ ಗಣ್ಯರಲ್ಲಿ ಕೋರುತ್ತೇವೆ. ಎಲ್ಲರಿಗೂ ಧನ್ಯವಾದಗಳು.
Light is a symbol of brightness, expels the darkness, brings prosperity and happiness in our life. Now, we feel very privileged to invite the Karnataka Government's Minister for Forest, Ecology and Environment Department, Shri Ishwar Khandre Sir, to inaugurate today's conference MEDICON 23 by lighting the lamp. We request all the dignitaries on the dais to join hands. Gundurav Yakal, Swati. Or you are calling Gundurav?
Swati is
called. Then call Swati. ಫೋಟೋನೇ ಆಡ್ತಿದ್ರು ತೋರಿಸು. ನಾನೊಂದು ಸಾಧ್ವಿ ಬರ್ತವನ ಬಂದಿವತ್ತು ಸರಿ ಯಾರು ಅವರು ಕೊಡಲ್ಲ. We thank all the dignitaries on the dais.
ಈ ದಿನದ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ ಆಗಮಿಸಿರುವ ಸಚಿವರಾದ ಶ್ರೀ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಇವರನ್ನು ಅತಿಥಿ ಭಾಷಣ ಮಾಡಬೇಕೆಂದು ಕೋರುತ್ತಿದ್ದೇವೆ.
ಹಸ್ತಾಂತರ ಆಗಿ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥವರು ಡಾಕ್ಟರ್ ಎಸ್ ಶ್ರೀನಿವಾಸ್ ರವರೇ, ನಮ್ಮ ಮಾಜಿ ವಿಧಾನ ಪರಿಷತ್ ಸದಸ್ಯರಾಗಿರ್ತಕ್ಕಂಥ ಸನ್ಮಾನ್ಯ ವಿಜಯ್ ಸಿಂಗ್ ರವರೇ, ಈ ಕಾನ್ಫರೆನ್ಸಿನ ಆರ್ಗನೈಸಿಂಗ್ ಚೇರ್ಪರ್ಸನ್ ಡಾಕ್ಟರ್ ಚಂದ್ರಕಾಂತ್ ಗುಡಾಗೇರವರೇ, ಮತ್ತೊಬ್ಬರು ಡಾಕ್ಟರ್ ವಿಜಯಶ್ರೀ ಬಶೆಟ್ಟಿ ಅವರೇ, ಡಾಕ್ಟರ್ ಮಲ್ಲಿಕಾರ್ಜುನ್ ಪನ್ಶೆಟ್ಟಿರವರೇ, ಹಾಗೂ ವೇದಿಕೆ ಮೇಲೆ ಉಪಸ್ಥಿತಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ IMA ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಬ್ರಾಂಚಿನ ಎಲ್ಲ ಗಣ್ಯರೇ, ಎಲ್ಲ ಸದಸ್ಯರುಗಳೇ, ಮಾಜಿ ಅಧ್ಯಕ್ಷರುಗಳೇ, ಹಾಗೂ ಈ ಒಂದು ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಬಂದಿರತಕ್ಕಂಥ ಎಲ್ಲ ವೈದ್ಯಕೀಯ ಅಧಿಕಾರಿಗಳೇ, ಎಲ್ಲ ಡಾಕ್ಟರ್ಸ್ ರವರೇ, ಹಾಗೂ ಎಲ್ಲ ಆತ್ಮೀಯ ಸಹೋದರ ಸಹೋದರಿಯರೇ, ಇವತ್ತು ನಿಮ್ಮ ರಾಜ್ಯ ಮಟ್ಟದ ಸಮ್ಮೇಳನ ಬೆಳಗ್ಗೆಯಿಂದ ಈ ಕಾರ್ಯಕ್ರಮ ನಡೀತಾ ಇದೆ. ಹಾಗೂ ಬಹಳ ಒಂದು ಅತ್ಯಂತ ಮುಖ್ಯವಾದಂಥ ವಿಚಾರಗಳ ಬಗ್ಗೆ ತಾವು ಈ ಕಾನ್ಫರೆನ್ಸ್ನಲ್ಲಿ ಚರ್ಚೆ ಮಾಡ್ತಾ ಇದ್ದೀರಾ. ಈ ವೈದ್ಯಕೀಯ ಒಂದು ಕ್ಷೇತ್ರ ಏನಿದೆ, ಇದು ಬಹಳ ಒಂದು ಪ್ರಮುಖ ಕ್ಷೇತ್ರ. ಬಹಳ ಒಂದು ರಾಜ್ಯದ, ಒಂದು ರಾಷ್ಟ್ರದ ಬೆಳವಣಿಗೆಯಲ್ಲಿ ಬಹಳ ಪ್ರಮುಖ ಪಾತ್ರವನ್ನು ವಹಿಸ್ತದೆ. ಆರೋಗ್ಯ ಕ್ಷೇತ್ರ ಬಹುಶಃ ಎಲ್ಲ ಕ್ಷೇತ್ರಕ್ಕಿಂತ ಹೆಚ್ಚು ಅದಕ್ಕೆ ಇಂಪಾರ್ಟೆನ್ಸ್ ಇರತಕ್ಕಂಥ ಆದ್ಯತೆ ಕ್ಷೇತ್ರ ಅಂತ ಹೇಳ್ಬೋದು. ಶಿಕ್ಷಣನೂ ಕೂಡ ಬಹಳ ಮುಖ್ಯ. ಆದರೆ ಆರೋಗ್ಯ ಇಲ್ಲದೆ ಹೋದರೆ ಏನಿದ್ರೂ ಕೂಡ ಏನೂ ಪ್ರಯೋಜನ ಇಲ್ಲ. ಮತ್ತು ನಮ್ಮ ಆರೋಗ್ಯ ಎಲ್ಲಿಂದ ಪ್ರಾರಂಭ ಆಗುತ್ತೆ ಅಂತ ಹೇಳಿದ್ರೆ, ಒಂದು ಮಗು ಹೊಟ್ಟೆಯಲ್ಲಿ ಇರುವಂಥ ಒಂದು ಸಂದರ್ಭದಿಂದನೇ ಆ ಒಂದು ಆರೋಗ್ಯದ ಒಂದು ವಿಚಾರವನ್ನು ನಾವು ನೋಡ್ತಕ್ಕಂಥದ್ದು ಅವಶ್ಯಕತೆ ಬಂದ್ಬಿಡ್ತದೆ. ಅಥವಾ ಅದಕ್ಕಿಂತ ಮೊದಲನೇ ಆ ತಾಯಿಯ ಆರೋಗ್ಯ ಪರಿಸ್ಥಿತಿ ಏನಿರ್ತದೆ ಅಲ್ಲಿಂದನೇ ಪ್ರಾರಂಭ ಆಗ್ತದೆ. ಸೊ ತಾಯಿ ಚೆನ್ನಾಗಿದ್ರೆ ಮಗು ಚೆನ್ನಾಗಿರ್ತದೆ, ಮಗು ಚೆನ್ನಾಗಾದರೆ ಮಗು ಚಿಕ್ಕ ವಯಸ್ಸಿನಿಂದನೇ ನಾವು ಅದನ್ನು ಸರಿಯಾದ ರೀತಿಯಲ್ಲಿ ಪೌಷ್ಟಿಕಾಂಶಗಳು ಮತ್ತು ಅಗತ್ಯ ಇರತಕ್ಕಂಥ ಆರೋಗ್ಯ ಸೇವೆಗಳನ್ನೆಲ್ಲವನ್ನು ಕೂಡ ಅದಕ್ಕೆ ಕೊಡ್ತಾ ಬಂದರೆ ಅದು ಗಟ್ಟಿಯಾಗಿ ಮುಂದೆ ನಿಲ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ಶಕ್ತಿ ಸಿಗ್ತದೆ. ಸೊ ಆರೋಗ್ಯ ಇಲ್ಲದೆ ಹೋದರೆ ನಾವು ಏನನ್ನು ಕೂಡ ಸಾಧಿಸೋಕೆ ಆಗೋದಿಲ್ಲ ಮತ್ತು ನಮ್ಮ ಜೀವನವನ್ನು ಪರಿಪೂರ್ಣವಾಗಿ ನಡೆಸೋದಕ್ಕೆ ಸಾಧ್ಯ ಆಗೋದಿಲ್ಲ. ಅದರಿಂದ ಒಂದು ಸಮಾಜದ ಬೆಳವಣಿಗೆಯಲ್ಲಿ ಆರೋಗ್ಯ ಸ್ಥಿತಿಗತಿ ಬಹಳ ಮುಖ್ಯ ಆಗ್ತದೆ. ಮತ್ತು ಅದನ್ನು ಆರೋಗ್ಯವನ್ನು ಕಾಪಾಡ್ತಕ್ಕಂಥದ್ದು ಒಂದು ಕಡೆ, ಆರೋಗ್ಯ ಕೆಡೋದಕ್ಕಿಂತ ಮುಂಚೆ ನಾವು ತಗೊಳ್ತಕ್ಕಂಥ ಕೆಲವು ತೀರ್ಮಾನಗಳು, ಮತ್ತು ಆರೋಗ್ಯವನ್ನು ರಕ್ಷಣೆ ಮಾಡ್ತಕ್ಕಂಥವ್ರು, ಮತ್ತು ಯಾವಾಗ ಆರೋಗ್ಯ ಕೆಡ್ತದೆ ಅದನ್ನು ಸುಧಾರಣೆ ಮಾಡ್ತಕ್ಕಂಥವ್ರು ಯಾರಂತ ಹೇಳಿದ್ರೆ ನೀವುಗಳು, ನಮ್ಮ ಡಾಕ್ಟರ್ಗಳು. ಅದರಿಂದ ಡಾಕ್ಟರ್ಸು ಅತ್ಯಂತ ಒಂದು ಪವಿತ್ರವಾದಂಥ ಕ್ಷೇತ್ರ ಅಂತ ಹೇಳಿದ್ರೆ ತಪ್ಪಾಗಲಾರದು. ಅತ್ಯಂತ ಒಂದು ಪವಿತ್ರವಾದಂಥ ಮತ್ತು ಜನರ ಬದುಕಿನಲ್ಲಿ ಅನೇಕ ಸಂದರ್ಭಗಳಲ್ಲಿ ನಾನು ನೋಡಿದ್ದೇನೆ, ಬಹಳಷ್ಟು ಜನ ಡಾಕ್ಟರ್ಗಳನ್ನು ದೇವರ ಸಮಾನವಾಗಿ ನೋಡ್ತಕ್ಕಂಥದ್ದು ಕೂಡ ನಾವು ನೋಡ್ತೀವಿ. ಯಾಕಂದರೆ ಅಷ್ಟೊಂದು ಶಕ್ತಿ ನಿಮ್ಮ ಕೈಯಲ್ಲಿದೆ, ಅಷ್ಟೊಂದು ಜ್ಞಾನ ನಿಮ್ಮ ಕೈಯಲ್ಲಿದೆ. ಒಬ್ಬ ವ್ಯಕ್ತಿ ಅನಾರೋಗ್ಯಕ್ಕೆ ಒಳಗಾದಾಗ ನಿಮ್ಮ ಹತ್ರ ಬಂದಾಗ ನೀವು ಅವರನ್ನು ಸರಿಯಾಗಿ ರೀತಿಯಾಗಿ ನೋಡಿಕೊಂಡು ಅವರನ್ನು ಚೆನ್ನಾಗಿ ಮಾತನಾಡಿಸಿ ಅವರಿಗೆ ಗುಣಪಡಿಸ್ತಕ್ಕಂಥ ಕೆಲಸ ಮಾಡಿದಾಗ ಅವರ ಜೀವನ ಪರ್ಯಂತ ನಿಮ್ಮನ್ನು ಮರೆಯೋದಿಲ್ಲ. ಅವ್ರು ಯಾವಾಗಲೂ ಕೂಡ ಮಾತಾಡ್ತೀವಿ, ಅವ್ರು ಡಾಕ್ಟರ್ ರೀ, ಅವ್ರು ಎಷ್ಟು ಚೆನ್ನಾಗಿ ನಮ್ಮನ್ನು ನೋಡಿಕೊಂಡ್ರು, ಅವರು ನಮ್ಮ ಅವರಿಂದಲೇ ನಾನು ಇವತ್ತು ದಿವಸ ಬದುಕಿದ್ದೇನೆ ಅಂತ ನಾವು ಇದನ್ನು ಸಹಜವಾಗಿ ನಾವು ಕೇಳ್ತಾ ಇರ್ತೀವಿ. ಸೊ ಡಾಕ್ಟರ್ಸಿನ ಪಾತ್ರ ಏನಿದೆ ಅಂತ ಹೇಳಿದ್ರೆ ಭಾಳ ಮುಖ್ಯ. ಅದರಿಂದ ಡಾಕ್ಟರ್ಸು ನಾವು ಒಂದು ರೀತಿ ದೇವರ ಸಮಾನ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಅವರನ್ನು ಚೆನ್ನಾಗಿ ನೋಡ್ಕೊಳ್ದೆ ಹೋದರೆ ಮತ್ತು ನಾವು ಕೂಡ ತಪ್ಪು ಮಾಡ್ದಂಗೆ ಆಗತ್ತಲ್ವಾ. ಒಂದು ಸರ್ಕಾರದ ಜವಾಬ್ದಾರಿ ಕೂಡ ಅಷ್ಟೇ ಇರ್ತದೆ, ಸಮಾಜದ ಜವಾಬ್ದಾರಿ ಕೂಡ ಇದೆ. ನಮ್ಮ ಡಾಕ್ಟರ್ಸ್ ಚೆನ್ನಾಗಿರಬೇಕು, ಅವರು ಒಂದು ಸುರಕ್ಷಿತವಾಗಿರಬೇಕು, ಅವರ ಕಾರ್ಯನಿರ್ವಹಣೆಯಲ್ಲಿ ಎಲ್ಲ ರೀತಿಯ ಒಂದು ಸಹಕಾರವನ್ನು ಕೊಡ್ತಕ್ಕಂಥದ್ದು ಅದು ನಮ್ಮ ಕರ್ತವ್ಯ, ನಮ್ಮ ಜವಾಬ್ದಾರಿ. ಅದು ಎಷ್ಟು ಸಾಧ್ಯ ಆಗುತ್ತೆ ಅಷ್ಟು ನಿಮ್ಮ ಕೆಲಸದಲ್ಲಿ ನಿಮಗೆ ಎಲ್ಲ ರೀತಿಯ ಸಹಕಾರ ಕೊಡ್ತಕ್ಕಂಥದ್ದು ನಾವು ಮಾಡಬೇಕಾಗ್ತದೆ. ಆದ್ದರಿಂದ ಇವತ್ತು ಆ ಕಾರಣದಿಂದಲೇ ಇವತ್ತು ನಿಮ್ಮ ಅಸೋಸಿಯೇಷನ್ ಬಹಳ ಕ್ರಿಯಾಶೀಲವಾಗಿ ಇವತ್ತು ಕೆಲಸ ಮಾಡ್ತಾ ಇದೆ. ನನ್ನ ಜೊತೆಯಲ್ಲಿ ಈಗಾಗಲೇ ನಾನೀಗ ಮಂತ್ರಿಯಾಗಿ ಸುಮಾರು 5-6 ತಿಂಗಳಾಗಿದೆ. ಹಲವಾರು ಬಾರಿ ಈಗಾಗಲೇ ನನ್ನನ್ನು ಭೇಟಿಯಾಗ್ಬಿಟ್ಟಿದ್ದಾರೆ ಮತ್ತು ನನ್ನನ್ನು ಅನೇಕ ಸಂದರ್ಭಗಳಲ್ಲಿ ಕರೆಸಿ ಮಾತನಾಡಿಸಿ ಅವರ ಸಮಸ್ಯೆಗಳ ಬಗ್ಗೆ ಇವತ್ತಿನ ದಿವಸ ನನಗೆ ಹೇಳಿದ್ದಾರೆ. ಆದ್ದರಿಂದ ನಾನು ಖಂಡಿತವಾಗಿಯೂ ಆ ಎಲ್ಲ ಒಂದು ವಿಚಾರಗಳ ಬಗ್ಗೆ ಅವರೇನೇನೋ ಈಗ ಅನೇಕ ಸಮಸ್ಯೆಗಳ ಬಗ್ಗೆ ಏನು ಹೇಳ್ತಾ ಇದ್ದಾರೆ, ಖಂಡಿತವಾಗಿಯೂ ನಾವು ಅದನ್ನು ನಮ್ಮ ಕಡೆಯಿಂದ ಎಲ್ಲವನ್ನು ಕೂಡ ಬಗೆಹರಿಸ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ನನ್ನ ಪ್ರಾಮಾಣಿಕ ಪ್ರಯತ್ನ ಇರುತ್ತೆ ಅಂತ ಕೂಡ ನಾನು ಮತ್ತೊಮ್ಮೆ ನಿಮಗೆ ಹೇಳೋದಕ್ಕೆ ಬಯಸ್ತಾ ಇದ್ದೀನಿ. ಯಾಕೆಂದರೆ ನಾವು ಅದನ್ನು ಮಾಡಬೇಕಾಗ್ತದೆ. ಪ್ರೊಫೆಷನಲ್ಲಿ ಇವತ್ತು ಡಾಕ್ಟರ್ಸ್ಗೆ ಆಗ್ತಕ್ಕಂಥ ಕಿರುಕುಳನೂ ಇರ್ಬೋದು, ಅವರ ಕೆಲಸ ಮಾಡ್ತಾ ಇರೋ ಸಂದರ್ಭದಲ್ಲಿ ಇರುವಂಥ ಒತ್ತಡಗಳಿರ್ಬೋದು, ಮತ್ತು ಸರ್ಕಾರಿ ರೂಲ್ಸ್ ಏನಿದೆ ಅದರಿಂದ ಆಗ್ತಕ್ಕಂಥ ತೊಂದರೆಗಳಿರ್ಬೋದು, ಅದೇನೇ ಇರ್ಬೋದು, ಅದೆಲ್ಲವನ್ನು ಕೂಡ ಖಂಡಿತವಾಗಿಯೂ ಪರಿಹಾರವನ್ನು ಹುಡುಕ್ತಕ್ಕಂಥದ್ದು ಕೂಡ ನಾವು ಮಾಡೋಣ. ಅದು ಕೆಲವು ಈಗಾಗಲೇ ಹೇಳಿದ್ದಾರೆ, ಟ್ರೇಡ್ ಲೈಸೆನ್ಸ್ ವಿಚಾರ ಮತ್ತು ಈ ಫೈರ್ ಪರ್ಮಿಷನ್ನು ಆಸ್ಪತ್ರೆಗಳಿಗೆ ಇದೆಲ್ಲ ತಗೊಳ್ತಕ್ಕಂಥದ್ದು ಕೂಡ ಸಮಸ್ಯೆಗಳಾಗ್ತಾ ಇದೆ ಅಂತ. ಅದು ಕೂಡ ಹಳೆಯ ಆಸ್ಪತ್ರೆಗಳಿಗೆ ಹೊಸ ರೂಲ್ಸನ್ನು ಹಾಕಿದ್ರೆ ಅದನ್ನು ಕೂಡ ಮಾಡೋದು ಭಾಳ ಕಷ್ಟ ಆಗ್ತದೆ. ಸೊ ಈ ರೀತಿಯಾಗಿ ಏನೇನು ಮಾಡೋದಕ್ಕೆ ಸಾಧ್ಯ ಆಗುತ್ತೆ, ಖಂಡಿತವಾಗಿಯೂ ಹಳೆಯ ಅಧ್ಯಕ್ಷರು ಈಗ ಇದ್ದಾರೆ, ಹೊಸ ನೂತನ ಅಧ್ಯಕ್ಷರು ಕೂಡ ನಾವು ಭರವಸೆ ಕೊಡ್ತಾ ಇದ್ದೀವಿ. ನೀವು ನಮ್ಮ ಕಚೇರಿ ನಿಮಗೆ 24 ಗಂಟೆ ಯಾವಾಗ ಬೇಕಾದ್ರೂ ನಮ್ಮ ಹತ್ರ ಬರ್ಬೋದು. ನೀವು ನಿಮ್ಮ ಸಮಸ್ಯೆಗಳಿಗೆ ನಾವು ಸೂಕ್ತವಾದಂಥ ರೀತಿಯಲ್ಲಿ ಅದನ್ನು ಬಗೆಹರಿಸ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ನಾವು ಖಂಡಿತವಾಗಿಯೂ ಮಾಡಿಕೊಡ್ತೀವಿ ಇರುವಂಥ ಚೌಕಟ್ಟಿನಲ್ಲಿ. ಯಾಕಂದರೆ ಎಲ್ಲವನ್ನು ಕೂಡ ಬ್ಯಾಲೆನ್ಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಆದರೆ ನಿಮ್ಮ ಒಂದು ಸಮಸ್ಯೆಗಳಿಗೆ ಖಂಡಿತವಾಗಿಯೂ ಆದ್ಯತೆಯನ್ನು ನೀಡಬೇಕಾಗ್ತದೆ. ಇವತ್ತು ನಮ್ಮ ಮಂಜುನಾಥ್ ಅವರ ಭಾಷಣವನ್ನು ಕೂಡ ಕೇಳ್ತಾ ಇದ್ದು, ಭಾಳ ಅವರು ಅದ್ಭುತವಾಗಿ ಅವರು ದೊಡ್ಡ ಸಾಧನೆಯನ್ನೇ ಮಾಡಿಬಿಟ್ಟಿದ್ದಾರೆ. ಮಂಜುನಾಥ್ ಅವರು ಅಂತ ಹೇಳಿದ್ರೆ ಇವತ್ತು ಅವರೇ ಒಂದು ಇನ್ಸ್ಟಿಟ್ಯೂಷನ್. ಅವರು ಜಯದೇವ ಎರಡು ಒಂಥರ ಮರ್ಜ್ ಆಗ್ಬಿಟ್ಟಿದೆ ಈಗ. ಮಂಜುನಾಥ್ ಅಂದರೆ ಜಯದೇವ ಇನ್ಸ್ಟಿಟ್ಯೂಟು, ಜಯದೇವ ಅಂತ ಹೇಳಿದ್ರೆ ಮಂಜುನಾಥ್ ಅಂತ ಹಂಗೆ ಆಗ್ಬಿಟ್ಟಿದೆ. ಅವರ ಮಾತುಗಳನ್ನು ನಾವು ಕೇಳ್ತಾ ಇದ್ದೋ ಡಾಕ್ಟರ್ಸಿನ ವಿಚಾರದಲ್ಲಿ, ಮತ್ತು ಯಾವ ರೀತಿಯಾಗಿ ನಾವು ಹೊಸ ಪ್ರಯೋಗಗಳನ್ನು ಸರ್ಕಾರದ ಜೊತೆ ಈಗೆಲ್ಲ ನಾವು ಮಾಡೋದಕ್ಕೆ ಹೊರಟಿದ್ದೇವೆ ಅದರ ಬಗ್ಗೆನೂ ಎಲ್ಲ ಹೇಳಿದ್ದಾರೆ. ಸೊ ಖಂಡಿತವಾಗಿಯೂ ನಾವು ನಮ್ಮ ಇಲಾಖೆಯಿಂದ ಇನ್ನೂ ಹೆಚ್ಚು ಆರೋಗ್ಯ ಸೇವೆಗಳಲ್ಲಿ ಹೆಚ್ಚು ಒತ್ತು ಕೊಡ್ತಕ್ಕಂಥದ್ದು, ಇಂಪ್ರೂವ್ ಮಾಡ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ, ಮತ್ತು ವೈದ್ಯಕೀಯ ಸೇವೆಗಳು ಏನಿದೆ ಅದು ಇನ್ನೂ ಪರಿಪೂರ್ಣವಾಗಿ ನಮ್ಮ ಜನರಿಗೆ, ಸಾಮಾನ್ಯ ಬಡ ಜನರಿಗೆ ನಮ್ಮ ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಯಲ್ಲೂ ಕೂಡ ಎಲ್ಲ ರೀತಿಯ ಸೌಕರ್ಯಗಳನ್ನು ಕೊಡ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ನಾವು ಮಾಡೋದಕ್ಕೆ ನಮ್ಮ ಪ್ರಯತ್ನ ಇರ್ತದೆ. ಈಗ ಅವ್ರು ಹೇಳಿದ್ರು ಸ್ಟೆಮಿ ಪ್ರಾಜೆಕ್ಟ್ ಏನಿದೆ ಅದನ್ನು ಈಗ ನಾವು ವಿಸ್ತೀರ್ಣ ಮಾಡಿಕೊಂಡು ಅದನ್ನು ಇವಾಗ ನಾವು ಇನ್ನೂ ಸುಮಾರು 80 ತಾಲೂಕುಗಳಿಗೆ ಅದನ್ನು ವಿಸ್ತೀರ್ಣ ಮಾಡಿ ಇನ್ನೂ ಬೇರೆ ಬೇರೆ ಭಾಗಗಳಿಗೆ ಅದನ್ನು ಸೇರಿಸ್ಕೊಂಡು, ಮತ್ತು ಆ ಹೊಸ ಇಂಜೆಕ್ಷನನ್ನು ಕೂಡ ಈ ಏನು ಆವಾಗ ಯಾರಿಗೆ ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಆಗುವಂಥ ಸಂದರ್ಭದಲ್ಲಿ ತಾಲೂಕು ಆಸ್ಪತ್ರೆಗಳಲ್ಲೇ ಅವ್ರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ತಕ್ಕಂಥದ್ದನ್ನು ನಾವು ಮಾಡೋದಕ್ಕೆ ಅದನ್ನು ಕೂಡ ನಾವು ಮಾಡೋದಕ್ಕೆ ಶುರು ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಮತ್ತು ಈ AEDಗಳೇನಿದೆ, ಡಿಫಿಬ್ರಿಲೇಟರ್ಸ್ ಏನಿದೆ, ಅದನ್ನು ಕೂಡ ನಾವೀಗ ನಮ್ಮ ಹೊಸ ಒಂದು ನೂತನ ಯೋಜನೆಯಲ್ಲಿ ತೊಗೊಂಡು ಬಂದಿದ್ದೇವೆ. ನಮ್ಮ ಎಲ್ಲ ಬಸ್ ಸ್ಟ್ಯಾಂಡ್ಗಳಲ್ಲಿ, ರೈಲ್ವೆ ಸ್ಟೇಷನ್ಗಳಲ್ಲಿ ಮತ್ತು ಏರ್ಪೋರ್ಟ್ಗಳಲ್ಲಿ ಮತ್ತು ಸಾರ್ವಜನಿಕ ಸ್ಥಳಗಳಲ್ಲಿ ಈ AEDಗಳನ್ನು ಅದು ವಿಶೇಷವಾದಂಥ ಸೌಲಭ್ಯವನ್ನು ಒದಗಿಸ್ತಕ್ಕಂಥ ವ್ಯವಸ್ಥೆಯನ್ನು ನಿರ್ಮಾಣ ಮಾಡ್ತಕ್ಕಂಥದ್ದು ಕೂಡ ನಾವು ಇವತ್ತು ತೀರ್ಮಾನ ಮಾಡಿದ್ದೇವೆ. ಸೊ ಇದನ್ನು ಯಾಕಂದರೆ ಆ ಸಮಯಕ್ಕೆ ಸರಿಯಾದ ಸಮಯಕ್ಕೆ ನಾವು ಅವ್ರಿಗೆ ಆ ಒಂದು ಚಿಕಿತ್ಸೆಗೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ರೆ ಅವ್ರು ಬದುಕ್ತಾರೆ. ಅದೇನು ಗೋಲ್ಡನ್ ಅವರ್ ಪೀರಿಯಡ್ ಅಂತ ಹೇಳ್ತೀವಿ, ವಿದಿನ್ 1 hour, ವಿದಿನ್ 2 hours ಅವ್ರಿಗೆ ಆ ಟ್ರೀಟ್ಮೆಂಟ್ ಸಿಕ್ಕಿದ್ರೆ ಅವ್ರಿಗೆ ಬದುಕುವಂಥ ಅವಕಾಶ. ಇಲ್ಲದೆ ಹೋದರೆ ನಾವು ಒಂದು ಗ್ರಾಮದಿಂದ ಒಂದು ತಾಲೂಕು ಆಸ್ಪತ್ರೆಗೆ ಕರ್ಕೊಂಬರೋದು, ತಾಲೂಕು ಆಸ್ಪತ್ರೆಯಿಂದ ಜಿಲ್ಲಾ ಆಸ್ಪತ್ರೆಗೆ ಕರ್ಕೊಂಡು ಹೋಗೋಷ್ಟೊತ್ತಿಗೆ ಎಷ್ಟೋ ಜನ ದಾರಿಯಲ್ಲೇ ಸತ್ತೋಗಿರ್ತಾರೆ, ಅಥವಾ ಬರುವಷ್ಟೊತ್ತಿಗೆ ಅವ್ರಿಗೆ ತುಂಬ ತಡ ಆಗೋಗಿರ್ತದೆ. ಸೊ ಈ ರೀತಿಯಾದಂಥ ವ್ಯವಸ್ಥೆಗಳನ್ನು ಖಂಡಿತವಾಗಿಯೂ ನಾವು ಅನೇಕ ಬೇರೆ ಬೇರೆ ನಮ್ಮ ಇಲಾಖೆಯಿಂದನೂ ಕೂಡ ನಾವು ಹೊಸ ತಂತ್ರಜ್ಞಾನ, ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟೆಲಿಜೆನ್ಸ್ ಇರ್ಬೋದು, ಮತ್ತು ಟೆಲಿಮೆಡಿಸಿನ್ ಇರ್ಬೋದು, ಇಂಟರ್ನೆಟ್ ಇಂಟರ್ನೆಟ್ಗಳನ್ನು ಉಪಯೋಗ ಮಾಡಿಕೊಂಡು, ಮತ್ತು ಏನು ಕ್ಲೌಡ್ ಬೇಸ್ಡ್ ಏನು ಈ ಸರ್ವಿಸಸ್ ಇದೆ ಅದನ್ನೆಲ್ಲ ಉಪಯೋಗ ಮಾಡಿಕೊಂಡು ಈ ಆದಷ್ಟು ಆಧುನಿಕ ಮತ್ತು ಸೂಪರ್ ಸ್ಪೆಷಾಲಿಟಿ ಸರ್ವಿಸಸನ್ನು ನಾವು ನಾವು ಒಂದು ಪ್ರೈಮರಿ ಲೆವೆಲ್ವರೆಗೂ ತೊಗೊಂಡೋಗ್ತಕ್ಕಂಥ ಒಂದು ಪ್ರಯತ್ನವನ್ನು ಮಾಡೋದಕ್ಕೆ ನಾವು ಈಗ ನಮ್ಮ ಎಫರ್ಟ್ಸ್ ಇದೆ. ಸೊ ಇದೆಲ್ಲ ನಮ್ಮ ಇಲಾಖೆಯಿಂದ, ನಮ್ಮ ಕಡೆಯಿಂದ ಖಂಡಿತವಾಗಿಯೂ ನಾವು ಮಾಡ್ತೀವಿ ಅಂತ ಈ ಸಂದರ್ಭದಲ್ಲಿ ಹೇಳಿ, ಆಮೇಲೆ ಕೆಲವು ನಮ್ಮ IMA ಅವರು ಹೇಳಿದ್ದಾರೆ, ನಮ್ಮ ABRK ಏನಿದೆ, ಏನು ಹಣ ಇದೆ ಅದು ರೇಟ್ಸು ಕೂಡ ಭಾಳ ಕಮ್ಮಿ ಆಗಿಬಿಟ್ಟಿದೆ ಅಂತ ಅವ್ರು ಹೇಳ್ತಾ ಇದ್ದಾರೆ. ಅದರ ಬಗ್ಗೆ ನಮ್ಮ ಗಮನ ಇದೆ. ಯಾಕಂದರೆ ಇದು ರೇಟ್ಸನ್ನು ನಿಗದಿಯಾಗಿ ಸುಮಾರು ಈಗಾಗಲೇ ಬಹುಶಃ 10 ವರ್ಷ ಆಗೋಗಿರ್ಬೋದು, 10 ವರ್ಷ ಆಗೋಗಿದೆ. ಈ ಪ್ರೊಸೀಜರ್ಸ್ಗೆ ಏನೇನು ರೇಟ್ಗಳಿದೆ ಅದನ್ನು ಖಂಡಿತವಾಗಿಯೂ ಅದು ಕಮ್ಮಿ ಇದೆ ಅಂತ ನಾನು ಒಪ್ಕೊಳ್ತೀನಿ. ಅದನ್ನು ಹೆಚ್ಚು ಮಾಡ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ನಾನು ಈ ವರ್ಷನೇ ಆಗುತ್ತೆ ಅಂತ ಹೇಳೋಕೆ ಆಗೋದಿಲ್ಲ, ಆದರೆ ಮುಂದಿನ ವರ್ಷದ ಒಳಗಡೆ ನಾವು ಅದನ್ನು ಸ್ವಲ್ಪ ನ್ಯಾಯಬದ್ಧವಾದಂಥ ರೇಟ್ಗೆ ತಗೊಳ್ತಕ್ಕಂಥದ್ದಕ್ಕೆ ಖಂಡಿತವಾಗಿಯೂ ಅದನ್ನು ತೀರ್ಮಾನವನ್ನು ಮಾಡಿಸ್ತೀನಿ ಅಂತ ಕೂಡ ನಿಮಗೆ ಹೇಳೋದಕ್ಕೆ ಬಯಸ್ತಾ ಇದ್ದೀನಿ. ಸೊ ಈ ರೀತಿಯಾಗಿ ಹಲವಾರು ನಮ್ಮ ಕೆಲಸಗಳನ್ನು ಮಾಡೋದಕ್ಕೆ ನಮ್ಮ ಎಫರ್ಟ್ಸ್ ಇದೆ. ಅದೇ ಒಂದು ಮಂಜುನಾಥ್ ಅವರು ಹೇಳಿದಾಗ ನನಗೂ ಕೂಡ ಮಾಹಿತಿ ಇದೆ. ಈಗ ಆರೋಗ್ಯ ಏನಾಗಿದೆ ಅಂತ ಹೇಳಿದ್ರೆ, ಆರೋಗ್ಯ ಇವತ್ತು ನಮ್ಮ ಕೈಯಲ್ಲೇ ಇದೆ. ಹಿಂದೆ ಎಲ್ಲ ಸುಮಾರು 20 ವರ್ಷ, 30 ವರ್ಷ, 50 ವರ್ಷದ ಹಿಂದೆ ಜನರ ಆಯುಷು ಕಮ್ಮಿ ಇತ್ತು. ಸ್ವತಂತ್ರ ಬಂದಾಗ ನಮ್ಮ ದೇಶದ ಜನರ ಆಯುಷು ಸುಮಾರು 32 ವರ್ಷ ಆಯ್ತು ಅಷ್ಟೇ. ಆವ್ರೇಜ್, ಸರಾಸರಿ ಒಬ್ಬ ವ್ಯಕ್ತಿ ಸರಾಸರಿ ಬದುಕುವಂತ ಅವನಿಗೆ ಏಜ್ ಎಷ್ಟಾಗ್ತದೆ ಅಂತ ಹೇಳಿದ್ರೆ 32 ವರ್ಷ ಅಂತ ಸರಾಸರಿ ಇರ್ತಾ ಇತ್ತು ಅವರ ಲೈಫ್ ಸ್ಪ್ಯಾನ್. ಈಗ ಸುಮಾರು 70 ವರ್ಷ ಆಗಿದೆ. ಮತ್ತು ಆವಾಗ ಇರ್ತಕ್ಕಂಥ ಕಾಯಿಲೆಗಳು ಯಾವ ಕಾರಣದಿಂದ ಅವರೆಲ್ಲ ಸತ್ತೋಗ್ತಾ ಇದ್ರು, ಸಾಂಕ್ರಾಮಿಕ ರೋಗಗಳಿಂದ ತೀರೋಗ್ತಾ ಇದ್ರು. ಕಾಲೆರಾ, ಟೈಫಾಯ್ಡ್, ಮಲೇರಿಯಾ, ಚಿಕನ್ ಪಾಕ್ಸ್, ಬೇರೆ ಬೇರೆ ಈ ರೀತಿಯಾದಂಥ ಕಾಯಿಲೆಗಳು, ಅದರಿಂದ ತೀರ್ಕೊಳ್ತಾ ಇದ್ರು. ಈಗ ಆ ಪರಿಸ್ಥಿತಿ ಇಲ್ಲ. ಈಗ ಅದೆಲ್ಲ ಬಹಳ ಕಮ್ಮಿ ಆಗ್ತಾ ಇದೆ. ಈಗ ಹೆಚ್ಚು ನಾವು ತೀರ್ಕೊಳ್ತಾ ಇರ್ತಕ್ಕಂಥದ್ದು ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್, ಸ್ಟ್ರೋಕ್, ಕ್ಯಾನ್ಸರ್, ಕಿಡ್ನಿ, ಈ ರೀತಿಯಾದಂಥ ಕಾಯಿಲೆಗಳು. ಸೊ ಈ ಕಾಯಿಲೆಗಳು ಎಲ್ಲಿಂದ ಬರ್ತಾ ಇದೆ? ಒಂದು ನಮ್ಮ ಜೆನೆಟಿಕ್ಸ್ ಇಂದ ಇರ್ಬೋದು, ಆನುವಂಶಿಕ ಕಾರಣಗಳಿಂದ ನಮಗೆ ಬರ್ತಾ ಇರ್ಬೋದು. ಅದನ್ನ ನಾವೇನು ಮಾಡೋಕ್ಕಾಗಲ್ಲ, ಯಾರು ಏನೂ ಮಾಡೋಕ್ಕಾಗಲ್ಲ, ಯಾಕಂದ್ರೆ ಅದು ನಮ್ಮ ಕೈಲಿಲ್ಲ. ಆದರೆ ಬಹಳ ಅದಕ್ಕಿಂತ ಹೆಚ್ಚಾಗಿ ಇವತ್ತು ನಾವು ಆರೋಗ್ಯ ಇವತ್ತು ಎಲ್ಲಿಂದ ಕೆಡ್ತಾ ಇದ್ದೀವಿ ಅಂತ ಹೇಳಿದ್ರೆ, ನಮ್ಮ ಲೈಫ್ ಸ್ಟೈಲು, ನಾವು 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 ತಗೊಳ್ತಾ ಇರ್ತಕ್ಕಂಥ ನಮ್ಮ ಆಹಾರ ಪದ್ಧತಿ ಮತ್ತು ನಮ್ಮ ಏನು ಫಿಸಿಕಲ್ ಆಕ್ಟಿವಿಟಿ ಇಲ್ದೇನೆ ಏನು ನಮ್ಮ ಜೀವನ ನಡೆಸ್ತಾ ಇದ್ದೀವಿ, ಆ ಕಾರಣ. ಸೊ ಈ ಹ್ಯಾಬಿಟ್ಸಿಂದ, ಲೈಫ್ ಸ್ಟೈಲಿಂದ, ಸ್ಟ್ರೆಸ್ಸಿಂದ ಈ ಕಾಯಿಲೆಗಳು ಹೆಚ್ಚಾಗ್ತಾ ಇದೆ. ಅಂದರೆ ಇವತ್ತು ಒಂದು ವ್ಯಕ್ತಿ ಸರಿಯಾದ ರೀತಿಯಲ್ಲಿ ತನ್ನ ಜೀವನವನ್ನು ನಡೆಸ್ಕೊಂಡು ಹೋದರೆ, ಈ ಆನುವಂಶಿಕ ಮತ್ತು ಬೇರೆ ಬೇರೆ ಕಾರಣಗಳಿಂದ ಕಾಯಿಲೆ ಬಂದು ಏನೂ ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ಆದರೆ ಸರಿಯಾದ ರೀತಿಯಲ್ಲಿ ನಡೆಸ್ಕೊಂಡು ಹೋದರೆ ಖಂಡಿತವಾಗಿ ಇವತ್ತು 80 ವರ್ಷ, 85 ವರ್ಷ, 90 ವರ್ಷವರೆಗೂ ಬದುಕ್ಬೋದು. ಇದರ ಅರ್ಥ ಏನಂತ ಹೇಳಿದ್ರೆ, ನಮ್ಮ ಆರೋಗ್ಯ ನಮ್ಮ ಕೈಯಲ್ಲೇ ಇದೆ. ಮತ್ತು ನಾವು ಯಾವ ರೀತಿಯಾಗಿ ನಮ್ಮನ್ನು ನಾವು ನೋಡ್ಕೊಳ್ತೀವಿ, ಚೆನ್ನಾಗಿ ನೋಡ್ಕೊಂಡ್ರೆ ನಾವು ಹೆಚ್ಚು ವರ್ಷ ನಾವು ಇವತ್ತಿನ ದಿವಸ ಬದುಕ್ಬೋದು. ವರ್ಷಕ್ಕೊಂದ್ಸಲ ನಾವು ಚೆಕಪ್ ಮಾಡಿಕೊಂಡು, ನಮ್ಮ ECG ಬೇಸಿಕ್ ಎಲ್ಲ ಚೆಕಪ್ ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ರೆ, ಕಿಡ್ನಿ ಫಂಕ್ಷನ್, ಲಿವರ್ ಫಂಕ್ಷನ್ ಎಲ್ಲ ಚೆಕ್ ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ರೆ, ಮೊದಲೇ ನಮ್ಗೆ ಏನಾದ್ರು ಕಾಯಿಲೆ ಬಂದರೂ ಕೂಡ ಗುಣಪಡಿಸ್ಕೊಳ್ತಕ್ಕಂಥ ಇವತ್ತೆಲ್ಲ ರೀತಿಯ ಸೌಲಭ್ಯಗಳಿದೆ. ಹಾರ್ಟ್ ಪ್ರಾಬ್ಲಮ್ ಆದರೆ ಬೈಪಾಸ್ ಮಾಡ್ಬೋದು, ಆಂಜಿಯೋಪ್ಲಾಸ್ಟಿ ಮಾಡ್ಬೋದು, ಕ್ಯಾನ್ಸರ್ ಅರ್ಲಿ ಡಿಟೆಕ್ಷನ್ ಆದರೆ ಕ್ಯೂರ್ ಮಾಡ್ಕೋಬೋದು. ಯಾವುದೇ ತೊಂದರೆ ಇದ್ರೂ ಕೂಡ ಅರ್ಲಿ ಡಿಟೆಕ್ಷನ್ ಇದ್ದರೆ ನೀವು ಅದೆಲ್ಲವನ್ನು ಕೂಡ ಗುಣಪಡಿಸ್ಕೋಬೋದು. ಮತ್ತು ಲೈಫ್ ಸ್ಟೈಲಿಂದ ಡಯಾಬಿಟೀಸ್, ಹೈಪರ್ ಟೆನ್ಷನ್ ಅನ್ನು ಕಂಟ್ರೋಲ್ ಇಟ್ಕೊಂಡ್ಬಿಟ್ರೆ ಯಾವ ಕಾಯಿಲೆಗಳು ಕೂಡ ಬರೋದಕ್ಕೆ ಅವಕಾಶ ಆಗೋದಿಲ್ಲ. ಸೊ ಇವತ್ತು ಮನುಷ್ಯನ ಆಯುಷ್ ಅವನ ಕೈಯಲ್ಲೇ ಇದೆ. ಮೊದಲು ಆ ಥರ ಇರಲಿಲ್ಲ. ಮೊದಲು ಅವರು ಸಾಂಕ್ರಾಮಿಕ ರೋಗ ಬಂದರೆ ಏನೂ ಮಾಡೋಕ್ಕಾಗ್ತಾ ಇರಲಿಲ್ಲ, ಸರಿಯಾದ ಟ್ರೀಟ್ಮೆಂಟು ಕೂಡ ಇರ್ತಾ ಇರಲಿಲ್ಲ. ಈಗ ಅದಕ್ಕೆಲ್ಲ ಕೂಡ ಐದರ್ ವ್ಯಾಕ್ಸಿನೇಷನ್ಸ್ ಇದೆ ಅಥವಾ ಬೇಕಾದಷ್ಟು ಮೆಡಿಸಿನ್ಸ್ ಇದೆ. ಸೊ ಇವತ್ತು ಬದುಕು ನಮ್ಮ ಕೈಯಲ್ಲಿದ್ದಾಗ 70, 75, 80, 90 ವರ್ಷವರೆಗೂ ಬದುಕ್ತಕ್ಕಂಥ ಅವಕಾಶ ಇವತ್ತು ಇದೆ. ಆದರೆ ಒಂದು ಸಂಗತಿ ಆಲೋಚನೆ ಮಾಡ್ತಕ್ಕಂಥದ್ದು, ಡಾಕ್ಟರ್ಸಿನ ಆಯುಷ್ ಕಡಿಮೆ ಇದೆ. 55 ಅಂದ್ರೆ 60 ವರ್ಷ ಇವತ್ತು ಸರಾಸರಿ ನಮ್ಮ ಡಾಕ್ಟರ್ಸಿನ ಒಂದು ಆಯುಷ್ ಅಂತ ಹೇಳಿ ಇವತ್ತಿನ ದಿವಸ ಇರುವಂತ ಮಾಹಿತಿ. ಸೊ ಸಾಮಾನ್ಯ ಜನ 70 ವರ್ಷವರೆಗೂ ಬದುಕ್ತಾ ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ಸ್ 60 ವರ್ಷವರೆಗೂ ಬದುಕ್ತಾ ಇದ್ದಾರೆ. ಸೊ ಇದೇನು ಅರ್ಥ? ನೀವೇ ನಮ್ಮನ್ನ ಉಳಿಸುವಂಥವ್ರು. ಅದೇ ನೀವೇ ನಿಮ್ಮ ಆರೋಗ್ಯ ನೋಡ್ಕೊಳ್ದೆ ಹೋದ್ರೆ ಇದಕ್ಕೆ ಕಾರಣ ಏನು ಅದನ್ನು ಕೂಡ ನೋಡ್ಬೇಕಾಗ್ತದೆ. ಯಾಕಂದ್ರೆ ಇರ್ಬೋದು, ನಿಮ್ಮ ಸ್ಟ್ರೆಸ್ ಲೆವೆಲ್ ಜಾಸ್ತಿ ಇರ್ಬೋದು, ಒತ್ತಡ ಇರ್ಬೋದು, ಒತ್ತಡದ ಜೀವನ, ಮತ್ತು ನಿಮ್ಮ ಬಹುಶಃ ನೀವುಗಳು ನಿಮ್ಮ ಆರೋಗ್ಯದ ಬಗ್ಗೆ ನಿಮ್ಗೆ ಗಮನ ಇಲ್ಲ ಅಂತ ಆಯ್ತು. ಈ ಮಾಹಿತಿ ನಾನು ಈ ಮಾಹಿತಿ ನೋಡಿದ್ರೆ ಡಾಕ್ಟರ್ಸಿನ ಆರೋಗ್ಯ, ನೀವು ನಿಮ್ಮ ಆರೋಗ್ಯಕ್ಕೆ ಹೆಚ್ಚು ಗಮನ ಕೊಡ್ತಾ ಇಲ್ಲ. ಸೊ ಅದು ಎಲ್ಲೋ ಒಂದ್ ಕಡೆ ಇದ್ರ ಬಗ್ಗೆ ಅವೇರ್ನೆಸ್, ಜಾಗೃತಿಯನ್ನ ಮೂಡಿಸ್ತಾ. ಯಾಕಂದ್ರೆ ನೀವುಗಳೆಲ್ಲ ನಮ್ಗೆ ಆಸ್ತಿ. ಒಬ್ಬ ಒಳ್ಳೆ ಡಾಕ್ಟ್ರು ಹೆಚ್ಚು ಜೀವ ನಡೆಸದೆ ಜೀವ ಇದ್ರೆ ಅವ್ರಿಗೆ ನಮಗೆ ಆಸ್ತಿಗಳು ತಾನೆ. ನೀವು ನಿಮ್ಮ ನಾಲೆಡ್ಜು, ನಿಮ್ಮ ಇನ್ಫಾರ್ಮೇಶನ್ನು ಎಷ್ಟು ಬದುಕ್ತೀರಾ ಅಷ್ಟು ನೀವು ನಮ್ಮ ಸಮಾಜಕ್ಕೆ ನೀವು ಪ್ರಯೋಜನ ಆಗ್ಬೋದು. ಮತ್ತು ನೀವು ಕೂಡ ಒಳ್ಳೆ ಜೀವನ ನಡೆಸ್ತಕ್ಕಂಥದ್ದು ಆಗ್ತದೆ. ಇದು ಖಂಡಿತವಾಗಿಯೂ ನೀವು ನೋಡ್ಬೇಕಾಗ್ತದೆ. ಬಹುಶಃ ನೀವು ಇಡೀ ದಿವಸ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಇರ್ತೀರಾ, ಅದ ನಂತರ ಕ್ಲಿನಿಕ್ಗೆ ಹೋಗ್ತೀರಾ, ಅದ ನಂತರ ನಿಮ್ಮ ಮನೆಗೆ ಹೋಗ್ತೀರಾ, ಮಧ್ಯದಲ್ಲಿ ಕಾಫಿ, ಸಮೋಸ, ಟೀ, ಅದು ಇದು ತಗೊಳ್ತಾ ಇರ್ತೀರಾ. ಸೊ ನಿಮ್ಗೆ ಟೈಮ್ ಇರೋದಿಲ್ಲ. ಮನೆಗೆ ಹೋದ್ರೆ ಮತ್ತೆ ಅಲ್ಲೆಲ್ಲ ಮಲ್ಕೊಳ್ಳೋಷ್ಟಕ್ಕೆ ಲೇಟ್ ಆಗಿ, ಅಥವಾ ಮಧ್ಯದಲ್ಲಿ ರಾತ್ರಿ ಹೊತ್ತು ಯಾರೋ ಫೋನ್ ಮಾಡ್ತಾರೆ, ಯಾರೋ ತಿಳಿಸ್ತಾರೆ ನಮ್ಗೆ ಹುಷಾರಿಲ್ಲ, ನಮ್ಗೆ ಇದಾಗ್ತಾ ಇದೆ, ಅದನ್ನ ಅಟೆಂಡ್ ಮಾಡಬೇಕು, ನಿದ್ದೆ ಸರಿ ಇರೋದಿಲ್ಲ, ಬೆಳಗ್ಗೆ ಎದ್ದು ಮತ್ತೆ ಹೋಗ್ಬೇಕು. ಸೊ ಎಲ್ಲೊಂದ್ ಕಡೆ ನಿಮ್ಮ ಒಂದು ಸ್ಟ್ರೆಸ್ ಇದೆ. ಡಿಸಾರ್ಡರ್ಸ್ ಇದೆ. ಸೊ ಇದು ಒಂದು ಗಂಭೀರವಾದಂಥ. ಸೊ IMA ಅವರು, I request IMA to take note of this. This is a very serious issue actually. If the age of the doctor is less than the age of the patient, then that is a very worrying issue. So this has to be also, I think, told to all the doctors that please take care of your own health. Address those issues, stress issues, lifestyle issues, work issues. So all those things I think are very important. And I think IMA should take serious note of this, because these are all not some made up statistics. These are all data which is available. So I request the new president of IMA and the new state president, new national president, to take up these issues, because we want our doctors to be healthy. They should work in a good environment, they should contribute more, and they should be able to function to the utmost of their capacities. That is what is our need, and definitely any support from our side, we are always there. So I want to congratulate our IMA for having organized this event, this program, the annual event, and I'm sure there any other issues that come up in their which they are facing, definitely we are with you, because ultimately we all have to work together. No one person can change everything. Everyone, if they work collectively, work together, talk to each other, communicate and sort out issues, every issues can be sorted out, every problem can be solved. Nothing is insolvable, or nothing can that nothing is impossible. So we are with you, and I want to congratulate the new president, and under his new chairmanship of this IMA Karnataka chapter, I'm sure that more good work will be done, and let us all work together for the progress of the people, for the progress of our state, the progress of our country. Thank you very much.
ಧನ್ಯವಾದಗಳು ಸರ್.
Now, we are pleased to invite Shri Ishwar Khandre sir to give his inaugural address.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರಗಳು. ಇಂದಿನ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ವತಿಯಿಂದ ಬೀದರ್ನಲ್ಲಿ 89ನೇ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನದಲ್ಲಿ ನಾವೆಲ್ಲ ಭಾಗವಹಿಸ್ತಾ ಇದ್ದೀವಿ. ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ವಿಶೇಷವಾಗಿ ಕರ್ನಾಟಕ ರಾಜ್ಯದ ಜನಪ್ರಿಯ ಮುಖಂಡರು, ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣ ಇಲಾಖೆಯ ಸಚಿವರು, ನನ್ನ ಆತ್ಮೀಯ ಮಿತ್ರ ಆದಂಥ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಅವರು ಆಗಮಿಸಿದ್ದಾರೆ. ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಮುಖ್ಯ ಅತಿಥಿಗಳಾಗಿ RV ಅಶೋಕನ್ ರವರು ಇದ್ದಾರೆ, ಶಿವಕುಮಾರ್ ಲಕ್ಕೋಲ್ ಅವರು ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಅವರು, ಕಾರ್ಯಕ್ರಮದ ಆಯೋಜಕರಾದಂಥ ಆತ್ಮೀಯರಾದ ಡಾಕ್ಟರ್ ಚಂದ್ರಕಾಂತ್ ಗುದ್ಗೆ ಅವರೇ, ಸಹೋದರಿ ಡಾಕ್ಟರ್ ವಿಜಯಶ್ರೀ ಬಶೆಟ್ಟಿ ಅವರೇ, ಡಾಕ್ಟರ್ ಮಲ್ಲಿಕಾರ್ಜುನ್ ಪಂಚೆಟ್ಟಿ ಅವರೇ, ಇನ್ನೂ ಅನೇಕ ಜನ ಎಲ್ಲ ವೇದಿಕೆ ಮೇಲೆ ಆಸೀನರಾಗಿದ್ದಾರೆ. ನಿಮ್ಮ ಭಾರತೀಯ ನಮ್ಮ ವೈದ್ಯಕೀಯ ಸಂಘದ ಮುಂದಿನ ಪದಾಧಿಕಾರಿಗಳು, ಹಿಂದಿನ ಪದಾಧಿಕಾರಿಗಳು, ಪ್ರೆಸಿಡೆಂಟ್ ಎಲೆಕ್ಟ್ ಇರ್ಬೋದು, ಅಥವಾ ಹಿಂದೆ ಆಗಿ ಹೋಗಿದ್ದವರು, ರಾಜ್ಯ ಮಟ್ಟದವರು, ರಾಷ್ಟ್ರ ಮಟ್ಟದವರು, ಹಾಗೆ ಇಲ್ಲಿ ಎಲ್ಲ ವೈದ್ಯರಿದ್ದೀರಿ, ತಜ್ಞ ವೈದ್ಯರುಗಳಿದ್ದೀರಿ, ವೈದ್ಯಕೀಯ ಸಿಬ್ಬಂದಿಯವರಿದ್ದೀರಿ, ಎಲ್ಲ ಮಾಧ್ಯಮದ ಮಿತ್ರರೇ, ಎಲ್ಲರಿಗೂ ಇವತ್ತಿನ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದ ಹಾರ್ದಿಕ ಅಭಿನಂದನೆ ಮತ್ತು ಶುಭಾಶಯಗಳನ್ನು ಕೋರ್ತಾ ಇದ್ದಾರೆ. ಮೊದಲನೇದಾಗಿ ನಾನು ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣ ಇಲಾಖೆ ಸಚಿವರಾದಂಥ ಮಾನ್ಯ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಅವರಿಗೆ ಜಿಲ್ಲೆ ಪರವಾಗಿ, ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ, ನನ್ನ ಪರವಾಗಿ ಕೃತಜ್ಞತೆಗಳನ್ನು ಸಲ್ಲಿಸಲಿಕ್ಕೆ ಇಚ್ಛೆ ಪಡ್ತೀನಿ. ಏಕೆಂದರೆ ನಿನ್ನೆ ನಾನು ಬೆಂಗಳೂರಿನಲ್ಲಿದ್ದೆ. ಅವರ ಕಾರ್ಯಕ್ರಮ ಬೀದರ್ಗೆ ಬರೋದು ಇರಲಿಲ್ಲ, ಸ್ವಲ್ಪ ದಿವಸದ ಕೆಳಗಡೆ ಬಂದು ಹೋಗಿದ್ರು. ನನಗೆ ಡಾಕ್ಟರ್ ಚಂದ್ರಕಾಂತ್ ಗುದ್ಗೆ ಸಾಹೇಬರು ಫೋನ್ ಮಾಡಿದ್ರು, ನೀವು ಆರೋಗ್ಯ ಸಚಿವರಿಗೆ ಇಲ್ಲಿ ಆಹ್ವಾನ ಮಾಡಬೇಕು, ಬರಲೇಬೇಕು ಅಂತ. ನಾನು ಅವರಿಗೆ ದೂರವಾಣಿ ಮುಖಾಂತರ ಸಂಪರ್ಕ ಮಾಡಿ, ಸರ್ ನೀವು ಬೀದರ್ಗೆ ನಾನು ಮೊನ್ನೆ ಬಂದಿದ್ದೀನಿ ಅಂತ ಹೇಳಿದರು. ಆದರೂ ನಮ್ಮೆಲ್ಲರ ವಿಶೇಷವಾಗಿ ವೈದ್ಯರ ಬೇಡಿಕೆ ಇದೆ, IMA ಪದಾಧಿಕಾರಿಗಳ ಬೇಡಿಕೆ ಇದೆ, ನಿಮ್ಮೆಲ್ಲ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಬದಿಗೊತ್ತಿ ನೀವು ಬರಬೇಕು ಅನ್ನೋಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಇವತ್ತು ಅವರು ನೇರವಾಗಿ ಬೆಂಗಳೂರು ಬೀದರ್ನಿಂದ ಇಲ್ಲಿಗೆ ಆಗಮಿಸಿ ಮತ್ತೆ ಈಗ ರಾತ್ರಿ ಅವರು ಹೈದರಾಬಾದಿಂದ ಹೋಗ್ತಾ ಇದ್ದಾರೆ. ಹೀಗಾಗಿ ಅವರಿಗೆ ಇಷ್ಟೊಂದು ಒತ್ತಡದಲ್ಲಿಯೂ ಅವರ ಅನೇಕ ಕಾರ್ಯಕ್ರಮಗಳಿದ್ದರೂ ಅವೆಲ್ಲವನ್ನು ಬದಿಗೊತ್ತಿ ಇಲ್ಲಿಗೆ ಬಂದಿದ್ದಕ್ಕಾಗಿ ಸ್ವಾಗತ ಮತ್ತು ಧನ್ಯವಾದಗಳನ್ನು ಹೇಳಲಿಕ್ಕೆ ಬಯಸ್ತಾ ಇದ್ದೇನೆ. ಆತ್ಮೀಯ ಬಂಧುಗಳೇ, ಇವತ್ತು ನೀವೆಲ್ಲ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ವತಿಯಿಂದ ಬೀದರ್ನಲ್ಲಿ, ಅದು ಈ ಒಂದು ಗಡಿ ಭಾಗದ ಜಿಲ್ಲೆ, ಇಲ್ಲಿ ನಮ್ಮ ಬೀದರ್ ಘಟಕದ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರು ಮತ್ತು ಪದಾಧಿಕಾರಿಗಳು ತಾವೆಲ್ಲ ಸೇರಿ ರಾಜ್ಯ ಮಟ್ಟದ ಈ ಒಂದು ಸಮ್ಮೇಳನೆಯನ್ನು ಆಯೋಜನೆ ಮಾಡಿದಿರಿ. ಈ ಸಮ್ಮೇಳನದ ಮುಖಾಂತರ ನಮ್ಮ ಭಾರತದಲ್ಲಿ ಆರೋಗ್ಯದ ವ್ಯವಸ್ಥೆಯನ್ನು ಯಾವ ರೀತಿಯಲ್ಲಿ ನಾವು ಬಲಪಡಿಸಬೇಕಾಗಿದೆ, ಭಾರತದಲ್ಲಿ, ನಮ್ಮ ದೇಶದಲ್ಲಿ, ರಾಜ್ಯದಲ್ಲಿ, ನಮ್ಮ ಜಿಲ್ಲೆಯಲ್ಲಿ, ವಿಶೇಷವಾಗಿ ಭವಿಷ್ಯದಲ್ಲಿ ಈ ಒಂದು ವೈದ್ಯಕೀಯ ವ್ಯವಸ್ಥೆ ಯಾವ ರೀತಿಯಲ್ಲಿ ಇರಬೇಕಾಗಿದೆ ಅಂತೇಳಿ ಈ ಸಮ್ಮೇಳನದಲ್ಲಿ ನೀವೆಲ್ಲ ಚರ್ಚೆ ಮಾಡಿದ್ದೀರಿ ಅಂತೇಳಿ ನನಗೆ ಮಾಹಿತಿ ಇದೆ. ಈ ವೇದಿಕೆ ಮೇಲೆ ಈಗಾಗಲೇ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ನವರು ಮಾತಾಡಿದ್ದಾರೆ, ಚಿಂತನ ಮಂಥನ ಬಹಳಷ್ಟು ನಡೆದಿದೆ. ಹೀಗಾಗಿ ಇವತ್ತು ನಮ್ಮಲ್ಲಿರುವಂಥ ಏನು ಆರೋಗ್ಯ ರಕ್ಷಣೆಗಳಲ್ಲಿ ಯಾವ ರೀತಿಯಲ್ಲಿ ನಾವೀನ್ಯತೆಗಳಿದ್ದಾವೆ, ಈಗಾಗಲೇ ಹೇಳಿದ್ರಿ ಟೆಲಿಮೆಡಿಸಿನ್ ಬಂದಿದೆ, ಈಗ ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟೆಲಿಜೆನ್ಸ್ ಮುಖಾಂತರ ಚಿಕಿತ್ಸೆ ಕೊಡುವಂಥದ್ದು, ಅನೇಕ ರೀತಿಯಲ್ಲಿ ಇವತ್ತು ಹೊಸ ಹೊಸ ಆವಿಷ್ಕಾರಗಳಾಗ್ತಾ ಇದೆ. ಇವೆಲ್ಲದರ ಬಗ್ಗೆ ಈ ಒಂದು ಸಮ್ಮೇಳನದಲ್ಲಿ ಚರ್ಚೆ ನಡೀತಾ ಇದೆ. ಇಂಥ ಒಂದು ಸಮ್ಮೇಳನದಲ್ಲಿ ಉದ್ಘಾಟನೆ ಮಾಡಲಿಕ್ಕೆ, ಭಾಗವಹಿಸಲಿಕ್ಕೆ ಭಾಳ ಸಂತೋಷ ಆಗಿದೆ. ಅದಕ್ಕೆ ನಾನು ಪ್ರಥಮವಾಗಿ ಸಮ್ಮೇಳನ ಆಯೋಜನೆ ಮಾಡಿದಂಥ ಎಲ್ಲರಿಗೂ, ಎಲ್ಲ ಆಯೋಜಕರಿಗೂ ಮತ್ತೊಮ್ಮೆ ನನ್ನ ವತಿಯಿಂದ, ನಮ್ಮ ಸರ್ಕಾರದ ವತಿಯಿಂದ ಹಾರ್ದಿಕ ಅಭಿನಂದನೆ ಮತ್ತು ಧನ್ಯವಾದಗಳನ್ನು ಸಲ್ಲಿಸ್ತಾ ಇದ್ದೇನೆ. ಆತ್ಮೀಯರೇ, ವೈದ್ಯ ವೃತ್ತಿ ಅತ್ಯಂತ ಪವಿತ್ರವಾದಂಥ ಒಂದು ವೃತ್ತಿ. ಇವತ್ತು ವೈದ್ಯೋ ನಾರಾಯಣೋ ಹರಿ ಅಂತ ಹೇಳ್ತಾರೆ. ವೈದ್ಯರಿಗೆ ದೇವರ ಸಮಾನ ಅಂತೇಳಿ ನಾವೆಲ್ಲ ಅಂದರೆ ಹೇಳ್ಕೊತಾ ಬಂದಿದ್ದೀವಿ. ಅದು ಸತ್ಯನೂ ಇದೆ. ಯಾಕೆಂತೇಳಿದರೆ ರೋಗ ಬಂದ ಮೇಲೆ ರೋಗಿ ಆಸ್ಪತ್ರೆಗೆ ಬರ್ತಾನೆ. ಆಸ್ಪತ್ರೆಗೆ ಬಂದಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಯಮರಾಜ ಬಂದು ನೀನು ಕರ್ಕೊಂಡು ಹೋಗ್ತೀನಿ ಅಂತ ಹೇಳಿದಂಥ ಸಮಯದಲ್ಲಿ ಯಾರಾದರೂ ಅವನದನ್ನು ತಡಿಲಿಕ್ಕೆ, ಅವನ ಜೀವ ಇವತ್ತು ಮತ್ತೆ ಮರುಜೀವ ಕೊಡಲಿಕ್ಕೆ ಯಾರಿಗಾದರೂ ಸಾಧ್ಯ ಇದ್ದರೆ ಅದು ವೈದ್ಯರಿಗೆ ಮಾತ್ರ ಸಾಧ್ಯ ಇದೆ, ಬೇರೆ ಯಾರಿಗೂ ಸಾಧ್ಯ ಇಲ್ಲ. ಹೀಗಾಗಿ ಇವತ್ತು ವಿಶೇಷವಾಗಿ ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಇವತ್ತು ಮೊನ್ನೆ ಏನು ನಮ್ಮ ಇಡೀ ದೇಶ ಅಷ್ಟೇ ಅಲ್ಲ, ಇಡೀ ಜಗತ್ತೇ ಕೋವಿಡ್-19ನಿಂದ ಭಾಳ ದೊಡ್ಡ ಮಟ್ಟದಲ್ಲಿ ತಲ್ಲಣಗೊಂಡಿತ್ತು. ಒಂದು ದೊಡ್ಡ ಮಟ್ಟದಲ್ಲಿ ಒಂದು ಭಯ ವಾತಾವರಣ. ಅಂಥ ಒಂದು ಸಂದರ್ಭದಲ್ಲಿ ನಾವೆಲ್ಲ ನೋಡಿದ್ದೀವಿ, ಯಾವುದೇ ವ್ಯಾಕ್ಸಿನೇಷನ್ ಇರಲಿಲ್ಲ. ಈ ರೋಗ ಬರ್ತದೆ, ಮಾಸ್ಕ್ ಹಾಕ್ಕೋಬೇಕು, ಇವತ್ತು ಎಲ್ಲರೂ ಬೇರೆ ಬೇರೆ ಇರಬೇಕು ಅಂತೇಳಿ ಹೇಳಿ ಕನಸಿನಲ್ಲಿ ಯಾರೂ ಊಹೆ ಮಾಡಿರಲಿಲ್ಲ. ಅಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಎಲ್ಲ ರೋಗಗಳಿಗೆ ಜೀವದ ಹಂಗನ್ನು ತೊರೆದು ನಿಜವಾಗಿಯೂ ಕೋವಿಡ್ ಯೋಧರಂತೆ ಇವತ್ತು ಅನೇಕ ಜನ ವೈದ್ಯರು, ವೈದ್ಯಕೀಯ ಸಿಬ್ಬಂದಿಯವರು ಇವತ್ತು ಅವರಿಗೆ ಚಿಕಿತ್ಸೆಯನ್ನು ಕೊಟ್ಟು ಲಕ್ಷಾಂತರ ಜನರ ಜೀವ ಉಳಿಸಿದಂಥ ಕೀರ್ತಿ ಇವತ್ತು ಯಾರಿಗಾದರೂ ಸಲ್ತದೆ ಅಂತ ಹೇಳಿದ್ರೆ ವೈದ್ಯರಿಗೆ ಸಲ್ತದೆ. ನಾವು ನೋಡಿದ್ದೀವಿ ಬಹಳಷ್ಟು ಕಷ್ಟ. ಅನೇಕ ಜನ ವೈದ್ಯರು ಹುತಾತ್ಮರಾಗಿದ್ದಾರೆ, ಅಂದರೆ ಅವರು ತಮ್ಮ ಜೀವನ್ನೇ ಕಳ್ಕೊಂಡಿದ್ದಾರೆ ಈ ಒಂದು ಕೋವಿಡ್ ಸಂದರ್ಭದಲ್ಲಿ. ಅಂಥ ಒಂದು ಕಷ್ಟ ನಾವೆಲ್ಲ ನೋಡಿದ್ದೀವಿ. ಹೀಗಾಗಿ ಇವತ್ತಿನ ದಿನಮಾನಗಳಲ್ಲಿ ನಾವು ನೋಡಿದ್ದೀವಿ. ಈಗ ನೀವು ಬೀದರ್ನಲ್ಲಿ ಈ ಒಂದು ಸಮ್ಮೇಳನ ಮಾಡ್ತಾ ಇದ್ದೀರಿ. ಇವತ್ತು ದಿನೇ ದಿನೇ ರೋಗಗಳು ಜಾಸ್ತಿ ಆಗ್ತಾ ಇದೆ. ಯಾಕೆ? ಸಂಶೋಧನೆಯೂ ಬರ್ತಾ ಇದೆ, ಆವಿಷ್ಕಾರಗಳು ಮಾಡ್ತಾ ಇದ್ದೇವೆ. ಆವಿಷ್ಕಾರಗಳು ನಾವು ಎಷ್ಟೇ ಮಾಡಿದ್ರು ಇವತ್ತು ರೋಗನೂ ಹೊಸದು ಬಂದು ಅಂತ ಹೇಳಿದ್ರೆ ಅದಕ್ಕೆ ಯಾವುದೇ ಚಿಕಿತ್ಸೆ ಇಲ್ಲ, ವ್ಯಾಕ್ಸಿನೇಷನ್ ಇಲ್ಲ, ಇಂಥವು ಸಮಸ್ಯೆಗಳು ಬರ್ತದೆ. ಅದಕ್ಕೆ ರೋಗ ಬಂದ ಮೇಲೆ ಚಿಕಿತ್ಸೆ ಪಡೋದಕ್ಕಿಂತ ನಾವು ರೋಗವೇ ಬರದಂತೆ ತಡೆಗಟ್ಟೋದು ಬಹಳ ಅವಶ್ಯಕತೆ ಇದೆ. ಪ್ರಿವೆನ್ಷನ್ ಇಸ್ ಬೆಟರ್ ದೆನ್ ಕ್ಯೂರ್ ಅಂತ ಹೇಳ್ತೀವಿ. ರೋಗವೇ ಬರದಂತೆ ತಡೆಗಟ್ಟಬೇಕು ಅಂದರೆ ಏನು ಮಾಡಬೇಕು? ಬಹಳಷ್ಟು ಮಟ್ಟದಲ್ಲಿ ನಾವು ಜಾಗೃತಿ ಮೂಡಿಸ್ಬೇಕಾಗ್ತದೆ, ನಾವು ಅರಿವು ಮೂಡಿಸ್ಬೇಕಾಗ್ತದೆ. ಯಾಕೆ ರೋಗಗಳು ಬರ್ತಾ ಇದೆ? ಒಂದು ಈ ಆಧುನಿಕ ಒಂದು ಯುಗದಲ್ಲಿ ಮನುಷ್ಯ ಯಂತ್ರದಂತೆ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದ. ನಾವೆಲ್ಲ ಒತ್ತಡದಲ್ಲಿ ಜೀವನ ಮಾಡ್ತಾ ಇದ್ವಿ. ಈಗಾಗಲೇ ಹೇಳಿದ್ರು ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಅವರು, ಇವತ್ತು ಸರಿ ಸಮಾನ ನಮ್ದು ಆಯುಷ್ಯ 70 ವರ್ಷ ಇದೆ ಭಾರತದಲ್ಲಿ, ಅಮೇರಿಕದಲ್ಲಿ 78 ವರ್ಷ ಇದೆ. ಆದರೆ ವೈದ್ಯರ ನನಗೂ ಗೊತ್ತಿರಲಿಲ್ಲ, ಈಗ ಮಾಹಿತಿ ಬಂತು, ವೈದ್ಯರ ವಯಸ್ಸು ಸರಾಸರಿ 60 ಇದೆ ಅಂತ. ಯಾಕೆ? ಆಲೋಚನೆ ಮಾಡಬೇಕಾಗ್ತದೆ. ಭಾಳ ಸ್ಟ್ರೆಸ್ ಇದ್ದೀರಿ ಅಂತ, ಭಾಳ ಒತ್ತಡದಲ್ಲಿ ನೀವು ನಿಮ್ಮ ವೃತ್ತಿ ಮಾಡ್ತಾ ಇದ್ದೀರಿ ಅಂತ ಇದರ ಅರ್ಥ. ಹೀಗಾಗಿ ಒತ್ತಡದ ಜೀವನ ನಿವಾರಣೆ ಮಾಡಲಿಕ್ಕೆ ನಾವು ಏನು ಮಾಡಬೇಕಾಗಿದೆ? ನಮ್ಮ ಯುವಕರು ಇವತ್ತೆಲ್ಲರೂ ನೋಡ್ತಾ ಇದ್ದಾರೆ, ಇಡೀ ಜಗತ್ತು ಭಾರತ ದೇಶದ ಕಡೆ ನೋಡ್ತಾ ಇದೆ. ಎಲ್ಲಕ್ಕಿಂತ ಹೆಚ್ಚಿನ ಒಂದು ಯುವಶಕ್ತಿ ಇದ್ರೆ ಅಣುಶಕ್ತಿ ಇದ್ದ ಹಾಗೆ ಭಾರತ ದೇಶದಲ್ಲಿದ್ದಾರೆ. ಸುಮಾರು 65% ಜನ 35 ವರ್ಷಕ್ಕಿಂತ ಕೆಳಗಡೆ ಇದ್ದಂಥವ್ರು ಇದ್ದಾರೆ. ಅಂತ ಒಂದು ಬಲಾಢ್ಯವಾದಂಥ ಯುವಶಕ್ತಿ ಇವತ್ತೇನು ಮಾನವ ಸಂಪನ್ಮೂಲ ಇದೆ, ವೈದ್ಯರಿದ್ದಾರೆ, ಇಂಜಿನಿಯರ್ ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ ಇದ್ದಾರೆ, ಪರಿಣಿತರಿದ್ದಾರೆ. ಇವತ್ತು ಅವರೆಲ್ಲ ದೇಶ ವಿದೇಶಗಳಲ್ಲಿ ದೊಡ್ಡ ದೊಡ್ಡ ಸ್ಥಾನದಲ್ಲಿದ್ದಾರೆ. ಅವ್ರಿಗೆ ವಾಪಸ್ ಕರೆಸ್ಕೊಂಡ್ರೆ ಆ ದೇಶದ ವ್ಯವಸ್ಥೆನೇ ಹಾಳಾಗಿ ಹೋಗ್ತದೆ. ಹೀಗಾಗಿ ಭಾರತ ದೇಶಕ್ಕೆ ಅಷ್ಟೊಂದು ಇವತ್ತು ಆ ರೀತಿಯಲ್ಲಿ ಅದಕ್ಕೆ ಗೌರವ ಇದೆ. ಹೀಗಾಗಿ ಆ ಯುವ ಶಕ್ತಿ ಏನಾದರೂ ಎಲ್ಲ ರೋಗಗ್ರಸ್ತ ಆದರೆ ಆರೋಗ್ಯವಂತವಾಗಿರ್ಬೇಕಲ್ಲ. ಹೇಳ್ತೀವಿ, ಹೇಳಿಕೆ ಇದೆ, ಆರೋಗ್ಯವೇ ಭಾಗ್ಯ ಅಂತೇಳಿ ಹೇಳಿ. ಆದರೆ ಆರೋಗ್ಯದ ಬಗ್ಗೆ ಆಲೋಚನೆ ಮಾಡುವಂಥದ್ದು, ನಮ್ಮ ಜೀವನದ ಪದ್ಧತಿ ಬಗ್ಗೆ ಜನರಿಗೆ ಅರಿವು ಮೂಡಿಸ್ಬೇಕಾಗ್ತದೆ. ಇವತ್ತು ನಮ್ಮ ಆಹಾರದ ಪದ್ಧತಿ ಬಗ್ಗೆ ಜನರಿಗೆ ಅರಿವು ಮೂಡಿಸ್ಬೇಕಾಗ್ತದೆ. ಒಂದೊಂದು ಕಡೆ ಒಂದೊಂದು ತರಹದ ರೋಗಗಳಿದ್ದಾವೆ, ಅದ್ರ ಬಗ್ಗೆನೂ ಸಂಶೋಧನೆ ಆಗಬೇಕು, ಅದ್ರ ಬಗ್ಗೆನೂ ಜನರಿಗೆ ತಿಳುವಳಿಕೆ ಹೇಳುವಂಥ ಕೆಲಸ ಇವತ್ತು IMAದವರು ಮಾಡುವಂಥದ್ದು ಅವಶ್ಯಕತೆ ಇದೆ ಅಂತ ನಾನು ಹೇಳಲಿಕ್ಕೆ ಬಯಸ್ತಾ ಇದ್ದೇನೆ. ಯಾಕೆ ಅಂತ ಹೇಳಿದರೆ, ಇವತ್ತು ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ, ಕೋವಿಡ್ ಬಂದ ಮೇಲೆ ಹೃದಯಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಂಥ ಏನು ಕಾಯಿಲೆಗಳು ಬರ್ತಾ ಇದೆ. ಇವತ್ತು ಮೊನ್ನೆ ಪತ್ರಿಕೆಯಲ್ಲಿ ಓದಿದೆ ನಾನು, ಅಹಮದಾಬಾದ್ನಲ್ಲಿ ಈ ದಸರಾ ನಿಮಿತ್ತ ಈ ಗರ್ಬಾ ಡ್ಯಾನ್ಸ್ ಮಾಡ್ತಾರಲ್ಲ, ಆ ಗರ್ಬಾ ಡ್ಯಾನ್ಸ್ ಮಾಡುವಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಸುಮಾರು 28 ಜನ ಮೃತಪಟ್ಟಿದ್ದಾರೆ. ಯಾರು? ಯುವಕರು, 20 ವರ್ಷದವರು, 28 ವರ್ಷದವರು, 40 ವರ್ಷದವರು ಇವತ್ತು ಆ ರಾಜ್ಯದಲ್ಲಿ ಮೃತಪಟ್ಟಿದ್ದಾರೆ ಅಂತ ಹೇಳಿದರೆ ಇದು ಆಫ್ಟರ್ ಕೋವಿಡ್ ಎಫೆಕ್ಟ್ ಅಂತ ಹೇಳಿ ಗೊತ್ತಿಲ್ಲ ನನಗೆ, ನಾನೇನು ವೈದ್ಯನಲ್ಲ, ನಮ್ಮ ಪರಿವಾರದವ್ರು ಭಾಳ ಜನ ವೈದ್ಯರಿದ್ದಾರೆ. ಆದರೆ ಇವತ್ತು ಅರ್ಥ ಏನು ಅಂತ ಹೇಳಿದರೆ, ಯಾವ ರೀತಿಯಲ್ಲಿ ಹಿಂದೆ ಒಂದಾನೊಂದು ಕಾಲದಲ್ಲಿ 40-50 ವರ್ಷ ತನಕ ಯಾರಿಗೂ ಹೃದಯ ಸಂಬಂಧಪಟ್ಟಂಥ ರೋಗಗಳು ಬರೋದಿಲ್ಲ ಅಂತ ಹೇಳಿದರು, ಈಗ ಬರ್ತಾ ಇದೆ ಅಂತ ಹೇಳಿದರೆ ಅದ್ರ ಬಗ್ಗೆ ಇವತ್ತು ಸಂಶೋಧನೆ ಮಾಡಬೇಕಲ್ಲ. ಆ ರೀತಿಯಲ್ಲಿ ಇವತ್ತೇನು ನಡೀತಾ ಇದೆ ನಾವು ನೋಡ್ತಾ ಇದ್ದೇವೆ. ಮಕ್ಕಳ ಬಗ್ಗೆ ಈಗಾಗಲೇ ಮಾನ್ಯ ಡಾಕ್ಟರ್ ಗುದ್ಗೆ ಸಾಹೇಬ್ರು ಹೇಳಿದರು, ಬೆಳಗ್ಗೆ ಮಕ್ಕಳ ರೋಗದ ಬಗ್ಗೆ ಅರಿವು ಮೂಡಿಸುವಂಥ ಒಂದು ಕೆಲಸ ಭಾಳ ಚೆನ್ನಾಗಿ ಇಲ್ಲಿ ನಡೀತಾ ಇದೆ. ನಾವೆಲ್ಲ ಶಾಲೆಗಳಿಗೆ ಹೋಗ್ತೀವಿ, ಸಣ್ಣ ಸಣ್ಣ ಮಕ್ಕಳಲ್ಲಿ BP ಇದೆ, ಸಣ್ಣ ಮಕ್ಕಳಲ್ಲಿ ಶುಗರ್ ಇದೆ, ಹೃದಯ ಕಾಯಿಲೆ ಇದೆ, ಕಿಡ್ನಿ ಕಾಯಿಲೆ ಇದೆ, ರಂಧ್ರ ಇದೆ ಅಂತ ಹೇಳ್ತಾರೆ. ಇವತ್ತು ಅನೇಕ ಜನ ಬುದ್ಧಿಮಾಂದ್ಯರಾಗಿ ಹುಟ್ಟುತ್ತಾ ಇದ್ದಾರೆ, ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಇದೆಲ್ಲ ತಡೆಗಟ್ಟಲಿಕ್ಕೆ ಏನು ಮಾಡ್ತಾ ಇದ್ದೀವಿ? ನಮ್ಮ ಭಾಗದಲ್ಲಿ ವಿಶೇಷವಾಗಿ ಅಪೌಷ್ಟಿಕತೆ, ಸ್ಟಂಟಿಂಗ್ ಇದೆ ಭಾಳಷ್ಟು, ಅವ್ರ ಬೆಳವಣಿಗೆನೇ ಇಲ್ಲ ಮಕ್ಕಳದು ನೋಡಿದರೆ. ಆ ರೀತಿಯಲ್ಲಿ ಇವತ್ತು ಯಾವ ರೀತಿಯಲ್ಲಿ ಎಷ್ಟು ಮಟ್ಟಿಗೆ ಅಪೌಷ್ಟಿಕತೆ ಇದೆ, ಆ ಪೌಷ್ಟಿಕಾಂಶದ ಆಹಾರ ಕೊಡಲಿಕ್ಕೆ ನಾವು ಏನು ಮಾಡಬೇಕಾಗಿದೆ? ಈ ಭಾಗದಲ್ಲಿ ಕೆಲವೊಂದು ಜನರಿಗೆ ವಿಟಮಿನ್ D ಕಡಿಮೆ ಇದ್ದರೆ, ಕೆಲವೊಂದು ಜನರಿಗೆ B12 ಕಡಿಮೆ ಇದೆ. ಇದು ಯಾಕಿದೆ ಅಂತಲೂ ಭಾಳಷ್ಟು ಜನರಿಗೆ ಮಾಹಿತಿ ಇಲ್ಲ. ಹೀಗಾಗಿ ಇಂಥದ್ರಲ್ಲಿ ಆರೋಗ್ಯವಂತ ಸಮಾಜ ನಿರ್ಮಾಣ ಆಗಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ಪ್ರತಿಯೊಬ್ಬರೂ ರೋಗರಹಿತವಾಗಿರಬೇಕು. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಇವತ್ತು ಹೆಚ್ಚಿನ ಸಂಶೋಧನೆ ಮಾಡುವಂಥದ್ದು ಬಹಳ ಅವಶ್ಯಕತೆ ಇದೆ ಅಂತೇಳಿ ನಾನು ಭಾವಿಸಿದ್ದೇನೆ. ಇವತ್ತು ಅದರ ಜೊತೆಯಲ್ಲಿ ಆರೋಗ್ಯ ರಕ್ಷಣೆಯಲ್ಲಿ ನಾವೀನ್ಯತೆಗಳು ನೀವೆಲ್ಲ ಚರ್ಚೆ ಮಾಡಿದಿರಿ. IMAದವರು ಪದಾಧಿಕಾರಿಗಳು ಇಲ್ಲಿದ್ದಾರೆ. ಇವತ್ತು ತಂತ್ರಜ್ಞಾನ ವಿಜ್ಞಾನ ಬಹಳ ಮುಂದುವರೆದಿದೆ. ಎಲ್ಲ ಕಡೆ ನೆಟ್ ವ್ಯವಸ್ಥೆ ಇದೆ, ಇಂಟರ್ನೆಟ್ ಇದೆ, ಗ್ರಾಮ ಪಂಚಾಯತಿಗಳೂ ಇದೆ, ಹಳ್ಳಿಗಳಲ್ಲೂ ಇದೆ. ಎಲ್ಲ ಗ್ರಾಮ ಪಂಚಾಯತಿಗಳು ಇವತ್ತಿನ ದಿವಸ ಈ ಇಂಟರ್ನೆಟ್ ಮುಖಾಂತರ ತಮ್ಮ ಕೆಲಸ ಕಾರ್ಯವನ್ನು ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಇಂಥದರಲ್ಲಿ ಟೆಲಿಮೆಡಿಸಿನ್ ಏನೀಗ ನೀವು ಪ್ರಾರಂಭ ಮಾಡಿದಿರಿ. ಈ ಟೆಲಿಮೆಡಿಸಿನ್ ಮುಖಾಂತರ ಎಲ್ಲಿ ಹಳ್ಳಿಗಳಿದ್ದಾವೆ, ಗಡಿ ಭಾಗದಲ್ಲಿದ್ದಾವೆ, ಅತ್ಯಂತ ಅಲ್ಲಿ ಯಾವುದೇ ರೀತಿಯ ಸೌಕರ್ಯ ಇಲ್ಲ ಅಂತ ಹೇಳಿದರೆ ಇವತ್ತು ಅವರಿಗೆ ನಾವೆಲ್ಲ ಸೇರಿ ಒಂದು ಟೆಲಿಮೆಡಿಸಿನ್ ಮುಖಾಂತರ ಅವರಿಗೆ ಚಿಕಿತ್ಸೆ ಕೊಡುವಂಥದ್ದು ನಾವು ವ್ಯವಸ್ಥೆ ಮಾಡಿದೀವಿ ಅಂತ ಹೇಳಿದರೆ, ಇವತ್ತೇನು ಕ್ವ್ಯಾಕ್ ಡಾಕ್ಟರ್ಸ್ ಇದ್ದಾರೆ, ಇವತ್ತು ನಮ್ಮವರೆಲ್ಲ ಹೋಗಿ ಇವತ್ತು ಸ್ನೇಕ್ ಬೈಟ್ ಆಯಿತು ಅಂತ ಹೇಳಿದರೆ ಅವ್ರು ನೇರವಾಗಿ ಸರ್ಕಾರಿ ಆಸ್ಪತ್ರೆಗೆ ಬರೋದಿಲ್ಲ. ಸ್ನೇಕ್ ವೆನಮ್ ನಾವು ಇಕ್ತೀವಿ. ನಾವು ಇಕ್ಕಿದ್ರು ಪ್ರತಿಯೊಂದು ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರದಲ್ಲಿದೆ, ಸಮುದಾಯ ಆರೋಗ್ಯ ಕೇಂದ್ರದಲ್ಲಿದೆ, ತಾಲೂಕು ಆರೋಗ್ಯ ಕೇಂದ್ರದಲ್ಲಿದೆ. ಆದರೂ ಅವರು ಬೇರೆ ಕಡೆ ಮಾಟ ಮಂತ್ರ ಕಡೆ ಹೋಗ್ಬಿಡ್ತಾರೆ, ವಿಳಂಬವಾಗಿ ಬರ್ತಾರೆ, ಜೀವ ಕಳ್ಕೊಂಡು ಬಿಡ್ತಾರೆ. ಜಿಲ್ಲೆಯಲ್ಲಿ ಸುಮಾರು ಎಷ್ಟು 50, 60, 100, 200 ತನಕ ಸ್ನೇಕ್ ಬೈಟ್ ಡೆತ್ಸ್ ನಮ್ಮ ಜಿಲ್ಲೆಯಲ್ಲಿ ಆಗ್ತವೆ. ಹೀಗಾಗಿ ಇದೆಲ್ಲವನ್ನು ತಡಿಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ಈ ಟೆಲಿಮೆಡಿಸಿನ್ ಏನಿದೆ, ಈ ಟೆಲಿಮೆಡಿಸಿನ್ ಮುಖಾಂತರ ಅನೇಕ ಜನರ ಜೀವನ ಉಳಿಸುವಂಥ ಒಂದು ಕೆಲಸ ನಾವು ಮಾಡಬಹುದಾಗಿದೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ IMAದವರು ಕಾರ್ಯೋನ್ಮುಖರಾಗಬೇಕು ಎಲ್ಲ ಕಡೆ. ಸರ್ಕಾರನೂ ಅದಕ್ಕೆ ಇವತ್ತು ಮಾನ್ಯ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ಜಿ ಅವರು ಇದ್ದಾರೆ, ಅವರು ಅದಕ್ಕೆ ಪೂರಕವಾಗಿ ಸಂಪೂರ್ಣವಾದಂಥ ನಮ್ಮ ಸರ್ಕಾರ ಬೆಂಬಲ ಸಹಕಾರ ಕೊಡ್ತದೆ ಅನ್ನುವಂಥ ಮಾತನ್ನು ಹೇಳಲಿಕ್ಕೆ ಬಯಸ್ತಾ ಇದ್ದೀನಿ. ಇದಕ್ಕೆ ಆತ್ಮೀಯ ಬಂಧುಗಳೇ, ಇವತ್ತು ಆರೋಗ್ಯದ ವ್ಯವಸ್ಥೆಯಲ್ಲಿ ಇನ್ನು ಹೆಚ್ಚಿನ ರೀತಿಯಲ್ಲಿ ಏನೊಂದು ಕಂದಕ ಇದೆ, ಏನೊಂದು ಗ್ಯಾಪ್ ಇದೆ. ಈ ಗ್ಯಾಪ್ ಎಲ್ಲಿದೆ? ಗ್ಯಾಪ್ ಎಲ್ಲಿದೆ ಅಂತ ಹೇಳಿದ್ರೆ, ಎಲ್ಲಿ ಬೆಂಗಳೂರಿನಲ್ಲಿ ಸಿಕ್ಕಂಥ ಚಿಕಿತ್ಸೆ ಇವತ್ತು ಕಲಬುರಗಿಯಲ್ಲಿ ಸಿಗೋದಿಲ್ಲ, ಕಲಬುರಗಿಯಲ್ಲಿ ಸಿಕ್ಕಂಥ ಚಿಕಿತ್ಸೆ ಇವತ್ತು ಬೀದರ್ನಲ್ಲಿ ಸಿಗೋದಿಲ್ಲ, ಬೀದರ್ನಲ್ಲಿ ಸಿಕ್ಕಂಥ ಚಿಕಿತ್ಸೆ ಭಾಲ್ಕಿಯಲ್ಲಿ ಸಿಗೋದಿಲ್ಲ, ಭಾಲ್ಕಿಯಲ್ಲಿ ಸಿಕ್ಕಂಥ ಚಿಕಿತ್ಸೆ ಹಳ್ಳಿಗಳಲ್ಲಿ ಸಿಗೋದಿಲ್ಲ. ನಾವು ನೋಡ್ತಾ ಇದ್ದೀವಿ. ಇದೊಂದು ಗ್ಯಾಪ್. ಈ ಗ್ಯಾಪ್ ಹೆಂಗೆ ನಿವಾರಣೆ ಮಾಡಬೇಕು? ಸರ್ಕಾರ ಅನೇಕ ಕಾರ್ಯಕ್ರಮಗಳು ಮಾಡ್ತಾ ಇದೆ. ಇಲ್ಲಿದ್ದಂಥ ತಜ್ಞ ವೈದ್ಯರಿದ್ದವರಿಗೆ ಕಂಪಲ್ಸರಿಯಲ್ಲಿ ಹಾಕಬೇಕು ಅಂತ ಮೊನ್ನೆ ಚರ್ಚೆ ಮಾಡಿದಾಗ ಗೊತ್ತಾಯಿತು. ದಿನೇಶ್ ಅವರಿದ್ದರು, ಮಾನ್ಯ ಮುಖ್ಯಮಂತ್ರಿಯವರಿದ್ದರು. ಈಗ ಎಷ್ಟು ಜನ ತಜ್ಞ ವೈದ್ಯರು ಈಗ ನಮ್ಮಲ್ಲಿ ಪ್ರೊಡ್ಯೂಸ್ ಆಗ್ತಾ ಇದ್ದಾರೆ ಅಂತ ಹೇಳಿದರೆ, ನಮ್ಮಲ್ಲಿ ಖಾಲಿ ಇರುವಕ್ಕಿಂತ ಜಾಸ್ತಿ ಇದ್ದಾರೆ. ಕಂಪಲ್ಸರಿ ಅವರಿಗೆ ಗ್ರಾಮೀಣ ಭಾಗದಲ್ಲಿ ಸೇವೆ ಮಾಡಲೇಬೇಕು ಅಂತೇಳಿ ನನ್ನ ಕಾಯ್ದೆ ಆಗಿದೆ. ಆ ಕಾಯ್ದೆಯಲ್ಲಿ ತಿದ್ದುಪಡಿ ಮಾಡಿ ಇವತ್ತು ಎಷ್ಟು ಖಾಲಿ ಇದೆ ಅಷ್ಟಕ್ಕೆ ಮಾತ್ರ ಸೀಮಿತವಾಗಿ ಕೊಡಬೇಕು ಅನ್ನೋಂಥದ್ದಾಗಿದೆ. ಅಂದರೆ ತಜ್ಞ ವೈದ್ಯರ ಕೊರತೆ ಕರ್ನಾಟಕ ರಾಜ್ಯದಲ್ಲಂತೂ ಆಗೋದಿಲ್ಲ. ಇಂಥದ್ರಲ್ಲಿ ಅಲ್ಲಿ ಏನು ಇಕ್ವಿಪ್ಮೆಂಟ್ಸ್ ಬೇಕಾಗಿದೆ, ಸಲಕರಣೆಗಳು ಬೇಕಾಗಿದೆ, ಏನು ವ್ಯವಸ್ಥೆ ಮಾಡಬೇಕಾಗಿದೆ, ಅವೆಲ್ಲ ವ್ಯವಸ್ಥೆ ಇವತ್ತು ANM ಸೆಂಟರ್ ಇಟ್ಕೊಂಡು, ಪ್ರಾಥಮಿಕ ಆರೋಗ್ಯ ಕೇಂದ್ರ ಇಟ್ಕೊಂಡು ಎಲ್ಲ ಕಡೆ ಇವತ್ತು ನಾವು ಮಾಡ್ಕೊತ ಬಂದು ತಾಲೂಕು ಮಟ್ಟದಲ್ಲಿ ಟ್ರಾಮಾ ಸೆಂಟರ್ಸ್ ಮಾಡಿ, ಅಥವಾ ಜಿಲ್ಲಾ ಮಟ್ಟದಲ್ಲಿ ಎಲ್ಲೋ ಹೈದರಾಬಾದ್ಗಾಗಲಿ, ಬಾಂಬೆಗಾಗಲಿ, ಶೋಲಾಪುರ್ಗಾಗಲಿ ಬೇರೆ ಕಡೆ ಹೋಗದ ರೀತಿಯಲ್ಲಿ ಇವತ್ತು ಕ್ವಿಕ್ ರೆಸ್ಪಾನ್ಸ್ ಏನಿದೆ ಅಲ್ಲ, ಇವತ್ತು ಜೀವ ಉಳಿಬೇಕು ಅಂತ ಹೇಳಿದ್ರೆ ತಕ್ಷಣವೇ ಇವತ್ತು ಆ ರೋಗಿಗೆ ನೀವು ಸ್ಪಂದನೆ ಮಾಡಿದರೆ, ಈಗ ಅದೃಷ್ಟವಶಾತ್ ಸುಮಾರು ಜನ ಕಾರ್ಡಿಯಾಲಜಿಸ್ಟ್ ಬಂದಿದ್ದಾರೆ ಈಗ ಬೀದರ್ನಲ್ಲಿ. ಹೀಗಾಗಿ ಅವರೆಲ್ಲ ಹೃದಯ ತಜ್ಞರು ಬಂದಿದ್ದ ಕಾರಣ ಅನೇಕ ಜನರ ಜೀವ ಉಳಿತಾ ಇದೆ. ಕಲಬುರಗಿಯಲ್ಲಿ ಈಗ ಜಯದೇವ ಮಾಡಿದ್ದೀವಿ. ಆ ಜಯದೇವ ಮಾಡಿದ್ದಕ್ಕಾಗೂ ಸುಮಾರು ಬಡವರೆಲ್ಲರೂ ಹೋಗಿ ಚಿಕಿತ್ಸೆ ಪಡೆಯುವಂಥ ಒಂದು ವ್ಯವಸ್ಥೆ ಆಗಿದೆ. ಅನೇಕ ಇವತ್ತು ಯೋಜನೆಗಳಿದ್ದಾವೆ. ಇವತ್ತು ಯಶಸ್ವಿನಿ ಯೋಜನೆ ಇಟ್ಕೊಂಡು ಸುಮಾರು ಇವತ್ತು ಕರ್ನಾಟಕ ಆರೋಗ್ಯ ರಕ್ಷಾ ಯೋಜನೆ, ಇಂಥ ಅನೇಕ ಯೋಜನೆಗಳು ಇವತ್ತು ಸರ್ಕಾರಿ ನೌಕರಿಗೂ ಇದೆ. ಇವೆಲ್ಲವನ್ನು ಬಳಸ್ಕೊಂಡು ಇದರ ಜೊತೆಯಲ್ಲಿ ಇವತ್ತು ಆರೋಗ್ಯದಲ್ಲಿ ಏನು ಪರಿಸರ ಇದೆ, ಪ್ರಕೃತಿ ಇದೆ, ಅರಣ್ಯ ಸಚಿವನಾದ್ಮೇಲೆ ನಾನು ಅದರ ಬಗ್ಗೆ ಹೆಚ್ಚಿನ ಒಂದು ಅಧ್ಯಯನವನ್ನು ಮಾಡಿದ್ದೇನೆ. ನಾವು ನೋಡ್ತಾ ಇದ್ದೇವೆ ಇವತ್ತು ಕ್ಯಾನ್ಸರ್ ಜಾಸ್ತಿ ಆಗ್ತದೆ, ಲಂಗ್ ಕ್ಯಾನ್ಸರ್ ಆಗ್ತದೆ. ಇವೆಲ್ಲದಕ್ಕೆ ಏನು ಕಾರಣಪ್ಪ? ಪ್ರಕೃತಿ ಪರಿಸರ ಸಂರಕ್ಷಣೆ ಮಾಡುವಂಥದ್ದು ಅದರಲ್ಲಿ. ಯಾಕೆಂದರೆ ಇವತ್ತು ಪ್ರತಿಯೊಂದರಲ್ಲಿ ಆಹಾರದಲ್ಲಿ ಮಾಲಿನ್ಯ ಇದೆ, ಗಾಳಿಯಲ್ಲಿ ಮಾಲಿನ್ಯ ಇದೆ, ನೀರಿನಲ್ಲಿ ಮಾಲಿನ್ಯ ಇದೆ, ಶಬ್ದ ಮಾಲಿನ್ಯದಿಂದಲೂ ಇವತ್ತು ಅನೇಕ ಕಡೆ ಜೀವ ಕಳ್ಕೊಳ್ತಾ ಇರುವಂಥದ್ದು ನಾವು ನೋಡ್ತಾ ಇದ್ವಿ. ಈ ಮಾಲಿನ್ಯವನ್ನು ತಡಿಲಿಕ್ಕೆ ಏನು ಮಾಡಬೇಕಾಗಿದೆ ಅನ್ನುವಂಥದ್ದು ಭಾಳ ಅವಶ್ಯಕತೆ ಇದೆ. ಸಾಂಕ್ರಾಮಿಕ ರೋಗಗಳೇನು ಬರ್ತವೆ, ಈ ಸಾಂಕ್ರಾಮಿಕ ರೋಗಗಳು ತಡೆಗಟ್ಟುವಂಥದ್ದು ಡೆಂಗ್ಯೂ ಬರ್ತದೆ. ಭಾಳ ಸಲ ಸಾವಿರಾರು ಜನ ಡೆಂಗ್ಯೂಗೆ ತುತ್ತಾಗ್ತಾರೆ. ಇವತ್ತು ಚಿಕನ್ ಗುನ್ಯಾ ಬರ್ತದೆ, ಅದರಲ್ಲೂ ನೂರಾರು ಸಾವಿರಾರು ಜನ ಒಬ್ಬರಿಂದೊಬ್ಬರಿಗೆ ಸುಮಾರು ಕಡೆ ಈ ಕೀಟಗಳು, ಇವೆಲ್ಲ ಸೊಳ್ಳೆಗಳು, ಇವೆಲ್ಲ ಸ್ವಚ್ಛತೆ ಕಾಪಾಡುವಂಥದ್ದು ಇವೆಲ್ಲ ಭಾಳ ಅವಶ್ಯಕತೆ ಇದೆ. ಅದರ ಜೊತೆಯಲ್ಲಿ ಇವತ್ತು ತಾವೆಲ್ಲ ವೈದ್ಯರಿದ್ದೀರಿ. ಯಾವ ವೈದ್ಯರಿಗೆ ಇಷ್ಟೊಂದು ಶ್ರೇಷ್ಠವಾದಂಥ ಒಂದು ಸ್ಥಾನಮಾನ ಇದೆ ಅಂತ ಹೇಳಿದ ಮೇಲೆ ಇವತ್ತು ಬರೀ ವೃತ್ತಿ ಜೊತೆಯಲ್ಲಿ ನಿಮ್ಮ ವೃತ್ತಿ ಇದೆ, ನಿಮ್ಮ ದೊಡ್ಡ ದೊಡ್ಡ ಆಸ್ಪತ್ರೆಗಳನ್ನು ನೀವೆಲ್ಲ ನಿರ್ಮಾಣ ಮಾಡಿದ್ದೀರಿ, ಎಷ್ಟೋ ಕಡೆ ಸಾಲ ಸೋಲ ಮಾಡಿಕೊಂಡಂಥದ್ದು ಇದೆ. ಅದರ ಜೊತೆಯಲ್ಲಿ ಇವತ್ತೊಂದು ಮಾನವೀಯ ಮೌಲ್ಯ ಏನಿದೆ, ನೈತಿಕತೆ ಇದೆ, ಇದರಲ್ಲಿ ಏನೊಂದು ನಿಮ್ಮ ಏನು ಪ್ರಮಾಣ ಇದೆ ನಿಮ್ಮದು, ಆ ಪ್ರಮಾಣದ ಪ್ರಕಾರ ಇವತ್ತು ಯಾರು ಬಡವರಿಗೆ ಕೈಗೆಟುಕುವ ದರದಲ್ಲಿ ನಾವು ಚಿಕಿತ್ಸೆ ಕೊಟ್ಟಿವಿ ಅಂತ ಹೇಳಿದರೆ, ಸಮಾನ ಆರೋಗ್ಯ ಎಲ್ಲಿ ಬೆಂಗಳೂರಲ್ಲಿ ಸಿಗುವಂಥ ಒಂದು ಚಿಕಿತ್ಸೆ ಇವತ್ತು ಹಳ್ಳಿಗಳಲ್ಲಿ ಸಹಿತ ಸಿಗುವಂಥ ರೀತಿಯಲ್ಲಿ ನಾವು ವ್ಯವಸ್ಥೆ ಮಾಡಿದೀವಿ ಅಂತ ಹೇಳಿದರೆ, ಇವತ್ತು ಆರೋಗ್ಯದ ಕ್ಷೇತ್ರದಲ್ಲಿ ಭಾಳಷ್ಟು ಬದಲಾವಣೆ ಆಗ್ತದೆ, ಒಂದು ಕ್ರಾಂತಿ ಆಗ್ತದೆ. ಆ ದೃಷ್ಟಿಯಿಂದ ಇಂಥ ಸಮ್ಮೇಳನಗಳಲ್ಲಿ ಅವೆಲ್ಲವೂ ಚರ್ಚೆ ಆಗಲಿ. ನೀವೇನು ಚರ್ಚೆ ಮಾಡ್ತೀರಿ, ಚಿಂತನ ಮಂಥನ ಮಾಡ್ತೀರಿ, ಆ ಚಿಂತನ ಮಂಥನದ ವಿಷಯಗಳು ಸರ್ಕಾರಕ್ಕೆ ನೀವೆಲ್ಲ ಸಲ್ಲಿಸಿದ್ರೆ, ಸರ್ಕಾರ ಮಟ್ಟದಲ್ಲಿ ಮಾನ್ಯ ಆರೋಗ್ಯ ಮಂತ್ರಿಗಳಿದ್ದಾರೆ, ನಾವಿದ್ದೀವಿ, ಎಲ್ಲರೂ ಕೂಡಿ ಸಚಿವ ಸಂಪುಟದಲ್ಲೂ ಚರ್ಚೆ ಮಾಡಿ ಇನ್ನು ಹೆಚ್ಚಿನ ರೀತಿಯಲ್ಲಿ ಸುಧಾರಣೆ ಮಾಡಿ ಇವತ್ತು ನಮ್ಮದೇ 75, 80 ಇನ್ನು ಉತ್ತಮ ರೀತಿಯಲ್ಲಿ ಯುವಕರಿಗೆ ಒಳ್ಳೆ ರೀತಿಯಿಂದ ಸದೃಢವಾದಂಥ ಸುಂದರವಾದಂಥ ಆರೋಗ್ಯಕರವಾದಂಥ ಸಮಾಜ ನಿರ್ಮಾಣ ಮಾಡಲಿಕ್ಕೆ ಸಾಧ್ಯ ಆಗ್ತದೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಈ ಭಾರತೀಯ ನಮ್ಮ ಏನು ವೈದ್ಯಕೀಯ ಸಂಘದ ವತಿಯಿಂದ ಇವತ್ತಿನ ಸಮ್ಮೇಳನ ನಡೀತಾ ಇದೆ. ಈ ಸಮ್ಮೇಳನ ಯಶಸ್ವಿ ಆಗಲಿ. ಈ ನಿಮ್ಮ ಏನೇನು ಸಮಸ್ಯೆಗಳು ನಿಮ್ಮದು ಇದೆ, ಈಗಾಗಲೇ ಹೇಳಿದರು, ನಿಮಗೆ ಹರಾಸ್ಮೆಂಟ್ ಮಾಡುವಂಥದ್ದಾಗಲಿ ಅಥವಾ ನಿಮಗೆ ಇವತ್ತಿನ ದಿವಸ ಕಿರುಕುಳ ಕೊಡುವಂಥದ್ದಾಗಲಿ, ಹಲ್ಲೆ ಮಾಡುವಂಥದ್ದಾಗಲಿ, ನಿಮಗೆ ರಕ್ಷಣೆ ಕೊಡುವಂಥದ್ದು ಪ್ರತಿಯೊಬ್ಬ ಸಾರ್ವಜನಿಕರ ಕರ್ತವ್ಯವಾಗಿದೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ನಮ್ಮ ಕಡೆಯಿಂದ ಏನು ಸಹಕಾರ ಸಿಗೋ ಉಸ್ತುವಾರಿ ಮಂತ್ರಿಯಾಗಿ ಸಚಿವ ಸಂಪುಟ ಸದಸ್ಯನಾಗಿ ನಿಮ್ಗೆ ಏನು ಸಹಕಾರ ಬೇಕಾಗಿದೆ ಅಥವಾ ಕಾನೂನಲ್ಲಿ ಏನಾದರೂ ಇನ್ನೂ ಹೆಚ್ಚಿನ ರೀತಿಯಲ್ಲಿ ಬಲಪಡಿಸುವಂಥ ಒಂದು ಕೆಲಸ ಮಾಡಬೇಕಾದ್ರೂ ನಮ್ಮ ಸಂಪೂರ್ಣವಾದಂಥ ಬೆಂಬಲ ಸಹಕಾರ ನಿಮ್ಮ ಜೊತೆಯಲ್ಲಿ ಇದೆ ಅನ್ನುವಂಥ ಮಾತನ್ನು ಹೇಳಿ ಈ ಒಂದು ಸಮ್ಮೇಳನ ಯಶಸ್ವಿ ಆಗಲಿ. ಈ ಸಮ್ಮೇಳನದಿಂದ ರಾಜ್ಯದಲ್ಲಿ ರಾಷ್ಟ್ರದಲ್ಲಿ ಇನ್ನೂ ಆರೋಗ್ಯ ರಕ್ಷಣೆಗೆ ಹೆಚ್ಚಿನ ಒಂದು ಒತ್ತು ಸಿಗಲಿ ಅಂತೇಳಿ ಹೇಳಿ ಹಾರೈಸಿ ನಿಮ್ಮೆಲ್ಲರಿಗೆ ಶುಭವನ್ನು ಹಾರೈಸಿ ನನ್ನ 2 ಮಾತು ಮುಗಿಸ್ತೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
Thank you very much, sir. We feel privileged to invite the respect.
ಮಾನ್ಯ ಮಂತ್ರಿಗಳ ಪೂರ್ವ ನಿಗದಿತ ಕೆಲಸಗಳಿಂದಾಗಿ ನಮ್ಮ ಈ
We feel very privileged to invite the respected IMA National President-elect Dr. R.V. Ashokan, sir, to release of souvenir of the MEDICON 2023. And we also request editor of the souvenir, Dr. Mahesh Tondare, sir, to get the souvenir. We also request Dr. R.V. Ashokan, sir, to launch the IMA Karnataka MediChoice hospital software. We request Dr. Jaspal Singh, sir, Chairman, Digital Committee, to please come on to the stage.
Good evening, all the respected dignitaries on the dais, off the dais. I am Dr. Jaspal Singh, Chairman of the Digital Subcommittee, IMA KSB. I thank all of you to allow me to stand here today in front of this august gathering to present IMA Karnataka's MediChoice, the hospital software. May I have the teaser, please? Thank you. These These are the highlights of the software. Now I request Dr. R.V. Ashokan sir, President-elect IMA National, to do the honors by inaugurating the software and launch it today at this August gathering. You can have the view here, sir. Our IMA KSP's leadership under Dr. Shivkumar Lakul sir, who has been a friend to all of us, and the guiding force, Dr. Yoganand Reddy sir, Dr. Hannigoda sir, Madhusudan sir, and Dr. Arvind Patil and Dr. Pawan Patil sir. And this is the subcommittee under which this team of work has taken up to develop the software from the last 1 year, and we have come to the launch today at Bidar. I thank all of you, the Bidar IMA, to allow us to launch. And he is the CEO who's talking to us from California. He is the CEO of the Doc Choice, who has helped us, giving us this software at a very...
Doctor delegates and all the participants of this event. Thank you on behalf of Doc Choice and Doc Choice team, and congratulations on embarking this new journey in digitalizing state of Karnataka healthcare system under MEDICON. My journey with Doc Choice has been not just as a product, but as a platform digitalizing multiple states, multiple countries, multiple languages. Our vision is to bring in state-of-art technology, healthcare system integrated seamlessly with all the participants. And thank you again to everyone who has been involved in making this event successful and bringing the technology to the platform. Honorable Chief Guest, Dr. R.N. Ashokan, thank you very much for accepting our invitation to inaugurate our product, MediChoice, and thank you very much.
Thank you, sir. Thank you. Thank you, sir. Thank you all here to allow us to do this honors at the hands of Dr. Ashokan, sir. And the demo here of this software is available at stall number 10. I request all of you to have a look of the software, and there is an inaugural offer. First 10 purchasers will be getting WhatsApp integration system free for first 1 month in the softwares. I thank one and all here to allow me, and kindly take this opportunity and book your softwares. Thank you very much.
Maintaining of a hospital records and patient details will be mandatory in the future. It provides better health care by improving all aspects of patient care. Keeping this in view, IMA KSB has worked out to provide hospital record software to its members for all level hospitals of Karnataka at an affordable cost, which is less than 1/5 of the original cost, with pocket-friendly maintenance charges. Thank you, dignitaries. Now we request Dr. R.V. Ashokan sir to address the gathering. Dr. R.V. Ashokan sir, a practicing general physician running a 26-bedded hospital, along with his wife, Dr. Leila Ashokan, a gynecologist in Punalur, a small town in Kollam district of Kerala state. conceived and established IMAGE, the biomedical waste project of IMA Kerala state branch in 26 acres of land in Palakkad. Biomedical waste of entire Kerala state is being handled on daily basis by IMAGE, including COVID-19 waste. He served as IMA National Coordinator for TB for private-public partnership and also in Strategy Technical Advisory Group, STAG, of WHO in Geneva. He was the National Secretary of IMA Hospital Board of India for 4 years and its chairman for 4 years. He has worked as IMA State Secretary of Kerala for 3 years, IMA Kerala State President. He was the chairman of Action Committee which shaped the struggle against NMC. Honorary National Secretary of IMA Headquarters 2018 to 20. He is currently the National President-elect and an intellectual guiding force for national and state IMAs. We welcome you, sir.
President of IMA Karnataka State Branch, Dr. Shivakumar B. Lakol. Incoming President Dr. Srinivasa. Right Honorable Sri Ishwar Khandre. Thank you, sir, for staying back. Thank you for hearing us. And even in his absence, he made a presence. Sri Dinesh Gundrao, Health Minister, Honorable Health Minister of Karnataka. Dr. Prabhakara, Yogendra Reddy, Madhusudanava, Venkatachalapati, Karnakara, Dr. Chandrakant Kudagal, Dr. Pavan Patel, Dr. Shivakumar Shetkar, Dr. Madana Vaidyanath, Dr. Vijayashree Bashetti, Dr. Mallikarjun Panshetty, all the leaders, past presidents of IMA Karnataka State Branch, and my dear members of IMA Karnataka State Branch. First, let me congratulate you. It was an eye-opener, and it was a pleasant surprise that how Karnataka State Branch works so closely with your government. I think here is a lesson for all state branches to work with. There is an impression that Indian Medical Association is for strikes and agitations. And here is a state branch which is showing us a soft approach of how to work with the democratic government. I'm quite impressed. The way that your government is interacting with you, I think let all the state branches, including the headquarters, take a leaf out what you are doing in your state. I'm quite impressed. Again, yeah, congratulations will be for your intervention in the NEET for eligibility 0. It took some time for even IMA headquarters to understand the undercurrents of that. I would let me acknowledge that in the initial assessment, IMA headquarters went wrong. But it corrected itself from the feedback that came from our local branches regarding this issue. Right now, you are 28,000 plus. I remember the days when it was hovering around 10,000. And sometime before 5 years, they said we are crossing 20,000 with all those enthusiasm. Now it is 28,000. And holding this function in a place like Bidar, that itself shows that you have come of age. Karnataka State Branch IMA not only stands on its own, is a role model for many of the state branches. I can say that in our upcoming state conferences. And recognizing by giving public awards, the journalists, the people who interact in health is an example that other state branches also should follow. Your social security 2 schemes, PP scheme, and your own interaction with the government for KPME, Violence Act, Fire Act, I can see all these things came in the dice. And
ultimately the software and the team under Dr. Jaspal, Madhusudanava, Pavan, and Yogendra, this is impressive, very, very impressive, very impressive. And the IMA Focus KMJ, congratulations, IMA Karnataka State Branch. I am quite impressed. I go with a very good impression about Karnataka State Branch. I also congratulate the outgoing team for their activity and appreciate that the incoming team will have quite a job to do because they will be my team as well. Having said that, I think I need to take few minutes with you regarding the current status of the profession. We will have to acknowledge that the medical profession has lost the leadership in health. It's very painful to say. It's an industry which has taken over the leadership of health. Maybe it is inevitable, but we are in a unique position. Perhaps few countries in the world have doctor entrepreneurs. Doctor entrepreneurs are a vanishing species. All the developments which are going up are for the elimination of doctor entrepreneurs, small and medium hospitals. Small and medium hospitals is not a liability, it's an asset. It's a national asset of this country. It cannot be let go. It's not semantics to say that small and medium hospitals are different from for-profit hospitals. Small and medium hospitals, being run by doctors, are different, have to be regulated differently. They follow medical ethics. What is the ethics that for-profit hospitals follow? Any patient-centric institution should follow medical ethics. Medical ethics is the cream of human civilization. So it's our duty, not only our duty, the duty of the governments, the duty of the society to see that the entrepreneurship in the medical profession doesn't go away. That the leadership in health has to remain with doctors. How can it go to a for-profit industry? It cannot. We need to resist this. This elimination of the middle sector in another 10 years will land us with two options. One, the government sector, other the for-profit sector. The middle sector has to survive. It is important for the nation to support the middle sector. We have chosen some of the, there are umpteen number of issues that we have to deal with. We have lost count of the issues that we have to fight. We need to prioritize. We need to prioritize. We have prioritized some. One, the first will be the integrative medicine. Integrative medicine will not be acceptable. Indian Medical Association will resist it. We respect all systems of medicine. Let the patient choose. Let there be vertical science in all systems. Why mix them? Why integrate them? What is the benefit? Whose need it is? Integrative medicine is a threat. It is enunciated in the National Education Policy. Niti Aayog has been given the job of finalizing the mixing in public administration, clinical medicine, research, and education. The work has already started. It's reflected in what NMC is doing. And the government is on record saying that by 2030, there won't be modern medicine MBBS graduates. There will be only MBBS integrative medicine graduates. They are changing your DNA so that you will not react. This is something, and a crisis of identity, which has to be resisted, not only for the profession, but for the nation, for the patient. The catastrophe that is going to befall this nation
has to be stopped. And the only organization that can resist is Indian Medical Association. So our priority in the coming year will be, the first one will be integrative medicine. We know we sacrificed Dr. Vandana Das in the last year, and that is enough. Enough is enough on violence front. Violence has to be countenanced, has to be countered in all dimensions, not only by law, but in umpteen number of ways and dimensions it has to be countenanced. And the ambience to practice has to be secured. Unjust laws. You name any law which governs medical profession. Name it. Name any law. Injustice that has been inflicted on the medical profession for this past 75 years has to be corrected. Start with the criminal prosecution of the doctors. If a crime is defined as one which has been committed with a criminal intention, let me ask the society and the government, where is the criminal intention when a doctor touches a patient? The mens rea or the criminal intention is absent. Why prosecute my doctor under criminal law? Is it justified? We need to discuss this. We need to rise for this, because today, apart from the Consumer Protection Act, the blackmailing is done by criminal prosecution to extract money. And so many of our doctors are being sentenced. This is no longer acceptable. We need to rise. There are countries which have exempted doctors from criminal law. So one of them, PCP and DT, it has no validity or no reason why it should exist. We all want to protect life, protect the girl children. But why single out that ultrasound machine? Why single out my doctors? Why don't you test and has it reversed the nation's sex ratio? Let us deduct sex. Let the debate begin. Let us tag our girl children. Let us save them. Let us see that they are born. Why? So, the person who committed the crime, because he is a juvenile, gets away. The doctor who helped the victim did not inform, goes to 6 months jail. How is it justified? How is it justified? You name any law governing medical profession. It's time to stand up. We need to stand up. We need to resist. It's not done. We need to correct all these injustices. And add to this the unemployment of our young doctors. What is staring at them? We are fed up by hearing that how long you will lie to us? How long you will lie to us? Some of our states have a doctor-patient ratio which is better than the Western countries. And 1 million doctors in another 10 years. 706 medical colleges. 108,000 medical graduates every year. Where will they go? Where will they go? unemployment, anger, frustration. So the focus has to shift to our young doctors. We have started in the right direction, addressing the young doctors' issues. Today, after 5 years of very hard work, I can tell you that Indian Medical Association has got a presence in 500 and plus medical colleges of the country. Let me tell you, name few organizations which have a presence in all the 700 districts of this country. I can proudly say my Indian Medical Association is present in every district of this country. Tell me couple of even political parties who can challenge us. We need to stand up. My challenge is not government. My challenge is not society. My challenge is my member. The siege within, to reach to my member, to tell him that the house is on fire. You need to get up now, awake, is important. So that's why I came. The President said, we are thankful that you came to Bidar. Sir, I have a message. I have a message to all of you. Each one of you should tell our members that the house is on fire. We need to resist. We need to, your contribution in working with the government. Times have changed. Times have changed. We need to work with the governments. We have to have dialogue, listen, tell them our issues, make them understand that there is another perspective, that they have to look through our perspective as well. So, ladies and gentlemen, I am very grateful for inviting me to this August gathering. And I am grateful for the leadership that you have shown in many of the areas, which is a learning process for me. Today I unlearn and learn new things from you. Thank you so much.
Thank you very much, sir. That was quite overwhelming.
ನಮ್ಮೆಲ್ಲರ ನೆಚ್ಚಿನ ನಾಯಕರಾಗಿರುವ IMA ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರಾದ ಶಿವಕುಮಾರ್ ಲಕ್ಕೋಳ್ರವರು ತಮ್ಮ ಅನುಭವದ ಮಾತುಗಳನ್ನು ಆಡಬೇಕೆಂದು ಮನವಿ ಮಾಡಿಕೊಳ್ಳುತ್ತೇವೆ.
Dr. Shivkumar B. Lakkol, sir, got his MBBS from KIMS Hubballi. Started his practice as family physician at the remotest place of Karnataka, Roan. He has taken modern medicine to the doorsteps of least reachable part of Karnataka, providing comprehensive health care for people of all genders and all ages 5 decades back itself. He is the strong follower of IMA for the last 4 decades, and the president post is the reward for his hard work. During his term, he has emerged as a good leader who has shown integrity, self-awareness, courage, respect, empathy, gratitude, and decision-making skills. He has shown communication skills, developing striking personality, gaining experience, integrity, developing interpersonal skills, and command presence. His silent aggression has made many achievements possible. At this age of 74, he has visited more than 150 IMA local branches of Karnataka and inaugurated more than 10 women doctors' wing and 5 new buildings of IMA and conducted all the conferences for the year. Leadership is not the destination, it's a journey. We wish him all the best.
Thank you, madam, for your kind words. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ 89ನೇ ವಾರ್ಷಿಕ ಸಮ್ಮೇಳನ MEDICON 2023 ಇದರ ಉದ್ಘಾಟನಾ ಸಮಾರಂಭಕ್ಕೆ ಆಗಮಿಸಿ ಈಗ ತಾನೇ ನಮ್ಮನ್ನೆಲ್ಲ ಉದ್ದೇಶಿಸಿ ಕಾರ್ಯನಿಮಿತ್ತ ಹೋದಂಥ ಸನ್ಮಾನ್ಯ ಸಚಿವರಾದ ಶ್ರೀ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ರವರು, ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣ ಇಲಾಖೆ, ಕರ್ನಾಟಕ ರಾಜ್ಯ ಸರ್ಕಾರ, ಇವರಿಗೆ ನನ್ನ ನೆನಪುಗಳನ್ನು ಮಾಡ್ಕೊತ ಇವತ್ತಿನ ಈ ಸಮ್ಮೇಳನವನ್ನು ಉದ್ಘಾಟನೆ ಮಾಡಿರ್ತಕ್ಕಂಥ ಶ್ರೀ ಈಶ್ವರ್ ಬಿ ಖಂಡ್ರೆ ಮಾನ್ಯ ಅರಣ್ಯ ಹಾಗೂ ಜೈವಿಕ ಮತ್ತು ಪರಿಸರ ಇಲಾಖೆ ಹಾಗೂ ಬೀದರ್ ಜಿಲ್ಲಾ ಉಸ್ತುವಾರಿ ಸಚಿವರು ಕರ್ನಾಟಕ ಸರ್ಕಾರ ಹಾಗೂ ಈಗ ತಾನೇ ನಮ್ಮನ್ನೆಲ್ಲ ಉದ್ದೇಶಿಸಿ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ರಾಜ್ಯ ಶಾಖೆ ರಾಷ್ಟ್ರ ಶಾಖೆಯಲ್ಲಿ ಯಾವ ರೀತಿ ನಾವು ಮುಂದೆ ಮಾಡ್ತಕ್ಕಂಥ ಕೆಲಸ ಅದರ ಬಗ್ಗೆ ನಮಗೆ ಸವಿಸ್ತಾರವಾಗಿ ತಿಳಿಸ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ RV ಅಶೋಕನ್ ಚುನಾಯಿತ ರಾಷ್ಟ್ರೀಯ ಅಧ್ಯಕ್ಷರು IMA ಕೇಂದ್ರ ಶಾಖೆ ನವದೆಹಲಿ. ಹಾಗೆ ನನ್ನ ಅವಧಿಯು ಈ ಸುಂದರವಾದಂಥ ನಗರ ಕರ್ನಾಟಕದ ಕಿರೀಟಪ್ರಾಯವಾಗಿರ್ತಕ್ಕಂಥ ಬಿದಿರಿನ ಕರಕುಶಲಗಳಿಗೆ ತನ್ನದೇ ಅಂತ ಸ್ಥಾನವನ್ನು ಹೊಂದಿರತಕ್ಕಂಥ ಕರ್ನಾಟಕದ ಊಟಿ ಎಂದೇ ಪ್ರಸಿದ್ಧವಾಗಿರ್ತಕ್ಕಂಥ ಸರ್ವಜನಾಂಗದ ಶಾಂತಿಯ ತೋಟ ಹಾಗೂ ಬಸವಣ್ಣರ ನಾಡಾಗಿರ್ತಕ್ಕಂಥ ಬೀದರ್ನಲ್ಲಿ ನಡೀತಕ್ಕಂಥದ್ದು ಅವಿಸ್ಮರಣೀಯ ದಿನ. ಇಂಥ ಒಂದು ಸುಂದರವಾದ ನಗರದಲ್ಲಿ ನಾನು ನನ್ನ ಅಧಿಕಾರಾವಧಿಯನ್ನು ಮುಗಿಸಿ ಮುಂಬರಲಿರುವ ಹೊಸ ಚುಕ್ಕಾಣಿಯಲ್ಲಿರತಕ್ಕಂಥ ಡಾಕ್ಟರ್ S ಶ್ರೀನಿವಾಸ್ ಅವರೇ ಹಾಗೂ ನಮ್ಮ ರಾಜ್ಯ ಶಾಖೆಯ ಕಾರ್ಯದರ್ಶಿಯಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕರುಣಾಕರ್ ಅವರೇ, ಖಜಾಂಚಿಯಾಗಿರ್ತಕ್ಕಂಥ ವಿಜಯಸಾರಥಿ ಅವರೇ, ಜಂಟಿ ಕಾರ್ಯದರ್ಶಿ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಅನಿತಾ ಅವರೇ, PRO ಆದ ಡಾಕ್ಟರ್ ಪವನ್ ಪಾಟೀಲ್ ಅವರೇ, ನ್ಯಾಷನಲ್ ಅಸಿಸ್ಟೆಂಟ್ ಸೆಕ್ರೆಟರಿ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ವೆಂಕಟಾಚಲಪತಿ ಅವರೇ, ನ್ಯಾಷನಲ್ ಐಕೆನ್ಸಿನ್ನಾದ ಡೈರೆಕ್ಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ GN ಪ್ರಭಾಕರ್ ಅವರೇ ಹಾಗೂ ಈ ಸಮ್ಮೇಳನದ ಪ್ರೋಟೋಕಾಲ್ ಆಫೀಸರ್ ಮಾಜಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ YC ಯೋಗಾನಂದ ರೆಡ್ಡಿ ಅವರೇ ಹಾಗೂ ನನ್ನ ಜೊತೆ ಅವಿರತವಾಗಿ 1 ವರ್ಷದ ಅವಧಿಯಲ್ಲಿ ಉಪಾಧ್ಯಕ್ಷರಾಗಿ ಕಾರ್ಯಗಳನ್ನು ನಿರ್ವಹಿಸಿರ್ತಕ್ಕಂಥ ಸೀನಿಯರ್ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ ಅಂತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಪ್ರಸನ್ನ ಶಂಕರ್ ಅವರೇ, ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಮೂರ್ತಿ ಅವರೇ, ಡಾಕ್ಟರ್ ಶ್ರೀಶೈಲ್ ಅಮೇರ್ಕಡ್ ಅವರೇ ಹಾಗೂ ಡಾಕ್ಟರ್ ರಾಜಶ್ರೀ ಅನಗೋಳ್ ಅವರೇ ಹಾಗೂ ನನ್ನ ಜೊತೆ 1 ವರ್ಷ ಸತತವಾಗಿ ಕೆಲಸ ಮಾಡಿರ್ತಕ್ಕಂಥ ಅಸಿಸ್ಟೆಂಟ್ ಸೆಕ್ರೆಟರಿ ಆಗಿರ್ತಕ್ಕಂಥ LD ಬಾಕ್ಲೆ ಅವರೇ. ಹಾಗೆ ನಿಮಗೆಲ್ಲ ಗೊತ್ತಿದ್ದಂಗೆ ಇದು ನನ್ನ ಕೊನೆಯ ಮಾತು ಆಗಿರೋದ್ರಿಂದ ನನ್ನ ಗೌರವಾನ್ವಿತ ಹಿರಿಯರೂ ಆಗಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ವೈದ್ಯ ಮಿತ್ರರನ್ನ ಈ ಸಂದರ್ಭದಲ್ಲಿ ನೆನೆಸುತ್ತಾ 2024-25ನೇ ಸಾಲಿಗೆ ಅಧ್ಯಕ್ಷರಾಗಿ ನಿಯೋಜಿತಗೊಂಡಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಚಿನ್ವಾಲರವರೇ ಹಾಗೂ ಮಾಜಿ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ N ಪ್ರಭಾಕರ್ ಅವರು, ಈಗ ನಾನು ಹೇಳಿದ್ದೇನೆ, ಅವರು ನ್ಯಾಷನಲ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿದ್ದರು. ಹಾಗೆ ಡಾಕ್ಟರ್ ಮೇಟಿ ಅವರೇ, ಡಾಕ್ಟರ್ DGB ಬಿಡಾನಾಳ್ ಅವರೇ, ನಮ್ಮ ಇಮಿಡಿಯೇಟ್ ಪಾಸ್ಟ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಕುಡವ ಅವರೇ ಹಾಗೂ ಮುಂಬರುವ ಅವಧಿಗೆ ಅಧಿಕಾರವನ್ನು ತೆಗೆದುಕೊಳ್ಳತಕ್ಕಂಥ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕಿರಣ್ ದೇಶ್ಮುಖ್ ಅವರೇ ಹಾಗೂ ಪವನ್ ಪಾಟೀಲ್ ಅವರೇ, ರಾಜಗೋಪಾಲ್ ಅವರೇ, ಎಲ್ಲ ವೈದ್ಯ ಮಿತ್ರರೇ, ಹೀಗೆ ಈ ಎಲ್ಲ ವಿಚಾರಗಳನ್ನು ನಮ್ಮ ವೈದ್ಯ ಮಿತ್ರರನ್ನ ಎಲ್ಲರನ್ನು ನೆನೆಸುತ್ತಾ ಈ ಸಮ್ಮೇಳನಕ್ಕೆ ತನ್ನದೇ ಆದಂಥ ವೈಭೀಕರಣವನ್ನು ಮಾಡಿ ನಮಗೆ ಈ ಬೀದರ್ನಲ್ಲಿ ಮಾಡಲಿಕ್ಕೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ಬೀದರ್ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರು, ಕಾರ್ಯದರ್ಶಿ ಹಾಗೂ ಗೌರವಾನ್ವಿತ ಸದಸ್ಯರನ್ನು ನೆನೆಸುತ್ತಾ ಈ ಸಮ್ಮೇಳನದ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಕಾರ್ಯದರ್ಶಕರು ಹಾಗೂ ಸಮ್ಮೇಳನದ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಚಂದ್ರಕಾಂತ್ ಗುದಿಗೆ ಅವರೇ ಹಾಗೂ ಡಾಕ್ಟರ್ ವಿಜಯಶ್ರೀ ಬಸೆಟ್ಟಿ ಅವರೇ ಹಾಗೂ ಆರ್ಗನೈಸಿಂಗ್ ಸೆಕ್ರೆಟರಿ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಶೆಟ್ಟಿ ಅವರೇ, ಇಂಥ ಸುಂದರವಾದ ಕಟ್ಟಡ ಹಾಗೂ ಸ್ಥಳವನ್ನು ನಮಗೆ ಅವಕಾಶ ಮಾಡಿಕೊಟ್ಟಿರ್ತಕ್ಕಂಥ ನಿರ್ದೇಶಕರು ಆಗಿರ್ತಕ್ಕಂಥ ಶಿವಕುಮಾರ್ ಶೆಟ್ಟರ್ ಅವರೇ ಹಾಗೂ ಇವರೆಲ್ಲದರನ್ನು ಅಲ್ಲದೆ ನಮ್ಮ ಹಿರಿಯರು ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಹನುಮಶೆಟ್ಟಿ ಅವರೇ, ಡಾಕ್ಟರ್ ಆನಂದರಾವ್ ಅವರೇ, ಡಾಕ್ಟರ್ ವೈಜನಾಥ್ ತೋಗೇರವರೇ ಹಾಗೂ ಶೆಟ್ಕರ್ ಅವರೇ, ಇವರೆಲ್ಲರನ್ನು ನೆನೆಸ್ತಾ ಇದ್ದರೆ ಈ ಸಮ್ಮೇಳನ ನನಗೆ ಪೂರ್ತಿಯಾಗಿದೆ ಅಂತ ಅನಿಸಿಲ್ಲದ ಸಲುವಾಗಿ ನಾನು ಸ್ವಲ್ಪ ಸಮಯವನ್ನು ಅವರನ್ನು ನೆನೆಯಲಿಕ್ಕೆ ತಗೊಂಡದ್ದಕ್ಕೆ ಕ್ಷಮೆ ಇರಲಿ. ಇದು ನನ್ನ ಜೀವಮಾನದಲ್ಲೇ ಮರೆಯಲಾಗತಕ್ಕಂಥ ಸುದಿನ. 28/10/22 ಅಧ್ಯಕ್ಷನಾಗಿ ಚುನಾಯಿತನಾದ ನಂತರ ಅಧಿಕಾರಾವಧಿ ತೆಗೆದುಕೊಂಡ ನಂತರ ಮೂಡುಬಿದಿರೆಯಲ್ಲಿ ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಕುಡವಾರ ನಂತರ ಸುದೀರ್ಘವಾಗಿ ಇಲ್ಲಿಯವರೆಗೆ ನನ್ನ ಕೈಲಾದಂಥ ಕೆಲವಾರು ಕೆಲಸ ಕಾರ್ಯಗಳನ್ನು ನನ್ನ ತಂಡದೊಂದಿಗೆ ಮಾಡಿದ್ದೇನೆ ಅನ್ನೋದು ಹೆಮ್ಮೆಯಿಂದ ಈ ನಿಮ್ಮ ಮುಂದೆ ಕೆಲವು ವಿಚಾರಗಳನ್ನು, ಕಾರಣ ಸಮಯ ಬಹಳ ಆಗಿದೆ, ಹೆಚ್ಚಿಗೆ ಸಮಯವನ್ನು ತೆಗೊಳ್ಳೋಕ್ಕೆ ಇಷ್ಟಪಡೋದಿಲ್ಲ. ನಮ್ಮದೇ ಆದಂಥ 20 ಸಬ್ ಕಮಿಟಿಗಳನ್ನು ಮಾಡಿ ಅದರಲ್ಲಿ ಬೇರೆ ಬೇರೆ ಕಮಿಟಿಗಳನ್ನು, ಸಬ್ಜೆಕ್ಟ್ ಕಮಿಟಿ ಇರ್ಬೋದು, ಬೈಲಾ ಕಮಿಟಿ ಇರ್ಬೋದು, IMA KSB ಬಿಲ್ಡಿಂಗ್ ಕಮಿಟಿ ಇರ್ಬೋದು, KPPS ಹಾಗೂ KSS KHSನ ಸ್ಕೀಮ್ಸ್ಗಳು ಇರ್ಬೋದು, ಆಲ್ ಇಂಡಿಯಾ ಮೆಡಿಕಲ್ ಸೈನ್ಸ್ನ ವಿಂಗ್ ಇರ್ಬೋದು, IMCG ವಿಂಗ್ ಇರ್ಬೋದು, ಹೀಗೆ ಎಡಿಟರ್ ಆಫ್ ಕರ್ನಾಟಕ ಮೆಡಿಕಲ್ ಜರ್ನಲ್ ಹಾಗೂ ಫೋಕಸ್ ಇವೆಲ್ಲರನ್ನ ಒಳಗೊಂಡಂತೆ ಅನೇಕಾರು ಕೆಲಸ ಕಾರ್ಯಗಳನ್ನು ಮಾಡಿದ್ದೇವೆ. ನಮ್ಮ ಮೊದಲ ಧ್ಯೇಯ ಧೋರಣೆ ವೈದ್ಯರ ನಡೆ ಹಳ್ಳಿಯ ಕಡೆ, ವೈದ್ಯರ ನಡೆ ಶಾಲೆಯ ಕಡೆ, ವೈದ್ಯರ ನಡೆ ಸೈನಿಕರ ಕಡೆ, ವೈದ್ಯರ ನಡೆ ಜೀವ ಉಳಿಸುವ ಕಡೆ. ಹಾಗೆ ಈಗ ತಾನೇ ನಿರ್ಗಮಿಸಿರ್ತಕ್ಕಂಥ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಅವರು ಹೇಳಿದಂತೆ ವೈದ್ಯರ ನಡೆ ವೈದ್ಯರ ಹಾಗೂ ಅವರ ಕುಟುಂಬದ ಆರೋಗ್ಯದ ಕಡೆ ಎನ್ನುವುದ ನಿಟ್ಟಿನಲ್ಲಿ ಹೊಸ ಸ್ಲೋಗನ್ನೊಂದಿಗೆ ನಾವು ಕಾರ್ಯವನ್ನು ನಡೆಸಬೇಕಾದಂಥ ಒಂದು ಸುಸಂದರ್ಭ ಇವತ್ತಿನ ದಿವಸನೇ ನಾವು ಕಂಕಣಬದ್ಧರಾಗಿ ನಮ್ಮ ಆರೋಗ್ಯ, ನಮ್ಮ ಕುಟುಂಬ, ನಮ್ಮ ಸಮಾಜಕ್ಕೆ ಕಂಕಣಬದ್ಧರಾಗಿರುತ್ತಾ ಹೇಳ್ತಾ ಅನೇಕಾರು ವಿಚಾರಗಳನ್ನು ಈಗಾಗಲೇ ಈ ನಮ್ಮ ಘೋಷಣೆಗಳೊಂದಿಗೆ ಸಾಕಷ್ಟು ಶಾಖೆಗಳು ತಮ್ಮದೇ ಆದಂಥ ಹಳ್ಳಿಗಳನ್ನು ದತ್ತು ತೆಗೆದುಕೊಂಡು ಕಾರ್ಯಪ್ರವೃತ್ತಿಗಳನ್ನು ಸಾಕಷ್ಟು ಶಾಖೆಗಳು ಮಾಡ್ತಾ ಇದ್ದಾವೆ. ಹಾಗೆ ನ್ಯಾಷನಲ್ ಲೆವೆಲ್ ಜೊತೆಗೆ ಗಾಂಚಲಿಯನ್ನು ಅನುಷ್ಠಾನಕ್ಕೆ ತಂದು ಶ್ಲಾಘನೀಯ ಕೆಲಸ ಕಾರ್ಯಗಳನ್ನು ಮಾಡಿದ್ದಾರೆ. ಹಾಗೂ ಈಗ ತಾನೇ ಹೇಳಿದಂತೆ ಕಣ್ಮರೆಯಾಗುತ್ತಿರುವ ಕುಟುಂಬ ವೈದ್ಯರನ್ನು ಮುಂಚೂಣಿಗೆ ತರಲಿಕ್ಕೋಸ್ಕರ ನಾವು ಅನೇಕಾರು ಸಲ ಸನ್ಮಾನ್ಯ ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲೆಯ ಸಚಿವರನ್ನು ಹಾಗೂ ಶ್ರೀಮಾನ್ ಶರಣಪ್ರಕಾಶ್ ಪಾಟೀಲ್ ಅವರು ಎಜುಕೇಷನ್ ಮಿನಿಸ್ಟರ್ನು ಅವರು VC ಅವರುಗಳನ್ನು ಭೇಟಿಯಾದಾಗ ಸಕ್ರಿಯವಾಗಿ ಅದನ್ನು ಕಾರ್ಯರೂಪಕ್ಕೆ ತರಲು ಸ್ಪಂದಿಸಿದ್ದು ಸ್ಮರಣೀಯ. ಹಾಗೂ ಈಗಿನ ದಿನಮಾನದಲ್ಲಿ ವೈದ್ಯರ ಮತ್ತು ರೋಗಿಗಳ ನಡುವೆ ಹಳಸುತ್ತಿರತಕ್ಕಂಥ ಬಾಂಧವ್ಯವನ್ನು ಉತ್ತಮಗೊಳಿಸುವ ನಿಟ್ಟಿನಲ್ಲಿ ನಾವು ಕೆಲವು ವಿಚಾರಗಳನ್ನು ನಿಮ್ಮಲ್ಲಿ ಮುಂದೆ ಹೇಳಲಿಕ್ಕೆ ಇಡ್ತಾನೆ. ಈ ನಿಟ್ಟಿನಲ್ಲಿ ಕೆಲವಾರು ಕಾರ್ಯಾಗಾರಗಳನ್ನು ನಾವು ಸಮಾಜದ ಎಲ್ಲ ರೋಗಿಗಳಿಗೆ ರೋಗದ ಲಕ್ಷಣ ಅವು ಪರಿಹರಿಸತಕ್ಕಂಥ ಸಂದರ್ಭಗಳು ನಾವು ಯಾವ ರೀತಿ ಸಮಯವನ್ನು ಕಳ್ಕೊಳ್ಳಬಾರದು ಅನ್ನೋದರ ನಿಟ್ಟಿನಲ್ಲಿ ಕಾರ್ಯಾಗಾರ ಹಾಗೂ ಕೈಪಿಡಿಗಳನ್ನು ಮಾಡಿದ್ದೇವೆ. ಹಾಗೂ ಕೆಲವು ವಿಚಾರಗಳಲ್ಲಿ ನಾವು ಸತೆ ವೈದ್ಯರಾಗಿ ಕೆಲವು ಸಮಯಗಳನ್ನು ನಮ್ಮ ರೋಗಿಗಳಿಗೆ ಕೊಟ್ಟಿದ್ದೆ ಆದರೆ ಇಂಥ ಒಂದು ಅವಘಡಗಳನ್ನು ನಾವು ತಡೆಯುವುದು ನಿಜವಾಗಲೂ ಅನುಕೂಲಕರದಾಗಿತ್ತಂತಂದು ನಾವು ಈ ಸಮಯದಲ್ಲಿ ಮಂಥನವನ್ನು ನಾವು ಮಾಡಿಕೊಳ್ಳಬೇಕಾಗ್ತದೆ. ಹಾಗೆ ನಮ್ಮ ವೈದ್ಯರ ಅನೇಕಾರು ಸಮಸ್ಯೆಗಳನ್ನು ಈಗ ತಾನೇ ಸನ್ಮಾನ್ಯ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಅವರು ಹೇಳಿದರು. ಹಾಗೂ ನಮ್ಮ ಸನ್ಮಾನ್ಯ ಭೀಮಣ್ಣ ಖಂಡ್ರೆ ಸಾಹೇಬರು ಸತೆಗೆ ಹೇಳಿದರು. ನಮ್ಮಲ್ಲಿರ್ತಕ್ಕಂಥ ಕೆಲವು ಸಮಸ್ಯೆಗಳನ್ನು KPMA ಆ್ಯಕ್ಟ್ ಇರ್ಬೋದು, ಟ್ರೇಡ್ ಲೈಸೆನ್ಸ್ ಇರ್ಬೋದು, ಫೈರ್ ಲೈಸೆನ್ಸ್ ಇರ್ಬೋದು, ವೈಲೆನ್ಸ್ ಆ್ಯಂಟಿ ಕ್ವಾಕರಿ, PCP ಆ್ಯಂಡ್ ಆ್ಯಕ್ಟ್ ಹಾಗೂ ಯಶಸ್ವಿನಿ CPA, KMR ಆ್ಯಕ್ಟ್, ರಿನ್ಯೂವಲ್ ಆ್ಯಂಡ್ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಆಫ್ KMC ಆ್ಯಂಡ್ ಡಾಕ್ಟರ್ಸ್ ಪ್ರೊಟೆಕ್ಷನ್ ಆ್ಯಕ್ಟ್, ಹೀಗೆ ಹಲವಾರು ವಿಚಾರಗಳಿದೆ. ಈ ವಿಚಾರಗಳನ್ನು ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಸಾಹೇಬರಿಗೆ ಭೇಟಿಯಾದಾಗ ನಾನೇ 5-6 ಸಲ ಭೇಟಿಯಾಗಿದ್ದೆ. ಅದನ್ನೇ ಸೂಕ್ತವಾಗಿ ಹೇಳಿದರು, 5-6 ಸಲ ಭೇಟಿಯಾಗಿದ್ದಾರೆ ಅಂತ. ಈಗೂ ಸತೆಗೆ ಉತ್ತಮವಾದಂಥ ಸ್ಪಂದನ ಮಾಡಿ ಡ್ರಾಫ್ಟ್ ಮಾಡ್ಕೊಂಡು ಬಂದಿದ್ದೆ. ಆದರೆ ನಾವು ಪ್ರಾಮಾಣಿಕವಾದ ಪ್ರಯತ್ನ ಮಾಡಿ ಡಾಕ್ಟರ್ ಪ್ರೊಟೆಕ್ಷನ್ ಆ್ಯಕ್ಟ್ನಿಂದ ಹಿಡಿದು PCP ಆ್ಯಂಡ್ AT ಬಗ್ಗೆ ಈಗ ತಾನೇ ನಮ್ಮ ನಿಲುವು ಏನು ಅನ್ನೋದನ್ನು ನಮ್ಮ ನ್ಯಾಷನಲ್ ಪ್ರೆಸಿಡೆಂಟ್ ಎಲೆಕ್ಟ್ ಆಗಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ಅಶೋಕನ್ ಅವರು ನಿಮಗೆಲ್ಲ ತಿಳಿಸಿದ್ದಾರೆ. ಈ ಇದರಲ್ಲಿ ನಾವು ಭಾಳ ಎಲ್ಲ ಸರ್ಕಾರಿ ಅಧಿಕಾರಿಗಳನ್ನು, ಸರ್ಕಾರದ ಎಲ್ಲ ಮಾನ್ಯ ಸಚಿವರುಗಳನ್ನು ಭೇಟಿಯಾಗಿ ಕಾರ್ಯರೂಪಕ್ಕೆ ತರುವಲ್ಲಿ ಪ್ರಾಮಾಣಿಕ ಪ್ರಯತ್ನ ಮಾಡಿದ್ದೇವೆ. ಈಗಾಗಲೇ ನಮ್ಮ ಸೆಕ್ರೆಟರಿಯವರು ನಮ್ಮ ಅವಧಿಯಲ್ಲಿ ಆಗಿರ್ತಕ್ಕಂಥ ಅನೇಕಾರು ವಿಚಾರಗಳನ್ನು ಈಗಾಗಲೇ ತಿಳಿಸಿದರೆ ಅದನ್ನು ನಾನು ಹೆಚ್ಚಿಗೆ ಹೇಳಲಿಕ್ಕೆ ಇಷ್ಟಪಡಲ್ಲ. ನನ್ನ ಅವಧಿಯಲ್ಲಿ 9 ಸ್ಟೇಟ್ ವರ್ಕಿಂಗ್ ಕಮಿಟಿ ಆಗಿದೆ, 3 ಫಿಸಿಕಲ್ ಆಗಿದ್ದಾವೆ, 6 ವರ್ಚುವಲ್ ಆಗಿದೆ. ಹಾಗೆ ಸ್ಟೇಟ್ ಕೌನ್ಸಿಲ್ 4, ಇದು 4ನೇ ಕೌನ್ಸಿಲ್ಲು ಇಲ್ಲಿ ಬೀದರ್ನಲ್ಲಿ ನಡೆಯಿತು. ಮೊದಲನೇ ಸ್ಟೇಟ್ ಕೌನ್ಸಿಲು ಮೂಡುಬಿದಿರೆಯಲ್ಲಿ, ನಂತರ 2ನೇದು ಬೆಳಗಾವಿನಲ್ಲಿ, 3ನೇದು ವರ್ಚುವಲ್ಲು GST ಸಲುವಾಗಿ ನಡೆಯಿತು. ಅದನ್ನು ಈ ಸವಿಸ್ತಾರವಾಗಿ ಹೇಳುವಂಥ ಅವಶ್ಯಕತೆಯೇನು, ಏಕೆಂದರೆ ಟೈಮಿನ ಅಭಾವದಿಂದ ಸಂಕ್ಷಿಪ್ತವಾಗಿ ನಿಮಗೆಲ್ಲ ಹೇಳಲಿಕ್ಕೆ ಬಯಸ್ತೇನೆ. ಹಾಗೆ ನಮ್ಮ ಸೆಕ್ರೆಟರಿ ಹೇಳಿರೋದಂಗೆ ರಾಜಸ್ಥಾನದ ಪ್ರೊಟೆಸ್ಟ್ ಇರ್ಬೋದು, ಹಾಗೂ ಕೇರಳದ ಪ್ರೊಟೆಸ್ಟ್ ಇರ್ಬೋದು, ನಮ್ಮ ಕರ್ನಾಟಕ ರಾಜ್ಯವು ಯಾವ ರೀತಿ ಅಲ್ಲಿ ಪಾರ್ಟಿಸಿಪೇಟ್ ಮಾಡಿ ತನ್ನದೇ ಆದಂಥ ಒಂದು ಆ ಪ್ರೊಟೆಸ್ಟಿನ ಒಂದು ಪರಿಣಾಮ ಯಾವ ರೀತಿ ಪಾಸಿಟಿವ್ ಆಗಿ ಬಂದುತ್ತೆ ಅನ್ನೋದನ್ನ ಸವಿಸ್ತಾರವಾಗಿ ನಮ್ಮ ಸೆಕ್ರೆಟರಿ ಅವರು ನಿಮಗಾಗಲೇ ತಿಳಿಸಿದ್ದಾರೆ. ಹಾಗೆ ನಾವು ಅನೇಕಾರು ಕ್ಯಾಲೆಂಡರ್ ಆಫ್ ಈವೆಂಟ್ಸ್ಗಳನ್ನು ಅತ್ಯುತ್ತಮವಾಗಿ ನಡೆಸಿಕೊಂಡು ಬಂದಿದ್ದೇವೆ. ಹಾಗೆ ವೈದ್ಯ ದಿನಾಚರಣೆಯನ್ನು ಜುಲೈ 1 ನಾವು ಬೆಂಗಳೂರಿನಲ್ಲಿ ಬ್ರಿಮ್ಸ್ನಲ್ಲಿ ಮಾಡಿದೆವು. ಆವತ್ತಿನ ದಿವಸ ಸತೆಗೆ ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಸನ್ಮಾನ್ಯ ಸಚಿವರು ಕುಟುಂಬ ಕಲ್ಯಾಣ, ಆರೋಗ್ಯ ಮತ್ತು ಕುಟುಂಬ ಕಲ್ಯಾಣ ಕರ್ನಾಟಕ ಸರ್ಕಾರದವರು ಭಾಗವಹಿಸಿ ಕರ್ನಾಟಕದ ರಾಜೀವ್ ಗಾಂಧಿ ಯೂನಿವರ್ಸಿಟಿಯ ವೈಸ್ ಚಾನ್ಸಲರು MK ರಮೇಶ್ ಅವರು ಭಾಗವಹಿಸಿದರು. ಅತ್ಯುತ್ತಮವಾಗಿ ಸೇವೆಯನ್ನು ಮಾಡಿರ್ತಕ್ಕಂಥ ಸರ್ವತೋಮುಖ ಸಾಮಾಜಿಕವಾಗಿ, ಶೈಕ್ಷಣಿಕವಾಗಿ, ವೈದ್ಯಕೀಯವಾಗಿ IMA ಗೋಸತೆಗೆ ಸೇವೆಯನ್ನು ಸಲ್ಲಿಸಿದ 12 ಜನ ವೈದ್ಯರನ್ನು ಸನ್ಮಾನಿಸಲಾಯಿತು. ಹಾಗೆ ಇನ್ನು CGP ಬಗ್ಗೆ ಹೇಳಲಿಕ್ಕೆ ನಿಮಗೆಲ್ಲ ಗೊತ್ತಿರತಕ್ಕಂಥದ್ದೇ. ಈಗ ಗದಿನಲ್ಲಿ ಅದ್ಭುತವಾದಂಥ CGP ನ್ಯಾಷನಲ್ ಸೌತ್ ಝೋನ್ ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ ನಡೀತು. ಅಲ್ಲಿ 3 ಜನ ಮಿನಿಸ್ಟ್ರುಗಳು, ಲಾ ಮಿನಿಸ್ಟರ್, ಹೆಲ್ತ್ ಮಿನಿಸ್ಟರ್ ಆ್ಯಂಡ್ ಹೆಲ್ತ್ ಆ್ಯಂಡ್ ಫ್ಯಾಮಿಲಿ ಮಿನಿಸ್ಟ್ರು ಬಂದಿದ್ದು ನಿಮಗೆಲ್ಲ ಗೊತ್ತಿರತಕ್ಕಂಥದ್ದು. ಅದನ್ನು ಡಾಕ್ಟರ್ ಪವನ್ ಪಾಟೀಲ್ ಅವರ ತಂಡವರು ಅದ್ಭುತವಾಗಿ ನಡೆಸಿಕೊಟ್ಟರು. ಅವರಿಗೆ ನಾನು ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪರವಾಗಿ ಅನಂತ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತೇನೆ. ಹಾಗೆ AMSನ ಕಾನ್ಫರೆನ್ಸ್ ಜೊತೆಗೆ ತುಮಕೂರಿನಲ್ಲಿ ಆಗಸ್ಟ್ 9 ನಡೆಯಿತು. ಅಲ್ಲಿ ಡಾಕ್ಟರ್ JN ಪ್ರಭಾಕರ್ ಅವರ ನೇತೃತ್ವದಲ್ಲಿ ಆರ್ಗನೈಸಿಂಗ್ ಸೆಕ್ರೆಟರಿ ಆಗಿ ವೀರಭದ್ರಯ್ಯನವರು ಹಾಗೂ ತುಮಕೂರಿನ ಬ್ರ್ಯಾಂಚಿನ ಅಧ್ಯಕ್ಷರು, ಕಾರ್ಯದರ್ಶಿಗಳು ಹಾಗೂ ಗೌರವಾನ್ವಿತ ಎಲ್ಲ ವೈದ್ಯರನ್ನೊಳಗೊಂಡು ಅದ್ಭುತವಾದಂಥ ಯಾವುದೇ ಕಾನ್ಫರೆನ್ಸಿಗೆ ಕಡಿಮೆ ಇಲ್ಲದಂತೆ ಮಾಡಿರ್ತಕ್ಕಂಥ ಹೆಮ್ಮೆ ಮತ್ತು ಶ್ರೇಯಸ್ಸು ತುಮಕೂರು ಬ್ರಾಂಚ್ಗೆ ಸಲ್ಲುತ್ತದೆ. ಈ ಸಂದರ್ಭದಲ್ಲಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪರವಾಗಿ ನಾನು ಅವರಿಗೆ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತೇನೆ. ಹಾಗೆ ಅವತ್ತಿನ ದಿವಸ 9ನೇ ತಾರೀಕು ಸಾಯಂಕಾಲ ಗಂಗಾಧರಯ್ಯ ಮೆಮೋರಿಯಲ್ ಹಾಲ್ನಲ್ಲಿ ನಮ್ಮ ವೈದ್ಯರ ದಿನಾಚರಣೆ, ಶಿಕ್ಷಕರ ದಿನಾಚರಣೆಯನ್ನು ಆಚರಿಸಲಾಯಿತು. ಅಲ್ಲಿ 15 ಜನ ವೈದ್ಯರನ್ನು, ಅದ್ಭುತವಾದ ಸೇವೆ ಮಾಡಿರ್ತಕ್ಕಂಥ ವೈದ್ಯರನ್ನು ಅಲ್ಲಿ ಸನ್ಮಾನಗೊಳಿಸಲಾಯಿತು. ಹಾಗೂ ಅಲ್ಲಿ ಮಾಡಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ಕಾರ್ಯಕ್ರಮಗಳು ಅದ್ಭುತವಾಗಿದ್ದಾವೆ. ಅದಕ್ಕೋಸ್ಕರ ಮತ್ತೊಮ್ಮೆ ತುಮಕೂರಿನ ಎಲ್ಲ ವೈದ್ಯರಿಗೂ ಅವರ ಶಾಖೆಯ ಎಲ್ಲ ಗೌರವಾನ್ವಿತ ಪದಾಧಿಕಾರಿಗಳಿಗೂ ಮತ್ತೊಮ್ಮೆ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತಾ, ಇನ್ನು ಕನ್ನಡ ವೈದ್ಯ ಬರಹ ಬಳಗದ ವೈದ್ಯ ಸಮಿತಿಯ ಪರವಾಗಿ 4ನೇ ವೈದ್ಯಕೀಯ ಸಮ್ಮೇಳನ 2 ಮತ್ತು 3 ಸೆಪ್ಟೆಂಬರ್ರಂದು ಶಿವಮೊಗ್ಗದಲ್ಲಿ ಅದ್ಭುತವಾಗಿ ನಡೀತು. ಕಾರ್ಯಾಧ್ಯಕ್ಷರಾಗಿ ಶ್ರೀ ಡಾಕ್ಟರ್ ಶ್ರೀಧರ್ ರವರು ಸರ್ವಾಧ್ಯಕ್ಷರಾಗಿದ್ದರು. ಡಾಕ್ಟರ್ ಶಿವಾನಂದ್ ಕುಬಸೋದವರ ಅಧ್ಯಕ್ಷತೆಯಲ್ಲಿ ಅದ್ಭುತವಾಗಿ ನಡೀತು. ಇನ್ನು ಅದು ನಮ್ಮ ಮನಸ್ಸಿನಲ್ಲಿ ಚಿರಸ್ಥಾಯಿಯಾಗಿದೆ. ಅವರಿಗೂ ನಾನು ಅನಂತ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತೇನೆ. ಹಾಗೆ ಈಗ ನಿಮಗೆ ಗೊತ್ತಿದ್ದಂತೆ ಈಗ ತಾನೇ ಹೇಳ್ತಾ ಇದ್ರು, ವುಮನ್ ಡಾಕ್ಟರ್ಸ್ ವಿಂಗು ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಈಗಾಗಲೇ 8 ಹೊಸ ವುಮನ್ ಡಾಕ್ಟರ್ಸ್ ವಿಂಗನ್ನು ಪ್ರಾರಂಭ ಮಾಡಿದ್ದೇವೆ. ಮೊನ್ನೆ ತಾನೇ ದಾವಣಗೆರೆಯಲ್ಲಿ ಒಂದು ವುಮನ್ ಡಾಕ್ಟರ್ಸ್ ವಿಂಗ್ ಪ್ರಾರಂಭ ಆಯಿತು. ಹಾಗೆ ಅಲ್ಲಿ ವುಮನ್ ಡಾಕ್ಟರ್ಸ್ ವಿಂಗಿನ ಸಮ್ಮೇಳನವನ್ನು ಗಂಗಾವತಿಯಲ್ಲಿ ಅದ್ಭುತವಾಗಿ ಮಾಡಿದರು, ಆಯೋಜಿಸಲಾಗಿತ್ತು. ಕಾರ್ಯದರ್ಶಿಗಳಾಗಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಗಂಗಾವತಿ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರು, ಕಾರ್ಯದರ್ಶಿಯವರು, ಆರ್ಗನೈಜಿಂಗ್ ಚೇರ್ಮನ್ರಾಗಿ ಡಾಕ್ಟರ್ ಸುಲೋಚನಾ ಚಿನಿವಾಲರವರು ಮತ್ತು ಸೆಕ್ರೆಟರಿಯಾಗಿ ಡಾಕ್ಟರ್ ಅನಿತಾರವರು, ಅಲ್ಲಿಯ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಶಾಖೆಯ ಮಧುಸೂದನ್ KN ಹಾಗೂ ಪಟ್ಟಣ್ ಶೆಟ್ಟಿ ಅವರು ಹಾಗೂ ಅವರ ತಂಡ ಅದ್ಭುತವಾಗಿ ಡಾಕ್ಟರ್ ಮಧುಸೂದನ್ ಕಾರ್ಯಜ್ಞರವರ ಮಾರ್ಗದರ್ಶನದಲ್ಲಿ ಅಲ್ಲಿ ವಿಶೇಷತೆ ಏನೆಂದರೆ ಯಾವುದು ಪ್ಲಾಸ್ಟಿಕ್ ಬಳಸದೆ ಪೇಪರ್ಲೆಸ್ ಒಂದು ಅದ್ಭುತವಾದಂಥ ಒಂದು ಸಮ್ಮೇಳನವನ್ನು ನಡೆಸಿದರು. ಹಾಗೆ ಆಹಾರಗಳನ್ನು ಯಾವ ಥರ ವೇಸ್ಟ್ ಮಾಡಬಾರ್ದು ಅನ್ನೋ ಸ್ಲೋಗನ್ನಿಂದ ಚಾಚು ತಪ್ಪದೆ ಎಲ್ಲದನ್ನು ಅಳವಡಿಸಿಕೊಂಡು ಮಾಡಿರ್ತಕ್ಕಂಥ ಸಮ್ಮೇಳನದ ಒಂದು ಶ್ರೇಯಸ್ಸಿಗೆ ಭಾಗಿಯಾಗಿರೋದು ನಾನು ಗಂಗಾವತಿ ಶಾಖೆಯವರಿಗೆ ಈ ನಿಟ್ಟಿನಲ್ಲಿ ಅನಂತ ಧನ್ಯವಾದಗಳನ್ನು ಹೇಳುತ್ತೇನೆ. ಹಾಗೂ ಸೋಮಣ್ಣ ಮೆಮೋರಿಯಲ್ ಶಟ್ಲ್ ಬ್ಯಾಡ್ಮಿಂಟನ್ ಮಂಗಳೂರಿನಲ್ಲಿ ಅದ್ಭುತವಾಗಿ ನಡೆದದ್ದು ನಿಜವಾಗಲೂ ಚಿರಸ್ಮರಣೀಯ. 100ಕ್ಕೂ ಹೆಚ್ಚು ತಂಡಗಳು ಭಾಗವಹಿಸಿದ್ದವು. ಡಾಕ್ಟರ್ ವೇಣುಗೋಪಾಲ್ ಹಾಗೂ ಡಾಕ್ಟರ್ ಅಚ್ಯುತ್ ಬೋಲಾರ್ ಅವರ ನೇತೃತ್ವ, ಮಂಗಳೂರು ಶಾಖೆಯ ಎಲ್ಲ ವೈದ್ಯರ ಪರಿಶ್ರಮದಿಂದ 300ಕ್ಕೂ ಹೆಚ್ಚಿನ ಸಂಖ್ಯೆಯಲ್ಲಿ ವೈದ್ಯರು ಭಾಗಿಯಾಗಿದ್ದರು. ಅವರಿಗೂ ನಾನು ಅಭಿನಂದನೆ ತಿಳಿಸ್ತೇನೆ. ನನ್ನ ಅವಧಿಯಲ್ಲಿ 12 RGSS ಮೀಟಿಂಗನ್ನು ಅಟೆಂಡ್ ಆಗಿದ್ದೇನೆ. ಅಲ್ಲಿ ನಮ್ಮ ವೈದ್ಯರ, ನಮ್ಮ MS ವಿದ್ಯಾರ್ಥಿಗಳ, PG ಸ್ಟೂಡೆಂಟ್ಸ್ಗಳ ತೊಂದರೆಗಳು ಹಾಗೂ ನಾವು ಏನು ನಮ್ಮ ವೈದ್ಯರ ಮೇಲೆ ಅದು ಕರಿಕ್ಯುಲಮ್ ಆಗ್ಬೋದು, ಸಬ್ಜೆಕ್ಟ್ ಇಶ್ಯೂಸ್ ಆಗ್ಬೋದು, ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿರ್ತಕ್ಕಂಥ ತೊಂದರೆಗಳು, ನರ್ಸಿಂಗ್ ಕಾಲೇಜು, ಪ್ಯಾರಾಮೆಡಿಕಲ್ ಅಲೈಡ್ ಸೈನ್ಸ್, ಇವರೆಲ್ಲ ವಿಷಯಗಳನ್ನು ಸವಿಸ್ತಾರವಾಗಿ ತಿಳಿಸಿದೆ. ಕೆಲವು ವಿಚಾರಗಳಿಗೆ ಸ್ಪಂದಿಸಿದ ರಾಜೀವ್ ಗಾಂಧಿ ಯೂನಿವರ್ಸಿಟಿಯವರು ಕಾರ್ಯರೂಪಕ್ಕೆ ಕೆಲವು ವಿಚಾರಗಳನ್ನು ತರಲಿಕ್ಕೆ ಪ್ರಾಮಾಣಿಕ ಪ್ರಯತ್ನವನ್ನು ಮಾಡಿದ್ದೇನೆ. ಈಗಾಗಲೇ ತಿಳಿಸಿದಂತೆ 150ಕ್ಕೂ ಹೆಚ್ಚಿನ ಶಾಖೆಗಳನ್ನು ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಮಾಡಿದ್ದು, ಈಗಾಗಲೇ ಹೇಳಿದರು 74 ವಯಸ್ಸೇ ಇರತಕ್ಕಂಥ ಡಾಕ್ಟರ್ 150ಕ್ಕೂ ಹೆಚ್ಚಿನ ಶಾಖೆಯನ್ನು ಅವರು ಭೇಟಿ ಕೊಟ್ಟಿದ್ದಾರೆ ಅಂತಂತಂದರೆ ಹೇಗೆ ಅಂತ ನಾನೀಗ ಹೇಳ್ತಿದ್ದೆ. ಆಗ ಬೆಳಗ್ಗೆಯಿಂದ ನನಗೆ 74 ಅಲ್ಲ 47 ಅಂತ ಹೇಳ್ತಿದ್ದೆ. ಎಲ್ಲರೂ ಹಾಸ್ಯಾಸ್ಪದವಾಗಿ ಹೇಳ್ತಿದ್ರು. ನಿಜವಾಗ್ಲೂ ಇದೆಲ್ಲ ನಿಮ್ಮ ಪ್ರೀತಿ ಸಹಕಾರ, ಅದರ ಫಲವಾಗಿ ನಾನು ಇಷ್ಟು ಕಾರ್ಯಗಳನ್ನು ಮಾಡಲಿಕ್ಕೆ ಅನುವಾಯಿತು ಅಂತ ಹೇಳ್ತಾ, ಒಟ್ಟು ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಹೊಸದಾಗಿ ಕಟ್ಟಡಗಳನ್ನು ಉದ್ಘಾಟನೆ ಮಾಡಿದ್ದು ಬೆಂಗಳೂರಿನ ಶಾಖೆ ಅದ್ಭುತವಾದ ಕಟ್ಟಡವನ್ನು ಮಾಡಿದ್ದಾರೆ. ಅಲ್ಲಿನ ಅಧ್ಯಕ್ಷ ಇರ್ತಕ್ಕಂಥ ಈಗ ನಮ್ಮಲ್ಲಿ ಬಂದಿದ್ದಾರೆ, ಅವರು ಸತೆಗೆ ಇಲ್ಲಿ ಗೌರವ ಸ್ವೀಕಾರ ಮಾಡಲಿಕ್ಕೆ ಇಲ್ಲಿ ಆಯೋಜಿಸಿದ್ದಾರೆ. ಹಾಗೆ ಅನೇಕಾರು ಶಾಖೆಗಳನ್ನು ವಿನ್ಯಾಸಗೊಂಡಿರ್ತಕ್ಕಂಥ ಬಳ್ಳಾರಿ ಆಗಿರ್ಬೋದು, ಗಂಗಾತೀಯವಾಗಿರ್ಬೋದು ಇನ್ನೆಲ್ಲ ಉದ್ಘಾಟನೆ ಮಾಡಲಾಗಿದೆ. ಇನ್ನೂ ಹೆಚ್ಚಿನ ವಿಷಯಗಳನ್ನು ತಗೊಳ್ಳದೆ ಹೊಸದಾಗಿ ಶಾಖೆಯನ್ನು ಹೊಳಲ್ಕೆರೆಯಲ್ಲಿ ಮಾಡಿದ್ದೇವೆ. ಇನ್ನು ಕೆಲವೇ ದಿವಸದಲ್ಲಿ HSR ಲೇಔಟ್ ಮತ್ತು ಬಾಲ್ಕೆ ಶಾಖೆಯನ್ನು ಉದ್ಘಾಟನೆಯನ್ನು ಕೆಲವೇ ದಿನದಲ್ಲಿ ಜಾಗ ಆದಂಥ 4.5 ಎಕರೆ ಜಮೀನಿನಲ್ಲಿ ಎಣ್ಣೆ ಆದಂಥ ಲ್ಯಾಂಡ್ನಲ್ಲಿ ಮಾಡಿಸಿದ್ದು ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಆದ ಮಾಡದ ಕೆಲಸ. ಹಾಗೂ ಪ್ರತಿ ತಿಂಗಳು ಅದರ ವಿವರ ನಾನು ಏನು ಹೇಳಕ್ಕೆ ಬಿಡಲ್ಲ, ಅದು ನಿಮ್ಮ ಆಸ್ತಿ, ನಿಮಗೆಲ್ಲರಿಗೂ ಹೆಮ್ಮೆ. ಅಲ್ಲಿ ಮೀಟಿಂಗ್ ಮಾಡಿದ ಜೊತೆಗೆ ನಮಗೆ ಭಾಳ ಸಂತೋಷ ಸಂಗತಿ. ಪ್ರತಿ ತಿಂಗಳು 23ರಂದು ಅಧ್ಯಕ್ಷರ ಮಾತುಗಳನ್ನು ನೀವು ಕೇಳ್ತಾ ಇದ್ದೀರಿ. ನಾವು ಮಾತಿನಿಗಿಂತ ನೀವು ಇಂಟ್ರ್ಯಾಕ್ಟ್ ಮಾಡಿ ನಮ್ಮ ಸಮಸ್ಯೆಗಳನ್ನು ಬಗೆಹರಿಸಲಿಕ್ಕೆ ಪ್ರಾಮಾಣಿಕವಾದ ಪ್ರಯತ್ನ ಮಾಡಿದೆವು. ಹಾಗೂ ಕ್ಯಾಲೆಂಡರ್ ಪುಸ್ತಕವನ್ನು ಬಿಡುಗಡೆಗೊಳಿಸಿದ್ದು. ಹಾಗೆ ಅಲ್ಲದೆ IMAಯಲ್ಲಿ ಕ್ಯಾಂಟೀನನ್ನು ಪ್ರಾರಂಭಿಸಿದ್ದು, ವಿದ್ಯಾರ್ಥಿಗಳಿಗೆ ಅನುಕೂಲ ಆಗಲಿಕ್ಕೆ ಲೈಬ್ರರಿಯನ್ನು ಹೆಚ್ಚಿನ ಅನುಕೂಲತೆಗಳನ್ನು ಮಾಡಿ 300ಕ್ಕೂ ಹೆಚ್ಚು ವಿದ್ಯಾರ್ಥಿಗಳು ಅಲ್ಲಿ ಓದುತ್ತಿದ್ದಾರೆ. ಹಾಗೂ ವೈದ್ಯರಿಗೆ ಅನುಕೂಲವಾಗುವ ನಿಟ್ಟಿನಲ್ಲಿ ಸಾಫ್ಟ್ವೇರ್ ಅನ್ನು ಪ್ರಾರಂಭ ಮಾಡಿ ಈಗ ತಾನೇ ನೀವು ಅದನ್ನು ನೋಡಿದ್ದೀರಿ. ಅದು ನಿಜವಾಗ್ಲೂ ನಮ್ಮ ಕರ್ನಾಟಕನೇ ಮೊಟ್ಟ ಮೊದಲ ರಾಜ್ಯ ಸಾಫ್ಟ್ವೇರ್ ಫಾರ್ ಡಾಕ್ಟರ್ಸ್ ಕೊಟ್ಟಿರ್ತಕ್ಕಂಥದ್ದು. ಅದು ನಮ್ಮ ನ್ಯಾಷನಲ್ ಪ್ರೆಸಿಡೆಂಟಿಂದ ಉದ್ಘಾಟನೆವಾಗಿದ್ದು ನಿಜವಾಗ್ಲೂ ಇದು ಸ್ಮರಣೀಯ. ಹಾಗೂ ಕರ್ನಾಟಕ ಮೆಡಿಕಲ್ ಜರ್ನಲ್ ಕೂಡ ಬೆಳಗ್ಗೆಯನ್ನು ಇನ್ನು ಗೌರವಾನ್ವಿತ ನಮ್ಮ ಶರಣಪ್ರಕಾಶ್ ಪಾಟೀಲ್ ಸನ್ಮಾನ್ಯ ಮಂತ್ರಿಯವರುಗಳಿಂದ ಉದ್ಘಾಟನೆ ಆಗಿದ್ದು ನೀವೆಲ್ಲ ಸಾಕ್ಷಿಭೂತರಾಗಿದ್ದೀರಿ. ಅವರಿಗೂ ನಾನು KMG ಜರ್ನಲಿನ ಎಡಿಟರ್ ಆದಂತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಮಲ್ಕೆ ಪಾಟೀಲ್ರಿಗೂ, ಡಿಜಿಟಲ್ ಸ್ಟಾಫ್ ಸೇರಿನ ಸತತ ಪ್ರಯತ್ನದ ಜಸ್ಪಾಲ್ ಸಿಂಗ್ ಅವರ ಪ್ರಯತ್ನದಿಂದ ಅವರ ಟೀಮಿನಿಂದ ಆಗಿದ್ದಕ್ಕೆ ಅವರಿಗೂ ನನ್ನ ಅನಂತನಾದ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತೀನಿ. ಹಾಗೆ GST ಬಗ್ಗೆ ನಾನು ಸವಿಸ್ತಾರವಾಗಿ ಏನು ಹೇಳೋಕ್ಕೆ ಇಷ್ಟಪಡೋದಿಲ್ಲ, ಸಾಕಷ್ಟು ವಿಚಾರಗಳನ್ನ ಹೇಳಿದರೆ. ಅದರಲ್ಲಿ ಮೊಟ್ಟ ಮೊದಲನೇದಾಗಿ ನಾನು ಪ್ರಾಮಾಣಿಕವಾಗಿ ಹೇಳುವುದಂತಂದರೆ GSTಯನ್ನು ತುಂಬಿದಂಥ ಮೊಟ್ಟ ಮೊದಲ ರಾಜ್ಯ ಅಂದರೆ ಕರ್ನಾಟಕ ಅಂತ ಹೇಳ್ತಾ, ಹಾಗೂ ಇದಕ್ಕೆ ಸತತವಾಗಿ ಪ್ರಯತ್ನ ಮಾಡಿದ ಎಲ್ಲ ನನ್ನ ಹಿರಿಯ ವೈದ್ಯರುಗಳನ್ನು ಅಭಿನಂದಿಸ್ತೇನೆ. ಅದರಲ್ಲಿ ಹೆಚ್ಚಾಗಿ ಡಾಕ್ಟರ್ YC ಯೋಗಾನಂದ ರೆಡ್ಡಿ ಅವರು GST ಬಗ್ಗೆ ಮಾಡಿರ್ತಕ್ಕಂಥ 15 ದಿವಸದ ಸತತ ಹೋರಾಟ ಇನ್ನೂ ನಮ್ಮ ಕಣ್ಣು ಮುಂದೆ ಇದೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಎಲ್ಲ ವೈದ್ಯರು ಸಹಕಾರ ಮಾಡಬೇಕು. ತಲಾ 1,86,00,000 ರೂಪಾಯಿಯನ್ನು GSTಯನ್ನು ತುಂಬಿದ್ದೀವಿ. ಎಲ್ಲ ವೈದ್ಯರು ಪ್ರಾಮಾಣಿಕವಾಗಿ 700 ರೂಪಾಯಿ ಕಪಲ್ 1,100 ರೂಪಾಯಿನ ಕಾಂಟ್ರಿಬ್ಯೂಟ್ ಮಾಡಬೇಕು ಅಂತ ಕೇಳಿಕೊಂಡಾಗ 30% ಹೆಚ್ಚು ಅಮೌಂಟ್ ಈಗಾಗಲೇ ಸಂದೇಹವಾಗಿದೆ. ನಿಮಗೆ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪರವಾಗಿ ಅಭಿನಂದನೆಗಳನ್ನು, ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತೇನೆ. ಹಾಗೂ KSSನ್ನು ಸಂಪೂರ್ಣ ಡಿಜಿಟಲೈಸೇಷನ್ ಮಾಡಿದ್ದು, ಅದನ್ನು ಅಭಿವೃದ್ಧಿಗೆ ಪ್ರಾಮಾಣಿಕ ಪ್ರಯತ್ನ ಮಾಡಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಯೋಗಾನಂದ ರೆಡ್ಡಿಗೂ ನನ್ನ ಅನಂತ ಧನ್ಯವಾದಗಳು. ಹಾಗೂ ಈಗ ತಾನೇ ಹೇಳಿದಂಗೆ ಫೋಕಸ್ ಅತ್ಯುತ್ತಮವಾಗಿ ಮೂಡಿ ಬಂದಿರತಕ್ಕಂಥದ್ದು ನಿಮ್ಮೆಲ್ಲ ಮನಗಂಡಿದ್ದಾರೆ. ಅವರ ಎಡಿಟರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಶಂಕರನಾಡ ಅವರಿಗೂ ನಾನು ಈ ಸಂದರ್ಭದಲ್ಲಿ ಅಭಿನಂದನೆ ತಿಳಿಸ್ತೇನೆ. ಹಾಗೂ ಹೀಗೆ 10 ಹಲವಾರು ಕೆಲಸಗಳನ್ನು ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಮಾಡಿದ್ದೇನೆ. ಇನ್ನೂ ಕೆಲವು ವಿಚಾರಗಳನ್ನು ಹಂಚಿಕೊಳ್ಳಲಿಕ್ಕೆ ಸಮಯಾಭಾವದಿಂದ ನಾನು ನನ್ನ ಮಾತುಗಳನ್ನು ಮೊಟಕುಗೊಳಿಸುತ್ತಾ, ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಎಡೆಬಿಡದೆ ಬೆಂಬಲಿಸಿ ಸಹಕರಿಸಿ ಮಾರ್ಗದರ್ಶನ ಮಾಡಿದ ಡಾಕ್ಟರ್ ಹೊನ್ನೇಗೌಡ, YC ಯೋಗಾನಂದ ರೆಡ್ಡಿ, ಮಧುಸೂದನ್ ಕಾರಿಗ್ನೂರ್ ಇವರಿಗೆ ವಿಶೇಷವಾದ ನನ್ನ ಅನಂತನಾಥ ಧನ್ಯವಾದಗಳು. ಹಾಗೂ ನನ್ನ ಕಾರ್ಯದರ್ಶಿಯಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕರುಣಾಕರ್, ಖಜಾಂಚಿ ಆಗಿರ್ತಕ್ಕಂಥ ವಿಜಯಸಾರಥಿ, ಡಾಕ್ಟರ್ ಪವನ್ ಪಾಟೀಲ್ PRO ಹಾಗೂ ಡಾಕ್ಟರ್ LD ಬಾಕ್ಲೆ ಹಾಗೂ ನನ್ನ ನಂತರ ನನ್ನ ಅಧಿಕಾರಾವಧಿ ನಂತರ ಅಧ್ಯಕ್ಷರಾಗಿ ತೆಗೆದುಕೊಳ್ಳಲಿರುವ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ S ಅವರಿಗೆ ಶುಭ ಕೋರುತ್ತೇನೆ. IMEಯ ಯಶಸ್ಸಿಗಾಗಿ ನಾವೆಲ್ಲರೂ ಸದಾ ನಿಮ್ಮ ಜೊತೆ ಇರುತ್ತೇವೆ ಎಂದು ತಿಳಿಸುತ್ತೇನೆ. ನಿಮ್ಮ ಈ ಅವಧಿಯಲ್ಲಿ ಇನ್ನೂ ಹೆಚ್ಚಿನ ಕೆಲಸಗಳು ಆಗಲಿ, ವೈದ್ಯರ ಒಂದು ಎಲ್ಲ ಶ್ರೇಯೋಭಿವೃದ್ಧಿಗೆ ಇರತಕ್ಕಂಥ ಕಾನೂನು ತೊಡಕುಗಳು ಎಲ್ಲ ಯಶಸ್ವಿಯಾಗಿ ಬಗೆಹರಿಲಿ ಅಂತ ತಿಳಿಸ್ತಾ, ನನ್ನ ಅವಧಿಯಲ್ಲಿ ನಿರಂತರ ಸೇವೆಯನ್ನು ಮಾಡಿದ ನಮ್ಮ ಆಫೀಸಿನ ಸಿಬ್ಬಂದಿ, ಮ್ಯಾನೇಜರ್ ಆಗಿರ್ತಕ್ಕಂಥ ಶ್ರೀ ಅಶ್ವಥ್ ನಾರಾಯಣ್, ಅಕೌಂಟೆಂಟ್ ಆಗಿರ್ತ ರವಿಕಿರಣ್, ಡ್ರೈವರ್ ವೆಂಕಟೇಶ್ ಹಾಗೂ ಪುಟ್ಟಸ್ವಾಮಿ, ದಾಮೋದರ್ ಹಾಗೂ ಮಹಿಳಾ ಸಿಬ್ಬಂದಿಯವರಿಗೆ ನನ್ನ ಅನಂತ ಧನ್ಯವಾದಗಳು. ಈ ಸಮ್ಮೇಳನವನ್ನು ಅಚ್ಚುಕಟ್ಟಾಗಿ ನಡೆಸಿಕೊಡುತ್ತಿರುವ ಬೀದರಿನ ನನ್ನ ಹೆಮ್ಮೆಯ ಎಲ್ಲ ವೈದ್ಯ ಮಿತ್ರರನ್ನು ಮತ್ತೊಮ್ಮೆ ನಾನು ಹೃತ್ಪೂರ್ವಕವಾಗಿ ಅಭಿನಂದಿಸ್ತೇನೆ. ಕಾರಣ ನೀವೆಲ್ಲ ಗಮನಿಸಿದ್ದೀರಿ, ನಿನ್ನೆಯಿಂದ ಎಷ್ಟು ಸುಂದರವಾಗಿ ನಮ್ಮನ್ನು ಬರಮಾಡಿಕೊಳ್ಳೋದಿರ್ಬೋದು, ಆದರ ಆತಿಥ್ಯ ಇರ್ಬೋದು, ಸೈಂಟಿಫಿಕ್ ಸೆಷನ್ ಇರ್ಬೋದು, ವಿವಿಧ ಕಾರ್ಯಕ್ರಮಗಳಿರ್ಬೋದು, ಎಲ್ಲವನ್ನು ಅಚ್ಚುಕಟ್ಟಾಗಿ ಇಷ್ಟು ಸುಂದರವಾದಂಥ ಈ ಒಂದು ಬ್ರಿಮ್ಸಿನ ಆವರಣದಲ್ಲಿ ಉತ್ತಮವಾದಂಥ ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಕೊಟ್ಟಿದ್ದಕ್ಕೆ ನಾವು ಅನಿತಿತ್ತು. ನಾರ್ತ್ ಕರ್ನಾಟಕದಲ್ಲಿ ಮೊದಲನೇದಾಗಿ ಸಮ್ಮೇಳನ ನಡೆಯುತ್ತಿದೆ, ಹೇಗೆ ನಡೆಯುತ್ತಿದೆ ಅಂತ ಅವರಿಗೂ ಆತಂಕ ಇರ್ತಿತ್ತು. ನಾವು ಮತ್ತು ಯೋಗ ರೆಡ್ಡಿ ಅವರು, ಮಧುಸೂದನ ಕಾರಿಗ್ನವರವರು ಅನೇಕ ಸಲ 5-6 ಸಲ ಇಲ್ಲಿ ಬಂದೋಗಿದ್ದೀವಿ. ಅನ್ನಿಸ್ತು ನಮಗೆ ನಿಜವಾಗ್ಲೂ ಅವರ ಉತ್ಸಾಹ, ಅವರಲ್ಲಿರ್ತಕ್ಕಂಥ ಒಂದು ಕಾರ್ಯಕ್ಷಮತೆ, ಕನ್ಸರ್ನ್ ಏನಿತ್ತು ಅದು ಇವತ್ತು ಫಲವಾಗಿ ಬಂದು ಈ ಥರ ಒಂದು ಉತ್ತಮವಾದಂಥ ಸಮ್ಮೇಳನ ಮಾಡಿದರೆ ನಮ್ಮ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪರವಾಗಿ ನಿಮ್ಮೆಲ್ಲರಿಗೂ ಅನಂತ ಧನ್ಯವಾದಗಳನ್ನು ತಿಳಿಸ್ತೇನೆ. ಹಾಗೂ ನನ್ನ ಒಂದು ವರ್ಷದ ಅವಧಿಯಲ್ಲಿ ಸಹಕರಿಸಿದ ನನ್ನ ಧರ್ಮಪತ್ನಿ ಶ್ರೀಮತಿ ಚಂದ್ರಕಲಾ ಲಕ್ಕೋಳ್ ಹಾಗೂ ಡಾಕ್ಟರ್ ತ್ರಯಂಬಕೇಶ್ವರನ್ನ ಮರೆಯಲಾಗುವುದಿಲ್ಲ. ಕಾರಣ ನಾನು ಊರಿನಲ್ಲಿದ್ದಿದ್ದೇ ಭಾಳ ಕಡಿಮೆ, 12 ತಿಂಗಳಲ್ಲಿ ಒಂದು 7-8 ದಿವಸ ಇರ್ಬೋದು ಅಷ್ಟೇ. ನನ್ನ ಸೇವೆಯಿಂದ ವಂಚಿತರಾಗಿರುವ ನನ್ನ ರೋಗಿಗಳಿಗೂ ಆಪ್ತರಿಗೂ ಕ್ಷಮೆ ಕೋರುತ್ತೇನೆ. ಹಾಗೂ ನನ್ನ ಅವಧಿಯಲ್ಲಿ ಏನಾದರೂ ಮಾತು ಮತ್ತು ಕೆಲಸದಲ್ಲಿ ತಿಳಿಯದೆ ಆದ ತಪ್ಪುಗಳಿಗೆ ಕ್ಷಮೆಯನ್ನು ಯಾಚಿಸುತ್ತಾ ಈ ಮೆಡಿಕಾನ್ 89 ಸಮ್ಮೇಳನವು ಯಶಸ್ವಿಯಾಗಿ ನಡೆಯಲೆಂದು ಹಾರೈಸುತ್ತೇನೆ. ನಮಸ್ಕಾರಗಳು. ಒಗ್ಗಟ್ಟಿನಲ್ಲಿ ಬಲವಿದೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಚಿರಾಯವಾಗಲಿ. ಜೈ ಕರ್ನಾಟಕ. ನಮಸ್ಕಾರ.
ನಿರ್ಗಮಿತ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಲಕ್ಕೋಳ್ ರವರು ತಮ್ಮ ಅಧ್ಯಕ್ಷೀಯ ಸ್ಥಾನವನ್ನು ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಎಸ್ ಇವರಿಗೆ ಹಸ್ತಾಂತರಿಸಬೇಕಾಗಿ ಮನವಿ ಮಾಡಿಕೊಳ್ಳುತ್ತೇವೆ. ಧನ್ಯವಾದಗಳು ಸರ್.
Next, it's our privilege to invite
ಎಲ್ಲ ಉಪಾಧ್ಯಕ್ಷರು ಕೂಡ ತಮ್ಮ ಸ್ಥಾನಗಳನ್ನು ಅಲಂಕರಿಸಬೇಕಂತ ಕೇಳ್ಕೊಳ್ತೀನಿ. ಇನ್ಕಮಿಂಗ್ ವೈಸ್ ಪ್ರೆಸಿಡೆಂಟ್ಸ್ ಪ್ಲೀಸ್ ಆಕ್ಯುಪೈ ದ ಫ್ರಂಟ್ ಸೀಟ್ಸ್. ಐ ರಿಕ್ವೆಸ್ಟ್ ಡಾಕ್ಟರ್ ಕಿರಣ್ ದೇಶ್ಮುಖ್, ರಾಜಗೋಪಾಲ್ ಶೆಟ್ಟಿ ಪ್ಲೀಸ್. The outgoing presidents, vice presidents, we thank you.
Next, it's our privilege to invite our newly installed IMA KSB President, Dr. Srinivasa S. Sir, to address the gathering and to give his valuable inputs for the development of IMA. Dr. Srinivasa S. Sir has pursued MBBS from WIMS Bidar Medical College, further pursued MD in Pediatrics from MRMC Gulbarga. Also a former professor and HOD Pediatrics KIMS Bengaluru, President IMA Bengaluru Branch 2018, President IAP Bengaluru 2019, Secretary IMA Karnataka State, CIAP EB member 2014. He has also got 40 publications to his name, 25 international and 15 national. Here is our new president of IMA Karnataka State for you.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. So dignitaries on the dais and dignitaries off the dais. respected inaugurators of 89th MEDICON 2023 of IMA KSB, the Honorable Minister, Forest, Ecology and Environment, and also District in Charge Minister, Karnataka Government, Sri Ishwar Khandre Sir, we are very thankful to you for inaugurating our 39th State MEDICON. And until now you are be there, we are very fortunate to have you, sir. And we are very, very extremely grateful and thankful to you, sir. I also thankful to our Health and Family Welfare Minister, Dr. Dinesh Gundu Rao, for gracing this program. Since he has to be leave for some other work, he left. We are very, very thankful to him also. I welcome our National IMA President-elect, Dr. R.B. Ashokan, who came all the way from Kerala to grace the new team of IMA KSP. So he is very honest and very sincere and very regular, and IMA work means he is ready to do anything. That is the Dr. Ashokan sir. My sincere thanks to Dean and Director of Bidar Institute of Medical Sciences, Dr. Shivkumar Shetkar, for his great contribution in conducting this conference. At the outset, I would like to thank our esteemed members of IMA and particularly State and Central Council members for having unanimously elected me and my team to Karnataka State. In continuation of hard work done by previous President, Dr. Shivkumar Lakol, I would like to lead IMA KSP to greater heights. I extend my warm welcome to Honorable State Secretary B.P. Karunakara, Treasurer Vijay Sarathi, Joint Secretary Dr. Anita, and National Joint Secretary Dr. Ventar Chalapati, and AKN Sinha Director Dr. Prabhakar Chian, and our new President-elect Dr. Chiniwal. I also welcome outgoing Vice President of our IMA KSB, Dr. Prasanna Shankar, Dr. Rajashri Anugol, Dr. Narayan Murthy, and Dr. Shailesh Amarked, and our PRO, Dr. Pawan Kumar Patil, and also incoming Vice Presidents, Dr. Pawan Kumar Patil, Dr. Kiran Deshmukh, Dr. Rajgopal Shetty, and PRO, Dr. Devadas. I expect complete and honest cooperation from my office bearers and esteemed members to achieve our goal. I welcome all the past presidents of IMA KSB, especially Dr. Honegowda, who is mentor and advisor to me all the time. And also Dr. Yoganand Reddy is a protocol officer of this MEDICON, whose role is very immense in conducting this conference. He has done a lot of work to bring this conference to the present state. Dr. Madhusudan Karignur, young and dynamic and past president, who is ready to do any work for the welfare of IMA. I really a pleasure to work with them, who knows how to make a friendly and inspiring work environment. Their dedication, enthusiasm, and insight are really inspiring. I take this opportunity to congratulate IMA Bidar, led by President Vaidyanath Madna, the organizing team, sponsors, delegates, principal, staff, students, and administrators of the Bidar Institute of Medical Sciences for the strong sense of commitment, service, and responsibility that has transferred this conference into a temple of learning led by organizing chairpersons Dr. Chintakad Guduge, Dr. Vajashri Bachetti, and Secretary Mallikarjun Panshetty. He is a very, very active personality. Almost in 7 or 8 months, he is working very hard in success of this conference. And our seniors like Anuma Shetty and my good friend, classmate, and very, very close friend of me, Dr. Anand Rao, and also Vaidyanath Tugave, I wish every success to all the members of this endeavor. I extend my wishes to the respected working committee members of my dream team, all the past state and national presidents and vice presidents, the president and secretaries of all local branches of Karnataka, the team MEDICON 2023 of Bidar. I am so grateful to all of you who make up the loyal community of IMA Karnataka, to whom now I am connected. And also, I am pleased to extend my warmest welcome to the print and social visual press media here.
and also ladies and gentlemen. So Indian Medical Association is a voluntary organization, the doctors of modern scientific system of medicine, and also the largest non-government medical organization in the world. The objects of our associations are promoting the improvement of public health and medical education, these things. So I'm not going to tell, already I have given my message with booklet I gave. I'm not going to take much time since already time is over here. And only I will tell about what are the things I am going to do, my programs, that is the points I am going to take it now. IMA activities proposed in 2023-24. So only academic activities conducting CMEs at all branches, which are ongoing programs to update the knowledge of our members and providing skill-based training. So one more action I am going to dig that geriatrics, especially in our doctors, especially after 60 years. Just now, our Health and Family Welfare Minister, Dr. Dinesh Gundrao sir, he told about that. So it has life expectancy is very well as in our community. We have to do some work, we have to do some measures he expected. So this Indian Medical Association this year, we want to concentrate much about the geriatric doctors there and all. What else we can do that? So you know that we have got lot of physical, mental and domestic problems. All those doctors is there. We are planning to do what sort of this one along with the psychiatry, this one. We have to do some programs for the geriatric peoples, those who are above 60 years here. At the same time, we are planning some aspects, especially for the adolescent girls, that we want to work in coordination with the adolescent center, especially we have got on adolescent associations also is there all over Karnataka. In association with that, we want to plan some aspect, and we are requesting the state government almost to provide adolescent vaccine, especially HPV vaccine, to all adolescent girls free of cost, so that we can prevent the CSR vaccine them. That is also one of the major measures. I'm planning to meet health minister also, and I request our present minister here, Ishwar Khandre sir, to help in some aspect, so to get this program successful. That is also one of the most aspect we are doing that. So many other activities I already given in my booklets, but here other committees also we are planning this time. Medical teacher subcommittee, geriatric subcommittee, rules and bylaw, all these committees I already given booklet to you. I'm not going to take much time. I'm very happy that Dr. Ashokan has come here to grace this occasion. I'll promise, I'll tell you that whole year, whatever he tells, we are ready to do that. Definitely, sir, I'll promise you, whatever work he gave, Karnataka IMA will be there with you. We'll see that something, we'll do good thing for our doctors. This is this one, sir. I'll promise. I'm very thankful for everybody for patient hearing. So once again, I have to congratulate, I have to appreciate, I have to acknowledge the work done with the Bidar IMA, and thank you one and all.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಈಗ ಈ ಸಮಾರಂಭದ ಎಲ್ಲರ ಬಹುನಿರೀಕ್ಷಿತ ಕಾರ್ಯಕ್ರಮ, ಅದುವೇ ಪ್ರಶಸ್ತಿ ಪ್ರದಾನ ಸಮಾರಂಭ. ಇದನ್ನು ನಿಕಟಪೂರ್ವ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ಶಿವಕುಮಾರ್ ಲಕ್ಕೋಳ್ ಮತ್ತು ಅವರ ತಂಡ ನಡೆಸಿಕೊಡಬೇಕಾಗಿ ವಿನಂತಿ. ವೇದಿಕೆಯ ಮೇಲೆ ಇರುವ ಗಣ್ಯರು ಕೈ ಜೋಡಿಸಬೇಕಾಗಿ ಮನವಿ ಮಾಡಿಕೊಳ್ಳುತ್ತೇವೆ. ಮೊದಲಿಗೆ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ 2023ರ ಸಾರ್ವಜನಿಕ ಸೇವಾ ಪ್ರಶಸ್ತಿ. ಈ ಪ್ರಶಸ್ತಿಯನ್ನು ಇದೇ ಮೊದಲ ಬಾರಿಗೆ 3 ಸಾಧಕರಿಗೆ ನೀಡಲಾಗುತ್ತಿದೆ. ಈ ಪ್ರಶಸ್ತಿಗೆ ಭಾಜನರಾಗಿರುವವರು
ಬೀದರ್ ಜಿಲ್ಲೆಯ ಹುಮ್ನಾಬಾದಿನ ಶ್ರೀಮತಿ ಅಂಬಾಬಾಯಿ ಮಾಳ್ಗೆ. ಇವರು ದಯವಿಟ್ಟು ವೇದಿಕೆಗೆ ಬಂದು ಈ ಪ್ರಶಸ್ತಿಯನ್ನು ಸನ್ಮಾನ್ಯ ಈಶ್ವರ್ ಖಂಡ್ರೆ ಸರ್ ಮತ್ತು ಉಳಿದ ಗಣ್ಯರಿಂದ ಸ್ವೀಕರಿಸಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ಳುತ್ತೇವೆ.
ಮತ್ತೋರ್ವ ಸಾಧಕರು ಬಳ್ಳಾರಿ ಜಿಲ್ಲೆಯ ಪತ್ರಕರ್ತರಾದ ಶ್ರೀ ಮಂಜುನಾಥ್ ಕೆಎಂ. ಇವರು
ಶ್ರೀಮತಿ ಅಂಬುಬಾಯಿ ಮಾಳಗೆ ಬೀದರ್ ಜಿಲ್ಲೆಯ ಹುಮನಾಬಾದ್ ತಾಲೂಕಿನ ಹಳ್ಳಿ ಚಿಟುಗುಪ್ಪದ ಸಮಗಾರ ಮನೆತನದಲ್ಲಿ ಜನಿಸಿದ ಅಂಬುಬಾಯಿ ಅಕ್ಷರಶಃ ಬಡತನದಲ್ಲೇ ಬೆಳೆದವರು. ಸ್ಥಳೀಯ ಸಂಪ್ರದಾಯದಂತೆ ಎಳೆಯ ವಯಸ್ಸಿನಲ್ಲಿ ಮದುವೆಯಾದರು. ಗಂಡನ ಚಪ್ಪಲಿ ಹೊಲಿಯುವ ಕಾಯಕದೊಂದಿಗೆ ಕೈ ಜೋಡಿಸಿದರು. ಓಣಿಯಲ್ಲಿರುವ ನೂರಾರು ಕುಟುಂಬಗಳ ಬಡತನವೇ ಅವರನ್ನು ಬಗ್ಗದ ಹೋರಾಟಗಾರ್ತಿಯಾಗಿ ರೂಪಿಸಿತು. 2008ರಿಂದ 2022 ಡಿಸೆಂಬರಿನವರೆಗೆ ಅವರು ಮನರೇಗಾ ಕೆಲಸಕ್ಕಾಗಿ ಜಿಲ್ಲೆಯಾದ್ಯಂತ ನೂರಾರು ಹೋರಾಟಗಳನ್ನು ಸಂಘಟಿಸಿದ್ದಾರೆ. 2005ರಲ್ಲಿ ಹೆಣ್ಣು ಭ್ರೂಣ ಹತ್ಯೆ ನಿಷೇಧ ಅಭಿಯಾನದಲ್ಲಿ ಪಾಲ್ಗೊಂಡು ಬೀದರ್ ಜಿಲ್ಲೆಯಾದ್ಯಂತ ಜಾಥಾದ ಉಸ್ತುವಾರಿ ಮಾಡಿದರು. 2008ರಲ್ಲಿ ಮನರೇಗಾ ಕೆಲಸಕ್ಕಾಗಿ ದಿಲ್ಲಿ ಚಲೋದಲ್ಲಿ ಬೀದರ್ನಿಂದ ನೂರಾರು ಮಹಿಳೆಯರನ್ನು ಕರೆದುಕೊಂಡು ಹೋಗಿ ಇತಿಹಾಸ ನಿರ್ಮಿಸಿದರು. 2017-18ರಲ್ಲಿ ಬೀದರಿನ ಅಂಗನವಾಡಿ ಮಹಿಳೆಯೊಬ್ಬಳ ಮೇಲಾದ ಅತ್ಯಾಚಾರವನ್ನು ಖಂಡಿಸಿ ಬೃಹತ್ ಹೋರಾಟ ಅಣಿನೆರೆಸಿದರು. ಅಪರಾಧಿಗಳಿಗೆ ಶಿಕ್ಷೆ ಮಾಡಿಸಿದರು. ನೊಂದ ಮಹಿಳೆಗೆ ಪರಿಹಾರ ದೊರಕಿಸಿದರು. ಇಂಥ ಸಾಮಾಜಿಕ ಹೋರಾಟಗಾರ್ತಿಗೆ ಸನ್ಮಾನಿಸುವುದು ನಮ್ಮ IMAಗೆ ಹೆಮ್ಮೆಯ ವಿಷಯ.
ಮತ್ತೋರ್ವ ಸಾಧಕರು ಬಳ್ಳಾರಿ ಜಿಲ್ಲೆಯ ಪತ್ರಕರ್ತರಾದ ಶ್ರೀ ಮಂಜುನಾಥ್ KM. ಇವರು ದಯವಿಟ್ಟು ವೇದಿಕೆಗೆ ಬಂದು ಈ ಪ್ರಶಸ್ತಿಯನ್ನ ಗಣ್ಯರಿಂದ ಸ್ವೀಕರಿಸಬೇಕಾಗಿ ವಿನಂತಿಸಿಕೊಳ್ಳುತ್ತೇವೆ. ಶ್ರೀ KM ಮಂಜುನಾಥ್ ಹುಟ್ಟಿದ್ದು ಬಳ್ಳಾರಿ ತಾಲೂಕಿನ ಡಿ ಕಗ್ಗಲ್ ಗ್ರಾಮದಲ್ಲಿ 1977ರಲ್ಲಿ. ಹಂಪಿ ವಿಶ್ವವಿದ್ಯಾಲಯದಲ್ಲಿ ಪತ್ರಿಕೋದ್ಯಮ ಹಾಗೂ ಸಮಾಜಶಾಸ್ತ್ರದಲ್ಲಿ ಸ್ನಾತಕೋತ್ತರ ಪದವಿ ಓದುವಾಗ ಬೀದರ್ನಲ್ಲಿ ನಡೆದ ಯುವಜನೋತ್ಸವದಲ್ಲಿ ಚಿನ್ನದ ಪದಕ ಪಡೆದಿರುವ ಇವರು ಕಳೆದ 20 ವರ್ಷಗಳಿಂದ ಪತ್ರಿಕೋದ್ಯಮದಲ್ಲಿ ಸೇವೆ ಸಲ್ಲಿಸುತ್ತಿದ್ದಾರೆ. ಇದೀಗ ಕನ್ನಡಪ್ರಭ ಜಿಲ್ಲಾ ಪ್ರಧಾನ ವರದಿಗಾರರಾಗಿ ಕಳೆದ 8 ವರ್ಷಗಳಿಂದ ಸೇವೆ ಸಲ್ಲಿಸುತ್ತಿದ್ದಾರೆ. ಇವರ ಸಾಧನೆಗಳೆಂದರೆ ಬಳ್ಳಾರಿ ಜಿಲ್ಲೆಯ ಸಾಮಾಜಿಕ ಸಮಸ್ಯೆಗಳನ್ನು ಬೆಳಕು ಚೆಲ್ಲಲು ಈವರೆಗೆ 500ಕ್ಕೂ ಹೆಚ್ಚು ಲೇಖನಗಳನ್ನು ಬರೆಯುವುದರ ಜೊತೆಗೆ ತೆರೆಮರೆಯಲಿದ್ದ ಕಲಾವಿದರು, ಕ್ರೀಡಾಪಟುಗಳು, ಸಮಾಜಮುಖಿ ಚಿಂತಕರು ಹಾಗೂ ಸಮಾಜ ಸೇವಕರನ್ನ ಗುರುತಿಸಿದ್ದಾರೆ. ಜಿಲ್ಲೆಯ ಕೃಷಿ ಸಾಧಕರನ್ನ ಗುರುತಿಸಿ ಅವರ ಯಶೋಗಾಥೆಯ ಕುರಿತು ವಿಶೇಷ ವರದಿಗಳನ್ನು ಮಾಡಿ ಬೇರೆಯವರಿಗೆ ಪ್ರೇರಣೆ ತರುವ ಕೆಲಸ ಮಾಡಿದ್ದಾರೆ. ಅವರ ಪಡೆದಿರುವ ಪ್ರಶಸ್ತಿಗಳೆಂದರೆ 2021ರಲ್ಲಿ ಕರ್ನಾಟಕ ಕಾರ್ಯನಿರತ ಪತ್ರಕರ್ತರ ಸಂಘ ಕೊಡಮಾಡುವ BG ತಿಮ್ಮಯ್ಯ ಪ್ರಶಸ್ತಿಗೆ ಭಾಜನ. ಇಂತಹ ನೈತಿಕ ಪತ್ರಕರ್ತರನ್ನ ಸನ್ಮಾನಿಸುವುದು ನಮ್ಮ IMAಗೆ ಹೆಮ್ಮೆಯ ವಿಷಯ.
ಮತ್ತೋರ್ವ ಸಾಧಕರು ಬೆಂಗಳೂರಿನ ನಿವೃತ್ತ IPS ಅಧಿಕಾರಿಗಳಾದ ಶ್ರೀ S ಮರಿಸ್ವಾಮಿ. ಇವರು ದಯವಿಟ್ಟು ವೇದಿಕೆಗೆ ಬಂದು ಈ ಪ್ರಶಸ್ತಿಯನ್ನು ಗಣ್ಯರಿಂದ ಸ್ವೀಕರಿಸಬೇಕಾಗಿ.
Dr. Yoganand Reddy YC sir, a well-known practicing pediatrician at Prithvi Children's Hospital of Ballari. In recognition of his years of dedication, innovation, meticulous and wise diplomatic work in serving our IMA Karnataka, we are honored to present him with the IMA KSB Lifetime Achievement Award 2023. He is active and productive member in the IMA Karnataka for past 2 decades and have stimulated significant innovation in overall development. His mature and diplomatic leadership in association activities has been instrumental in creating and sustaining a culture of cooperation among the state members. On behalf of the members, it's a great pleasure that we present you with the first IMA KSB Lifetime Achievement Award 2023. Congratulations on this remarkable achievement. We thank you for your dedication and achievement. Next comes the IMA Karnataka State Branch Achievers Award. The IMA KSB Achievers Award 2023 is presented to Kumari Shrishti Suresh, daughter of Dr. Suresh Ballari. She has an outstanding achievement in the field of music. She has reached the semi-finals of Zee Kannada music competition and has mesmerized everyone with her melodious voice. Shrishti Suresh is a child prodigy, daughter of Dr. Suresh and Srimati Sunita of IMA Ballari. She is the shining star in television as Sarigama Pa singer of season 19. She has performed at various prestigious stages of Karnataka. At the age of 10, she has performed at the Hampi Utsava. With her versatile singing, she has reached the semi-finals. She is the winner of Hadu Kogile classical singing competition of Hospete Agashwani 2018. She has also performed in the Dasra Utsav 2023 in the Mysore Palace Hall. Next, the IMA KSB Achievers Award 2023 is presented to Kumari Kriti Anwar, daughter of Dr. Bhagwanta Anwar of Yadgiri, for her outstanding achievement in the field of medical academics.
Every year, IMA KSB felicitates distinguished doctors of Karnataka in recognition of their exceptional performance, dedication, hard work, and commitment to excellence. We request the following doctors to come on to the stage: Dr. Krishna Prasad Kudlu sir from Udupi Karavali, Dr. Ramachandra Aithal sir from Karkala, Dr. S.P. Hegde from Shivamogga, Dr. Veerabaswanta Reddy from Yadgiri, Dr. Sangama Veerabaswanta Reddy from Yadgiri.
Dr. Indira M. from Dodballapura, Dr. V. M. Venkatesh from Yalanka, Dr. Vajinath Tugave from Bidar, Dr. P. B. Hiremat from Hubli, and Dr. M. Kumaraswamy from Mangaluru. Dr. Krishna Prasad Kudlu from Udupi Karavali, Dr. Ramachandra Aithal, Dr. S.P. Hegde, Dr. Sangama Veerabaswanta Reddy, Dr. Veerabaswanta Reddy, Dr. Indira M., Dr. V. M. Venkatesh, Dr. Vajinath Tugave, Dr. P. B. Hiremat, Dr. M. Kumaraswamy.
Nadoja Dr. Krishna Prasad Kudlu, born on 23rd August 1973, MS Ophthalmology. He is a Senior Ophthalmologist, Medical Director of Prasad Netralaya Group of Eye Hospitals. Next, Dr. Ramachandra Aital, born on 22nd of May 1960, BSc from MGM College, Udupi, MBBS from MRMC, Gulbarga. Next, Dr. Subhash Chandra Bhujanga Hegde, born on 3rd July 1946, got his MBBS from MMC Mysore, established a charitable trust by the name of Malnad Heart Foundation, which educates general public in prevention of heart attacks.
Srimati Dr. Sangamma Veerabaswanta Reddy got her MBBS from MR Medical College. She is serving professionally in the VBR Multi-Speciality Hospital of Yadgiri. Dr. Veerabaswanta Reddy got his MBBS MS General Surgery from MR Medical College, Gulbarga. He is the Senate member of RGHS, National Governing Council member ASI, and MLA of Yadgiri Constitution in 2004. Dr. Indira R. got her MBBS from BMC Bengaluru, DGO from JJMMC Davangere. She actively participates in school health education programs. She is one of the major organizers for Guinness World Recorded Pap Smears Camp in Dodbalapura, where 630 smears were examined on one day. Dr. Y.M. Venkatesh got his MBBS from Adi Chunchandgiri Institute of Medical Sciences. He is working as a family physician at Yalanka. He is the founder member of IMA Yalanka branch in 1997.
Now it's time for branch awards. Branch awards are given in special recognition of outstanding performance and commitment to excellence. First, IMA KSB First Best Small Branch for the year 2023 goes to
IMA Honnavara branch.
Next, it's time for branch awards. Branch awards are given in special recognition of outstanding performance and commitment to excellence. First, IMA KSB First Best Small Branch for the year 2023 goes to
IMA Honnavara branch.
It's a rolling trophy donated by Dr. Sudha M. Kalyanpurkar. Next, IMA KSB Second Best Small Branch for the year 2023 goes to
IMA Harapnahalli branch.
Next, IMA KSB Second Best Small Branch for the year 2023 goes to
IMA Yadgiri branch. I request everyone clear the platform as soon as they receive the
IMA KSB first best small medium branch for the year 2023 goes to
IMA Yadgiri branch.
Diamond Jubilee Rolling Trophy. Next, IMA KSB second best small medium branch for the year 2023 goes to
IMA Sulia branch.
Next, IMA KSB first best large medium branch for the year 2023 goes to
IMA Gangavati branch.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪ್ರಥಮ ಉತ್ತಮ ದೊಡ್ಡ ಮಾಧ್ಯಮ ಶಾಖೆ 2023ರ ವಿಜೇತರು IMA ಗಂಗಾವತಿ ಶಾಖೆ.
Next, IMA KSB second best large medium branch for the year 2023 goes to
IMA Yalanka branch.
Congrats.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ದ್ವಿತೀಯ ಉತ್ತಮ ದೊಡ್ಡ ಮಧ್ಯಮ ಶಾಖೆ 2023ರ ವಿಜೇತರು IMA ಯಲಹಂಕ ಶಾಖೆ.
Next, IMA KSB first large best branch for the year 2023 goes to
IMA Shivamogga branch.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ಪ್ರಥಮ ಉತ್ತಮ ದೊಡ್ಡ ಶಾಖೆ 2023ರ ವಿಜೇತರು IMA ಶಿವಮೊಗ್ಗ ಶಾಖೆ.
Next, IMA KSB second large best branch for the year 2023 goes to
IMA Mangaluru branch.
ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆಯ ದ್ವಿತೀಯ ಉತ್ತಮ ದೊಡ್ಡ ಶಾಖೆ 2023ರ ವಿಜೇತರು IMA ಮಂಗಳೂರು ಶಾಖೆ.
Next is the special awards category. Best branch for the medico-social and community health activity goes to
IMA Ballari branch.
Rolling trophy donated by IMA South Canara branch.
IMA Ballari branch for best branch for medico-social and community health activity.
You? Yeah, see, one thing is make it statement that people who don't have their own vehicles, they wanted to say that people who don't have their own vehicles, cab is arranged with the
Next, rolling trophy for the most active branch in conducting scientific activities
Goes to IMA Gadag branch.
Next, IMA Karnataka branch sports award goes to
IMA Mangaluru branch. IMA Mangaluru branch for branch sports award.
next.
This program is live telecasted on THG and CCN news channels.
Next, rolling trophy for the branch which registers maximum increase in membership among biggest branches during the year 2023 goes to
IMA Yelahanka branch. IMA Yelahanka branch registers maximum increase in membership among the biggest branches during the year 2023.
Next, IMA KSB Best Ladies Wing Award for the year 2023 goes to
IMA Hasana branch. IMA Hasana branch for Best Ladies Wing Award for the year 2023. No, sir.
Next, IMA KSP Best AMS Academy of Medical Specialties Chapter Award goes to
IMA AMS Tumakuru branch.
IMA KSP Best AMS Academy of Medical Specialties Chapter Award goes to
IMA AMS Tumakuru branch.
Next, Best Local Branch Award for conducting Save the Girl Child activities installed by Dr. Naz Jahan Sheikh Hospiti branch goes to
IMA Sulia branch. IMA Sulia branch for Best Local Branch Award conducting Save the Girl Child activities.
IMA KSB Best Local Branch President Award 2023 is backed by
Dr. Venkataraya Bhandari P., President, IMA Udupi Karavali, for setting up a remarkable example of teamwork and leadership. The Best Local Branch President Award.
IMA KSB Best Local Branch Secretary Award 2023 is backed by
Dr. Hemant Kaujalgi, Honorary Secretary, IMA Belgaum Branch, for setting a remarkable example of teamwork and leadership.
IMA KSB Best Local Branch Secretary Award 2023 is backed by
Dr. Hemant Kaujalgi, Honorary Secretary, IMA Belgaum Branch, for setting a remarkable example of teamwork and leadership.
Next, IMA KSB President's Appreciation Award. We would like to call upon IMA Raichur Branch, IMA Bengaluru North Branch for constructing their own building with conventional hall. We would like to call upon IMA Raichur Branch onto the stage. IMA KSB President's Appreciation Award, IMA Raichur Branch. Next, we would like to call upon IMA Bengaluru North Branch. Next, we would like to call upon IMA Bhadravati Branch. Next, we would like to call upon IMA Chitradurga Branch. We would like to call upon IMA Bhadravati Branch onto the stage. Next, we would like to call upon IMA Chitradurga branch.
IMA is there? Branch on the stage. Yeah.
Next, we would like to call upon IMA Hubli branch. Next, we would like to call upon IMA Hubli branch.
Next, I would like to call upon IMA Jamkhandi branch. I would like to call upon IMA Jamkhandi branch. Next, I would like to call upon IMA KGF branch. I would like to call IMA KGF branch. Next, I would like to call IMA Sirsi branch.
Here is a point of information. As you all know, a banquet hall, that is Zira Convention Hall. So we have arranged buses and cabs from our institute to Zira Convention Hall. So we request everyone, you can go via our arranged buses and cabs.
Next, we would like to call upon IMA Mandya branch.
IMA Mandya branch. Next, it's IMA Kumta branch. IMA Kumta branch.
Next, we would like to call upon IMA Mysore branch onto the stage.
Next, I would like to call upon IMA Chikkodi branch. IMA Chikkodi branch. Next, I would like to call upon IMA Chikmagaluru branch. Now, I would like to call upon Dr. Mithun M. of GIMS Gadag. Sir has been working tirelessly for MSN. Next, Dr. K.M. Jayakumar, IMA Chalakere branch for serving IMA for years. Dr. K.M. Jayakumar, sir.
ಮಲ್ಲಿಕಾರ್ಜುನ್ ಪಂಚೇಟಿ ಅದು ಕೆಳಗಿಂದ ಇಲ್ಲ ರೈಟ್ ವೋಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಮುಗಿತು.
Hello. There's an important announcement. The venue for the banquet is Jira Convention Hall. Jira Convention Hall. Guests who do not have their individual or personal vehicles can use a bus and few cabs which are arranged outside the building.
Now, now we request the organizing secretary of MEDICON 2023, Dr. Mallikarjun Panshetty sir, to give vote of thanks.
I'm sure none of you are interested to wait here for longer than 1 minute. So I just would like to thank our honorable ministers who have taken their time to come and be the chief guest for this conference, and also IMA KSB for giving us an opportunity to conduct this conference at our place. I thank one and all, and please, I request everyone to join us at the banquet. Thank you. Thank you all.
Thank you, sir.
Two, three times the same announcement. Okay.